And how was the exam? How was the exam? All right. So I'm going to start the physiology discussion. There were 17 questions in physiology, and we will discuss them so that we are absolutely clear about the physiology concepts. So let's look at the first question. Now, the first question says, which of the following receptors respond to a change in texture? Now, as far as texture is concerned, whenever you want to feel the texture, for example, if you want to feel the texture of any cloth, for instance, you use your fingertips. And the fingertips have got abundant Meissner's corpuscles. Meissner's 60% of the sensory input from the fingertips is from Meissner's corpuscles. So my best answer to this question is Meissner's corpuscle. Now, Merkel's discs and Meissner's corpuscles have got overlapping functions, almost similar functions. They are both meant for fine touch, for texture, for topognosis, but a slightly better answer for whether it is fine touch, texture or topognosis, slightly better answer becomes Meissner's corpuscles. Meissner's corpuscles are rapidly adapting receptors. Anjum says the paper was on the tougher side. So that is the reason why we are coming for discussion on the same day, because we want to make sure that your concepts about the questions which have been asked are absolutely clarified and that you get a better understanding of all the subjects. Okay. Anjum again says paper looks like the INI-CET type, but this is a fact, Anjum, that the FMG paper, now that gap between the FMG and the INI-CET paper of the FMG or the NEET paper, which was there a few years back, has now narrowed down, and in fact the standard of questions being asked in the FMG paper are definitely higher than a few years earlier. So yes, it is, I can understand that this is slightly on the tougher side, but like I said, we are going to discuss all these questions so that things look a little simpler. All right, so this is Meissner's corpuscle. So coming back to my first question. Now, there are rapidly adapting receptors and there are slowly adapting receptors. Three very important examples of rapidly adapting receptors, and that is Pacinian corpuscle, Meissner's corpuscles, and the hair end organs. Pacinian corpuscle is meant for fast vibration up to 800 cycles per second, and this is also meant for deep pressure, which is poking. Now again, a question which has been asked, and which is the receptor for deep pressure, and that is going to be Pacinian corpuscle. And like I told you, Meissner's corpuscle is for fine, well localized touch, for texture and for topognosis, and it is also meant for slow vibration up to 80 cycles per second. Hair end organs will detect light movement on the skin. Now you have these slowly adapting receptors, Merkel's discs. Like I said, overlapping functions with Meissner's, fine well localized touch, texture, topognosis, but better answer for all these three will be Meissner's corpuscles. I told you 60% of the sensory input from fingertips is from Meissner's. Even if you are asked a question on Braille, Braille is a script for the visually challenged, better answer, Meissner's. Meissner's more than Merkel's. Ruffini's end organs are meant for fine, well localized touch and for prolonged pressure. C mechanoreceptors for crude touch and for pressure. Remember, if the question says deep pressure, better answer is Meissner's corpuscle. Muscle spindle for muscle length or muscle stretch. Golgi tendon organ for muscle tension. Joint receptors for joint and position sense. Muscle spindles, Golgi tendon organs, and the joint capsule receptors. These are three important receptors for proprioception. What is proprioception? This is joint and position sense. Thermoreceptors, They detect temperature of objects placed on the skin, and nociceptors are meant for pain. All right. So these are your rapidly and slowly adapting receptors, and I've told you what are the commonly asked questions from this particular topic. And just a slide of the Meissner's corpuscle. Meissner's corpuscle is an elongated encapsulated receptor. Elongated encapsulated receptor. It lies in the dermis, but actually there are these finger-like projections, these of the dermis into the epidermis, which are called the dermal pegs. And in these dermal pegs, you've got the Meissner's corpuscles. Merkel's discs are present in the epidermis. Meissner's dermis, but in the dermal pegs. Merkel's discs are in the epidermis. The nerve fiber from Meissner's corpuscles, A beta. Dermal pegs of glabrous skin. Very importantly, what is glabrous skin? Glabrous skin is the non-hairy skin. And I've already told you that this is a receptor for fine, well-localized touch, also called discriminative touch. Now, please remember, again, this was a question which was asked, which is a receptor for discriminative touch. Discriminative touch does not mean two-point discrimination. Discriminative touch is another term for fine, well-localized touch. So for fine, well-localized touch, your better answer is going to be Meissner's. Slow vibration, texture, topognosis, and braille. This is Meissner's corpuscle. Slowly adapting receptors, like I told you, Merkel's. Merkel's is present in the epidermis. As you can see in this diagrammatic representation, this is Merkel's disc, which is present in the epidermis. But Merkel's disc is present in the epidermis of hairy, Merkel's disc is present in the epidermis of hairy and glabrous skin. Some books say that Merkel's disc is only in hairy skin, but remember, it is both hairy and glabrous. Once again, Meissner's rapidly adapting receptor, present in the epidermis of glabrous skin. Meissner's, once again, rapidly adapting receptor, present in the dermal pegs, dermis of glabrous skin. Merkel's disc is a slowly adapting receptor, present in the epidermis of hairy and glabrous skin. All right, now Gajendra Chauhan, this is not a recorded video, I'm live, and that is why I am able to answer your questions. Yes. Save Rahega video, yes, of course it will be available. Of course it will be available. Vicky Babu, no doubt about that. This will be available to you even after this discussion. All right. Okay. So can I move on? Any doubts as far as? Yes, Mohammed, I am live with you. So any doubts as far as this particular topic is concerned? बहुत important topic है. बार ये question receptors को लेकर आते हैं. And especially Meissner's और Merkel's को लेकर there is always some doubt, some confusion. Once again, I'm going to repeat that. Meissner's is rapidly adapting receptor. It is present in the dermis of glabrous skin, especially in the dermal pegs. And this is your answer for fine, well-localized touch, for texture, for topognosis, and for braille. अगर discriminative touch पूछा जा रहा है, that is the same as fine, well-localized touch. Better answer is Meissner's. What about Merkel's? Merkel's is a slowly adapting receptor. It is present in the epidermis of, it is more superficial, it is present in the epidermis of both hairy as well as glabrous skin. All right. Fine touch is asked, Jack Sparrow, you should be able to say, Meissner's. Meissner's is a better answer for all. Fine touch, texture, topognosis, braille. Meissner's is a better answer than the I didn't understand. Cost of, what are you? MDS aspiration के लिए भी Paris? Sorry, I don't follow that. All right. Okay, great. Pasinin corpuscle, Mohammed Shehzad. Pasinin corpuscle is again a very rapidly adapting receptor. The nerve fiber which is associated with, this is what a pasinin corpuscle looks like, encapsulated receptor. Nerve fiber associated is again a beta. This is meant for fast vibration as well as for deep pressure. सिर्फ प्रेशर पूछा जाए then your answer is C mechanoreceptors. लेकिन अगर deep pressure पूछा जाए then your answer is Pacinian corpuscles. क्योंकि जो Pacinian corpuscles हैं, they have a deep location. This is a Pacinian corpuscle. They are deeply located in the dermis, in the fascia, in the muscles. So this is for deep pressure. Samar Khan says 179. Is it good? Yes, it is. Okay. Chaliye, let's go on to the next question. Now this says, which of the given statements are true regarding the regulation of calcium and phosphate levels? Now, this is extremely important for us to understand what is the role of parathormone, calcitonin and vitamin D. Now, parathormone, it increases the serum calcium levels and decreases serum phosphate. This is true, right? How does parathormone increase the serum calcium and decrease the serum phosphorus? Parathormone, the two actions of parathormone are, on the PCT, parathormone decreases the inorganic phosphorus reabsorption and therefore decreases the plasma phosphorus levels. Right? Phosphorus or phosphate, these are used interchangeably. They mean the same thing, inorganic phosphorus and phosphate. So it decreases the plasma or the serum phosphorus or phosphate levels. Parathormone will act on the DCT. In the DCT, it increases the calcium reabsorption. So that is how it increases the plasma calcium level. Number two, the parathormone will also act on the bone. The parathormone receptors on bone are present on osteoblasts. So it acts on osteoblasts. Please be very careful. Parathormone receptors are on osteoblasts. Calcitonin receptors are on osteoclasts. But we know that parathormone increases bone resorption. So how does it do that? It acts on osteoblasts. It increases the secretion of rank ligand. And what does rank ligand do? Rank ligand will increase what is known as the monocyte colony stimulating factor, MCSF. And this monocyte colony stimulating factor acts on osteoclastic precursor cells and causes their differentiation into mature osteoclasts. So once again, parathormone receptors are on osteoblasts, but it causes a secondary increase in osteoclastic activity. It increases the bone resorption. That is how it increases the plasma calcium level. Right? So remember, receptors for parathormone, osteoblasts, secondary increase in osteoclastic activity. And what is secreted is rank ligand. Rank ligand, right? And this increases the monocyte colony stimulating factor, and that in turn will act on osteoclastic precursor cells, causing a secondary increase in osteoclastic activity. Osteoclastic precursor cells will differentiate into mature osteoclasts. So this is how it's going to increase the plasma calcium or the serum calcium levels, right? Now, another action of parathormone is, parathormone will act on the kidney and it increases the activity of 1-alpha hydroxylase. And what is the role of 1-alpha hydroxylase? It acts on 25-hydroxycholecalciferol and converts it into 1,25-dihydroxycholecalciferol. What is 1,25-dihydroxycholecalciferol? That is the active form of vitamin D. And what is the role of vitamin D? Vitamin D will increase the intestinal as well as the renal absorption of calcium and phosphate. So that is the yes, Aryan. Osteoclast is the primary, okay, for calcitonin. All right. So this is your parathormone increases serum calcium and decreases, is true. Calcitonin decreases the serum calcium levels. Now, what is the role of calcitonin? Now, calcitonin, the receptors are present on osteoclasts. And on the osteoclasts, it reduces osteoclastic activity, inhibits the osteoclastic activity, decreases the bone resorption. Now, as far as physiology is concerned, the two major agents which control calcium and phosphorus levels are parathormone and vitamin D. In normal physiological conditions, calcitonin does not have a very important role. What is more important is parathormone and vitamin D. But yes, calcitonin decreases osteoclastic activity, and that is why calcitonin is used in the treatment of Paget's disease, Paget's or Paget's disease, isn't it? Which is characterized by increased osteoclastic activity. So calcitonin is used to reduce that. So calcitonin increases the serum calcium level. So this becomes false. Sorry. Sorry, this is true. Sorry, I made a mistake here. 1 second. Parathormone decreases serum calcium, increases serum phosphate. No, this is false. It will reduce serum phosphate and increase the serum calcium level. So this is also true. So my answer here, 1, 2 and 3 are correct, and this is your answer is D. Sorry, I got a little distracted here. Okay. Okay. All right. So Dr. Sarabjit is answering your questions as well. Okay. All right. So this is your okay, so let's go on to our next question, and that is dye dilution technique is used for the measurement of various body fluid compartments. Using inulin dye, it is observed that ECF constitutes 1/3 of the total body water. If 10 grams of insulin is administered, 10% gets metabolized. After equilibration, plasma inulin levels are 50 milligrams per 100 ml. Calculate the ECF volume. So Akash says, how does parathormone activate osteoclasts? Let me just explain this to you once again. Parathormone receptors are present on osteoblasts. It acts on osteoblasts. It increases the secretion of rank ligand by the osteoblasts. And this rank ligand in turn increases what is known as the monocyte colony stimulating factor, which acts on osteoclastic precursor cells. And there is now an increased differentiation mature osteoclasts, right? So this is one way that this is going to act, right? Another thing that parathormone does is, parathormone decreases, the second action of parathormone is, parathormone decreases what is known as osteoprotegerin. Parathormone, the second action is, it decreases what is known as osteoprotegerin. What is osteoprotegerin? Osteoprotegerin is a decoy receptor for rank ligand. Now, what do you mean by a decoy receptor? Decoy receptor means it is a false receptor for rank ligand. झूठ मूठ का रिसेप्टर है ये, रैंक लाइगेंड को बाइंड करके उसकी एक्टिविटी को कम करता है. So if I reduce the osteoprotegerin, what will happen to rank ligand activity? Increases, है ना? और rank ligand activity, if it increases, more osteoclasts will be formed. More mature osteoclasts will be formed. So there is an increase in osteoclastic activity. Is that okay? Somebody was asking me this question. Okay. How does the okay. Somebody was asking me this question about the how does parathormone increase osteoclastic activity. So this should be absolutely clear. Receptors on osteoblasts, but secondary increase in osteoclastic activity. Okay. All right. Now, next question. Dye dilution technique is used for the measurement of various body fluid compartments. Now, measurement of various body fluid compartments is done by what is known as the dye dilution technique. And the formula for measurement of body fluid compartments is V is equal to Q minus E over C. And what is V here? V is the volume that you have to determine. Q is the known quantity of the dye which is used, which is given in this question. Q is 10 grams or 10,000 milligrams. Remember, 1 gram is equal to 1,000 milligrams. What is E? E is the amount of dye which is metabolized. It's been given over here, 10% gets metabolized. So this is 10% means 10% of 10 grams is 1 gram. So that means 1,000 milligrams gets metabolized. Okay. So, and what is C? C is the concentration of a dye in a sample after equilibration. So this is given as 50 milligrams per 100 ml. So this will be 10,000 minus 1,000 divided by, now 50 milligram per 100 ml is 0.5 milligram per ml. So this is 0.5 milligram per ml. Milligram and milligram will get cancelled. So this is 9,000 divided by 0.5, that is 18,000 ml or 18 liters. All right, so this is your this is what is known as the dye dilution technique. What is the formula for dye dilution technique? Remember, V is equal to Q minus E over C. Q here, the important thing whenever you get a numerical in physiology, the important thing is please pay attention to the units. Right? Units is, for instance, in this question, you have milligram, you have gram, so you must use similar units. So that's what I did. I converted 10 grams to milligrams, and then this was per 100 ml, I took it in per ml, so that made my calculation easier. All right. Okay. Okay, so this is what is known as the dye dilution technique. So Aryan says using inulin to measure kidney function. So inulin, clearance of inulin is used for the estimation of GFR. So that's a little different from here. This here, inulin is a substance which is being used in this question for the measurement of the ECF volume. So there's a little difference here, whereas in the kidney we use the clearance of inulin for estimation of GFR. What is clearance? Clearance is volume of plasma cleared of inulin in unit time. Have you understood? And the clearance of inulin, the unit for clearance of inulin will be ml per minute, right? And that is what is that is used for the estimation of GFR, right? Okay. All right, let's go on to the next question. Which of the following is or are the only excitatory neurotransmitter? Now this can be, the important point here is that the term used is only excitatory. Now out of this, glutamate is definitely an excitatory neurotransmitter. Glycine and GABA are both inhibitory, without a doubt. Glutamate is the most important excitatory neurotransmitter in the CNS. 75% of the excitation in the central nervous system is done by glutamate. Now what about serotonin? Now serotonin is inhibitory, but it can also be excitatory, right? So it's both inhibitory and excitatory, and of course the actions will depend upon which are the receptors present, right? So only excitatory, my best answer here becomes glutamate. Glutamate. So answer is A. That is only 2. Yes? All right. Always important to read the question carefully. Question says only excitatory. So my answer here would be glutamate. Okay. Yes. Apurvashri, very important that that before the exam, and especially when you've got a few days left, to motivate yourself, to pull yourself together, to take corrective action. You have time now to take corrective action in case there have been some mistakes. And so important that we go through the all the topics and the discussions carefully, right? Okay. All right. Which of the given factors decrease prolactin levels? Now, as far as prolactin levels is concerned, prolactin secreted from the anterior pituitary, this is under the prolactin inhibiting factor, inhibitory control of prolactin inhibitory factor from the hypothalamus. And what is prolactin inhibiting factor? This is dopamine. This decreases the prolactin secretion. Now, what can increase prolactin secretion? There is a small mnemonic for that, which is called new pet's shop. These will increase prolactin. New is nursing, when the mother is feeding the baby, pregnancy, estrogen, TRH, stress, strenuous exercise, NREM sleep, stages 3 and 4, sexual intercourse, this is with S, hypothyroidism, opiates, and phenothiazines. So these are what will increase the prolactin secretion. So let's go through this. The question says, what will decrease prolactin secretion? Now, dopamine agonists like bromocriptine, this will definitely reduce, because dopamine, prolactin inhibiting factor, is nothing but dopamine. So yes. Glucocorticoids will also reduce the secretion of prolactin, somatostatin, and thyroid hormones will also reduce. Remember, TRH will increase, but thyroid hormones will decrease the prolactin secretion. So in a patient of hypothyroidism, where TRH secretion is high, there is many times you will see patients of hypothyroidism presenting, especially a non-pregnant woman presenting with galactorrhea. Hypothyroidism has to be ruled out, right? So remember, thyroid hormones will decrease prolactin secretion, but TRH will increase prolactin secretion, right? So this is as far as your the prolactin is concerned. All right, let's have a look at the next question, which says, which of the following statements is true regarding the left shift of the oxygen hemoglobin dissociation curve? Now, when you look at the left shift, remember, favors affinity shift to left, favors delivery shift to right, FAL, FDR. Rightward shift means more delivery, more disassociation. Leftward shift means more affinity, more association. So if there is a right shift of the curve, we expect there is an increase in P50, a decrease in affinity, more delivery, decreased affinity, more delivery. FAL favors affinity, a shift to left. This is a decrease in P50 and an increase in affinity, right? So this is FAL and FDR, right? Now, what are the conditions which will cause a rightward shift? Rightward shift is whenever there is increase in PCO2, increase in H+, decrease in pH, increase in temperature, increase in 2,3-BPG. 2,3-BPG is a byproduct of the glycolytic pathway, and hemoglobin S. And what is going to cause a decrease in P50? That means a shift to the left. That is, if there is a decrease in PCO2, decrease in H+, increase in pH, hypothermia, decrease in 2,3-BPG, hemoglobin F, and myoglobin. So let's see. Left shift of the curve. Decrease in pH favors a left shift? No, a decrease in pH causes a rightward shift. So this is incorrect. Decrease in 2,3-BPG favors, a decrease in 2,3-BPG causes a leftward shift. So this is true. P50 value decreases, true. HbS trait does not favor, this is also true. HbS trait favors a rightward shift. Stored blood in blood banks. Now what happens in stored blood? Stored blood, there is decreased glycolysis, decreased 2,3-BPG, so this also becomes true. So 2, 3, 4, 5 are true, and so that means my answer is B. Okay. All right. So the same thing which I've just discussed with you, and we can also write stored blood will cause a leftward shift, because when you store blood in the blood bank, you're reducing the glycolysis. And decrease in 2,3-BPG means a shift to the left. Identify the type of lung condition from the following diagram. So this is, now this is a question which has been asked as recently in your January exam. There was a flow volume loop which was given. So flow volume loop, so even if you feel that this is tough, but this has been asked in your exam. So let's see. Now, one important point that I must bring to your notice, and that is when you look at a flow volume curve or a flow volume loop, there are two ways in which to discuss this. Now, I can have the flow rate on the y-axis. Flow rate can be in liters per minute, liters per second. So that's fine. The rate means it has to be per unit time. So this is always on the y-axis. Now, on the x-axis, two things. Either I can have the lung volume in liters, or I can have volume of air expired or inspired in liters also on the x-axis. Slight difference, right? Please remember, flow volume loops can have on the x-axis either lung volume in liters or volume of air expired or inspired again in liters. Shape of the curve is the same in both, but slight difference. If it is lung volume, please listen to this very carefully. If it is lung volume on the x-axis, then the maneuver starts from total lung capacity and ends at residual volume. So the numbers given on the x-axis will be 6, 5, 4, 3, 2, 1, decreasing from left to right. Shape of the curve, if you look at a normal expiratory flow volume curve, will be like this. Sorry, let me just make a better diagram. And inspiratory curve will be something like this. This becomes a loop. But if I have volume on the x-axis, volume of air expired, let's say on the x-axis, then the curve will be, shape will be absolutely the same, except the numbers on the x-axis will be, let me just discuss this once again. From left to right, 1, 2, 3, 4, 5, 6. Is it all right? So just that minor difference will be there, right? And normally physiologists prefer the first one and clinical medicine prefers this particular graph, right? So shape of the graph, like I said, is not going to be different at all. Now when I look at the graph which is given here, if you look at the flow volume loop here, now what is the important point here, and that is when you look at the forced vital capacity. Forced vital capacity is the width of this loop. That is forced vital capacity. What you see over here in the defective loop, it is reduced. There is a decrease in the forced vital capacity. And again, this is also reflected in the first graph, where there is a reduction in the forced vital capacity. All restrictive lung diseases, vital capacity is reduced. What is restrictive? Restrictive means there is a restriction in lung expansion. So all lung volumes will be reduced. In obstructive lung disease, it is obstruction to flow. So what is affected more is the flow rate. And what happens in a obstructive lung disease is, so supposing this is my normal, if this is my normal graph, normal loop, in obstructive lung disease, the shape of the graph is something like, it is a scooped out curve. It is what is known as a scooped out curve. Yes? This is what looks like in the case of obstructive lung disease. It's a scooped out curve, like a ice cream scoop. Yes? So that is typically seen in obstructive lung disease. What you see in restrictive lung disease is mainly that the curve is narrower. The loop is narrower because the volumes are affected more than the rates here. In obstructive lung disease, the curve will be a scooped out curve. So this is typically seen, what you see over here is your restrictive lung disease. Restrictive lung disease. What happens to the FEV1 by FEVC ratio in obstructive lung disease and restrictive lung disease? The FEV1 by FVC ratio is reduced in obstructive lung disease. This is normal to maybe even increased in restrictive lung disease. A ratio will decrease when the numerator decreases more than the denominator, and a ratio will be normal if the decrease in both is to the same extent, right? And how will it increase? If the denominator, the decrease in denominator is more than the decrease in the numerator. So that is how you are going to distinguish between obstructive and restrictive lung diseases. Now, which of the following is correct regarding the physiology of the PCT? PCT reabsorbs 100% of the filtered glucose, which is true. It is impermeable to water. This is going to be false. In fact, 2/3 of water is reabsorbed in the PCT. No amino acids are reabsorbed in the PCT, which is absolutely false. 100% of amino acids are reabsorbed in the PCT. PCT is the site of action of aldosterone. No, aldosterone acts on late DCT and the collecting duct. If you have to make a choice between the two, your better answer is collecting duct. So this is also false. My answer becomes A. PCT reabsorbs 100% of the filtered glucose. So this should not be a problem. Okay. So glucose and amino acids to the tune of 100% are reabsorbed in the PCT, and water to the extent of 2/3. 2/3 is reabsorbed in the PCT. Electrolytes about 60%, sodium, potassium chloride, etc., and urea about 50 to 60%, or 50 to 60%. Which of the following GI regulatory substances is incorrectly matched with its source and regulation? Now, where is ghrelin going to be secreted from? Ghrelin is secreted from the stomach. It is secreted from the D1 or P cells, which are located in the fundus. And ghrelin is secreted whenever there is, ghrelin is an orexigenic. Orexigenic means it increases appetite, right? So this is, so when you're hungry, ghrelin secretion increases, yes? Now, so stomach, yes, that is true. Does it decrease after gastric bypass surgery? That is also true, because the main source of ghrelin is in fact the stomach. Ghrelin is also secreted from the pancreas, but major source of ghrelin secretion is going to be the stomach. Now, as far as VIP is concerned, now VIP is secreted not from the stomach, in fact from the small intestine. This is it is reduced by the adrenergic output. So this becomes incorrect. Pepsin is secreted from the stomach. So incorrect, not from the pancreas. It is decreased by vagal stimulation. No, in fact, vagal stimulation causes an increase. So this is also incorrect. Somatostatin. Somatostatin is delta cells, yes. D cells. Delta cells are present in the small intestine, also in pancreas. Somatostatin, D cells this is correct. It is increased by gastric acid secretion. This is also true. CCK. CCK is secreted by what are known as the eye cells in the upper small intestine. What stimulates the release of CCK are products of protein digestion and fatty acids. So it is increased by fatty acids, so this becomes incorrect. So which are the ones which are incorrectly matched? This is 2, 3, it says incorrectly matched. So this is going to be 2, 3 and 5, and my answer becomes B. Right? So the question has not said correctly matched, it said incorrectly matched. So be careful, always read the question carefully. Incorrectly matched is 2, 3 and 5. Right, let's go on to the next question. It says a 50-year-old male patient presents with symptoms of heart failure. On examination, heart rate is 90 beats per minute, BP is 142/94, JVP is elevated, 2D echo reveals ejection fraction of 35%. So obviously the heart is not pumping properly, but he is able to maintain his blood pressure. So that means there are some compensatory mechanisms which are helping to maintain this blood pressure. Question says, which of the following compensatory mechanisms is primarily responsible? Now again, the question here is primarily responsible for maintaining cardiac output in this patient. So let's look at the options. It says activation of the renin-angiotensin-aldosterone system. In patients of cardiac failure, yes, the system is activated. A decrease in cardiac output, decrease in blood flow to the kidneys, decrease in renal afferent arteriolar pressure will increase the renin secretion. From the JG cells in the kidney. So if renin increases, angiotensin will increase, angiotensin 2 will increase, aldosterone, there will be sodium and water retention. But is this the primary mechanism maintaining the blood pressure in this patient? No. But yes, this is also activated in a patient of cardiac failure. But question has said primarily responsible. So let's look at the other options. Yes, let's go over it one by one. Now the next one says increased production of ANP. Now what happens in a patient of cardiac failure? Heart is not pumping blood effectively. There is the CVP, or the central venous pressure, increases. Yes, it is not able to pump blood effectively. There is stretch of the atria. Atrial stretch will stimulate the atrial stretch receptors, which increases ANP. Atrial natriuretic peptide. Atrial natriuretic peptide will increase natriuresis, will increase loss of sodium in urine, loss of water in urine. Yes. So it will regulate the blood volume, but not really the primary mechanism for maintaining blood pressure in this patient. Atrial natriuretic peptide secretion will increase. There's no doubt about that. Right? But is it the primary mechanism maintaining blood pressure? No. Let's look at the next one. Activation of the baroreceptor reflex. Baroreceptors also will be activated. If heart is not pumping blood properly, there is less flow, there is a fall in blood pressure. Whenever there is a fall in blood pressure, baroreceptors will try to increase the blood pressure by increasing the sympathetic discharge. Fourth option says activation of the sympathetic nervous system. ये तो पक्का हो रहा है. So my best answer here becomes activation of the sympathetic nervous system, which will cause a peripheral vasoconstriction. It will increase the heart rate. It will increase the force of contraction of the heart. It will increase the stroke volume. Right? There is an increase in heart rate. There is an increase in the force of contraction of the heart. It increases the stroke volume and it increases the cardiac output. So primarily due to activation of the sympathetic nervous system. Baroreceptor reflex will also cause activation of sympathetic nervous system, but ultimately what is really responsible is the activation of the sympathetic nervous system. So my best answer here becomes activation of the sympathetic nervous system. Okay? Okay, can I move on to the next question? Anything so far? Let's look at the next one. It says, it's again a clinical but very simple question really. It says there's a known case of hypothyroidism. There is a type 1 diabetes mellitus presented to the emergency with complaints of abdominal pain, generalized weakness, excessive thirst. You check the vitals, 104, 112, SpO2 97, RBS 450. You decide to give him IV sodium chloride, administer IV insulin. Put on a saturation probe, order the nurse to record SpO2 and RBS. While discussing the case, the attendant consultant advises you to monitor serum values of which of the following ions. And whenever you're giving IV insulin, insulin will increase the activity of the sodium-potassium ATPase pumps. Sodium-potassium ATPase pumps are ubiquitous. They're present in all the cells. Whenever the activity of sodium-potassium ATPase increases, the sodium will move out of the cell and potassium will move into the cell. Potassium in plasma is as it is between 3.5 to 5 millimoles per liter. Normal potassium level kitna hai? Just 3.5 to 5 millimoles per liter. If potassium starts moving into the cells, what will happen to plasma potassium levels? Reduce. So plasma potassium levels, if they reduce, if hypokalemia happens, it can have dangerous results, consequences. So he has to monitor the plasma potassium levels. Insulin increases activity of sodium-potassium ATPase pumps, causes inward movement of potassium and will reduce the plasma potassium levels. Sodium, of course, is moving out of the cells, but yaad rakhein, plasma ka sodium already is very high, 135 to 145 millimoles per liter. So outward movement of sodium will not cause a very large change in the already high sodium. Lekin inward movement of potassium will lower the plasma potassium levels. So we have to be very careful if there is a fall in potassium. Okay, let's look at the next question. Which of the following peaks is responsible for ovulation? Now this is a very commonly asked diagram, which has been asked a number of times. The A is LH, B is FSH, C is estrogen, and D is progesterone. And we know that, isn't it? Pre-ovulatory phase, estrogen will show you a rise. Post-ovulatory, it is going to be progesterone. And what are these two? The largest rise that you see is almost 8 to 10-fold increase is seen in the LH levels just before ovulation. LH begins to rise about 24 to 48 hours before ovulation. Then the peak of LH is approximately 16 hours before ovulation. So this is, and without this LH surge, ovulation which will not happen. So the hormone which is going to be responsible will be LH, or your answer will be A. So this is a simple question. Which of the following are known as resistance vessels? Large arteries are known as Windkessel vessels. Arterioles are known as resistance vessels. Capillaries are your exchange vessels. And veins are your capacitance vessels. Why are they called capacitance vessels? Because they are thin-walled and they have the capacity to distend. Veins, venules, veins, vena cava hold almost 2/3 of the blood volume. Arterioles are called your resistance vessels because when we talk about total peripheral resistance, we are talking of resistance mainly at the level of arterioles. Because when you look at arterioles, arterioles have got so much of smooth muscle, thick walls, plenty of smooth muscle, very good sympathetic supply. And so they are thick walled with plenty of smooth muscle. So these are your seat of peripheral resistance, arterioles, and therefore they are called resistance vessels. Let's look at the next question. This is a diagram of a sarcomere. This is a Z line. What is present between two Z lines is the structural and the functional unit of the muscle, which is the sarcomere. So C is sarcomere. What is A? A is the dark band. And when I say dark band consists of myosin plus the overlapped actin. What is D? D is the edge zone, slightly lighter area within the dark band, which is the edge zone. This has only myosin. What is E? E is the I band. I band has only actin. I band is the light band. And what is B? B is actually half of an I band. Remember, half of I band lies in one sarcomere, half lies in a neighboring sarcomere. So E is the total I band or the light band. A is the dark band. But between two Z lines is the sarcomere. So question says, what is A made of? A is made of myosin plus overlapped actin. Myosin plus overlapped actin. So my answer to this is C. Any questions? Right. Let's look at the next one. It says, if the refractory period of a nerve is 1/2000th of a second. What is refractory period? Refractory period means during this time a nerve is not going to respond to another stimulus. The cell is not going to respond. It is refractory. It is refractory to a second stimulus. It will not respond. What is the maximum frequency of excitation? Maximum frequency of excitation will be reciprocal of the absolute refractory period. So that is 1/1 of 2000th of a second. In other words, this is 2000 per second. This is the maximum frequency. Theoretically, I can stimulate this nerve 2000 times per second. Remember, less than 1/2000th of a second, it is not going to respond. So if I give this nerve stimuli at the rate of 2000 times per second, the nerve will respond. So my answer is 2000 times. Right, let's go on to the next one, which says, which of the following is an example of feed-forward mechanism? Now, what is feed-forward mechanism? Feed-forward is different from feedback. Feedback is, most of the control systems in the body are feedback, especially negative feedback. Feedback can be negative, few examples of positive feedback as well. Now, feed-forward is what is known as anticipatory control. So once you remember, this is anticipatory control. Key word here is anticipatory, right? In anticipation. So let's see. The example here is salivation in anticipation of food, right? Your blood pressure increases just before, your sympathetic drive increases just before you start exercise. In anticipation of exercise, there is increased sympathetic drive. That is called feed-forward control. Let's see the other options. It says increased blood pressure during supine position. So when you go from standing to supine position, there is the effect of gravity is gone. There is more blood. What is going to happen here? There is more, less peripheral pooling of blood, right? So this is the effect of going on to a supine position, it is not a feed-forward mechanism, right? Shivering on exposure to a cold environment, when you lose body heat, you begin to shiver. That is the response to loss of body heat, not a anticipatory. Raised blood pressure on sharp cutaneous pain, when there is sharp pain, pain fibers will increase the sympathetic discharge. So again, this is a response to the pain, not anticipatory. So my answer to this question is salivation in anticipation of food, right? Okay, let's go on to the next one. Which of the following statements is correct? Urea clearance is little more than, now please remember, clearance of inulin is equal to GFR. Why so? Because inulin is a substance which is freely filtered, not reabsorbed, not secreted. The rate at which inulin is removed from the body is the rate at which it is filtered by the kidney. Volume of plasma free of inulin in unit time is the rate at which inulin is filtered, because inulin is neither reabsorbed nor secreted in the kidney. So clearance of inulin is equal to GFR. Now any substance which is reabsorbed, if a substance is reabsorbed, that means it re-enters into the plasma, its clearance is will be less than the clearance of inulin, very importantly. Again, keep in mind, what is the definition of clearance? Volume of plasma free of that substance in unit time, right? So if a substance is reabsorbed, its clearance will be less than the clearance of inulin. If a substance is secreted, its clearance is more than the clearance of inulin. Now there are two substances we are talking about, urea and creatinine. Urea is a substance which is freely filtered and partly reabsorbed. So its clearance will be lower than the clearance of inulin. Creatinine is a substance which is freely filtered and slightly secreted. So its clearance will be more than the clearance of inulin. So let's see this in mind now. Let's keep this in mind and let's answer the question. Urea clearance is little more than creatinine clearance? No, it is less than creatinine clearance. It is less than inulin, less than creatinine clearance. Urea clearance is the same as creatinine clearance? Again, incorrect. It is lower than creatinine clearance. Inulin clearance is little more than creatinine clearance? Incorrect. It is creatinine clearance which is slightly more than inulin clearance. So inulin clearance is little less than creatinine clearance. This is true. So my answer to this question becomes D. Absolutely. This should be absolutely clear. Any substance which is reabsorbed will have a clearance lower than the clearance of inulin. Any substance which is secreted will have a clearance more than the clearance of inulin. And this is an interesting graph. This substance C here is the clearance of inulin, which is at 125 ml per minute, which is your GFR. A and B are both have a clearance more than the clearance of inulin, so they must be secreted. D is a substance which is reabsorbed. Any substance which is reabsorbed will have a clearance lower than the clearance of inulin. Any substance which is secreted will have a clearance higher than the clearance of inulin. What are these? C is clearance of inulin. B is creatinine. I told you creatinine is a substance which is freely filtered and slightly secreted. Creatinine clearance will be slightly more than the clearance of inulin. ठीक है? And आपको पता ही है कि practically speaking, clinical experience में creatinine clearance is also used for the estimation of GFR. लेकिन जो gold standard है GFR के लिए, somebody had asked me this question right in the beginning. For that you have to answer inulin clearance, right? But clinical practice में creatinine clearance को भी use किया जाता है for estimation of GFR, right? Can you repeat secretion part why D is correct? Okay, I'll just tell you. Now what is A? A is para-aminohippuric acid. What is para-aminohippuric acid? Remember, para-aminohippuric acid in low concentration is freely filtered and completely secreted. And para-aminohippuric acid in high concentration is freely filtered and partly secreted. Right? Now, Jack Sparrow, just keep in mind, सबसे पहले जो important चीज़ which you have to keep in mind is that you have to remember the definition of clearance. Clearance क्या है? Volume of plasma free of that substance in unit time. और clearance का जो formula है, that is UV by P. U is urinary concentration, V is rate of urine flow, P is plasma concentration. ठीक है? Volume of plasma free of that substance in unit time. अब अगर remember, जैसे ये diagrammatic representation है nephron का, this is afferent arteriole, glomerular capillaries, efferent arteriole. अब अगर कोई substance reabsorb होगा तो वो nephron से plasma में जाएगा, तो volume of plasma free of that substance in unit time will reduce, it will become less. अगर कोई substance secrete होगा, that means वो plasma से nephron में जाएगा, so volume of plasma free of that substance in unit time will increase. ठीक है? Clearance of inulin हम लेते हैं as equal to GFR, right? Creatinine क्या है? Freely filtered and slightly secreted. तो इसका मतलब वो plasma से nephron में आ रहा है. So volume of plasma free of creatinine unit time will be slightly higher than the clearance of creatinine. Is it okay? Jack Sparrow, that is why we said D is correct, isn't it? Inulin clearance is little less than creatinine clearance, or in other words, creatinine clearance is slightly more than inulin clearance. So my answer to this becomes D. Is it okay, Jack Sparrow? Understood? I want you to be absolutely clear about clearance because this is a topic which is asked again and again. So here in this diagram, C is the clearance of inulin equal to GFR. B is creatinine clearance, slightly more than inulin clearance. A is clearance of para-aminohippuric acid because para-aminohippuric acid in low concentration is completely secreted, very high clearance. But in high concentration, the clearance of para-aminohippuric acid decreases and the clearance will reduce. And that's exactly what is happening in A. And when you look at D, what is D? D is the clearance of glucose. Now, very important, this is the last point which I'm taking up. Look at glucose. Now, glucose below a certain plasma concentration, which is known as renal threshold. There is no glucose in urine. What is renal threshold? Definition, again, renal threshold is the plasma concentration beyond which glucose begins to appear in the urine. Less than this plasma concentration, no glucose in urine. Glucose is freely filtered and completely reabsorbed. What is the formula for clearance? UV by P. अगर urine में glucose है ही नहीं, अगर ये 0 है, anything multiplied by 0 is 0. तो clearance 0 हो जाएगा. So below renal threshold, the clearance of glucose is 0. ठीक है? याद रखिए renal threshold क्या है? Plasma concentration beyond which glucose begins to appear in the urine. So as soon as my plasma concentration, x-axis पर plasma concentration है. As soon as the plasma concentration of glucose exceeds renal threshold, it begins to appear in the urine. So clearance will start increasing. Yes? लेकिन हमेशा इनुलिन की क्लियरेंस से कम होगा क्योंकि कुछ ग्लूकोज तो रीअब्सॉर्ब हो रहा है. आपको पता ही है, अभी मैं बता चुकी हूँ कि if there is a reabsorption, clearance will be lower than the clearance of inulin. If a substance is secreted, clearance will be more than the clearance of inulin. So this is as far as your physiology questions were concerned. Hopefully you have enjoyed the discussion as much as I have enjoyed in conducting this session, and hopefully, so what is renal threshold? Now you have to, renal threshold is, I'll repeat it once again. What is renal threshold? Renal threshold is the plasma concentration beyond which, oh, how much is it? How much is it? This is 180 to 200 milligrams per deciliter. Renal threshold is 180 to 200 milligrams per deciliter. Yes, and this is that per deciliter means deciliter is 100 ml. So I can write this as 2 milligram per ml. Right. Thank you so much, and I'll hand it over to Dr. Sarvjit. He'll be taking the discussion forward, and all the best. Keep studying, be regular, brush up all your important concepts as far as physiology is concerned. I can assure you that physiology will be cakewalk. Thank you very much, and God bless.
Hello everyone. So this is Dr. Sarvjit, your very own ENT faculty, and I'm going to discuss the ENT questions for you. I know the 30th July exam has been announced, and now we have less than 2 months for this exam. So this is the right time to analyze yourself. What are your mistakes? What are your shortcomings? Which are your questions, which are the subjects where you need to do the questions, understand them. And probably this is the situation of students that I can see right now. A lot of students are like this कि बहुत सारा कोर्स है, बहुत सारी बुक्स हैं, क्या करें और क्या नहीं करें. Okay, so I'm going to talk about it on a separate video, what you have to do now. But yes, hello Jack Sparrow, hello Yash, hello Dr. Ajay, Dr. Purva. So we're going to take the discussion, but don't be bogged by so many books. You guys have a problem of plenty, so don't go by that, right? What we have to do in this grand test, in the idea was, you don't have to remember the mistakes. You have to remember the lessons that you have learned from today's test. And the lessons, most important lesson is, this paper, right, 2 months before your exam, it serves an analysis of your subjects, your preparation. And you can give it the right direction that is very much needed over here. Okay. Yes, Dr. Thorachan Sau. So I hope you guys are with me. So shall we start with a discussion of ENT? Let's go to the first question over here. And the ENT questions were pretty straightforward. So in this paper, what is a good score? You see, the question paper, so the paper was designed in a way so that you are tested properly. Okay. So all your concepts are tested properly. Now remember that the paper is going to be clinical. They are going towards the next exam, which is coming up in December. So this is probably the last FMGE exam. And therefore, the questions will come clinical. Good evening, Jayansh. So, if you have scored 150 and above in this marks, so, you are pretty much where you should be. Okay, so anyone who's got 150 to, let's say, 180 or 200. So I'm still to see who's the topper over here, but who's got this 150 to 180, you are pretty much in a zone which I will not call it as a safe zone right away, straight away. Okay, so you will be in a zone where you keep on doing what you are doing right now. Okay, don't falter from it. All right, and you will definitely pass the exam. Okay, all you have to do is to maintain your consistency for the next 2 months. Now, students who are in 120 to 150 zone, okay, so now you guys, you are very near to where you should be. You are not there, but you are very near, and you have 2 months time to get there. Okay, you have those 2 months to get there. I'll say this is the time is little less than 2 months now. It's around 50-55 days that are left. Ram Ram sir, Ram Ram Mayank. So yes, 55 days are left over here. So you have to work hard, and definitely you can have the score of 150 plus. You can even take it till 180. Right? Now people who are less than 120, okay, who are like 100 to 120, I'll say. Now you guys need to do some hard work, okay, and a lot of assessment of yourself. Okay, you need to do a lot of assessment for yourself. I said some hard work, but a lot of assessment. You need to know what are your strengths, what are your weaknesses, and what all you can turn around in these 2 months. It is still doable, but you will have to sacrifice a lot of things to make it possible, right? Okay, so let's start with the questions. So first question over here, they were pretty straightforward question as far as ENT is concerned. CSF from anterior cranial fossa can reach the nose through all of the following routes except. So it was a trick question. Why? The trick question didn't lie in the option. The trick question, you see, the trick lied in the question itself. They were not in the option, they were in the questions. Anterior cranial fossa. So right now you're looking at CSF which is coming from anterior cranial fossa. Okay, so if I draw a diagram of the nose, just you have to remember over here. Right. So you can see that this is the frontal sinus over here. We have the anterior cranial fossa over here. Okay, and now CSF from anterior cranial fossa, it can go to the ethmoid sinus, it can go to the frontal sinus. So this is the cribriform plate. Remember, what you have to remember over here, the sphenoid, it forms a part of middle cranial fossa. It forms a part of middle cranial fossa. We over here have the pituitary gland. So what is coming from sphenoid is not coming from anterior cranial fossa. It is actually coming from the middle cranial fossa. So that is how the answer was over. It was a pretty straightforward question, but look, it was a tricky question. Okay, right? So that was the answer over here. Let's go to the second question. Which of the following is false about tonsillectomy? So I hope the questions are clear. Please stay communicated with me. Keep on writing your comments if you don't understand anything or if you want me to explain it in further details. ठीक है बेटा, आगे बढ़े क्वेश्चन में. Yes, okay. So the neck of the patient. तो इसमें क्या देखना है हमारे को? False. So this is very important. You have to find out what you have to see, whether you have to find out the true thing or the false thing. So here we have to find out the false thing. The neck of the patient is hyper extended during the procedure. Is it? Rose position होता है, extension होता है, hyper extension होता है क्या? No. We extend the neck at the two joints. Okay, so its extension is there. Do we hyper extend it? I don't think so. Now, active infection is the contraindication for the procedure. Yes, we don't do. In case of, so instead of marking me over here like this, let me just put it like this. So this is a true statement. Whenever there is acute tonsillitis, we postpone the patient, we don't do the surgery over here. This is a true statement. Friend, this is not a false statement. Okay, reactionary hemorrhage can occur within 24 hours post tonsillectomy. This is also a true statement. Yes, recurrent infection is the most common indication for tonsillectomy. So we have studied about sore throat. In our lectures, we have studied about sore throat. We know more than equal to 7 episodes 1 year, more than equal to 5 episodes per year for 2 years, more than equal to 3 episodes per year for 3 years. Okay, right? Or if the patient misses school or office for more than 14 days in 1 year because of sore throat. So this is also a true statement. So you see, the neck of the patient is not hyperextended. It is just extended, right? So that is our answer over here in this. The answer is choice A. We had to find out the false statement. So this statement is a false statement over here, right? Okay. ठीक है बेटा, समझ में आई बात आगे. So again थोड़ी सी ट्रिक यूज की थी यहाँ पे. Okay, इसको एक्सटेंशन की जगह हाइपर एक्सटेंशन किया था. So small, you know what I wanted to do in this paper was not to give you very long clinical questions, not to test your knowledge. You guys all are very fantastic in ENT, but just to give you small tricks, you know, where you can make mistakes. Okay, so which of the following is true about brainstem evoked response audiometry? तो क्या देखना है हमारे को यहाँ पे? ये देखना है कि true क्या है बेरा के लिए. So we know all about बेरा. Yes, Dr. Ajay. Villagers बालक परवीन पनवर. Okay, right? Invasive test. बेरा invasive होता है? No, it's not an invasive test. Okay, it is not a invasive test. Is it a subjective test? No, it is a objective test. It is the most objective test. This is the best test for malingering. किसके लिए यूज करते हैं? Malingering के लिए यूज करते हैं. Best objective test for malingering is बेरा. So it is not a subjective test. Done only for those who are above 18 years. भाई ये भी गलत false statement है. क्यों? Neonates में भी तो करते हैं confirmatory test. Confirmatory test for neonatal deafness क्या होता है? बेरा. और screening test क्या होता है neonatal deafness के लिए? OAE. Okay? तो OAE क्या है? Screening test है. Screening test क्या हुआ इसका? Neonates में OAE. Okay? और confirmatory test क्या हुआ? बेरा. तो न्यूनेट्स में करते हैं. सो दिस इज ऑल्सो ए फॉल्स स्टेटमेंट. डन फॉर सेंसरी न्यूरल हियरिंग लॉस. यस, दैट इज द आंसर. ओके, डन फॉर सेंसरी न्यूरल हियरिंग लॉस. विद दिस वी कैन differentiate into cochlear and retrocochlear deafness. So this is a test of retrocochlear deafness. It will tell you where the retrocochlear deafness lies, if it is because of the neural pathway. Okay, so it is a test of retrocochlear deafness. So that is the correct statement over here, right? Okay, let's go to the next question. A 6-year-old boy presented to hospital with sore throat. भाई sore throat पे क्वेश्चन आए हैं. एक और क्वेश्चन आया है sore throat पे. टॉन्सिल्स पर क्वेश्चन है. ओके क्या टॉन्सिल्स का क्वेश्चन है? शॉर्ट थ्रोट सुन के ऐसा लगता है? ध्यान से देखेंगे। ऑन एग्जामिनेशन ए स्वेलिंग इज सीन ऑन द साइड ऑफ द फेरिंग्स विथ टॉन्सिल शिफ्टेड टू मिड लाइन। तो ये क्वेश्चन एफएमजी क्वेश्चन है और ये रिपीट क्वेश्चन है। आई वांटेड टू गिव दिस क्वेश्चन क्योंकि यह कंट्रोवर्शियल क्वेश्चन है। तो बात याद रखेंगे बेटा, दो ऑप्शन होती हैं यहाँ पे। पहली होती है हमारी क्विंसी, ओके, और दूसरी होती है पैराफ्रेंजियल एब्सेस। क्विंसी होती है और पैराफ्रेंजियल एब्सेस होती है। दोनों का प्रेजेंटेशन ऑलमोस्ट सेम होता है, राइट। दोनों में से क्या मार्क करेंगे? क्विंसी यानी कि पेरीटॉन्सिलर एब्सेस एंड पैराफ्रेंजियल एब्सेस, दोनों में से क्या मार्क करेंगे? सो हिमांशु इज सेइंग ए, मयंक इज सेइंग सी, राइट। दोनों में से क्या आंसर? तो याद रखेंगे अगर पैराफ्रेंजियल एब्सेस है और क्विंसी है, उनमें क्या डिफरेंस है? तो क्विंसी में बोलेंगे टॉन्सिल्स। एग्जामिनर क्या बोलेगा बेटा आपको? टॉन्सिल्स कैसे हैं? रेड हैं, कंजेस्टेड, एनलार्ज्ड। ये तीन वर्ड जरूर यूज होंगे। टॉन्सिल्स आर रेड, कंजेस्टेड, एनलार्ज, ओके। दे आर हाइपरट्रॉफिड। एनलार्ज मतलब दे आर हाइपरट्रॉफिड एंड दे आर रीचिंग मिड लाइन। वो खुद से पहुंचे बड़े होकर के, ठीक है, राइट। दे आर रीचिंग मिड लाइन। और पैराफ्रेंजियल एब्सेस, पैराफ्रेंजियल एब्सेस, पैराफ्रेंजियल एब्सेस में क्या होगा? सो पैराफ्रेंजियल एब्सेस में क्या होगा बेटा? पैराफ्रेंजियल एब्सेस में लेट्स लुक ओवर हेयर। पैराफ्रेंजियल स्पेस एब्सेस में क्या होगा? पैराफ्रेंजियल स्पेस एब्सेस में देयर इज ए स्वेलिंग इन लेटरल वॉल ऑफ नेक। अगर स्वेलिंग इन लेटरल वॉल ऑफ नेक बोला किसी ने आपको, ओके, तो इसका मतलब वो क्या हुआ? इसका मतलब वो हो गया आपका पैराफ्रेंजियल स्पेस एब्सेस। सेकंड, तो टॉन्सिल्स कुछ नहीं होंगे, टॉन्सिल्स आर पुश्ड, दे आर पुश्ड टू मिड लाइन, राइट। नंबर थ्री क्या होगा यहां पे? पेशेंट कैन हैव ट्रिस्मस। ट्रिस्मस इज इन्वॉल्वमेंट ऑफ मीडियल टेरिगॉइड मसल, right? And number 4, we will also have over here, we can sometimes have swelling in neck, upper 1/3 of SCM, ठीक है, राइट। तो यहां पे देखो ये कंडीशन जो है, ये क्वेश्चन जो है, ये सेटिस्फाई कर रहा है पैराफ्रेंजियल एब्सेस को, ओके। तो इसमें आंसर क्या हो गया? पैराफ्रेंजियल एब्सेस हो गया, राइट। टॉन्सिल्स के बारे में रेड, कंजेस्टेड कुछ नहीं मेंशन है, सिर्फ ये मेंशन है कि टॉन्सिल्स आर शिफ्टेड टू मिड लाइन। तो बेटा लोग ये चीज़ें याद रखना है, एग्जाम में ये क्वेश्चन रिपीटेडली आता है, इसको मिस नहीं करना है, राइट। लेट्स गो नेक्स्ट क्वेश्चन। फेवरेट क्वेश्चन है एग्जामिनर्स का, मल्टीपल टाइम आ चुका है ये इमेज, नेजोफेरिंग्स का इमेज है। सो द एंडोस्कोपिक इमेज ऑफ नेजोफेरिंग्स इज गिवन बिलो। आइडेंटिफाई द साइट ऑफ ओरिजिन ऑफ नेजोफ्रेंजियल क्वेश्चन कार्सिनोमा। एक क्वेश्चन को थोड़ा सा ट्विस्ट कर दिया, हमें पता होना चाहिए मोस्ट कॉमन साइट ऑफ नेजोफ्रेंजियल कार्सिनोमा। तो मोस्ट कॉमन साइट ऑफ नेजोफ्रेंजियल कार्सिनोमा इज फोसा ऑफ रोजनमुलर, FOR, फोसा ऑफ रोजनमुलर। तो हमेशा क्वेश्चन पूछते हैं कि फोसा ऑफ रोजनमुलर कहाँ है। इस बार हमने थोड़ा सा इमेज को चेंज कर दिया, तो यहाँ देखेंगे क्या क्या दिख रहा है आपको। यू कैन सी दिस इज द यूस्टेशियन ट्यूब ओपनिंग, दिस ओवर हेयर इज टॉरस टुबेरियस, और इसके पोस्टीरियर सुपीरियरली जो ब्लाइंड रिसेस होता है इसको बोलते हैं फोसा ऑफ रोजनमुलर। दिस इज द मोस्ट कॉमन साइट ऑफ ओरिजिन ऑफ NPC, नेजोफ्रेंजियल कार्सिनोमा। यस कपिल देव, बिल्कुल ठीक बोल रहे हैं आप। इन क्विंसी यूविला पॉइंट्स टुवर्ड्स द नॉर्मल साइट, ठीक है, ये बहुत इंपॉर्टेंट पॉइंट है। अगर आपके पास इमेज आएगी क्विंसी की, पेरिटॉन्सिलर एब्सेस की, तो उसमें ऐसे ही आएगा। बिल्कुल करेक्ट है आपका ये, राइट, ओके ओके जी। चलें नेक्स्ट क्वेश्चन पे चलते हैं। ये क्वेश्चन क्लियर है सबको आंसर? तो इसमें क्या मार्क किया हुआ था फोसा ऑफ रोजनमुलर के लिए? 1 मार्क किया हुआ था इमेज के अंदर, तो 1 हमारा आंसर हो गया, ठीक है बेटा। 3 तो मार्क किया हुआ था कपिल, 3 तो मार्क किया हुआ था हमारा, 3 क्या मार्क किया हुआ था? 3 मार्क किया हुआ था हमारा टॉरस टुबेरियस पे, 2 मार्क था यूस्टेशियन ट्यूब पे, 1 मार्क था फोसा ऑफ रोजनमुलर पे, ठीक है। तो आंसर क्या हो गया हमारा? 1 हो गया। चले नेक्स्ट क्वेश्चन पे चलें। विच ऑफ द फॉलोइंग आर्टरीज डज नॉट सप्लाई द पैलेटाइन टॉन्सिल्स? तो मैंने आपको पढ़ाते हुए एक निमोनिक दिया हुआ है, टडाड, टॉन्सलर आर्टरी, ब्रांच ऑफ फेशियल आर्टरी, असेंडिंग पैलेटाइन, डिसेंडिंग पैलेटाइन, असेंडिंग फेरेंजियल, डॉर्सल लिंगुअल, ब्रांच ऑफ लिंगुअल, ओके। तो बताओ भाई, ग्रेटर पैलेटाइन तो है नहीं ना, ग्रेटर पैलेटाइन तो नोज में है। देखो डॉर्सल लिंगुअल आर्टरी आ गई, टॉन्सिलर ब्रांच ऑफ फेशियलैट्री आ गई, असेंडिंग डिसेंडिंग पैलेटाइन आ गई। ग्रेटर पैलेटाइन तो आती ही नहीं है, ग्रेटर पैलेटाइन नोज में होती है। तो ये निमोनिक याद रखेंगे टडाड, और इससे आंसर हो जाएगा हमारा सॉल्व इसमें, राइट। ओके, सो याद रखेंगे टॉन्सिल्स के अंदर सिर्फ असेंडिंग पैलेटाइन और डिसेंडिंग पैलेटाइन आर्टरी सप्लाई करती हैं, ग्रेटर पैलेटाइन नहीं करती। ठीक है बेटा, नेक्स्ट क्वेश्चन पे चलें। कपिल, हिमांशु, कोई प्रॉब्लम अब तक? हाँ जी, चलें आगे, चलिए। ए मदर ब्रिंग्स हर 4 years old डॉटर टू द emergency रूम। तो 4 years old daughter, she gives history that the child was having her meal when she suddenly started choking। ठीक है जी, तो चोकिंग हो रही है, इसका मतलब फूड कहाँ चला गया? एयरवे में चला गया। और जब एयरवे में चला जाता है तो क्या करते हैं इमीडिएटली कैसे उसको रिमूव करेंगे? उसको रिमूव करेंगे बाय हेमलिच मैनूवर। ओके, सो चोकिंग हो रही है तो क्या करेंगे? इनफैक्ट this maneuver, sometimes the choking is there, it is done in the restaurant, in the house only, so Heimlich maneuver is the maneuver that has to be done। कैसे करते हैं? so you make thumb, एक से इससे अपना रिस्ट लेंगे पूरा, इससे अपना पूरा अपना पंच बनाएंगे एक हैंड से और दूसरा हैंड कवर करेंगे, एंड यू विल पुट एट द स्टर्नम एंड विद वन blow you will try to take it out। okay, so that is your Heimlich maneuver, right। next, which of the following muscle is abductor muscle of vocal fold? तो vocal folds के बारे में हमने क्या पढ़ा अभी तक? vocal folds के बारे में हमने पढ़ा है कि all muscles are adductors, all are adductors except PCA, posterior cricoid, only abductor। और ये क्वेश्चन फेवरेट है एग्जामिनर्स का, बहुत बार आता है इस PCA, posterior cricoid, posterior most muscle of larynx, only abductor of larynx। okay, that is your posterior cricoid। चलिए, स्ट्रेट फॉरवर्ड क्वेश्चन आया था। अच्छा, ये क्वेश्चन कोविड-19 का क्वेश्चन है, रिपीट क्वेश्चन है, और ये कई बार एग्जाम में आया है, सो वी कैन स्टिल एक्सपेक्ट कि कोविड पे कुछ क्वेश्चंस आ सकते हैं। साइड, so a patient, 50-year patient with a history of COVID-19 few months back, presents with headache, blurring of vision and proptosis। okay, so क्या हो रहा है पेशेंट को? ब्लरिंग ऑफ विजन है, प्रोप्टोसिस है। ओके, कोविड-19 की हिस्ट्री है। ऑन एग्जामिनेशन क्या आया? एग्जामिनेशन में हमारे को मिला ब्लैक टर्बिनेट्स आर सीन एंड ए डायग्नोसिस ऑफ म्यूकरमाइकोसिस इज मेन। सो म्यूकरमाइकोसिस का डायग्नोसिस है। म्यूकरमाइकोसिस क्वेश्चन के, जो द फॉलोइंग ऑर्गेनिज्म इज रिस्पॉन्सिबल फॉर दिस कंडीशन। तो क्वेश्चन स्ट्रेट फॉरवर्ड है, म्यूकरमाइकोसिस में ही म्यूकर आता है पहली बात तो डिजीज किससे बना? एक तो म्यूकर और राइजोपस, दो ऑर्गेनिज्म कॉज करते हैं इसको। तो इसका आंसर क्या हो गया बेटा? बच्चे लोग, इसका आंसर हो गया डी आंसर, बोथ ए एंड सी। ठीक है, राइट। क्वेश्चन में ट्रिक, यहाँ पे भी थोड़ा सा ट्रिक यूज किया था। हमेशा आप गलती वहीं पे करते हैं जहाँ पे आप सुपर कॉन्फिडेंट होते हैं, राइट। जहाँ पे आप सुपर कॉन्फिडेंट होंगे वहाँ पे आप गलती करेंगे। तो ये कोशिश की थी आपसे, आपको फोर्स करवा के कि कुछ गलतियाँ करवाई जाएं, ताकि हम देखें कि आप कहाँ कहाँ गलती कर सकते हैं और उनको आप फिर एग्जाम में रिपीट नहीं करें। तो रिमेंबर माय डायलॉग, फॉरगेट द मिस्टेक्स, रिमेंबर द लेसन्स। तो लेसन याद रखना है कि डायरेक्टली जंप नहीं करना है, सारी चॉइसेस देखनी है। ओके, तो बोथ ए एंड सी, राइजोपस ऑल्सो कॉजेज रेनियोसेरेब्रल म्यूकरमाइकोसिस। नेक्स्ट क्वेश्चन, विच ऑफ द फॉलोइंग साइनस कैन बी सीन अर्लीस्ट इन एक्सरे आफ्टर बर्थ? ओके, सो कैन यू एक्सप्लेन अदर ऑप्शंस एज वेल? सो बेटा एस्परजिलस, ओके, एस्परजिलस अगर हम यहाँ पे देखेंगे, एस्परजिलस से क्या होता है? एस्परजिलस से फंगल राइनोसाइनोसाइटिस होता है, फंगल बॉल, रिमेंबर फंगल बॉल, राइट। ओके, एस्परजिलस से म्यूकरमाइकोसिस नहीं होता बेटा। म्यूकरमाइकोसिस किससे होता है? म्यूकरमाइकोसिस होता है राइजोपस और म्यूकर से। ओके, एस्परजिलस से नहीं होता। एस्परजिलस से क्या बनता है? फंगल बॉल, जिसको हम क्या बोलते हैं? एस्परजिलोमा, राइट। ओके, तो उसका बोलते हैं एस्परजिलोमा, वो होता है। मोस्ट कॉमन फंगल डिसऑर्डर ऑफ द नोज इज कॉज्ड बाय एस्परजिलस, राइट, एस्परजिलस फ्यूमिगेटस। ठीक है जी। एलर्जिक फंगल राइनोसाइनोसाइटिस में कौन होता है? बाइपोलैरिस कर्विलेरिया, और उसमें भी एस्परजिलस होता है। लेकिन राइनोसेरेब्रल म्यूकरमाइकोसिस जो इन्वेजिव है, उसमें क्या होता है? उसमें राइजोपस और म्यूकर होते हैं। ठीक है बेटा, राइट। ओके, तो गलती हो गई, कोई बात नहीं, लेकिन गलती आगे नहीं होगी, इसको करेक्ट करेंगे गलती को। राइट, विच आर द फॉलोइंग साइनस कैन बी सीन अर्लीस्ट इन एक्सरे आफ्टर बर्थ। ओके, तो अर्लीस्ट कौन सी साइनस आती है आफ्टर बर्थ? मैक्सिलरी साइनस। कब आती है? कब आती है? 4 to 5 months आफ्टर बर्थ वी कैन सी इट ऑन एक्सरे। 4 to 5 months आफ्टर बर्थ वी कैन सी इट ऑन एक्सरे। इथमॉइड साइनस कब विजिबल होती हैं? बाय द एज ऑफ 1 year। ओके, बाय द एज ऑफ 1 year। फ्रंटल साइनस कब विजिबल होती है? सी, फ्रंटल इज द लास्ट टू स्टार्ट ग्रोइंग। बर्थ पे होती है, नाउ वी से ऑल द साइनसेस आर प्रेजेंट एट बर्थ। लेकिन क्या होता है कि फ्रंटल साइनस अराउंड 2 years के बाद डेवलप होना शुरू होगी, लेकिन ये जैसे ही ये क्रीज क्रॉस करेगी, ओके, सो इट विल स्टार्ट बिकमिंग विजिबल। तो 4 to 5 years आफ्टर बर्थ इट विल स्टार्ट बिकमिंग विजिबल ऑन ए एक्सरे। स्फिनॉइड इज द लास्ट टू बिकम विजिबल ऑन एक्सरे। ओके, राइट, सो आंसर ओवर क्या था यहाँ पे? तो आंसर हो गया यहाँ पे मैक्सिलरी साइनस। राइट बच्चे लोग, चलो इजी क्वेश्चन, आगे बढ़ते हैं। प्रेग्नेंट फीमेल कम्स टू योर ओपीडी कंप्लेनिंग ऑफ हियरिंग लॉस, प्योटन ऑडियोमेट्री। बड़ी टिपिकल फोटोग्राफ है बच्चे लोग, ये टिपिकल फोटोग्राफ। यस, योगी आदित्यनाथ जी, मैक्सिलरी साइनस इज द लार्जेस्ट साइनस ऑल्सो। मुझे नहीं पता था कि यूपी के सीएम साहब भी हमारा यहाँ पे एक्सप्लेनेशन देख रहे हैं, ओके, और उनका ईएनटी में इतना इंटरेस्ट है। चलिए, अच्छी बात है। सो प्रेग्नेंट फीमेल कम्स टू योर ओपीडी कंप्लेनिंग ऑफ हियरिंग लॉस, प्योटन ऑडियोमेट्री फाइंडिंग्स आर शोन। सो ये बहुत टिपिकल फोटोग्राफ है जो आपको याद रखना है। ओके, टिपिकल फोटोग्राफ क्या है इसमें? ये टिपिकल फोटोग्राफ है जहाँ पे आपको दिख रहा है ए बी गैप। ओके, तो दिस ए बी गैप सिग्निफाइज क्या? कंडक्टिव हियरिंग लॉस। एंड आपको दिख रहा है यहाँ पे डिप एट 2000 हर्ट्ज, यानी कि क्या है? करहार्ट्स नॉच। अगर ये दोनों दिख गए तो आंसर क्या बनेगा हमारा? ऑटोस्क्लेरोसिस। टिपिकल फोटोग्राफ है, टिपिकल प्योटन ऑडियोमेट्री कर्व है जो आपको याद रखना है यहाँ पे। राइट, और उसमें क्या है? शी हियर्स वेल इन ए नॉइजी सराउंडिंग। तो चलो बेटा, एक हिंट और मिल गया आपको यहाँ पे। क्या हुआ ये? इसको क्या बोलते हैं? इसको बोलते हैं पैराक्यूसिस विलिसाई, बेटर हियरिंग इन नॉइजी एनवायरनमेंट। ठीक है, तो दोनों चीजें मिल गई आपको यहाँ पे। पैराक्यूसिस विलिसाई मिल गया, एक टिपिकल ऑडियोमेट्री फाइंडिंग जिसमें करहार्ट्स नॉच और कंडक्टिव हियरिंग लॉस, सब कुछ मिल गया। ओके, यस। सो 4000 हर्ट्ज पे डिप होता तो नॉइज इंड्यूस हियरिंग लॉस होता, लेकिन उसके अंदर बेटा योगी साहब, उसके अंदर जो है आपको बहुत इंपॉर्टेंट है कि 4000 हर्ट्ज पे डिप तो हो, लेकिन साथ में वो सेंसोन्यूरल हियरिंग लॉस हो। पहले आपको ये चीज देखनी कि सेंसोन्यूरल हियरिंग लॉस है या नहीं है। राइट, ओके, तो इसका आंसर क्या हो गया हमारा? ऑटोस्क्लेरोसिस। चलिए नेक्स्ट क्वेश्चन पे बढ़ते हैं। फॉलोइंग द पेरिटिड सर्जरी द पेशेंट प्रेजेंट्स विद फेशियल एसिमेट्री। राइट, फेशियल पैल्सी है पेशेंट को, पेरिटिड सर्जरी हो गई। ड्रिबलिंग ऑफ सलाइवा, ड्रूपिंग ऑफ एंगल ऑफ माउथ ऑन वन साइड। सो टिपिकल फेशियल सिमेट्री एसिमेट्री है, फेशियल पैल्सी है पूरी की पूरी। विच आर द फॉलोइंग इज नॉट ट्रू अबाउट दिस कंडीशन। ठीक है, तो क्या देखना है? फॉल्स ढूंढना है भाई, ट्रू नहीं ढूंढना है। ट्रू से मत यहाँ पे कंफ्यूज हो जाना, ये इंपॉर्टेंट है, इसको दिमाग में बिठा लिया करो, ये वाली मिस्टेक्स नहीं करनी है। ठीक है जी, राइट, ओके। मोस्ट कॉमन लाइकली कॉज ऑफ दिस कंडीशन इज आइट्रोजेनिक ट्रॉमा टू फेशियल नर्व ड्यूरिंग पेरिटोडेक्टमी। तो ये तो ट्रू स्टेटमेंट लग रहा है। ठीक है, इंजरी होगी पेरिटोडेक्टमी करते हुए फेशियल नर्व को, बड़े कॉमन है। अगर पेरिटिड सर्जरी आप कर रहे हैं तो उसमें उसके अंदर इंजरी हो सकती है। ओके, मोस्ट कॉमन आइट्रोजेनिक कॉज ऑफ फेशियल पैल्सी इज पेरिटिड सर्जरी। ये गलत स्टेटमेंट है। क्यों? मोस्ट कॉमन आइट्रोजेनिक कॉज ऑफ फेशियल पैल्सी इज नॉट पेरिटिड सर्जरी, दैट इज मैस्टोइडेक्टमी। आइट्रोजेनिक कॉज ऑफ फेशियल पैल्सी मोस्ट कॉमन इज मैस्टोइडेक्टमी। ओके, तो ये फॉल्स स्टेटमेंट था। मोस्ट कॉमन कॉज ऑफ फेशियल पैल्सी इज बेल्स पैल्सी। ये ठीक है भाई, ये भी स्टेटमेंट ट्रू स्टेटमेंट। ठीक है, ये भी स्टेटमेंट ट्रू स्टेटमेंट है। अच्छा, और इसके अंदर बताओ भाई, मोस्ट रिलायबल लैंडमार्क फॉर आइडेंटिफिकेशन ऑफ फेशियल नर्व ड्यूरिंग पेरिटोडेक्टमी इज टिम्पैनोमेस्टॉइड सूचर। ये ट्रू है कि गलत है? ये भी ट्रू है। कौन कौन से लैंडमार्क होते हैं पेरिटिड सर्जरी में? तो अगर हम पेरिटिड सर्जरी की बात करेंगे तो फेशियल नर्व लैंडमार्क कौन कौन से हैं बेटा? देखो 5 लैंडमार्क होते हैं। सबसे पहला होता है ट्रेगल पॉइंटर। ओके, राइट, ट्रेगल पॉइंटर नंबर 1 लैंडमार्क, कार्टिलेजिनस पॉइंटर बोलते हैं इसको। ठीक है, नंबर 2 लैंडमार्क क्या हो गया? पोस्टीरियर बेली ऑफ डाइगैस्ट्रिक, राइट। ये दोनों लैंडमार्क कैसे हैं? सॉफ्ट टिश्यू लैंडमार्क है, रिलायबल नहीं है। नंबर 3 लैंडमार्क स्टाइलॉइड प्रोसेस, ये बोनी लैंडमार्क है, रिलायबल है, लेकिन ये होता है मीडियल टू फेशियल नर्व, मतलब यहां तक पहुंच गए तो फेशियल नर्व आपने काट ही दी होगी, राइट। तो ये बोनी जरूर है लेकिन मतलब मीडियल टू फेशियल नर्व है, फेशियल नर्व इसके लेटरल होती है। चौथा होता है टिम्पैनोमेस्टॉइड सूचर, ओके। चौथा क्या हो गया? टिम्पैनोमेस्टॉइड सूचर। तो ये बोनी लैंडमार्क है, फेशियल नर्व इससे 6 to 8 मिलीमीटर आगे होती है, एंड दिस वी कंसिडर एट द बेस्ट लैंडमार्क। लेकिन कभी कभार बिकॉज ऑफ ट्यूमर वी कांट फाइंड एनी ऑफ दीज 4 लैंडमार्क्स, तो हम उल्टा प्रोसेस करते हैं। वी फर्स्ट फाइंड द पेरिफेरल ब्रांचेस ऑफ फेशियल नर्व एंड देन वी कम बैक। इनफैक्ट मेरी लास्ट 2 सर्जरीज के अंदर जब मैंने पेरोटिड सर्जरी की थी, वन आई डिड few weeks back, 2 weeks back and the one I did last month, तो दोनों सर्जरीज में the tumor was overlying the facial nerve, so any of those landmarks were not visible, so I had to go and dissect the parotid gland till anteriorly and then come back by looking the peripheral branches. So ये पांचों लैंडमार्क हम रेगुलरली यूज करते हैं। बेस्ट लैंडमार्क इज टिम्पैनोमेस्टॉइड सूचर, तो ये भी ट्रू स्टेटमेंट हो गया बेटा। तो फॉल्स स्टेटमेंट कौन सा था? हमने आइडेंटिफाई किया था, ओके। सो दिस इज योर आंसर ओवर हियर। मोस्ट कॉमन हाइड्रोजेनिक कॉज ऑफ फेशियल पैल्सी इज mastoidectomy, it is not parotid surgery, ठीक है जी, राइट। ग्रेडी-नीगो सिंड्रोम इन्वॉल्व विच आर द फॉलोइंग क्रेनियल। तो ग्रेडी-नीगो सिंड्रोम, इसको मैं बोलता हूँ ग्रेड डी सिंड्रोम, क्योंकि इसमें 4 डी होते हैं। कौन कौन से 4 डी? पहला हो गया डिप्लोपिया ऑफ लेटरल गेज, 6 नर्व पैल्सी, ठीक है। और क्या होता है इसमें? और क्या होता है? डिस्चार्ज, लॉन्ग स्टैंडिंग डिस्चार्ज, राइट। और क्या होता है? डीप सीटेड रेट्रो ऑर्बिटल पेन, ओके। किसमें मिलता है ये? पीट्रोसाइटिस में, डीप सीटेड रेट्रो ऑर्बिटल पेन, राइट, ओके, राइट। तो पेन क्यों हो रहा है? पेन हो रहा है बिकॉज ऑफ फिफ्थ नर्व की वजह से पेन हो रहा है, राइट। अच्छा, डिप्लोपिया क्यों होता है? डिप्लोपिया होता है बिकॉज ऑफ सिक्स नर्व की पैल्सी क्यों होती है? 6 नर्व की पैल्सी होती है बिकॉज ऑफ डोरेलोस कैनाल, ठीक है जी। तो आंसर क्या हो गया इसमें? 5th and 6th, दैट इज योर आंसर ओवर हियर इन दिस क्वेश्चन, राइट, ओके। लेट्स गो द नेक्स्ट क्वेश्चन। व्हिच ऑफ द फॉलोइंग डज नॉट फॉर्म द बाउंड्री ऑफ मैकीवन्स ट्रायंगल। तो याद करेंगे बेटा टेम्पोरल बोन का डायग्राम। टेम्पोरल बोन के डायग्राम में ये हो गया हमारा EAC और ये हो गया इसके पीछे मेस्टॉइड। यहाँ से एक जाइगोमेटिक प्रोसेस होता है और ये जाइगोमेटिक प्रोसेस, राइट, ये हमारा टेम्पोरोमैंडिबुलर जॉइंट यहाँ पे, और ये जाइगोमेटिक प्रोसेस प्रोसीड करता है, ऊपर है सुप्रामिएटल क्रेस्ट। क्या प्रोसीड करता है? सुप्रामिएटल क्रेस्ट, जिसको हम बोलते हैं इंफीरियर टेम्पोरल लाइन। याद रखेंगे बच्चे लोग, सुपीरियर टेम्पोरल लाइन इज नॉट इन द टेम्पोरल बोन, इट इज रादर इन द पैराइटल बोन। ये ऊपर बनती है एक लाइन, ओके। सो यहाँ पे हमेशा आपको कंफ्यूज करेंगे बिटवीन द 2 लाइंस, सुपीरियर टेम्पोरल लाइन एंड इंफीरियर टेम्पोरल लाइन। तो हमेशा याद रखेंगे कि सुपीरियर टेम्पोरल लाइन इट डज नॉट फॉर्म बाउंड्रीज ऑफ मैकीवन ट्रायंगल। मैकीवन ट्रायंगल्स की बाउंड्री देख लेते हैं हम, ओके। तो एक होगी हमारी सुप्रामिएटल क्रेस्ट, ओके, एक होगी पोस्टीरियर सुपीरियर वॉल ऑफ द EAC, और तीसरी हो गई टेंजेंट ड्रॉन फ्रॉम द पोस्टीरियर वॉल लाइक दिस, ओके। तो इन तीनों के बीच में यहाँ पे हमारा आ गया सुप्रामिएटल ट्रायंगल या मैकीवन्स ट्रायंगल। दिस इज द लैंडमार्क फॉर मेस्टॉइड एंट्रम, ओके। सो सर्जिकल लैंडमार्क फॉर मेस्टॉइड एंट्रम इज मैकीवन्स ट्रायंगल, और ये डेफिनेटली बाउंड्रीज की नहीं है, राइट बेटा लोग, ठीक है। आगे बढ़े, चलिए लास्ट क्वेश्चन पे आते हैं। आई थिंक दिस इज द लास्ट क्वेश्चन फॉर ENT। सो स्टेपिस इज राइट फ्रॉम विच फेरेंजियल आर्च। तो ये हमने क्वेश्चन पढ़ा हुआ है, कई बार पढ़ा हुआ है कि फर्स्ट आर्च यानी कि मैंडिबुलर आर्च से क्या बनता है? मैकल्स कार्टिलेज, और मैकल्स कार्टिलेज से बनता है मैलियस एंड इनकस। और सेकेंड आर्च यानी कि हायोड आर्च, इससे बनता है हमारा रिकट्स कार्टिलेज, और रिकट्स कार्टिलेज से बनता है स्टेपिस। सो जब मैं स्टेपिस की बात करता हूं तो मैं बात करूंगा स्टेपिस सुप्रा स्ट्रक्चर की, ओके। रिमेंबर फुट प्लेट स्पेशली कौन सा सरफेस, मीडियल सरफेस of stapes foot plate. This forms from otic capsule. Okay, so this forms from otic capsule. Just remember that, right? Okay, so these were the ENT questions that were asked today, right? तो आंसर क्या हो गया इसका? इसका आंसर हो गया सेकंड आर्च. ठीक है बेटा. सो कपिल, प्रवीण, योगी जी, Apurva, Himanshu, Mayank, कोई क्वेश्चन, any question that you want to ask, I'll be happy to answer them, right? Shall we? कुछ और पूछना है बेटा? Okay, चलो. So नहीं पूछना है तो all I'll say to you is that these 2 months just stay focused. Okay, right? तो याद रखना है boys, बुलाएगी लेकिन जाने का नहीं. फोकस रखना है. उसको बोलना 2 महीने बाद आके मिलूंगा तुझसे. अभी सिर्फ और सिर्फ एक ही फोकस है मेरा, वो है एग्जाम. ठीक है, राइट? ओके, चलो. थैंक यू सो मच. कीप स्टडिंग. बेस्ट ऑफ लक.
गुड इवनिंग फ्रेंड्स, होप यू आर डूइंग वेल. एग्ज़ाम अच्छा हुआ होगा. तो पहला मैसेज तो मैं ये कन्वे करूँगा कि यदि एग्ज़ाम में तुमने जो भी अटैम्प्ट किया है, तुम्हें लगे कि यार क्वेश्चन नहीं आते थे, डिफ़िकल्ट थे, तो टेंशन नहीं लेने का. ठीक है, क्योंकि यू नेवर नो कि एग्ज़ाम में क्या पैटर्न आने वाला है. ओके, और कितनी तुम्हारी प्रिपरेशन है, इससे इवेलुएट मत करना, क्योंकि प्रिपरेशन लेवल तुम्हारा बहुत हाई है, ये मान के चलेंगे. हाय अपूर्वा. तो ये मान के चलना है कि हमारा प्रिपरेशन लेवल बहुत हाई है, हमने हार्ड वर्क किया है. व्हेन एवर यू डू हार्ड वर्क इट इज़ पेड सूनर और लेटर. ओके, तो वी स्टार्ट. वेरी गुड इवनिंग ऑल द गजेंद्र. पहला क्वेश्चन बड़ा कॉमन क्वेश्चन है. विजुअल हेलुसिनेशन, ऑर्गेनिसिटी. विजुअल हेलुसिनेशन सजेस्ट ऑर्गेनिसिटी. रिसेंटली आस्क्ड क्वेश्चन इन जनवरी 23 FMG. विजुअल हेलुसिनेशन कहाँ कहाँ हो सकता है? LSD, लव सेक्स और धोखा, ये सब हेलुसिनेशन ही है, विजुअल हेलुसिनेशन. ओके, सिजोफ्रेनिया को हम फंक्शनल डिसऑर्डर कहते हैं, अभी डिस्कस करेंगे. फॉर द टाइम बीइंग इन दोनों को मैंने हटा दिया. टेम्पोरल लोब एपिलेप्सी यूजुअली प्रेजेंट विद फॉर्म्ड विजुअल hallucination. Okay, Lewy body dementia, recently asked question in INICT, visual hallucination, बड़ा कॉमन है. तो आंसर क्या हो गया? प्लीज डू रिप्लाई. कहाँ कहाँ मैंने विजुअल हेलुसिनेशन कहा है? LSD, यस, टेम्पोरल लोब एपिलेप्सी, लेवी बॉडी डिमेंशिया, तीनों पे क्वेश्चन आ चुका है. सिजोफ्रेनिया की बात करें, सिंपल सिजोफ्रेनिया पे क्वेश्चन आता है. इसमें ओनली एंड ओनली नेगेटिव सिम्टम्स होते हैं. क्या कहा मैंने? ओनली नेगेटिव सिम्टम. हेलुसिनेशन क्या है? हेलुसिनेशन डिल्यूजन आर पॉजिटिव सिम्टम्स. दीज आर पॉजिटिव सिम्टम्स, तो यानी कि सिंपल सिजोफ्रेनिया में तो हेलुसिनेशन होते ही नहीं है, तो विजुअल और ऑडिटरी की तो बात ही नहीं। सो सिजोफ्रेनिया फंक्शनल डिसऑर्डर है, यूजुअली इसमें ऑडिटरी हेलुसिनेशन होते हैं, रेजिडुअल हो या अदर सिजोफ्रेनिया हो। रेजिडुअल का मतलब क्या है, पहले बहुत सारे सिम्टम्स थे, अब रेजिडुअल सिम्टम्स बच गए, कुछ सिम्टम्स बच गए हैं, मेजर जो पॉजिटिव सिम्टम्स आर गॉन, नेगेटिव सिम्टम्स कुछ बचे हुए हैं। तो रेजिडुअल सिजोफ्रेनिया, सिंपल सिजोफ्रेनिया में यूजुअली हेलुसिनेशन रेयर होते हैं, और यदि होंगे भी रेजिडुअल में तो ऑडिटरी हेलुसिनेशन होंगे। सो आंसर इज ए, करेक्ट। सेकंड, ये बड़ा इंपॉर्टेंट टॉपिक है, हमेशा एक क्वेश्चन आता है, कैसे याद रखना है। DSM 5 ने कहा ये 5 सिम्टम्स हैं, मैं इसको डिटेल में डिस्कस करूंगा फॉर द टाइम बिंग। 5 सिम्टम्स हैं, इन 5 सिम्टम में एक बार देख लेते हैं। डिल्यूजन, हेलुसिनेशन, डिसऑर्गेनाइज स्पीच, ओके, फॉर्मल थॉट डिसऑर्डर, कैटाटोनिक बिहेवियर, नेगेटिव सिम्टम्स। इन 5 में से कोई भी 2 सिम्टम्स या 2 से ज्यादा सिम्टम्स हो, डिल्यूजन है, हेलुसिनेशन है, फॉर मोर देन 6 मंथ, मोर देन 6 मंथ्स, डायग्नोसिस इज सिजोफ्रेनिया। वही सिम्टम्स डिल्यूजन, हेलुसिनेशन 1 महीने से, यानी यही सिम्टम्स 1 महीने से 6 महीने तक है, सिजोफ्रेनिफॉर्म डिसऑर्डर। और लेस देन 1 मंथ, ब्रीफ साइकोटिक डिसऑर्डर। सो इन दिस क्वेश्चन 28-year-old वुमेन है, नो हिस्ट्री ऑफ मेंटल इलनेस, पहले कोई मेंटल इलनेस नहीं थी, अब वो बड़ा अजीब सा बिजार बिहेवियर है, बिकमिंग पैरानोइड, मीन्स डिल्यूजन्स आर देयर, हेलुसिनेशंस आर देयर, डिसऑर्गेनाइज्ड स्पीच इज देयर, ओके, means these symptoms fulfill the criteria of schizophrenic or psychotic symptoms. Duration of symptom few days, duration of symptom few days, जहां पे few days आ गया, yes, less than 1 month, तो answer would be brief psychotic disorder. You have given the correct answer, Apurva. Yes, brief psychotic disorder. Clear? और देख लेते हैं इसमें, MSC पे ब्लंट इफेक्ट होता है, ब्लंट इफेक्ट यूजुअली सिजोफ्रेनिया में होता है, साइकोटिक डिसऑर्डर में होता है, इंपेयर जजमेंट साइकोटिक डिसऑर्डर में होता है। तो इन्होंने बहुत सारे सिम्टम्स दिए हैं, द ओनली कैचिंग पॉइंट इज द ड्यूरेशन। ऑप्शन डी को एक बार मैं एक्सप्लोर करूंगा। इन दिस क्वेश्चन देयर इज नो अफेक्टिव डिसऑर्डर, अफेक्टिव मीन्स मूड डिसऑर्डर, नो मूड डिसऑर्डर सिम्टम, means depressive symptoms are not there, manic symptoms are not there. Schizoaffective disorder diagnosis is made when both schizophrenic symptom and affective symptoms are together. Okay, so answer is C. कोई डाउट? Yes, तो इसमें तुम्हें ये याद रखना है, हमेशा क्वेश्चन आता है, कई बार FMG का क्वेश्चन है, they will give the same scenario, point it out. Very, very important. In place of brief psychotic disorder, they will give ATPD. यानी ऑप्शन में they have not given brief psychotic disorder and they gave ATPD. तो आंसर would be ATPD because ICD ने इसका नाम दिया है, ICD 11, 10 दोनों में क्या नाम है, ATPD. FMG का फेवरेट क्वेश्चन हुआ है ये कि they will not give brief psychotic disorder और ATPD. They will give acute psychosis. Then answer would be acute psychosis. तो समझ गए, 3 नाम है, 3 names for the same thing. Okay, either they will give brief psychotic disorder, ATPD or acute psychosis. In this question they have given the name brief psychotic disorder. So definitely answer is C. Clear? Although ATPD is little bit different, but you will remember like this. नेक्स्ट, इस क्वेश्चन को सॉल्व करने से पहले, यस, आई विल डिस्कस एंटी सोशल पर्सनैलिटी डिसऑर्डर, सलमान खान, ही इज नॉट हैविंग बट वी कैन रिमेंबर बाय सलमान खान. अनलॉफुल बिहेवियर, सो मेनी केसेस आर देयर ऑन अ सलमान खान. नो रिगार्ड्स फॉर द राइट ऑफ अदर, यू नो द पर्सन हु स्लीप ऑन फुटपाथ, दे हैव देयर ओन राइट, और उसने वायलेट भी किया था, यू रिमेंबर. लैक फीलिंग ऑफ गिल्ट, काला हिरन मार दिया उसके बाद भी गिल्ट नहीं आया. No empathy, don't learn from past mistake. So many girlfriends left him, but he never learned how to make girlfriends happy. तो लर्न नहीं कर पाता वो। एक्सट्रीम सेंस ऑफ राइट, सब्सटेंस यूज, 18 साल से ज़्यादा है, एंटी सोशल। यदि यही सिम्टम्स लिटिल बिट लेस सीवियरिटी, व्हाट आई सेड, मोर और लेस सेम सिम्टम्स with little bit less severity and below the 18 years, yes, conduct disorder, बच्चों में होगा conduct disorder, disregard for the right of others, bullying, lying, stealing, truancy from school, school bunk कर देते हैं, dissocial behavior, okay? कई बार होगा तुम्हें ऐसा मिलेगा कि बच्चा इतना शरारती है, पेरेंट्स आएंगे कहेंगे डॉक्टर साहब परेशान कर रखा है, छोटे जो जानवर होते हैं उन्हें बड़ा टॉर्चर करता है। कल की बात लो, एक पपी था, उसकी पूंछ में धागा बांध दिया, बम फोड़ दिया। तो these types of these children are there and they have conduct disorder. Okay, so this is conduct disorder. In this question 13 साल का बच्चा है, यानी कि एंटी सोशल पर्सनैलिटी के लिए एज कितनी होनी चाहिए? 18। ये तो नहीं हो सकता। Brought to child psychiatry by his parents. Parents report that child frequently lies, bully, yes, misbehave teacher, bully करता है, ठीक है। सिंपल डायग्नोसिस क्या बन गई? कंडक्ट डिसऑर्डर। तो आंसर इज कंडक्ट डिसऑर्डर। क्लियर? व्हाट अबाउट द अदर ऑप्शंस? अपोजिशनल डिफिएंट डिसऑर्डर, नेम इटसेल्फ टेल्स यू। अपोजिशनल डिफिएंट डिसऑर्डर मींस चाइल्ड डू एग्जैक्टली अपोजिट व्हाट इज बीइंग टोल्ड। पेरेंट्स ने कहा बेटा डोंट डिस्टर्ब योर यंगर ब्रदर, yes, father immediately slapped yes, the children immediately slapped younger children. Okay, so oppositional defiant disorder, do exactly opposite defy order, that is oppositional defiant disorder. तो ये disruptive behavior disorder के पार्ट हैं दोनों, याद रखना। क्वेश्चन हैज बीन आस्क रिसेंटली। तो कंडक्ट डिसऑर्डर आंसर हो गया, अपोजिशनल डिफिएंट डिसऑर्डर बता दिया मैंने। ADHD, कंडक्ट डिसऑर्डर की डिफरेंशियल डायग्नोसिस ADHD होती है। पॉइंट इट आउट, द डिफरेंशियल डायग्नोसिस ऑफ कंडक्ट डिसऑर्डर इज ADHD। लेट मी टेल यू, yes, in attention deficit hyperactivity disorder, patient has inattention, means will not give attention, so make frequent mistakes. Hyperactivity will not remain seated at one place, will roam around in the class. Okay, impulsivity, yes, don't wait for their turn, blurt out answer before completion of question. And the age criteria now 12 years. Okay, previously it was 7 years, but now it is 12 years, recently asked question. So in this answer is conduct disorder, very very clear answer. Now middle-aged woman with known case of schizophrenia. Schizophrenia, extrapyramidal symptoms by antipsychotic is a very important topic. For last 3 years, every exam is having question. If a schizophrenic patient, you are giving antipsychotic, may develop extrapyramidal symptom, you will remember first extrapyramidal symptom, acute muscle dystonia, you gave haloperidol, antipsychotic in the morning, in evening patient came with twisted neck or uprolling of eyeball. This recently asked question. Uprolling of eyeball, yes, no need to worry, you gave injection promethazine, methazine or benchtropine. Yes. Akathisia, patient is unable to remain seated at one place, he is having restlessness, subjective and objective restlessness. Treatment, no need to worry, give beta blocker. Drug induced Parkinsonism, tremors, rigidity, bradycardia, now tardive dyskinesia. You must have seen old person without teeth, they do like this, means old person without teeth, that is tardive dyskinesia or chorioathetoid movements. Yes, if a young person is doing like this on antipsychotic for 15 years, now he is doing, he is bank manager, every day he is bitten because whenever a lady comes, he do like this. So very disturbing, this is tardive dyskinesia. In this question, for 20 years patient is taking antipsychotic. Yes, persistent lip smacking, grimacing, rapid eye blinking. What is the drug of choice? This is tardive dyskinesia. And in tardive dyskinesia, drug is valbenazine or tetrabenazine. Yes, these question has been asked. Recently, valbenazine has been approved. Propanol, akathisia, I have just discussed. Dantrolene for neurolapt malignant syndrome. Yes, drug of choice for neurolapt malignant syndrome. So all are question. So very good. Answer is valbenazine. Good. Now, the last question. 30-year-old man. Yes, many times you will find a long clinical question, and in last you will find that only the catching point is last line. If I say in this, which of the following is incorrect statement about cocaine abuse? Yes, let me discuss cocaine as Coca-Cola. If you take Coca-Cola regularly, your tongue would be jet black tongue. Okay, Coca ni tera Coca. If you wear Coca at nasal septum, nasal septal perforation. Cockroach means if you are taking cocaine, you will feel that cockroach or insects are crawling under the skin or over the skin. That is tactile hallucination. So these are common features. Cocaine inhibit reuptake. Suppose this is synapse. It inhibit reuptake of norepinephrine and dopamine. So when norepinephrine and dopamine reuptake is inhibited, both are increased. If dopamine is increased, question is asked that in schizophrenia dopamine increases and it causes positive symptoms, delusion and hallucination. Delusion and hallucination due to increased dopamine. Norepinephrine increases, cause vasoconstriction. When vasoconstriction occur, yes, coronary artery, myocardial infarction. Vasoconstriction, if you are snorting cocaine again, vasoconstriction of nasal septum, necrosis, perforation, nasal septal perforation. Clear? Vasoconstriction is there. That's why it is used in those surgery which is highly prone to for bleeding. Just like ENT surgery, we can use cocaine as anesthetic agent. So also used as anesthetic agent, true. Cocaine is associated with flashback phenomena. No, flashback is commonly seen with, yes, please do reply, cannabis and LSD. This is question. Formication, delusion of persecution are seen together in cocaine psychosis. I told you, yes, delusion and hallucination, delusion of persecution and hallucination, tactile hallucination seen with cocaine. Yes, this tactile hallucination, other name is formication or Magnon phenomena. Magnon phenomena. Both are question, recently asked question. So this is true. Blocks reuptake of dopamine and norepinephrine. This is also true. So answer is B. Okay. So now you can read all these things. Again I repeat, many times you will find long clinical question. Don't afraid of those long clinical question. Sometimes on the last line will help you. So many times we say read the options, and in last line if a very long question is there and you are short of time, if you have sufficient time, definitely you will read the whole question, but many times you will encounter these types of questions. And yes, all questions has been discussed. Now the last message I want to convey is that be positive. Whatever hard work you have done will be paid sooner or later. So with your positive approach, you can crack this exam very easily. So stay tuned. Now Dr. Sushant is coming for pathology. Thank you and best of luck.
Okay, so hi, evening friends, evening everybody, bache, evening everybody. I know we conducted the paper today and we are getting a very mixed response with respect to the paper. About 50% students are very well satisfied ki we were able to do the paper acha tha, we were well prepared. About 20-25% students found the paper to be slightly tougher. But frankly speaking, this is the kind of paper that we expect to come in the FMG exam. So whether, it's a very sincere request from my side for the students who have not given the paper, please go to the LN Next app, give the paper first. I want all of you to give the paper, to commit to the answer before seeing the discussion and then have a look at the discussion. This is the ideal way to go about this. Now, talking with respect to pathology as usual, the path questions were simple, straightforward. It is always going to give you a buffer. So hi friends, hi everybody bache. So let's start with one of our first questions and examiner's favorite, that is kidney. Now in kidney, a patient has been diagnosed as solid cancer of the bowel. He experienced massive proteinuria after a few months of initial diagnosis. That means the patient is a known case of carcinoma urinary bladder, now presenting with nephrotic syndrome. So which is the most common nephrotic syndrome in a case of known case of carcinomas? That is MGN, membranous glomerulonephritis. फटाफट से देखते हैं. There are 4 primary nephrotic syndromes, that is MCD, minimal change disease, MGN, membranous glomerulonephritis, MGN, MPGN, membranoproliferative glomerulonephritis, and FSGS, focal segmental glomerulosclerosis. Starting with MCD, it is the most common. This slide that we are making, you always get 2 to 3 questions from kidney in your FMGE exam. This will serve as your fundamental basic slide. Minimal change disease, that is MCD, it is the most common nephrotic syndrome in children. अगर बच्चों में हो रहा है, if it is occurring in children, let us have a soft heart for kids. So good prognosis, poor prognosis, good prognosis. That means it is steroid responsive in nature. Next, minimal change. So light microscopy is normal or unremarkable, whereas the diagnostic hallmark is electron microscopy, which shows diffuse effacement of foot processes of podocytes. Diffuse effacement of foot processes of podocytes. This is MCD, minimal change disease, MCD. Your previous 2 recent FMG exam questions, any child with nephrotic syndrome, diagnosis MCD, steroid responsive. Next, MGN, membranous glomerulonephritis, that is MGN. It is the most common nephrotic syndrome associated with hepatitis B virus, associated with syphilis, and associated with malignancies. MGN, membranous glomerulonephritis. This was the question. Known case of carcinoma bladder, now presenting with nephrotic syndrome. Diagnosis MGN. MPGN, membranoproliferative glomerulonephritis. MPGN. Think of Kolkata, think of MPGN. MPGN on electron microscopy has the classical double contour or the tram track appearance. Double contour or tram track appearance. This is MPGN, arising due to splitting of the basement membrane. So our 3 primary nephrotic syndromes, MCD, MGN, MPGN. And lastly is FSGS, focal segmental glomerulosclerosis, which is occurring due to reduction in renal mass. For whatever reason, there is a reduction in renal mass. This in turn leads to FSGS. It is the most common nephrotic syndrome associated with HIV. And the nephrotic syndrome with HIV has a special name to it called as collapsing glomerulopathy. Called as collapsing glomerulopathy. Easy to remember. The patient went to have some fun, but his whole world collapsed around him. So collapsing glomerulopathy is associated with HIV, seen in FSGS. Next couple totally agreed. The stain of choice in a renal biopsy is pass. If I have to use one stain in a renal biopsy, The stain of choice is pass, that is periodic acid Schiff. So this was with respect to our first question. Massive proteinuria with, in a known case of malignancy, MGN, membranous glomerulonephritis. Next point. This gets us to a second question. I want you to tell me this. A young female presented to OPD with swelling in the neck. She had a history of exposure to radiation earlier. Now the examiner has already told you that it is carcinoma thyroid along with orphan NEI nucleus. The examiner has told you everything. I need not even magnify on the image here. Orphan NEI nucleus, it shows the presence of a large clear nucleus, but it does not matter. We always go for the most common malignancy in our exams. Suppose it is a case of young male with orchidectomy. I want all of you to tell these answers. Fair enough, this is a plain simple answer, PTC, papillary carcinoma thyroid, diagnostic hallmark, orphan NEI nucleus. Keep on telling me the answers in the chat box. Young male with orchidectomy, which is the most common tumor? Seminoma. Young female with oophorectomy, which is the most common tumor of seen in young female in ovaries? Teratoma. Next, young male presenting with a CNS tumor. Which is the most common primary CNS tumor? All these are recent questions. The examiner gave you a history of epilepsy with headache with a frontal mass. Diagnosis, meningioma. Thyroid tumor, diagnosis, papillary carcinoma thyroid. So if I have to write it on the side, if it is a case of CNS, if it is a central nervous system tumor, if it is a case of CNS, our answer is meningioma. Young male with testicular tumor, seminoma versus female, that is teratoma. We always go for most common. Coming to thyroid questions. Which thyroid tumor is associated with amyloid deposition? Amyloid deposition, medullary carcinoma thyroid. Which protein is getting deposited? ACAL, amyloid calcitonin, ACAL. Next, this gets us to the next one. Young male presented with the following finding after a trivial fall. Lab investigations are given. Platelet count is normal. Normal platelet count is 1.5 to 4 lakh per microliter. Platelet count is normal. BT is okay. PT is normal. PTTK is increased. Diagnosis. Now, in this question, again the image itself is a spotter. Where is the bleeding taking place? I am able to appreciate a deep thigh or a deep knee joint bleeding, that is hemarthrosis. This is hemarthrosis, which is associated with hemophilias. Perfect. It can be a case of either hemophilia A or B occurring due to deficiency of coagulation factors 8 and 9. Which occurs due to deficiency of coagulation factors 8 and 9. Hemophilia. Perfect. Hemarthrosis, hemophilia. Next, PTTK is prolonged in extrinsic pathway. So another commonly asked question is the secondary hemostatic plaque formation. Let's quickly have a look at this. There are two pathways, intrinsic and the extrinsic pathway of coagulation. Extrinsic pathway begins from tissue factor. It begins from tissue factor, which in turn activates factor 7 and goes to the common pathway. What is common pathway? The first step is factor 10 to 10A conversion, that is activated form of factor 10, which needs three things: calcium, phospholipids. It needs three things, that is calcium, phospholipids and factor 5. Activated form of factor 10 converts prothrombin to thrombin, which in turn converts fibrinogen to fibrin, which in turn converts fibrinogen to fibrin. This is extrinsic plus common pathway versus the intrinsic pathway, which begins from factor 12, goes to factor 11, 9, 8 and common pathway. This is the intrinsic pathway. Extrinsic pathway is evaluated by PT, that is prothrombin time, versus intrinsic pathway, which is evaluated by PTTK or APTT. what is the normal PT? I want you to tell me this. But what is the normal prothrombin time? Normal PT, that is 14 to 16 seconds versus normal PTTK 24 to 36 seconds. This is secondary hemostatic plaque formation. An important slide, which coagulation factors are involved in intrinsic pathway, which are involved in extrinsic pathway, and so on. In our question, APTT was increased. That means intrinsic pathway was abnormal. It was a deficiency of coagulation factor 8-9 hemophilia. Even the image was a spotter, and so is this slide. Next, diagnosis. Before I speak out the diagnosis, answer bache, answer. A young boy is admitted with fever and polyarthritis with a previous history of streptococcal sore throat. ESR is also increased along with fever. So what is the diagnosis in this case? Answer, diagnosis. We have a child with fever and polyarthritis. The minute the examiner is pointing you towards polyarthritis, migratory polyarthritis, he is taking you towards RHD with a previous history of streptococcal infection. That means even the essential criteria is met. Perfect, perfect, bang on right. Everybody is right in this, Jack, but totally agreed. That is a case of RHD. Acha, before I go further, Jayansh, bache, cause of isolated elevation of PTTK are hemophilia, because in hemophilias factor 8, 9 are deficient. Hemophilia ABC, deficiency of coagulation factors 8, 9, 11, and von Willebrand disease. These are your two main causes. Next, this is the Jones criteria being met, diagnosis RHD. What is happening in RHD? In RHD, the child got the infection, streptococcal infection. Antibodies against M protein of streptococcal infection cross-react with host antigens. The antibodies were supposed to react against something, but they cross-reacted against something else. So the pathogenesis of RHD is molecular mimicry. Pathogenesis is molecular mimicry. It is an antibody-mediated hypersensitivity type 2. So the answer was A, it is type 2 hypersensitivity. Next question. Middle-aged female with chronic fatigue, generalized lymphadenopathy with expression of BCL2. A very, very important slide. What is the likely diagnosis? Now this is a question from blood cancers. Let us have a look at 4 main non-Hodgkin's lymphoma. Let us start with CLL. Chronic lymphocytic lymphoma, follicular lymphoma. We'll have a look at 4, CLL, follicular lymphoma, mantle cell lymphoma, and Burkitt's lymphoma. Now, all these are B cell lymphomas. Which is the pan B cell marker? All these, they are the B cell lymphomas. So, which is the pan B cell marker? That is, it is positive on all the B cells. CD19. That means all 4 lymphomas are CD19 positive. In addition, CLL is CD5 positive, CD23 positive. Whether we know anything else or not, we have to know this. CLL, chronic lymphocytic lymphoma, shows the presence of smudge cells on peripheral smear, firstly. Next, it is CD5 positive, CD23 positive. Follicular lymphoma, it is CD10 positive. It is CD5 negative, CD10 positive. Next, follicular lymphoma, translocation 1418, translocation 1418, protein expression BCL2 versus mantle cell lymphoma, translocation 1114, protein BCL1 and cyclin D1 positive. Extremely important. Perfect, perfect. It is firstly CLL, shows the presence of smudge cells. Secondly, follicular lymphoma, translocation 1418, BCL2. Mantle cell lymphoma, translocation 1114, BCL1 positive and cyclin D1 positive. Next, Burkitt's lymphoma, almost everybody's favorite. Translocation, gene mutation. Translocation 814. This was recent FMGE exam question only. Gene mutation, MIC. MIC is a proto-oncogene. It is MIC proto-oncogene positive. Which MIC? MIC are of three types: CMIC, NMIC, LMIC. CMIC. NMIC is neuroblastoma, LMIC, L small cell carcinoma lung. This is with respect to the B cell NHLs, and as you had very rightly said, BCL2 positive, that is follicular lymphoma. Plain and simple. Totally agreed, Kapil. Totally agreed. Translocation at 14, CMIC. I'm not getting into the fact that a young male presented with rapidly enlarging jaw mass. Diagnosis: Burkitt's lymphoma. Diagnosis: Burkitt's. Agreed. Next question. Now, this was tricky. I'll give you 10 seconds on this question. I want you to commit to this. And we have analyzed what you guys marked in the paper also. Majority of the students went wrong in this question, and I guess with respect to pathology, we had about 14 questions in this exam, mock test, and this was the only question where majority of you went wrong. Rest of the questions in path were simple, straightforward. A 10-year-old child. So first have a look at the age. 10 years. Presented with lytic lesions on X-ray. Hematological and urinary testing, the second the examiner is telling you is that there is no abnormality on urine testing, along with a skull X-ray is given to you. Perfect. Totally agreed. I mean, really thanks for the kind words. So it is a case of Langerhans cell histiocytosis. Now what happened in the paper was, the minute students saw a lytic lesion in the skull, they went for multiple myeloma. What is the classical age group of multiple myeloma? Elderly. Elderly with low back pain, multiple myeloma. In urine examination on protein electrophoresis, it shows the presence of M band. M stands for a monoclonal band. M band. In urine, it is also associated with Bence-Jones proteinuria. Every FMG paper has 2 to 3 questions from multiple myeloma. You know that very well. Now, but in this case, it was a case of LCH. It was a single lytic lesion in the skull. Multiple lytic lesions, multiple myeloma, and this is what multiple myeloma skull X-ray looks like. You are able to see the presence of multiple lesions in the skull, in turn giving it a raindrop appearance. This is multiple myeloma versus this, which was a case of LCH, Langerhans cell histiocytosis. Totally agreed. Multiple myeloma is increased number of plasma cells with Kraft features. That was multiple myeloma. Next question. 47-year-old chronic smoker presented with shortness of breath. Lung biopsy was performed, which is napsin A and TTF1 positive. Now, before I go further, which lung cancer has the strongest association with smoking? When the examiner gives you a history of smoking, in smoking, the strongest association with smoking. Answer bache, small cell carcinoma lung. Small cell carcinoma followed by squamous cell carcinoma. Easy to remember, SM is smoking, strongest association is small cell followed by squamous. But the most common lung malignancy in smokers is squamous cell carcinoma. Why? Because squamous cell carcinoma is so common. It is so common that the most common lung malignancy in smokers, squamous cell carcinoma. Higher association is with small cell, but higher association is small cell, but most common, squamous cell carcinoma. So in this question, examiner gave you history that the patient is a smoker. So on history, he is taking you towards small cell carcinoma or squamous cell carcinoma. But on lung biopsy, it is napsin A and thyroid transcription factor, TTF1 positive, making it as a case of adenocarcinoma. The lung biopsy always takes precedence over the clinical history. Napsin A and thyroid transcription factor 1, these are the tumor markers for adenocarcinoma lung. Which is the tumor marker for small cell carcinoma lung? Small cell carcinoma, it is NSE, neuron specific enolase, NSE positive, and it is associated with which gene mutation? We just saw that, MIC proto-oncogene. Which MIC? CMIC, NMIC, LMIC? L, which is L for lung, Only lung cancer with L in it, small cell carcinoma lung. Everybody, please give me a thumbs up if all of you are comfortable with all the questions that we have done till now. Please give me a thumbs up or like the video if you're comfortable with all the points that we have covered till now. I agree. Actually, Jack, it's a beautiful point that you noticed. The third point that the examiner mentioned was it is seen at periphery. Lung associated, smoking associated carcinomas, they are central in location. Sir say smoking, sir say central. Grossly, the ones associated with smoking are central versus females and non-smokers, that is adenocarcinoma, it is peripheral in location. How does it matter to the clinician whether it is central or peripheral? Taking a biopsy is easier if it is peripheral, so they are better prognosis. Worst prognostic lung cancer, small cell carcinoma. Worst prognostic is small cell. You already know that. Next question. Main pathological finding in Parkinson's diseases. We usually have one CNS based question also in the paper. Parkinson's, which it is associated with accumulation of Lewy bodies. This was this time's NEET PG question also. Easy NEET PG questions, that is NEET PG 2023. Easy NEET PG questions are always asked in your FMGE exam. So I have put it in your FMG paper. Parkinson's, Lewy bodies. Neurofibrillary tangles, that is Alzheimer's disease. Most common cause of dementia in elderly, Alzheimer's disease. Which protein is getting deposited in Alzheimer's in amyloidosis? We have one brain now, A beta. A beta. Which protein is getting deposited? A beta. Next question. What is the pathogenesis behind the structure shown in the image? Now, King Rajbachi, I didn't understand. This is a doubt session. If you have any doubts, I mean, feel comfortable to ask me right now. I mean, you guys know me, I'm extremely friendly. If you have any doubt whatsoever, feel comfortable to ask. Next, now the minute I see this peripheral smear, this is peripheral smear, it shows the presence of RBC with basophilic stippling. What is basophilic stippling? Basophilic stippling, firstly tell me the diseases associated with basophilic stippling. Most common cause of basophilic stippling being lead poisoning. It is associated with lead poisoning, followed by thalassemia and megaloblastic anemia. Basophilic stippling. Next, what are they? They are remnants of rough endoplasmic reticulum. That is, these are basophilic. They are blue in color. Basophilic ribosomal precipitates. They are rough endoplasmic reticulum. RER, rough endoplasmic reticulum. Totally agreed. Most common causes lead poisoning followed by thalassemia and megaloblastic anemia. This was basophilic stippling. They do not contain iron. No. That is Pappenheimer bodies. Couple, that is Pappenheimer bodies. This was basophilic stippling. Next question. Characteristic histological feature of Crohn's diseases. There are two inflammatory bowel diseases. There are two IBDs, that is Crohn's disease versus ulcerative colitis. These two, they are opposite of each other. Crohn's disease, it can involve anything from esophagus to colon, but rectum is spared. It shows the presence of skip lesions. Skip lesions means we have affected normal, in turn giving it what is the classical appearance called as? In turn giving it the classical cobblestone mucosa appearance. Cobblestone mucosa. Lastly, most common site of Crohn's disease involvement is ileum. Rectum is spared. Versus ulcerative colitis, which has a continuous involvement. In ulcerative colitis, there is continuous involvement. There were skip lesions in Crohn's, continuous involvement in ulcerative colitis, and in this, rectum is always involved. So think of it yourself. Rectum is always involved. It is a continuous involvement. So descending colon, transverse colon, ascending colon. It is involved continuously, in turn leading to toxic megacolon. Peristalsis is affected, so it causes megacolon, toxic megacolon, and lead pipe appearance radiologically. This is gross. Crohn's versus ulcerative colitis. This is gross. Microscopically, Crohn's disease is associated with transmural inflammation. It involves all the layers: transmural inflammation, serositis, and granuloma formation. It is associated with transmural inflammation, serositis, and granulomas. Versus ulcerative colitis, which microscopically shows the presence of pseudopolyps. Again, important hai bache. This term is again asked. Pseudopolyps are a feature of ulcerative colitis versus transmural inflammation with granuloma formation, Crohn's disease. So the answer was C. The answer was C. Next, again a question on vasculitis. Answer: a 45-year-old female presented with sinusitis, asthma, and peripheral neuropathy, along with eosinophilia. There were presence of eosinophils. All 4 options are on vasculitis. Which vasculitis has eosinophilia? Chug-Strauss syndrome. That is Chug-Strauss. Easy to remember. Chug-Chug is coughing. Coughing is asthma. So asthma is associated with eosinophilia, Chug-Strauss syndrome. Next question. Vasculitis with strongest association with smoking? Keep on telling me the answers. Vasculitis with strongest association with smoking. Which are the vessels affected in smoking? The peripheral vessels, tibial and the radial vessels. That is, it is also associated with intermittent claudication, tau, thromboangiitis obliterans, or Buerger's disease. Next question. Elderly, let's have a look at 4 questions of vasculitis. Elderly with thick palpable temporal artery involvement. We have an elderly with thick palpable temporal artery involvement, also associated with sudden blindness. Diagnosis: giant cell arteritis. Diagnosis: giant cell arteritis. And lastly, young male presenting to the OPD with feeble femoral pulses. Diagnosis: that is the pulseless syndrome. Tug are the pulses. Pulseless syndrome, that is Takayasu syndrome. Tug are the pulses, that is Takayasu. So 4 vasculitis. Chug-Chug is coughing, asthma, eosinophilia. Chug-Strauss. Thromboangiitis obliterans or Buerger's disease, that is smoking, intermittent claudication. Feeble femoral pulses, Takayasu syndrome. Next question. Which of the following is characteristic feature of reversible cell injury? So first tell me, which is the first organelle affected in reversible cell injury? First organelle affected, mitochondria. First organelle, mitochondria. So the first biochemical feature of reversible cell injury, reduced ATP. First biochemical, what is the role of mitochondria? It is the powerhouse of the cell, reduced ATP. First microscopic feature of cell injury, reduced ATP leads to reduced sodium potassium ATPase pump. That is, there is influx of sodium and water leading to cellular swelling. Which is seen as swelling of the cytoplasm. All these are the first mistakes. देखो पहली गलती तो सबकी माफ होती है ना. All these are the first mistakes, so they are reversible in nature. Swelling of the cytoplasm, reversible cell injury. Plain and simple. Lastly, we have already taken care of this question. Elderly male presented with chronic renal failure who is undergoing dialysis and is associated with amyloidosis. Which amyloidosis is associated with chronic renal failure? We have 2 kidneys, that is until we have not purchased an iPhone, we have 2 kidneys. So which is the protein associated? Beta 2 microglobulin. AA is secondary amyloidosis. Most common cause of secondary amyloidosis being rheumatoid arthritis. AA. Primary amyloidosis, AL, amyloid light chain associated with multiple myeloma. Secondary amyloidosis, AA. Next, A beta, that is Alzheimer's disease. We have already seen that. A beta, Alzheimer's. Transthyretin, systemic senile amyloidosis, or that is A beta. Done, bache. So on this note, I mean, I want to say all of this to all of you from the bottom of my heart. Bestest of luck. Do the paper well. Don't worry about anything. You guys know your stuff. Plus, as such, with respect to pathology, pathology is always going to give you a buffer. You will be marking more than 50% answers right very comfortably in path. You're going to have a simple paper. So don't worry about it. Everything will turn out well. And we are in this together. Thank you, and take care. Hello all of you, welcome. So today we'll be discussing various important questions. The first one being the 7-month-old child presented to the OPD with complaint of symmetrical eczematous vesicular plaques with characteristic crusting at the edges. Now they are saying that these lesions are particularly over hand, feet and mouth, and the mother revealed that the baby had been recently weaned off breastfeeding. The baby has also been experiencing diarrhea, anemia, poor weight gain. What is the likely diagnosis? The lesions are eczematous vesicular plaques with crusting at the edges. Now, if you see this image, what you can see that the lesions which are erythematous and scaly, and they are present where? Perioral area, isn't it? What is perioral area? That is around lips, around the mouth. These lesions are present, okay? And these lesions are present over which areas? Hand and feet. Do you know what we call hand and feet together? These are acral areas, isn't it? Acral parts. What are acral parts? Palm and sole, hand and feet. These are acral areas. And do you know any condition which starts with acral? Yes, it is acrodermatitis enteropathica. From the name itself, it is very clear that acral parts are involved. So acral parts are involved, that is hand feet involvement. Along with hand and feet involvement, there is also involvement of perioral area, like you can see in the images, and these patients can also present with perianal area involvement. So perianal. So these are the common sites. Now another word after acro is dermatitis. What is dermatitis? Derma means skin and itis means inflammation. So there is inflammation of the skin, and whenever there is inflammation of the skin, what happens? The skin becomes red in color. So that's why these are red lesions. As you can see, these are erythematous or eczematous lesions. And entero means gut. Okay, so there is one finding associated with gut, and that is diarrhea. So you can see diarrhea is also present. So entero, that is gut involvement, is also present. So just from the name of the disease, you can make out all the clinical features which are seen. That is, acral part is involved. What is seen over acral part? Dermatitis, that is redness, and along with acral part, perioral and perianal areas are also involved, and there is also diarrhea associated. And because this is very common in pediatric age group, these patients can present with diarrhea, anemia, and poor weight gain. Now, this is one condition which occurs due to zinc deficiency. So you can very easily remember the clinical features of this condition, and this is due to zinc deficiency, acrodermatitis enteropathica. Let us move on to the next question. Here you can see again a long clinical question is mentioned, and there are so many clinical findings which are there. They are saying that 24-year-old uncircumcised male developed painful ulcers. Which type of ulcers? Painful ulcers. If you remember, I told you that whenever you are approaching a case of sexually transmitted infection, what happens? You should look for whether the lesions are painful or painless. Okay, and painful conditions are only two, and that is herpes and chancroid. So just from knowing this point, that is the ulcers are painful, it is either herpes or it is chancroid. Okay, so just from the first line you can make out the answer. But still, let us read this question. Over the prepuce and the glans, so patient is suffering from painful genital ulcers 5 days after the sexual intercourse. So there is history of contact with a professional sex worker. On examination, the patient has multiple, so lesions are multiple, not single, so multiple painful non-indurated ulcers with undermined edges. Undermined edges, such an important point. Undermined edges are seen in very few conditions, and these conditions are, yes, so undermined edges are seen in chancroid. They are also seen in tuberculosis, and they are also seen in pyoderma gangrenosum. Pyoderma gangrenosum. So these are three conditions, and as soon as you read that the lesions were having undermined edges, always remember these three conditions. It can be due to chancroid, it can be due to tuberculosis, or it can be due to pyoderma gangrenosum. Along with painful and suppurative adjacent inguinal lymph nodes, what is the most likely bedside test and to diagnose this condition? So from the diagnosis point of view, what is the diagnosis? So you know that the clinical features are all suggestive of which condition? Yes, chancroid. And which bedside test we can do? Chancroid is caused by Haemophilus ducrei, and Haemophilus ducrei, when we do gram staining, they are present in parallel rows or chains, that is school of fish appearance. So gram staining will be done. Okay, so yes, so Mirmoy Dhar, he has given the correct answer here, that is A, gram staining. And why gram staining? I told you that chancroid presents with such type of characteristic ulcers which can be multiple, painful, with undermined edges. Undermined edges. So undermined edges are seen, and it is caused by Haemophilus ducrei, so which gives school of fish or railroad track appearance. This is very characteristic, and when you want to see this, you should do gram staining. Okay. One thing more I want to tell you here, that whenever you encounter a question of sexually transmitted infection or genital ulcers, always look for pain. If the lesions are painful, then, so if the lesions are painful, then think of herpes and chancroid, because here the lesions are painful, while painless lesions can be seen in syphilis, LGV and donovenosis. Okay, so that's why the answer here is chancroid, because chancroid can be identified by gram staining. Dark ground microscopy is done for syphilis, but why the answer is not this? Because the ulcers are painful. Painless lesions are seen in syphilis. Then PCR can be done. Culture from the ulcer. Culture is generally done when we have, like we commonly do Thermartin for gonorrhea, but gonorrhea don't present with genital ulcer, they generally present with urethral discharge. Okay, so all these are the mechanisms, but here because it is chancroid, we will do gram staining. Moving on to the next question. 45-year-old man presents with fever, red swollen areas on the right cheek. So over the right cheek, this swollen area is present. On examination, the area is tender, warm to touch. So they are talking about inflammation. Tender, that is painful, warm, so collar, rubber, dubber. So this is very inflamed area. Well demarcated and raised margins. So lesions which are present over cheek, they have raised margins and they are well demarcated, almost feeling like a wall on palpation. Now this is very characteristic of which condition? Yes, there is no obvious abscess of pus. What is the likely causative organism? So they are not asking the diagnosis, they are asking the causative organism. So what is the diagnosis here? Yes, anybody can type in the chat box. What is the diagnosis here? So yes, so diagnosis is erysipelas. Erysipelas. See, sometimes students get confused with cellulitis, because cellulitis can also have lot of inflammation, and here also the skin becomes very painful, tender and warm, and there is hardness, like they are saying that wall-like demarcation. But remember that what is differentiating cellulitis from erysipelas? Always examine the borders of the lesions, and borders are sharp while they are diffuse in cellulitis. So here they have mentioned that they are sharp. So how you know that these are sharp? Because you can see that they are mentioning that the borders, that is the margins, are raised and they are well demarcated. So well demarcated lesions are seen in erysipelas. So erysipelas is caused by group A beta hemolytic streptococcus, and that's why the answer is erysipelas, that is A, group A beta hemolytic streptococcus is the answer here. So here you can see this is a patient suffering from erysipelas, and here you can see this well demarcated border of the lesion which is present over cheek. Now I don't know whether you have read about this or not, but there is one very important sign which is known as Millen ear sign. By just examining the ear of the patient, you can differentiate whether it is erysipelas or cellulitis. How to differentiate? Cellulitis involves deeper subcutaneous tissue which is absent in ear. So that's why in cellulitis ear is spared, but in erysipelas ear can get involved. So when the patient walks to a clinic, just by examining the ear of the patient, you can differentiate whether this patient is having erysipelas or cellulitis. So remember, in cellulitis ear is spared, in erysipelas ear can be involved. So just by examining the ear, you can identify that this is erysipelas or cellulitis. This is known as Millen ear sign. But remember that this is only limited to facial lesions. Okay, so if somebody is having cellulitis over the leg, you are not going to examine the ear of the patient. Okay, so that's why this Millen ear sign, this we see in these cases of erysipelas. Now the next question. In this next question, they are saying 20-year-old man complains of having several smooth, creamy, white to yellow, well demarcated, painless papules and between 1 to 2 mm in size, very small in diameter, where over the lips. Okay, so they are present where? Over the lips. So do you know any condition where over lips these benign, asymptomatic, no lesions are present, though no symptoms are present, they are not painful, they are not itchy, they are smooth and creamy in color, like you can see in this image also, over the lips these creamy color small papular lesions are present. Okay, according to the patient, these papules have been around for a while, so this is persisting for many months and years. What is the diagnosis? Yes, so these are Fordyce spots. Okay, why it is not herpes? Because in herpes vesicles are seen. Which type of vesicles? Grouped, painful. So they are painful, they have symptoms, they are grouped together and they are fluid filled. Okay, molluscum contagiosum, here papules are present, with central umbilication. Here papules are present with central umbilication. They are solid and they are having a central umbilication which is absent here. Fordyce spots is the answer here, while sebaceous hyperplasia generally involves the nose area or the sebaceous area, and there is thickening, and these lesions differ from Fordyce spots. So this is a characteristic picture of Fordyce spots, which are what? They are which type of glands? Ecrine, apocrine or sebaceous? Yes, anybody can tell? Yes, these are what? These are ectopic sebaceous glands. Yes, so these are what? These are ectopic sebaceous glands. Correct. So here again you can see these creamy colored asymptomatic lesions generally present over lips, though there are other sites also where they might be present. Sometimes they might be present over buccal mucosa or in the groin area, but the common site is lips. So these are what? These are Fordyce spots. Can you tell me what is Fox-Fordyce disease? It is disorder of ecrine, apocrine or sebaceous. Yes, so very important question. 3 questions which are commonly asked. Malaria is disorder of, Fox-Fordyce disease is disorder of, and Fordyce spots are disorder of. So remember that malaria is disorder of ecrine sweat gland, Fox-Fordyce disease is disorder of apocrine sweat gland, while Fordyce spots are ectopic sebaceous gland. So don't get confused with Fox-Fordyce. Fox-Fordyce is disorder of apocrine. Malaria is disorder of ecrine sweat glands. Yes, very good. So yes, Parveen Panwar, you have told the correct answer. Yes, Apurva, Jack Sparrow, all of you are correct. It is apocrine. So Fox-Fordyce is apocrine. Now the next question, here they are saying that 45-year-old male patient arrived with an itchy rash on his wrist. So which site is involved? Wrist is involved, and the lesions are itchy. They are also present over ankle. Upon examination, they are flat topped. Yes, what is this suggestive of? Flat topped, that is plain topped, flat topped, shiny papules which are purple in color. So you are getting so many P's here, isn't it? They are plain, they are purple, they are papules, and they are pruritic, that is itchy. So already 4 P's we can see here. Plain, purple, polygonal, pruritic, papules are seen in? Yes. So this is a case of lichen planus. Very obvious because all the options have lichen planus in the answer. Okay, so obviously the answer is lichen planus. Now what they are saying, that these purple hue were seen on the flexural aspect of both the wrist and ankle. On the body parts had no lesions. The patient also revealed that he has been on antihypertensive drugs for past 3 months. Which of the following statement regarding lichen planus is true? So you have to tell the true statement about lichen planus. So this is a patient suffering from lichen planus, and lichen planus cannot affect mucous membrane. This is totally wrong statement. Why? Because we know that in these patients they have a white, lacy or reticulate pattern over buccal mucosa. So mucosa can be involved in lichen planus, and this involvement is commonly in the form of white lacy pattern. Now the second option is lichen planus commonly presents as vesicles over the skin. No, never. It never presents with fluid-filled lesions. Instead, it presents with papules, as it is mentioned in the question. But sometimes these papules become confluent. They come together and form a larger lesion which is known as plaques. So plaques can be seen, papules can be seen, but vesicles are not seen. So this is again a wrong option. Then lichen planus is not associated with itching. Totally wrong, because in the question itself they are saying these are itchy rashes. So it is associated with itching. So this is also a wrong option. The only option left is this one, which is the correct option, that is lichen planus is usually a self-limiting condition. So lichen planus is an autoimmune condition, and sometimes when it is limited to few areas, like here only over the wrist and the ankle, it might self-limit and it might respond automatically. But if the patient is not responding and the disease is progressively increasing, then we have to treat this patient. And because it is autoimmune condition, how we treat this condition? We treat this condition with the help of mainly steroids. So steroids are used in the treatment. These steroids can be given topically. So you can apply over the lesion. You can inject, that is intralesionally, you can inject within the lesion, or you can give oral steroids, that is systemic steroids. There is also role of dapsone in the treatment of this condition. Okay. Here you can see this is the white reticulate pattern over buccal mucosa. Here you can see these are small papules of lichen planus, and when they heal they leave behind pigmentation, and sometimes they show one important phenomena which is mentioned here in this image also. Now who will tell me what is the name of this phenomena? Yes. Let me see, write in the chat box which phenomena you can see here. What is this? Why these lesions are present in linear fashion? Which phenomena? Yes. So who will tell the answer? Yes, it is Koebner's or isomorphic phenomena. This is true Koebner's or isomorphic. Very good, Praveen. So Praveen Parvar, correct. This is true Koebner's phenomena. That is when the patient scratches, multiple lesions start developing along the line of trauma. So this is known as true Koebner's phenomena, which is also seen in psoriasis and vitiligo along with lichen planus. Yes, correct. So Dr. Mukesh, Jayansh, Parveen, everybody have answered this correct. That is true Koebner's phenomena. So this is all from my side. Thank you very much. And now the pediatric questions will be discussed after a short break. Thank you.
Hello friends, good evening. How was your paper? I'm sure it was very easy one. All the questions I feel were very easy, and I'm sure you would have aced the section of pediatrics. So let us start with the first question. A 3-month-old infant is brought to the neonatal follow-up clinic. The infant is put prone on the couch and you observe the following posture as shown in the image. What is the expected age of the baby? So tell me what is the correct answer to this? Anybody? Anyone? Yes, the correct answer to this is 12 weeks. So how do we come to know this is 12 weeks? So if you see a child in the prone position, what is their development in that? So first of all, at 4 weeks, 2 weeks, the child just clears the nose of the couch. Remember that, right? Then 4 weeks, 6 weeks, the child has this thing. It's the pelvis is extended, and then at 8 weeks you should know that the child lifts the head of the couch at an angle of 45 degree. Very, very important. How do you remember this? 8:45, remember that, 8:45. So at 8 weeks the angle made by the face with the couch will be 45 degree. And then at 12 weeks, so this is all we are seeing the development in the prone position. So how does the development takes place? At 12 weeks the child bears weight on the flexed forearms, as we saw in our baby in the question, and then at 6 months the child bears weight on extended forearms. What do you mean by extended forearms? So extended forearms means more or less on the palms. So I'll just show you the pic and then you will understand. So this is, if you see, this is a 8-weeker child, 45 degree angle with the couch. And then we have this, you know, just clearing the face of the couch. So this is around 2 to 4 weeks, right? In fact, and then this is on the flexed forearms, similar to what was shown in the question. So this is 12 weeks. And then we have here on extended arms, right? Extended forearms, basically on the palms the child is, you know, bearing the weight. So this will be around 6 months, right? So this was the question which was asked to you. Then next question is, which of the following is not considered one of the initial steps of resuscitation for a 3 kg baby born limp with meconium stained liquor according to the NRP 2020 guidelines? So NRP 2020 guidelines are the latest guidelines which we are following right now, and remember there are no special recommendations for resuscitating a child born through meconium stained liquor. This should be very clear to you. And now they have asked about the initial steps. So what are the initial steps? Initial steps, if you see, this is the protocol what we follow, the NRP resuscitation algorithm. In this box tells you about the initial steps. Initial steps are the steps carried out by the pediatrician when the baby first comes to us right after the delivery. That is, we may try to maintain the temperature by wiping the amniotic fluid, by keeping the child warm in the preheated towel, and we try to clear the airway by doing the suction, positioning the neck. These are all the initial steps, and while doing the initial steps, the ongoing evaluation continues. And this is the time when we are going to assess the heart rate and the respiratory efforts. Please remember this. Before this, nothing is done. While performing the initial steps, we assess the heart rate and the respiratory effort, and then we see if the child's heart rate is less than 100 or if the child is apneic or gasping, then we move on to our resuscitation protocol. So during initial steps, obviously this is the positive pressure ventilation, this is not done. So this was the answer, that this was the odd one out. Rest all 3 steps are carried out while doing the initial steps of resuscitation protocol, right? Yes, so the correct answer, very good. Mrinmoy Dhar has given the correct answer. Jack Sparrow, Dr. Apurva Shri, good. Yes, the correct answer is option D, right? Okay, then let us move on to the next question, and that is, which of the following is not a criterion used to assess severe acute malnutrition when examining a 2-year-old female child brought by her mother who complains about the child's poor weight gain? So they are asking you the criteria to assess the SAM, that is severe acute malnutrition, right? This is also known as SAM in short form. So what are the criteria? Yes, we know this. The first is the criteria, weight for height below -3 standard deviation. Then presence of bipedal edema is the other criteria. And the third criteria is mid-upper arm circumference below 11.5 centimeters. So very good. Dr. Parveen, Dr. Purva, Dr. Jansh has answered correctly. The option is B. Weight for age is not a criteria for assessing severe acute malnutrition. You should know these are the 3 criteria, and remember these 3 criteria are used to assess malnutrition in a child who is between 6 to 59 months of age. And below 6 months of age, MUAC, that is mid upper arm circumference, is not used as a criteria. We just use the other 2 criteria. So please remember this, that these are the 3 criteria we just discussed. Good going. Okay. Then let us come to the next question. A 1.5-year-old boy presents to the emergency department with bilateral painful hands and feet. On examination, the child has pallor, icterus and splenomegaly. Lab investigations reveal a low hemoglobin level and his peripheral blood film is shown in the image. Which of the following is not true about this case? So what do you think is the clinical scenario fitting in? What are the answers? Anybody? Yes, you are correct. It is sickle cell anemia, and you can see the sickle cells on the, see these are the sickled cells which are seen on the peripheral smear, right? So sickling, this is a case of sickle cell anemia. Now what is wrong in this? That is what they have asked. So it is an example of point mutation where you have the substitution of glutamic acid by valine. Very true. And where is the point mutation? Can somebody answer me this? The point mutation is in the beta globin. Yes, the beta globin chain of hemoglobin at position 6. So at position 6, the glutamic acid is substituted by valine, and this results in formation of a very unstable hemoglobin, and this results in the sickling of the RBCs, right? So, and these sickled RBCs, they go and occlude the microcapillaries, and that results in micro-occlusive vasocrisis. So that is what we are seeing over here. Now let us see the other option. Affected cells have a lifespan of 10 to 20 days due to rapid hemolysis. Very true. The normal lifespan of RBCs we all know is 120 days in a normal human adult. However, in a newborn it is around 90 days. But this is too less a lifespan, and this occurs because of the non-deformability of the RBCs, right? Now the child has vaso-occlusive pain. As I told you, yes, this is a kind of presenting feature. Pain is the presenting feature because the sickled RBCs go and occlude the microcapillaries that can be there in the bones. So usually the long bones like the femur, tibia and the vertebrae, they are also involved, and the short bones of the hand and feet are involved, and that is what the child has actually presented to you. This is known as, anybody? Yes, this is known as dactylitis. So dactylitis is the painful hands and feet that we see because of the vaso-occlusive crisis. Apart from that, vaso-occlusive crisis can also affect the CNS, resulting in strokes, paresthesias, hemiplegia. It can also affect the lungs and hence result in dyspnea, chest pain, breathlessness. It can also affect the corpus cavernosum in a male child, resulting in priapism, right? So these are all the examples of vaso-occlusive crisis resulting in pain, right? Very good. Dr. Apurva is saying dactylitis is seen. Very true, right? Okay, and Mrinmoy has also answered that it is at position 6 of the beta chain. Okay, now let us look at the fourth option. This child requires an exchange transfusion for the current condition. No. So this is the answer for today. Now why this is the answer? So you should know the exchange transfusion is usually required when any of these 4 features exist. And what are these 4 features? Let us see. If the child is having a cerebrovascular accident because of sickle cell anemia, so maybe he is presenting to you with neurological signs and symptoms in the form of paresthesias, hemiplegia, obtunded consciousness. So then you will go for exchange transfusion. How does exchange transfusion help? It decreases the, HbS sickle cell hemoglobin to less than 30%. So that is the aim of exchange transfusion to decrease the sickled hemoglobin to less than 30%, right? So first is CVA. If the child is having acute chest syndrome, that is another example or another indication of going for exchange transfusion. The third indication for going for exchange transfusion is acute sequestration crisis. And what is acute sequestration crisis? When there is sudden increase in the size of the spleen and the child lands up with pallor and sudden loss of consciousness. So this is because of the splenomegaly devouring all of your RBCs. So this is acute sequestration crisis. You have to go for exchange transfusion. And yes, the fourth indication is if the male child lands up with priapism which is not getting okay by adequate analgesics and hydration. You know, the main stay of treatment for sickle cell anemia is, remember always, good hydration and oral analgesics if the child is able to take it, right? Otherwise we give IV analgesics. So hydration and oral analgesics are the mainstay for treatment, and if the priapism is not getting okay by hydration and oral analgesics, then you will go for exchange transfusion. So these are only the 4 indications where you go for exchange transfusion. In rest of the cases, you are not supposed to do anything other than good hydration and oral analgesics. And as we see the question once again, here the child is having dactylitis, so therefore exchange transfusion is not the correct option for this child, right? So yes, the correct answer is the D option in this case. Okay, so now let us come to the next question, and that is, a mother brings her 3-year-old child with fever for 6 days, and on examination you notice a generalized rash on the trunk, redness and swelling of both palms, bilateral conjunctivitis without discharge and tongue as shown in the picture. What is the most probable diagnosis? So tell me students, what is the most correct diagnosis in this case? Anyone? Yes, you are right. The answer is Kawasaki disease, a typical picture of Kawasaki disease. We know there are certain diagnostic criterion of Kawasaki disease. It is a medium vessel vasculitis, and in this what we see is fever lasting for at least 5 days, presence of any 4 of the following 5 conditions, which can be non-purulent conjunctivitis, changes of the mucosa of the pharynx, resulting in infected pharynx or infected lips or strawberry tongue, then changes of the peripheral extremities, that is edema or erythema of the hands or feet. In convalescent stage, it may progress to desquamation, which usually begins perianguli, and then polymorphous rash can be there, but which is never vesicular, that you have to remember, and cervical lymphnopathy, at least one lymph node more than 1.5 centimeter in diameter. And the 6th C thing is that the illness should not be explained by any other known disease process. So considering this, yes, this fits in the diagnostic criteria of Kawasaki disease. Why not HSP? HSP we know again is a vasculitis, but here in HSP we get to see palpable purpura without thrombocytopenia, very importantly, and along with it we have abdominal pain. So let me know, palpable purpura is there, right, and then there is abdominal pain in this, yes, and there is arthritis in this. And of course, renal manifestations can also come up. Renal manifestations in the form of proteinuria, hematuria, and acute nephritis kind of picture. So this is not HSP for sure. Why not scarlet fever? Scarlet fever is caused by, group A beta hemolytic streptococci. Yes, it also has a strawberry tongue, but in scarlet fever we have a rash which feels like a sandpaper kind of, gives a sandpaper kind of feel, right? So that is more of a papular rash in scarlet fever. And why not juvenile dermatomyositis? Juvenile dermatomyositis have many signs, we know this. In this we get to see a shawl sign, mechanic's hand, Gottron's papules. So all these things would be there which are missing in the question, and this question typically fits into that of Kawasaki disease. Another difference between scarlet fever and Kawasaki is that scarlet fever, being of infectious etiology, would respond dramatically to your antibiotics, while in Kawasaki we will not use antibiotics, and in Kawasaki there is involvement of the heart in form of giant coronary artery aneurysms, while that would not be seen in scarlet fever. So yes, these are all the differences, and hence what we see is that here the correct option is the C option, and that is Kawasaki disease, right? Okay, then let us move on to the next question, and the next question is, a newborn female child presents with salt wasting, hypotension and ambiguous genitalia. Remember, it's a female child. Lab investigation reveals low levels of cortisol and aldosterone and elevated levels of testosterone and 17-hydroxyprogesterone. Which of the following enzyme deficiency is most likely the cause of these findings? Now, what do we see over here? We have a child, female child with ambiguous genitalia, and that is female pseudo-hermaphrodite, and this child is now presenting to you with salt wasting and circulatory collapse, right? So this is a classical example of congenital adrenal hyperplasia, and you know that more than in CAH, what is CAH first of all? It is an autosomal recessive disorder of cortisol synthesis. So this, you have to remember this definition, that it is a problem with the cortisol synthesis. It has got nothing to do with aldosterone or the problem with the sex steroid synthesis. Remember, if the aldosterone is increasing or decreasing, or for that matter sex steroids are also increasing or decreasing, they are all part of the collateral damage. The main problem over here is there is a problem with the cortisol synthesis. And if we see the pathway, then 21 hydroxylase deficiency accounts for more than 90% cases of CH. Remember this always. And what do we see in 21 hydroxylase deficiency is there would be deficiency of aldosterone, yes, and there would be deficiency of cortisol, that has to be there, then only it will be classified as CH, and there is increase in the levels of sex steroid. And what are the sex steroids we know of? Yes, we know that as DIA, DHEA and androstenedione. So these two sex steroids are increase in the content. So that is the increased level of these sex steroids are seen, and hence these sex steroids, what do? They cause virilization of the female genitalia, and hence what virilization of the female genitalia, and hence what we see is female pseudo hermaphrodite. So that is what this child has actually presented to us. And what do you mean by female pseudo hermaphrodite is that genetically, genotypically, this child will be XX, no doubt about that. The internal reproductive system will be entirely female type. That means the child will be having ovaries and fallopian tubes and uterus and cervix and vagina, everything. But the outside, the external genitalia would be somewhat malish in character. And what do you mean by that? The external genitalia of this female would be having something, the clitoris would be increased in size, would be hypertrophied, clitoromegaly would be seen, and there could be partial or total fusion of the majora and minora, resembling the formation of scrotum. But of course the scrotum would be empty because this is a female child, so no testis would be seen over here, right? So this is what is female pseudo hermaphrodite, and this occurs because of increased levels of your sex steroids. And because of the deficiency of aldosterone, the child loses salt in their urine, and there is retention of potassium, and hence this is known as salt wasting. And deficiency of cortisol, the child will present to you with hypoglycemia. So this is what is seen, and this is usually the presentation occurs at around second week of life, and these children present to you with features of circulatory collapse. In the females, if you have a look at the genitalia, you will have a idea that probably this is an ambiguous genitalia, somewhere between a male and a female genitalia, and then you will approach this child with cardiovascular collapse in a different way, considering CH in mind. What happens in the male child? In the male newborn is actually born with a normal genitalia, remember that. And hence what happens is that these male newborns, they go undetected, although they will also present with salt wasting and circulatory collapse, but they do not evoke the suspicion of ambiguous genitalia, of congenital adrenal hyperplasia, because their external genitalia are absolutely normal. And therefore, what we see in CAH due to 21-hydroxylase deficiency is mortality is increased in males, right, because they are not diagnosed very easily. Females are caught easily by virtue of ambiguous genitalia. So therefore, in 21-hydroxylase deficiency, mortality is more in males. And what do we do for the treatment? Of course, you have to go for the cortisol replacement, and you also have to go for the aldosterone replacement. So these children are treated by fludrocort and hydrocortisone replacement, and obviously the shock part is treated by fluid resuscitation. And beyond 3 to 4 months of age, the females undergo corrective surgery depending on the degree of virilization of their external genitalia. So this was a classic question telling you about congenital adrenal hyperplasia due to 21-hydroxylase deficiency, right? Yes. So Dr. Mukesh has given the right answer. Yes, Dr. Apurva is also correct, and so are many other people. Mrinmoy Dhar, Dr. Apurva, Shri, Dr. Himanshu, Dr. Mukesh. Yes. Okay, then let us come on. So this is the flow chart, showing you the formation of the different things. And here what we see as per the question is when there is 21-hydroxylase deficiency, so 21-hydroxylase is not working here also not working, and hence your 17-hydroxyprogesterone is going to be high, so is going to be your sex steroids going to be high, and they would ultimately lead to increase in testosterone, and that was what given in the question, right? Okay, then let us move on to the next question. A 1.5 kg baby is born to a hepatitis B positive mother. What is true about the immunization protocol of this case as per IAP guidelines? So do you administer HBIG and hepatitis B vaccine followed by repeat hepatitis B vaccine at 1 month and 6 months, or you administer both HBIG and hepatitis B vaccine at birth and then repeat dose of hepatitis B vaccine at 1 month, 2 months and 6 months, or you go for administer HBIG and hepatitis B vaccine at birth followed by hepatitis B vaccine at 1 month, 2 months and 12 months, or you administer hepatitis B vaccine alone at birth without HBIG followed by hepatitis B vaccine at 1 month, 2 months and 6 months. So what is the correct answer here? Children, batao. I am waiting for your answer. Yes, the correct answer over here is the B option. Now let us see how do you approach a child. Yes, many children have given correct answer. Dr. Apurva, Dr. Mukesh, Dr. Mrinmoy, excellent, very good going, good. Okay, so what is the, how do we approach this question? So first of all, you should know the immunization protocol of a normal term child. If the mother is HBs antigen positive, yes, you have to give, there's a slight deviation from the normal protocol, that is you also have to give hepatitis B immunoglobulin with the 0 dose of hepatitis B vaccine at 12 hours of birth. Right, within 12 hours of birth you have to give both of these together, and 12, in some books it is written 12 to 24 hours, but anyways within 12 hours of birth, that is what our objective is, using 2 separate sites on the same thigh. Both immunoglobulin and the vaccine are not to be given. Remember, they are given on 2 separate areas, that is 2 separate limbs are used. So you can use both the separate thighs, one for HB immunoglobulin and one for hepatitis B vaccine, right? And the dose of hepatitis B immunoglobulin is 0.5 ml intramuscular. However, it can be given up to 7 days of birth, but then remember after 48 hours its efficacy is questionable. And then this child has to be given 3 more doses in variable schedule. Some like to give 6, 10, 14 in accordance with the pentavalent vaccine which is available, or somewhere in hexavalent vaccine also we give in 6, 10, 14 schedule, or you can simply give in 6, 6, 14 and then 6 months, or you can give in 6, 10 and 6 months, whatever schedule you can give 3, you have to give 3 more doses. So that is for a normal term child, right? Normal birth weight and normal term child. Okay, then if the HBIG immunoglobulin is not available, then what we do is, If it is not available, then hepatitis B vaccine is given in a schedule of that is at the birth it is given, and then at 1 month, and then at 2 months. So 0, 1, 2 with an additional dose at anywhere between 9 to 12 months. So remember, if hepatitis B immunoglobulin is not available, then you give 0, 1, 2 dose. That's 0, 1 and 2. This indicates at birth, remember, and then at 1 month of age, and then at 2 months of age, with an additional dose between 9 to 12 months of age. So this is how you will manage a baby if hepatitis B immunoglobulin is not available, with mother being HBs antigen positive. And therefore these children, all children who are born to HBs antigen positive mothers, they should be tested for HBs antigen and anti-HBs antigen bodies, at the age of 9 to 15 months to identify either the carriers or the non-responders. So you have to, this is for a normal term child. Now let us come to the question what we were doing, and that is the 1.5 kg child or a preterm child. How do you approach this child if the mother is HBs antigen positive? Remember, there's a dictum. If there is a preterm infant or a low birth weight infant with birth weight of less than 2 kg, anyways these children do not respond favorably to the birth dose of hepatitis B. So we usually give the hepatitis B vaccine in these children. See, remember here the mother is not HBs antigen positive, right? Here the mother is normal. So this mother is normal, but the child is a preterm child or a LBW infant. So normally these children will not respond favorably to the birth dose of hepatitis B vaccine, and hence what we give is that we give the first vaccine at the chronological age of 1 month. So that is what we do, right? So this is for the immunization of preterm infants born to a mother who is not HBs antigen positive. Now let us say if the child is born, a preterm infant or a LBW infant, is born to a mother who is HBs antigen positive. Now how do we approach this child? So in this case what we do is that the preterm infant, if more than 2 kgs, we follow as we did for the full term infant. That means we will give the 0 dose, that is at birth we will give the dose of hepatitis B with hepatitis B immunoglobulin, and then we will repeat 3 more doses of hepatitis B vaccine. So this is very similar to what we did in a term child we just studied. What if the mother is, the child is less than 2 kgs, either it is a LBW or a preterm infant. If the mother is HBs antigen negative, then again the dose 1 is given at 30 days of age only, and dose 2 and 3 is as per schedule adopted for the full term infants. But if the mother is HBs antigen positive and the child is less than 2 kg, that is our question. We are now discussing the question. Now what we do is you have to give hepatitis B vaccine and HB immunoglobulin within 12 hours of birth. So that is very clear that if the mother is HBs antigen positive, be it a preterm baby, be it a LBW baby, be it a term baby, you have to give hepatitis B vaccine which with HB immunoglobulin at within 12 hours of birth. That should be very clear. Then we don't consider that this child is preterm or this child is LBW and will not, mount a good immune response. This we will not consider at that time. So we have to give the birth dose, and then 3 more doses beginning at 4 to 6 weeks of age. Similar 6, 10, 14 has to be given to this child. So total 4 doses have to be given, and then check anti-HBs antigen and HBs, antibody has to be checked 1 month after we complete the series. Complete series, when completed, we have to check for HBs antigen antibodies and the HBs antigen also to again check for non-responders or the carriers. I hope it was clear. Yes, all are correct. So we have to give the second option, that was correct. Okay, then let us come to the next question. A 2-day-old term newborn is admitted to the neonatal unit with a total serum bilirubin level of 18 milligram per deciliter. Infant is otherwise healthy and breastfeeding well. Phototherapy is initiated to manage hyperbilirubinemia, right? Which of the following is the primary mechanism of action of phototherapy in the treatment of neonatal jaundice? Is it induction of hepatic enzyme activity? No, such things are not done. Is it inhibition of bilirubin production? No, it is not. This is not the mechanism how phototherapy acts. Is it conversion of bilirubin to lumirubin? Yes, correct. So many children have answered correctly. I am so happy. Dr. Parveen Panwar, Dr. Apurva Shri, yes, you are correct. C option. Is it enhancing red blood cell production? No, there is nothing like that with phototherapy. So this is conversion of bilirubin to lumirubin. So there are three ways in which phototherapy acts. I hope you know this. It is photoisomerization. Yes, Dr. Jayansh Vijay is absolutely right. Lumirubin is a non-toxic form of bilirubin and it is easy to excrete out in the bile. So that is how the structural isomerization part will take place. So there are three ways in which the phototherapy acts. One is photoisomerization. I hope you know this. Another is structural isomerization and the third variety is photooxidation. These are the three ways in which the phototherapy acts on the bilirubin. So what happens in each? Let us see. So in photoisomerization, what we see is that the natural isomers, the natural isomer of bilirubin. And what is the natural isomer of bilirubin? Can anybody tell me? Yes, it is 4Z, 15Z isomer. It undergoes E-isomerization under the effect of phototherapy and it gets converted into 4E, 15E isomers, and this is again more, it is a polar product and it is easy to excrete. So this is the first way in which the bilirubin, the phototherapy acts on bilirubin. Then next is structural isomerization, which was given in the option given in the question, in which the bilirubin gets converted to lumirubin. Yes, somebody said it is easy to excrete, and this is another way. And the third way is photooxidation. So first, second and third way. Now can anybody tell me which is the most efficient way in which the phototherapy acts out of these three? Yes, you are correct. It is the structural isomerization. This is the mechanism which is the most efficient mechanism. Can you tell me the bilirubin undergoes which mechanism the most? The highest percentage of bilirubin enters which mechanism? The answer to this is photoisomerization, but still this is not very effective because remember, photoisomerization is reversible. Yes, so Dr. Jayansh Vijay has answered correctly that the most efficient way in which the bilirubin gets excreted out or gets treated by phototherapy is structural isomerization. This is the most efficient way and this is non-reversible. But if somebody asks you that which is the percentage of bilirubin, the highest percentage undergoes which reaction, then the answer is photoisomerization. This should be very clear, but it is not efficient because it is being the reversible reaction, right? Okay. Then let us move on to the next question. So we have discussed this. And the next question is, 1-year-old male child presents with episodes of breath holding followed by loss of consciousness. These episodes are usually seen whenever the child becomes cranky for feed or toys. The child appears pale during the episodes and regains consciousness spontaneously after a short period. The examination of the child is normal. There is no family history of seizures. The most appropriate management for this condition is, so what is this? What have we diagnosed? What is the condition consistent with? Yes, you are correct. It is breath holding spell. It's a typical example of a breath holding spell. You should know this. This breath holding spell is usually seen between the age group of 6 months to 5 years of age, right? And it usually abates by 5 years of age. It is not seen before 6 months of age and it peaks around 2 years of age. So this is the time when the child will again and again be having this event of breath holding, and it's a reflex kind of spell and usually occurs when the child is either irritated or made to cry because of one reason or the other. It can be pain, it can be irritation, it can be frustration. And what happens when the child cries? The child stops the breath after full expiration and then either becomes cyanotic and blue or undergoes undergoes, transformation into a pale kind of color. It becomes white in color and may, stop breathing for a while, but eventually starts breathing. So either can turn pale or can turn cyanotic. So these are the two types of breath holding. What are we supposed to do? Remember, tell the parents to keep calm. It is a non-fatal condition. Yes, so it's a breath holding spell. Many people have answered very correctly. So first of all, the parent should be reassured, and the parental education is very important in this, that they have to be calm and they have to turn the child on one side to prevent, so that the secretions can flow from one side. Number one. Number two, very importantly, they don't have to show over concern, otherwise this will reinforce the child's behavior. So that should be again very, very importantly followed. And then the third thing is, they should not give in to the demands of the child for which he or she has thrown up a breath holding spell. Again, if they give in to the demands after the child throws up a breath holding spell, the child will be doing this again and again. This is going to reinforce the child's behavior, and hence the parents are taught to remain calm and cool and just turn the child on their side. What about the iron therapy? It is shown that iron deficiency anemia somehow potentiates the existence or the occurrence of breath holding spell. So iron deficiency anemia should be treated if at all concomitantly present in a child having breath holding spell. Otherwise, giving prophylactic iron has no role, but of course if the child has iron deficiency anemia, then that should be treated. So that is one thing that can be given to this child, otherwise no drug therapy is required. Yes, so everyone has done this correctly. I guess the pediatric section was a very easy one. Okay, now next question is, a 4-year-old female child is brought to pediatric OPD with a history of loose stools for the past 3 years with pallor despite iron supplements. That means anemia not responding to iron. The mother informs that since the child has started on complementary feeds, she started having loose stools. So that means there is a temporal relation of the loose stools with the introduction of complementary feeds. Her height for age is definitely below the 3rd centile as per WHO MGRS growth charts. What is the most probable diagnosis? So is it cystic fibrosis? Is it celiac disease? Is it cow's milk protein allergy? Is it immunodeficiency? Yes, Dr. Mrinmoy Dhar has answered it very much correctly. This is a classic presentation of celiac disease. Dr. Mukesh has also answered it correctly. So celiac disease, yes, this is typical allergy to wheat, gluten sensitivity. It is a sensitivity to the gluten, and because of which the children present with growth failure and anemia not responding to your usual hematonemics, and whatever else the child has is the features of all kind of malabsorption and growth failure. So that is what is seen in a child with gluten sensitivity. And then it is the most common cause of chronic diarrhea in children over 2 years of age in northern India, and the classic presentation is a small bowel diarrhea, growth failure anemia, and the child may also present to you with short stature, delayed puberty, rickets and osteopenia, depending on how fast or how delayed is the diagnosis made, right? And then what do we do is that on examination we see clubbing, pallor, failure to thrive, and loss of subcutaneous fat and rickets, and usually the diagnosis is made either by serology and substantiated by upper GI endoscopy, and then biopsy of the histology findings further substantiate the diagnosis. So let us see serology. What do we do? Yes, we do the TTG, IgA, and we can also go for the IgA antibody to which is the EMA, endomysial antibody. So these two antibodies are very much useful. They are highly sensitive and specific for the diagnosis of celiac disease. So this should be very clear. What do we see in upper GI endoscopy? We see loss of folds, so in the duodenal epithelium, so that is again very much diagnostic. And the histology, we see increase in intraepithelial lymphocytes, increased crypt length, partial to total villus atrophy, very important, and infiltration of plasma cells in the lamina propria. So these all clinch the diagnosis of celiac disease. Yes, okay. And the according to the Espegan criteria, what is Espegan? European Society of Pediatrics, Gastroenterology and Hepatology and Nutrition. So Espegan criteria tell us that these 3 criteria should be fulfilled for the diagnosis of celiac disease, and the 3 criteria are clinical features compatible with the diagnosis, positive intestinal biopsy with or without serology, and an unequivocal response to gluten-free diet within 12 weeks of initiation. So treatment is, yes, we have to go for gluten-free diet, and then we also have to start the child on iron and folic acid. Now the child will respond to, the child's anemia will respond. You know, once you make the child gluten free, then the anemia starts responding to the hematinic. So iron and folic acid have to be supplemented, and other multivitamin supplementation is also absolutely necessary in children suffering from celiac disease. So this is how the diagnosis has to be made. Now, was this, let us come back to the question, was this cow's milk protein allergy? No, because cow's milk protein allergy usually presents with colitis, you know, and usually we have a family history positive for atopy or the cow's milk protein allergy, and this is usually seen in children who are fed top milk. But remember, cow's milk protein allergy can also be seen in breastfed infants, you know, if the mother is taking cow's milk, and that cow's milk protein gets transferred on to the breast milk, and then the child who is totally on breast milk may also present to you with features of cow's milk protein allergy by virtue of mother drinking the cow's milk. So that should be very clear to you. What else is there in cow's milk protein allergy? That it is, you know, the diagnosis is made on elimination and then a subsequent challenge. So you eliminate the cow's milk protein from the diet, and then you again challenge it by introducing it. So again the symptoms would be there, and usually these children, 50% of the children outgrow their cow's milk protein allergy by 1 year of age, and almost 95% outgrow their allergy by 5 years of age. So therefore, this is how the cow's milk protein allergy will present to you, not as what is given in the question, right? Then what about cystic fibrosis? Cystic fibrosis, yes, is a multi-system disorder predominantly affecting the lungs, but then the child can present to you with features of malabsorption, greasy stools, greasy, large, bulky stools, and features of intussusception. These are the 3 features pertaining to gastrointestinal tract, right? So, but then any of this is not consistent with cystic fibrosis. Immunodeficiency would present to you with recurrent infections, serious infections, life-threatening infections, and usually death of a sibling with similar infections, and would be having fever and other features also. So again, immunodeficiency is not the answer. The correct answer is celiac disease, rightly answered by Dr. Mukesh and Mr. Relaxing. Good, you are relaxing. Okay, then let us move on to the next question, and that is your 5-year-old child, a syndromic question. 5-year-old child presents with distinct facial features including a broad forehead, a flattened nasal bridge, dental abnormalities such as small widely spaced teeth as shown in the picture. The child has a friendly and outgoing personality. Child also demonstrates delayed speech development and mild intellectual disability. Which of the following condition is most likely responsible for this clinical presentation? So this is a typical presentation of Williams syndrome. So this facies, if you see, has a triangular facies. So this is your elfin facies, is also known as elfin facies. Yes, very good. Dr. Apurva has answered it correctly. It is Williams syndrome. And of course, if I would have added one more feature, so can anybody tell me one more striking feature pertaining to cardiovascular system in a child with Williams syndrome? Anybody? So I'm waiting for the answer. And then I will write it down after some time. So one feature pertaining to cardiovascular system, which is a very important, hallmark feature of Williams syndrome. Can anybody tell me this? Good going, students. I am waiting for the answer. In the meantime, let us see Edwards syndrome. So Edwards syndrome, I'll just show you. No, Jayansh Vijay, it is not aortic stenosis. The correct way of saying it is supravalvular aortic stenosis. Always remember this. So just aortic stenosis will not help. You are almost 90% correct, but you should say supravalvular aortic stenosis. Yes, so I would still give marks to Dr. Jayansh Vijay. Yes, a striking feature of identifying Williams syndrome is supravalvular aortic stenosis, very commonly asked. Here we had, deliberately missed this so that we could test you that do you remember the other features of Williams syndrome or not. Right, so it is supravalvular aortic stenosis. Now coming to other syndrome. So what about the Edwards syndrome? So Edwards syndrome, usually children, they have a very prominent occiput. Can you see this? They have a, this thing, micrognathia, small jaw, and they have a congenital heart defect with VSD. Yes, okay, I give it to you, Jayansh Vijay. You are writing that you have writing fast, that's why you skipped. Good. So I give it to you. Yes, you were correct in writing aortic stenosis, but write it correctly. It is supravalvular aortic stenosis. Okay, so coming to Edwards syndrome. The commonest congenital heart disease seen in Edwards syndrome is VSD. So here Dr. Apurva would be right that yes, VSD is the most common congenital heart defect seen with Edwards syndrome, and other features are clinodactyly and overlapping of fingers. So beautiful picture given over here showing you overlapping of fingers, and you also get to see a rocker bottom feet. So rocker bottom feet and hypoplastic nails. Can you see the nails? The nails are also hypoplastic and has a very prominent occiput and has micrognathia and microcephaly along with cleft lip and palate, right? So these are the features of Edwards syndrome you have to remember. And Down syndrome we all know, but still a quick recap. Facial features have flat faces, upward slanting palpebral fissures, epicanthal folds, large protruding tongue, flattened nasal bridge, and you also get to see a single crease, that is a simian crease, and clinodactyly may be seen, and this is your sandal gap, that is the gap between the first and the second metatarsal. So this is Down syndrome for you. And finally we also have the Prader-Willi syndrome, in which we get to see obesity. Excessive eating leads to obesity, small eyes and small digits. Hypotonia is the rule over here, and usually these children have mental retardation with developmental delay, and short stature is the rule. So this is Prader-Willi syndrome. So I have covered all the 4 syndromes which were asked in your question. So this is typically the correct answer is Williams syndrome. Yes. So let us move on to the next question. The next question was, all of the following are components of TOF, that is tetralogy of Fallot, except. So we know. So waiting for the answer. Who will answer me first? What is the correct answer over here? Yes, the correct answer is tricuspid stenosis. So overriding of aorta is seen, right ventricular hypertrophy is seen, ventricular septal defect is seen, and what is the fourth thing? The most important part of TOF is infundibular stenosis. Remember, this is also a question that what is the most important component of TOF? It is infundibular stenosis. In fact, what is infundibulum? The lower part of the pulmonic valve is referred to as infundibulum. So it is not the pulmonic valve stenosis. Yes, it is infundibular stenosis. No, Jayansh Vijay, it is infundibular stenosis. That is the feature of TOF and not pulmonic stenosis. Please remember it correctly. You might be given an option between infundibular stenosis and pulmonic stenosis. Then you should know that pulmonic valve stenosis usually refers to the stenosis of the pulmonic valve leaflets per se, and infundibulum is the area just beneath the pulmonic valve, and that is why it is infundibular stenosis. So that is the fourth criteria or the fourth element of tetralogy of Fallot. Okay, so that is it. Many children have answered correctly. Good, good, good. The Dr. Apurva, Mrinmoy, Dr. Mukesh, good. Okay, now let us so this is the feature, or this is a diagram showing you TOF. So you can see right ventricular hypertrophy, you can see infundibular stenosis. See, so this is the pulmonic valve and the stenosis is beneath the pulmonic valve, and you have the VSD, and you also have overriding of aorta. What do you mean by overriding of aorta? That is, the origin of the aorta is such that it is sitting upon the defect of deep ventricular septum. That means it is sitting upon VSD, that is known as overriding of aorta, right? So this is, in fact, if somebody asks you which of the following 4 features of TOF does not have a clinical connotation to it, the answer is overriding of aorta. It only makes the aorta more anterior, so single S2, that is A2, is heard more clearly. Otherwise, it does not, contribute in any way to the pathophysiology of TOF. So remember that. Other 3 are very, very important: right ventricular hypertrophy, VSD, and of course, the most important being the infundibular stenosis, right? Okay, good. Chalo, let us move further. A 5-year-old female child presents to pediatric OPD with a complaint of not being able to stand or walk with or without support, with no significant family history, but with a birth history of low birth weight, with features of rickets on clinical and radiological examination, but with no response to vitamin D therapy. What is your impression? So yes, this is, if a child does not respond to vitamin D therapy, yes, the answer is going to be refractory rickets. Now, what is the response we are actually looking forward to when we give vitamin D to a child with rickets? So what is it? Yes, many people have answered it correctly. Good. Dr. Apurva, Dr. Mrinmoy and Dr. Mukesh, congratulations. But this is how we treat a child with rickets. So the dictum, nowadays is, previously we used to give a single dose like this. So this is the column telling you about the single dose, which is age related. You can correlate at 3 to 12 months. We used to give 50,000 IU. Between 1 to 12 years, it used to be 1,50,000, and more than 12 years, 3 lakh international units. But then what came next was the weekly therapy. Rather than the one dose therapy was known as the STOS therapy. Remember that? But now it is no longer in use. Now we came to the weekly therapy. For 6 to 8 weeks, we give 60,000 international units weekly. But now the dictum, the latest recommendations tell you that you have to, in fact, do away with the weekly therapy also. You should go for a daily therapy, because this actually mimics the physiological vitamin D administration, rather than giving such a high dose every week. So therefore, an ideal way would be the daily dose for 90 days. 3 months you have to give for daily dose. When you give this dose in appropriate amounts, then now what do we see? So after 4 weeks of stopping vitamin D, we get a repeat X-ray done, and we see the white line of heal. So this is the white line, if you can see. So this line is the line of healing of rickets. I will again show it to you. Okay, so now you see this is the white line which is seen at the border of epiphysis and metaphysis. Yes, this is the healing of rickets. This indicates now the calcium deposition or the mineralization of the cartilaginous matrix has started. So this is the healing of rickets. For example, if this line of healing is not seen, then the dictum was to repeat the dose. If the child had been given oral therapy, then repeat the dose, this time with IM therapy, and then again wait for 4 weeks and see. So after 2 doses of vitamin D, still if the child does not show line of healing, then we call it refractory rickets, right? So refractory rickets, how do we approach? We have to do a serum phosphate level. If it is high, then straight away the diagnosis becomes chronic kidney disease. If it is low or normal, do a blood pH. If the blood pH comes out to be low, it becomes renal tubular acidosis. If it is normal, that means everything is normal. Serum phosphate is normal, blood pH is also normal. Then you have to go for serum PTH and calcium. If they are totally normal, that means the serum phosphate was not normal, in fact it was low, then the diagnosis becomes hypophosphatemic rickets. And if these both are high, then this is vitamin D dependent rickets. So vitamin D dependent rickets is also known as VDDR1 and VDDR2. So these are 2 types of rickets which we see because of vitamin D dependency. That means because there is some problem over here. What is the some problem? In 1, there is a deficiency of 1-alpha hydroxylase. How do you remember? 1 stands for 1-alpha hydroxylase. There's a deficiency, right? And VDDR2, there's a end organ resistance to 1,25-dihydroxylase vitamin D3. So VDDR2 is the end organ resistance, and VDDR1 is deficiency of 1-alpha hydroxylase. This is how we approach a case of refractory rickets. So the condition given in the question was corroborating with the diagnosis of refractory rickets. Yes, very good. Everybody has answered it correctly. Jensh Vijay, it is not VDRR, it is VDDR. I know you have written it, hurriedly, so that is why I give you marks for this. Now, which of the given symptoms are seen in the child with congenital hypertrophic pyloric stenosis? Is it bilious vomiting? No. So, pyloric stenosis means there is stenosis at the pylorus, so how will the bile come in the vomit? So, this is a non-bilious vomiting is the rule over here. Is there a palpable mass? Yes, the pylorus is thickened and elongated, so there is a palpable olive shaped mass. Hypochloremia and hypokalemia is the rule because the child is vomiting out the gastric contents, so hypochloremia will be there, and because the child is vomiting out the gastric contents, the child will also land up with metabolic alkalosis. So, the correct answer is going to be 2, 3 and 4. Yes, Jensh Vijay, it is olive mass. Yes. Okay, Mrinmoy Dhar is correct. The answer is C, and Dr. Uday has also joined. Yes, the answer is C over here. Good. So, the correct answer over here was C. Hypertrophic pyloric stenosis usually presents at or beyond 3 to 4 weeks of life. But in Nelson, if you see, the presentation can be as earlier as 1 week. That is rare. But please remember, the usual presentation is around 3 to 4 weeks or maybe 5 weeks of life with features of non-bilious vomiting and projectile forceful vomiting, and usually after this vomiting occurs postprandially, that means after the child has taken up a feed, and then once the child vomits out all the contents, all the feed which he has taken, he is again very hungry. So, he has a voracious appetite and he eats very, he takes the feed very voraciously, but then again he vomits. So, this is how the child would present to you, and the child would also present to you prolongation of physiological jaundice, and usually what we see is a single bubble sign on the X-ray. I'll just show you that picture. Very good. So, this is the, this is the diagram which is showing you the thickened pylorus, and there's a olive shaped mass in the right upper quadrant. Yes, and then usually in this what we see is the single bubble sign on the abdominal X-ray. That is very, very clear. And then what happens is that if you do the ultrasound, this is the most sensitive and specific, in which we see the pyloric thickness is more than 4 mm. Yes, so this is more than 4 mm, and the pyloric length, this is more than 15 to 19 mm, and this pyloric diameter is more than 10 to 14 mm. And there are many signs seen if we do a contrast study. So, in that we see the string sign, we also see the shoulder sign, and we also see a double tract sign. Apart from this, we also seen something so known as the target sign. So, these are all the signs which are seen if we do a contrast study of a child having congenital hypertrophic pyloric stenosis. Remember, the word congenital is very much controversial, because it is said usually hypertrophic pyloric stenosis develops after birth. It is not present since birth, right? So, this is it. Yes, very true. Mrinmoy Dhar saying olive lump is there. Yes, okay. Now, let us move on to the next question. A child 2.5 years old presented to OPD with a maculopapular rash with a history of 3 to 4 days of fever. At the time of presentation, there was no fever. The child was admitted to the hospital and the rash disappeared after 24 hours without any pigmentation. What is the most probable diagnosis? So, this, what do you see in this is a 2.5-year-old child, and the rash is coming after the fever. That means the fever disappears, and the rash appears. So, this is so very typical. You have to remember, yes, the answer is roseola infantum, also known as sixth disease. Yes, why sixth disease? Is called by HHV6, remember, and it is usually seen between the age of 6 months to 3 years, right? So, this is sixth disease, roseola infantum. And here we get to see the appearance of rash after the fever disappears, very importantly, and usually the rash disappears. Here it is given after 24 hours, but usually please remember, in the, you should know the correct information. The rash usually takes around 3 to 4 days to disappear, right? 3 to 4 days, sometimes even 5 days to disappear without any pigmentation. Why not it is measles? Can anybody tell me? Remember, in measles, the rash typically occurs on the day 4 of fever, and the fever rises. The fever from mild grade becomes high grade with the appearance of rash, and then the rash would disappear, leaving a briny desquamation, right? So brony desquamation is seen following measles, which is two things which are totally opposite given in the question. Why not it is erythema infectiosum? Erythema infectiosum, we all know, is fifth disease. It is caused by parvovirus B19, and it typically presents with a slapped cheek appearance. And then there is a rash which is a erythematous rash which spreads from neck to the trunk and the extremities, and then the rash undergoes central clearing, giving it a lacy or a reticulated appearance. So I'll just show you that rash very nicely. It is given over here. You can see the central clearing is there in the rash, which is so typical of erythema infectiosum, right? And what about rubella? Rubella usually presents again with fever, with rash, but then the rash would persist with fever. Fever does not disappear on the appearance of rash. Number one. Number two, rubella is characterized by good amount of occipital, cervical, and axillary lymphadenopathy. So usually in rubella you will get to see all three features, and that is why this is not rubella. This is typically your as we just saw, this the diagnosis is roseola infantum, also known as exanthum subitum, also known as sixth disease, right? And then there are, I just got this thing for you so that you remember this, and that is the first disease is the name given to measles, the second disease is the name given to scarlet fever, third disease is rubella, fourth disease is Duke's disease, fifth disease is erythema infectiosum, and then sixth disease is roseola infantum, which we just saw, also known as exanthum subitum. I hope you enjoyed the discussion of pediatrics. Keep MCQing, and I'm sure you will be able to ace the exams. Well, it seems that most of you have done the pediatric sections almost correct. Thank you so much.
Hello friends, I am Dr. Harmeet Goyal, your OBS and Gynae faculty, and today I will be taking up the OBS and Gynae discussion which was given to you in the form of the grand mock test. Let us start with the discussions. Are you people ready? Just write down in the chat box. So let me start with the first question. Which of the following are true statements regarding emergency contraceptives? First of all, students, let me ask you and let me tell you, like this is just for your concept building, okay? Most of the time in FMG exam, there is only a single question and a single answer. More than one answer is given. The type of pattern is not going to be asked for FMG. It is usually a pattern being asked in the INICET, okay? But doesn't matter, this is just a practice session for you. So which of the following are true statements regarding emergency contraceptives? Emergency contraceptive pills interfere with the sperm penetration. It impairs the corpus luteum function. Pregnancies that develop after having this pill have increased chances of first trimester abortions. It prevents and delays ovulation. Emergency contraceptive pill is a hormonal contraceptive pill that has levonorgestrel of 1.75 milligram, usually taken as a single dose within 72 hours of unprotected intercourse. So what do you think is the correct answer? 1, 2, 3, 4, 5 are correct, or 1, 2, 4 or 1, 3, 4 or 2, 3, 5. So write down in the chat box. What do you think should be the correct answer? Are you there? I can see Dr. Bhavnesh has written B answer, okay. So let me tell you, emergency contraceptive pills are also called as the post-coital contraception. They are called as post-coital contraception or emergency contraception, or they are interceptives, okay, or they are interceptives. So emergency contraceptive pills interfere with sperm penetration, okay. It impairs with corpus luteum function. It prevents and delays ovulation, okay. Now in option number 5, it is written as emergency contraceptive pill is levonorgestrel of 1.75 milligram. That is very wrong. The dose is levonorgestrel pill is the most commonly used emergency contraception in India, and it is a single dose of 1.25 milligram, single dose to be given within 72 hours of unprotected coitus. So what did I tell you? I told you the dose is 1.25 milligram, okay. So this is wrong answer, and even this number 3, if pregnancies develop, there is increased chance of first trimester abortions. Again, I am not satisfied with this answer, okay. So the correct one is 1, 2 and 4 are correct, okay. Emergency contraception or post-coital contraception, okay. It is of two types, within 72 hours or within 5 days of unprotected coitus. Within 5 days is IUCD. Now which type of IUCD? It is only copper T. Remember, Mirena or LNG IUCD is not emergency contraceptive. Okay. So most commonly used in our country is LNG pill, and the dose is 1.25 milligram single dose. Number 2 is OCPs. Nowadays low dose OCPs are used. So 4 tablets, and after a gap of 12 hours 4 tablets are given. So any of the tablets that is Mala D, Mala N, Novelon, Familon, any of them can be used. Number 3 is RU486 can also be used. Okay. So these are to be given within 72 hours of unprotected coitus. Yes, one of the mechanism is also written that it can prevent or delays the ovulation. Okay. Now there is another pill which is Ulipristol, that is 30 milligram single dose within 5 days of unprotected coitus. In the other countries it has been used as an emergency contraception, but in our country the most commonly used emergency contraception is LNG pill, but the best emergency contraception is copper T. Okay. Now we switch over to the next question, that is all are sex cord stromal tumors except. Okay. All are sex cord stromal tumors except. It is single dose, Dr. Monk. Ulipristol is basically used for emergency contraception, and number 2, it is being used for fibroid uterus. Okay. This is 5 days of unprotected coitus. It is not given for 5 days. It is 5 days, within 5 days of unprotected coitus, and it is given as a single dose only. Okay. For fibroid it is given 5 milligram daily for 6 months. 5 milligram daily for 6 months. Then after 6 months shrinkage in the size of fibroid is seen. So that is what is Ulipristol. Fine. Now next, all are sex cord stromal tumors except. Okay. Now you know, according to WHO there are 4 types of ovarian tumors. Number 1 is epithelial ovarian tumors. Number 2 is germ cell tumors of the ovary. Number 3 is sex cord stromal tumors, and number 4 metastatic, which is Krukenberg. 90% of all ovarian tumors are epithelial, 3 to 8% are germ cell, around less than 3% is sex cord stromal tumors, and just 1% or less than 1% is metastatic. Primary tumor may be in the stomach or in the colon or in the breast. Okay. Now here let me talk about the sex cord tumors only, because otherwise the discussion will become too long. Okay. So sex cord stromal tumors. Sex cord stromal tumors, it can be feminizing or it can be virilizing. Now this is sex cord. These two are sex cord tumors. Now if you talk about stromal tumors, then it is fibroma, thecoma, and fibrothecoma. So this is your answer. Okay. If I talk about feminizing ovarian tumors are estrogen secreting ovarian tumors, that is granulosa cell tumor, which can occur at any age group. Now the tumor marker here is inhibin, and the histopathological examination is Karl-Exner bodies. Now when you talk about virilizing ovarian tumors, that means androgen secreting ovarian tumors. So it is Sertoli Leydig cell tumors, Sertoli cell tumors, or there is Hylas cell tumor. Sertoli Leydig cell tumor, ठीक है, then it is Leydig cell tumor and then Hylas cell tumor. So presently our question is stromal tumors, that is fibroma, thecoma or fibrothecomas. Okay. So fibroma is correct, granulosa cell tumor is correct because they have asked the full category. Thecomas are correct. So wrong answer is dysgerminoma. Dysgerminoma is germ cell tumor of the ovary, and it is malignant tumor. It is malignant tumor. It is radio sensitive tumor. Tumor markers are LDH and alkaline phosphatase, and the treatment is unilateral oophorectomy. Okay, because mostly the germ cell tumors are occurring in the young age group. Okay, but the good thing is mostly they are unilateral. So have you got your answer? So the answer is dysgerminoma is not sex cord stromal tumor, it is a germ cell tumor of the ovary. Next, match the images with their respective names. Now this is Cusco's speculum, so I am directly matching them. This is Cusco's speculum. So always when you get such a questions, A will be for 2. Okay, this is Cusco's speculum. Cusco's speculum, friends, is used. Okay, I agree. In your FMG exam, if you're talking about this kind of pattern is usually not been asked, it is for INICT. But what is there? Important thing is that we are building up concepts in you, and if there is any difficult pattern of questions being asked, you should be able to answer. Okay. So Cusco's is you are putting or retracting. It is a self-retaining speculum where you can visualize the cervix, you can visualize the vaginal walls, you can do a copper T insertion, you can do a pap smear, you can check if there is any cervicitis, that the discharge is coming from the cervix, or it can also be used for doing any DNC procedure. It can be used, usually we are using a SIM speculum, but this can also be used when you want to remove the IUCD, then also with an artery forceps you can hold the thread and you can remove it. So it is a self-retaining speculum, so that is why this has been preferred over the other SIM speculum, because you require an assistant in that case. Now this is Doyne's retractor. Doyne's retractor is used, so B goes for 1. Doyne's retractor is used in cases of abdominal surgeries. For example, you are doing a cesarean section or you are doing a hysterectomy. When you lift the utrovesical fold of peritoneum, you give a cut, you put in a Doyne's retractor to retract the urinary bladder, because you want to expose the lower uterine segment where you have to give incision during the cesarean section. So it is basically used to retract the bladder in abdominal surgeries. Now this is Karman's cannula, and Karman's cannula is used when you want to take the endometrial sampling. In cases you want to take the sample for endometrial hyperplasia or endometrial cancer, and you want to send the sample for histopathological condition. So this cannula is used. It can also be used at times for suction evacuation. Okay. Now next is, this is an here it is written wrongly. So number 5 is basically the Alice tissue forceps. So in case of D option it is number 5, and in case of E option it is number 4. Okay. So what is Alice tissue forceps? Alice tissue forceps is used, it is to hold the rectus sheet, to hold the skin while you are applying the stitches. It can also be used at other places during the abdominal surgeries, during the gynae surgeries, like to hold the tough structures, because it has got edges like this. Okay. So which is the correct answer to this question? A is 2, B is 1. So B is the correct answer to this question. Okay. Next. Now which STD color code kits with their numbers, STD kit colors syndrome? Okay. What is this matched? So this is basically, friends, don't just lose your confidence level. This topic is important. So you get to understand these are the topics I need to focus on. Of course, there may be some of the questions which are being, can be the repeat questions. Maybe the format of the question can change, like they are asking the question of the placenta previa image, abruptio placentae, magnesium sulfate. Okay, then they are asking on cancer cervix, they are asking on infertility. Okay, so that pattern we have been discussing in our sessions. Okay, this is just to tell you that if there is any deviation, because now it is going to be the next exam, so you should not lose confidence if any tough form of paper is being asked. Okay, just apply your concept, you will get the correct answers. Okay, more than one answer I don't think they have ever asked, okay, in your exam. Okay. Now color code, let us just mark. Okay. The first one you should remember is for term is cervicitis, where there can be any mucopurulent discharge, or there can be cervical erosion. So kit number 1 is used, and what is the color of that kit? The color of that kit is grey. Okay. Kit number 2 is for vaginitis. Okay. Any form of like foul smelling vaginal discharge. Basically in vaginitis you are expecting 3 type of organism, any one of them. It can be trichomoniasis, where it is a greenish color discharge and there is strawberry spots in vagina. It can be thick curdy white, then it is candidiasis, it is foul smelling, non-itching, then it is bacterial vaginosis. So the color code is the green. Okay, so these are NACO kits, and it is Suraksha Clinic, or this is reproductive tract infection or sexually transmitted infections. Okay, then it is just minimum investigation and give the treatment. That is what is the concept. Now there is kit number 5 I will talk about. That is for lower abdominal pain, which is PID, and like the kit is the yellow color kit. Then kit number 7 is the inguinal buboes, etc. Okay. So white color kit is for here urethral or cervical, it is grey color. Vaginal discharge, it is green color. Yellow is lower abdominal pain and genital ulcer is white. Okay. So A goes for 2, then B is 1, C is 4 and yellow is lower abdominal pain. You read about this reproductive tract infection or sexually transmitted infection or Suraksha clinic like this. Okay. So it is minimum investigation and give the treatment. Okay. So that is what is a NACO color code kits. So in gynae we are treating cervicitis, vaginitis, PID and ulcers. So it is covered in your dermatology as well. Okay. Next. Now, which of the following is not used in pre-eclampsia? A very straight question, and it is just for FMG exam level. This question was also for FMG exam level only. You should know the color code kits of the NACO here in gynae, because the herpes, ulcers and all that and inguinal buboes, basically if we get such a patients, we can refer it to the dermatology. What we are concerned as a gynecologist is cervicitis, where mucopurulent discharge coming from the cervix. So you can go for a pars speculum examination and there is a grey color kit. In vaginitis, you give it green color kit. In PID, you are giving the yellow color kits. Okay. Now, which of the following is not used in pre-eclampsia? Okay. The drug of choice for hypertension in pregnancy or hypertensive crisis in pregnancy is the labetalol. Labetalol is alpha plus beta blocker. So it is a drug of choice. Why this is a drug of choice? Number 1, it is very safe, no teratogenic effect and onset of action. Onset of action is quite fast. Okay. It can be given in oral form, or for acute hypertension you can give it IV also. So labetalol is a drug of choice. Then methyl dopa can also be used. Hydralazine, which is arteriolar dilator, can also be used. So the answer to this question is B, atenolol is not being preferred in pre-eclampsia or in pregnancy. Okay. Now the drug that is contraindicator is ACE inhibitors, because they cause teratogenic effect, and if given in second or third trimester, they cause placental insufficiency or fetal hypoxia. Okay. So I hope. So you can students, you can keep on writing your answers in the chat box. Now next, a 28-year-old woman presents to the emergency department with vomiting, constipation and abdominal distension. X-ray abdomen shows air fluid levels. Vaginal examination shows a loop of intestine protruding from the cervix. Which of the following history must be acquired? About the IUCD insertion can cause the perforation. History of like dilatation and curettage is also important. I don't think intestine protruding from the cervix there is any role of a laparoscopic surgery, and cancer endometrium also do not present like this. If it is an INI-CET exam, both the answers should be there, because if anyone who is a quack and doing a dilatation and curettage with the instrument, it can perforate the uterus and the loop of the intestine can come out. Even if IUCD insertion has been done and there is the IUCD has perforated the uterus, that can also be a complication. Fine. Now, if IUCD has perforated the uterus and gone into the peritoneal cavity, there is also one more complication, that is it can lead to intestinal obstruction, because copper T releases copper ions that can attract the polymorphs and can lead to adhesion formation. So, that if copper T has perforated the uterus, then you have to do removal by laparoscopy or laparotomy. Okay. So, here laparotomy has to be done to manage this condition. Now, which of the following statements tells that device being inserted in the correct position? Now, this is been inserted, okay, and which is the correct position for this? Now, if it is not expelled after increased intra-abdominal pressure, if bleeding does not occur, if patient feels discomfort, if it is cannot be felt by the patient in self-examination. Okay. So, what is this? This is a ring pessary used for genital prolapse occurring during pregnancy, during puerperium, or elderly female unfit for surgery. So, if it is not been expelled whenever the intra-abdominal pressure is raised, like in coughing, like in sneezing, like in laughing. Okay, that means it is placed in the correct position. Fine. Now, next question, shoulder dystocia is managed by all except. Shoulder dystocia is a condition where baby head is born and the shoulders are the one which is stuck up. So, it is seen in a macrosomia baby who comes for a delivery, because macrosomia, if it is a diagnosed case, then we will take this patient for elective cesarean section. Because weight of the baby is going to be more than 4 kg and it will land up in shoulder dystocia or obstructed labor. Okay. So, these are cases where the patient has been unbooked and there is no antenatal checkup being done and no ultrasound being done. Okay. So, she has just come and she is just landed up in the delivery. So, in that case, the baby has stuck up, the head is born and the shoulders are stuck up. So, in this case, no fundal pressure should be given. Fundal pressure, no fundal pressure is given. Rather, you should start with a Mac-Roberts maneuver where the legs of the lady are flexed and abducted in a way to increase the space for the delivery. If Mac-Robert maneuver fails, then you apply the Wood's corkscrew maneuver where delivery, it has to be rotation of the shoulder and posterior shoulder is hooked out and delivered. Wood's corkscrew. If suppose this is also not been successful, you can apply suprapubic pressure, there is no problem. Zavinali's maneuver is you put the fetal head back into the uterus and perform a cesarean section. So, these three are done. Fundal pressure is of course contraindicated, because if you apply a fundal pressure, it will cause more constriction of the fetal neck and immediately the baby will die. Next, what are the side effects of oxytocin bolus? Always oxytocin. Oxytocin is a drug of choice for active management of third stage of labor according to WHO. It's a drug of choice for managing atonic PPH. Oxytocin is a drug of choice for induction of labor or augmentation of labor. It is also a drug that is been used to manage. It is also been a drug that is used to manage to manage the breast engorgement. Okay. Now, oxytocin, the route is always intramuscular bolus, or it is given in IV infusion. IV infusion. Like you have started a drip, okay, then oxytocin can be added. So, if too much of oxytocin is given, it can lead to hypotension. Okay. So, the correct answer here is hypotension. Now, arrange the cardinal movements in the mechanism of labor. Okay. So, let me just write down what is the correct answer. So, it is first of all engagement, descent, flexion. When the occiput touches the pelvic floor at the level of ischial spine, this is ischial spine, there is internal rotation to 2/8 of a circle, so that occiput comes to lie behind the symphysis pubis. Then occiput stretches the perineal outlet. This is called as crowning. Then head is borne by extension. Then there is dropping of the head, that is called as restitution. After that there is external rotation, and rest of the body is delivered by lateral flexion. So, this is the correct sequence. So, descent is occurring in all the throughout, okay, descent of the fetal head is occurring throughout the mechanism. Okay. So, there is engagement, descent, flexion, okay, engagement, descent, flexion, internal rotation, delivery of the head, restitution, external rotation. Okay. So, rest of the body is delivered by lateral flexion. Okay. So, engagement, descent, flexion, okay. So, next, match the following with their definition. Engagement, crowning, restitution, internal rotation. What is engagement? Engagement is when the greatest diameter has passed the plane of inlet. So, A goes for 3 and B goes crowning. Crowning is when the maximum diameter of the head stretches the vulva and does not recede after contraction. Okay. C, restitution is to untwist the neck. Internal rotation, movement of the occiput towards the symphysis pubis. Okay. So, this is the correct answer. Now, two-cell gonadotropin theory of the follicular phase estrogen production. Okay. So, A here is granulosa cells. Granulosa cells have receptors for FSH, and C is estrogen. Granulosa cells produce estrogen. B here is theca cells. theca cells trap the cholesterol from the blood, and this D is the androgen, and this androgen, it passes to the granulosa cells, and this is aromatization. Okay. So, which is the correct answer? A is granulosa cells, B is theca cells, C is estrogen, and D is androgen. A is granulosa, B is theca, C is estrogen, and D is androgen. So, B is the correct answer. Okay. So, are you solving the questions with me? Dr. Mrinoy, Dr. Apurva, Dr. Monk, Dr. Bhavnesh, Dr. Jack, Uday, Jayansh. Okay. So, I hope your answers are matching with this discussion. Prostate gland is homologous to which of the following structures? Prostate gland is in the males and it is homologous with glands of skin. Bartholin glands is homologous with Cooper's glands in the males. This is very much an FMG exam question and it has been asked long ago in 2013. Fine. Now match the following time of splitting of zygote with the time of monozygotic twins. Okay. Monozygotic twins, when single ovum is fertilized by single sperm, it divides into two. So, the monozygotic twins have same genetic characters, it has same sex and their HLA typing is same. 80% of the twins are dizygotic and 20% are monozygotic. So, monozygotic twins, if the division is occurring within 3 days, the type of twins are diamniotic and dichorionic. So, friends, you can solve this and you can just tell me in FMG, the match the following question pattern has not been asked, but what they ask is if the division of the fertilized ovum occurs within 72 hours, what type of twins? So, the concept is you need to revise, okay, whatever format of question has been asked. जो मर्जी क्वेश्चन हो आपको रिवाइज करना है, दैट इज व्हाट इज इंपॉर्टेंट एंड दीज क्वेश्चंस विल बिल्ड कॉन्फिडेंस इन यू. सो लेट मी सी क्या मार्क कर रहे हो आप? जयांश, मृणय, डॉक्टर धर, डॉक्टर अपूर्वा, डॉक्टर मोंग, डॉक्टर भवनेश, डॉक्टर जैक, डॉक्टर उदय. What are you marking your answers? Okay. So, I just want to check. So, within 3 days it is, within 72 hours it is diamniotic dichorionic, within 4 to 8th day. So, that is A goes for 3, B goes for diamniotic monochorionic. If after 8th day, then it is monoamniotic monochorionic. So, C goes for 1 and D goes for 2. Okay. So, D goes for 2, C goes for 1 and this goes for 4. So, A is 3, B is 4, C is 1, D is 2. So, the answer here is C. Okay. So, you also check your answers. Dr. Mrinoy, Dr. Jack, Jayansh, Dr. Mrinoy, Dr. Apurva. I hope you are solving the questions with me. So, this is what is the correct answer. So, identify the type of compression sutures are used. So, this is B-Lin sutures and this has been asked in previous FMG exam. So, these sutures are applied for atonic PPH and it is the surgical management. Though atonic PPH, the management is a medical management. Then number 2, it is a mechanical compression where there is compression hemostasis, okay, that is like you are using Bakri balloon tamponade, okay. Then third one is the surgical management. So before you go for a vascular like ligation, that is ligation of the uterine artery or ovarian artery, that is you take a step of devascularization. What you say is devascularization. Systemic devascularization, you can try the B-Lynch sutures, okay. So this is for atonic PPH and this is the B-Lynch sutures. Now 28 years old G3P2 lady presents with ER with high grade fever, foul smelling discharge, okay. High grade fever, foul smelling discharge, and per vaginum examination there is tachycardia, TLC is raised, pulse rate is raised, TLC is raised, that means there is some sort of infection, okay. And on abdomen the uterus is tender because in infection there can be tenderness. There is no history of trauma, hepatosplenomegaly. What is your clinical diagnosis? Looking at this case, okay, it appears to me that there is premature rupture of membranes, okay, that is why there is some clear discharge and it has got infected, okay. So this nowhere it is showing any features of obstruction to me. Number 2, fatty liver does not present and there is no hepatomegaly, so it also rules out my diagnosis. And there is a foul smelling clear discharge that is coming from the cervix or the vagina, okay. So again it is not fitting into urinary tract infection because they are not saying that there is a burning micturition, frequency of micturition. So I am not going to think in terms of a like urinary tract infection. So it appears to me chorioamnitis, that somewhere the fetal membranes have ruptured and it is a long time, okay. So it has got infected and risk of chorioamnitis, it can lead to preterm labor and baby can also develop sepsis. If the premature rupture of membrane, the labor is not been proceeding and it is non-progress of labor, you might have to take the patient for cesarean section. Fine. Now next question, cervical incompetence can be caused by all except, okay. Cervical incompetence means cervical length shortening. Cervical length shortening where you can judge biclinically from the history or from the ultrasound, okay. Uterine anomalies can very well lead to cervical incompetence. Amputation of cervix can lead to cervical incompetence. DNC, if not been done properly, can also lead to cervical incompetence, because if, for example, instead of DNC, if it is DNE written where you are putting up the Hager's dilator and you want to evacuation of the uterus, then I am going to say even the DNE can also, if you are using the oversized dilator, for example, it is a 6 weeks pregnant uterus and you are doing MTP and you are using 8 number Hager's dilator, then that can lead to cervical incompetence, which is a complication of an MTP. But here DNC is written, DNC is mostly done for the gynae cases, okay. Cerclage is the treatment for cervical incompetence. So according to me, the uterine anomalies and amputation of cervix are the one which like fits into this. MTP with misoprostol is a wrong answer, okay. And the options are not matching actually here. The MTP with misoprostol, I am sure definitely 2 and 5 are already ruled out, okay. So it can be 1, 3 and even 4 can also be in the correct option, okay. So 1, 3 and 4, fine. which except, yes, it is except. So the answer, wrong answer is, I just make a correction. So wrong answer is 2, which cannot lead to cervical incompetence, and even dilatation. So cerclage is the treatment. So those which can lead to is 1 and 3. Fine. Next. G3P2 women with 42 weeks of gestation has been admitted for induction of labor. On examination, you find cervical dilatation is 3 centimeters, effacement is 20%, cervix is anteriorly placed, station of the fetal head is -2, and cervical consistency is soft. What is the Bishop score? Bishop score is a scoring for cervix when the patient goes into labor or you're planning for a normal delivery. So depending upon the Bishop score, you can go for wait and watch, you can go for augmentation of labor, or you can take the patient for cesarean, or you have to induce the labor. So these are the reasons for doing the Bishop score testing. Okay. So this is a Bishop score, you have to read this. Dilatation of the cervix is given as 3 centimeters, effacement is 20%, cervix is soft, it is placed anterior, and station is -2. Okay. So if you calculate, the score coming to be 7. Okay. So you can add on this. Now, which of the following is not a component of Palm-Cohen classification? Palm-Cohen classification is for AUB, that is abnormal uterine bleeding. AUB, which is abnormal uterine bleeding. Okay. So Palm-Cohen classification, P is for polyp. So you know, like this can occur in the puberty age group, it can occur in the reproductive age group, or it can occur in the menopausal age group, and causes may be different. So P stands for polyp, A stands for adenomyosis, L stands for leiomyoma, that is fibroid, M stands for malignancy, C stands for coagulation disorders, okay. O stands for ovulatory disorders, L is for leiomyoma. So molar pregnancy is not included, okay. Ectopic pregnancy is not included, leukocytosis is not included. So 1, 2, 4 and 6 is the correct answer. 1, 2, 4 and 6. So please read about AUB, abnormal uterine bleeding, which is a very upcoming and hot topic, and you should know what are the details. So P is for polyp, A is for adenomyosis, L is leiomyoma, which is fibroid, M is malignancy, C is coagulation disorder, O is ovulatory dysfunction, then there is iatrogenic, and then there is unclassified and neoplastic. A pregnant lady at 12 weeks of gestation presents with spotting and pain abdomen. 12 weeks. Per vaginum examination, cervical os is open, okay, and there is intrauterine pregnancy with dilated cervix. What is the likely diagnosis? In the question it is not written. Bleeding is there, but it is not written that products have been expelled out. So this type of abortion is an inevitable abortion. If it is written as cervix closed and ultrasound is done and the cardiac activity is present, I would have marked the threatened abortion as my answer. So treatment for this is D and E using the ovum, forceps followed by curettage. Fine. Ovum, forceps followed by curettage. Now next, true about obstetrical conjugate. Okay. So this is the symphysis pubis, upper border, midpoint and lower border, and this is the sacral promontory. So upper border to sacral promontory is true conjugate or anatomical conjugate, which is 11 centimeter. Midpoint to sacral promontory is obstetrical conjugate 10 centimeter. Lower border to this is diagonal conjugate 12 centimeter. Clinically we can measure diagonal conjugate. So like obstetrical conjugate is posterior border of symphysis pubis to the sacral promontory. Actually the correct point they should write is midpoint of symphysis pubis to the sacral promontory, and it is usually 10 centimeters. Fine. Now next is, what is the true statement about Mirena? Mirena is levonorgestrel releasing IUCD. Okay. It contains 52 milligram of levonorgestrel and releases 20 micrograms per day. Yes. So Mirena, it contains 52 milligram of levonorgestrel and release 20 micrograms per day. It has got effective period of 5 to 7 years. So this is wrong. It causes reduction in dysmenorrhea. This is correct. It is safe to use in breast cancer. No. Progesterone releasing contraceptives are not very safe in being used in the breast cancer patient. It can be used as emergency contraception. Wrong. So 1 and 3 are the correct answers. Fine. Now friends, what are the high or low parameters markers in Down syndrome? Okay. So this is what is the value given for a triple test. Now you can write your answers. Triple test is done in the second trimester where you take the maternal blood and do the markers. So what is your correct answer? You can write down in the chat box. So it is alpha fetoproteins, beta HCG and unconjugated estriol which has been done. So trisomy 21 and trisomy 18. Trisomy 21 alpha fetoproteins are decreased. You can write down your answer in the chat box. I am reading the chat. Dr. Dhar, Dr. Jack, Dr. Mrinmoy Dhar, Dr. Jayansh, Dr. Apurva. You can write down your answers in the chat box. So this is the correct answer. Okay. So it is high beta HCG, low alpha fetoproteins and low unconjugated estrogen. Okay, so this is a triple test. Now 38-year-old G3P2 patient with 20 weeks gestation, antenatal clinic with recurrent UTI. There is a history of cesarean section in the previous pregnancy. 4.6 kg baby was delivered and her blood sugar levels is 50 and 50 grams of glucose, it is 300. So it is already diabetic this time also. There is no, urine shows large amount of bacteria. What are the complications that can be present? Neonatal hypoglycemia, okay, chorioamnitis. So since it is already 20 weeks, so these things must have been ruled out. Now fetal hyperglycemia and macrosomia. So this is the correct answer to this question. Okay. Next, I am not going into very much details about this. You can read it because it is a long session. Now in medical abortion, the composite drugs are used. What are your answers? What have you marked for this? Medical abortion. Friends, it is mifepristone 200 milligrams oral. After a gap of 48 hours, it is tablet misoprostol 800 micrograms vaginal. Okay. So, this is the correct answer. Fine. You are an intern posted in OBGY. G3P2 woman comes with telling her that she has collapsed after attack of seizures and previously diagnosed as hypertensive. You administer the loading dose of magnesium sulfate. Which of the following reason is for omission of magnesium sulfate? Loading dose, you give it IV plus IM. That is 4 gram 20% magnesium sulfate and 10 gram 50% magnesium sulfate, and then you have to give maintenance. So, after this 4 hours, you have to check the knee jerk respiratory rate and urine output. Knee jerk has to be present, respiratory rate should be normal, and urine output should be more than 100 ml in 4 hours. So, why you have omitted this maintenance dose? Because there is absence of tendon reflexes. So, what you expect is magnesium sulfate toxicity. And what is the first sign of magnesium sulfate toxicity is disappearance of knee jerk. So, I have to replace it by the second line of anticonvulsant, that is injection phenytoin. Fine. Next. G2P1 woman comes to you at 12 weeks of gestation and this ultrasound is showing. This is straight away the frog eye sign which is seen in anencephaly. Okay, that is seen in anencephaly. Now, this is the cells of the histological profile. This is superficial cells. Okay, these are intermediate cells. These are the basal cells and these are the parabasal cells. So, superficial, intermediate, basal and parabasal cells. Fine. This is on the cytology, vaginal cytology. Fine. Next. Which of the following is done for ovarian reserve? Ovarian reserve, that presence of follicles, that is a test for ovarian reserve. This we do it in cases of infertility where there is diminished ovarian reserves. Okay. So, what are the investigation we are going to do is FSH levels, LH is not done. Okay. Inhibin is done, clomiphene challenge test, anti-Mullerian hormone, and which is the best investigation? Best is the anti-Mullerian hormone for ovarian reserve. Progesterone levels are also not checked, antral follicle count, estradiol. So, serum beta HCG is not checked. So, correct answer is 1, 3, 4, 5, 7 and 8. Okay. And the best is the anti-Mullerian hormone. Fine. And what is the treatment for diminished ovarian reserve is doing IVF using donor oocytes. Treatment is doing IVF using the donor oocytes. Fine. Which HPV virus is responsible for cancer cervix is 16, 18, 31, 33, 35, 39, 45, 58, 59 and 68. Okay. So, nowadays there is Gardasil 9 which is a nonavalent vaccine that is available. This is against strains HPV 6, 11, 16, 18, 31, 33, 45, 52 and 58. So, hope this session was useful to you. Keep revising and you can review this discussion later on also. So keep revising and you can always ask your doubts. Okay, so stay connected. Bye-bye from my side, and it was really wonderful taking your session. Fine. So now the subsequent sessions will be of the PSM and the medicine.
Hello, my dear friends. A very warm welcome to all of you. Let's start with the discussion of the questions. This is the first question of the logo of Niti Aayog, and they have asked which organization it replaced in the past. So Niti Aayog replaced Planning Commission, I hope you know, and the full form of Niti Aayog is National Institute for Transforming India, NITI. Okay, so it replaced Planning Commission, National Planning Commission, and it is National Institute for Transforming India. It is a think tank which give idea to government, give technical advices to government also, but it do not give any advice on referral service complex of India or government health system directly. Okay, so from 1950 till 2014 there was National Planning Commission who used to make 5-year plan and develop India, and it has all corrupt people of Congress in it. So when BJP came into power, they said, hey, all you corrupt people of Congress, go away. Now our corrupt people will work, and they replaced Niti Aayog with Planning Commission with Niti Aayog. The next is that there is a blood spill on the floor which can be used to disinfect it. Whether it's normal patient or HIV patient, we always take it as HIV positive and we wash it with 1% sodium hypochlorite. 0.5% sodium hypochlorite is used for wiping surface of table or doorknob. If you have a COVID patient, you have to wipe those surface by 0.5% sodium hypochlorite. 70% ethyl alcohol can be used for hand wash, but remember, we don't do hand wash we don't do sanitization. Hand sanitizer we use it, but we don't sanitize our hand if it is visibly soiled. And this has been asked 2 times in NICT. If you can see some soil particle on the hand, then there is no use of sanitization. Then you have to wash your hand with soap and water, of course. Okay. Now, a researcher is studying the difference in the incidence of asthma in children who are exposed to second-hand smoke and those who are not. If he wishes to express the incidence of asthma in exposed children as a percentage, which of the following should be used? So, they basically want you to know the definition of RR, AR and PAR properly. Here, when we talk about relative risk, this is incidence in exposed by incidence in non-exposed. Okay, for example, let's say children who are living in people in contact with living with people who are a smoker, suppose they have 4 times more risk of asthma than children who are not living in contact with a smoker. So it is 4 times more. That means relative risk is 4 times more in children who are living with smoking people in exposed. So relative risk we take in exposed. Similarly, when we talk about attributable risk, it is incidence in exposed minus incidence in non-exposed by incidence in exposed multiplied by 100. And whenever we talk in AR, let's say it came that 50% asthma is due to relatives who are smoking, okay, is due to living in close contact with a smoker. So it is due to smoker in the family, smoker family member. But in which group this is 50% asthma? This 50% asthma is in exposed group. For example, let me give a good example to explain it properly. Suppose there are 2 group of people, one who are alcoholic driver and one who are non-alcoholic driver. And we are doing a cohort study in which we follow them in future, and we found that out of 100 alcoholic driver, suppose let's say 80 have accident, and out of 100 non-alcoholic driver, let's say suppose 20 have accident. So first thing they ask is relative risk, which is so simple to understand. Incidence in exposed by incidence in non-exposed. We can simply understand how many more accident occur in alcoholic driver, because alcoholic driver are the exposed. These are non-exposed. So how many more accident occur in alcoholic driver? It's quite simple. 80 by 20 or 4 times more accident in those who drink and drive. When it comes to attributable risk try to find out that what is the incidence in exposed minus non-exposed. That means how many extra accident occur due to drink and drive. 80 will anyway occur. 80 is occurring in alcoholic driver. 20 is occurring in non-alcoholic also. So how many extra accident are due to drink and drive? You can see 80 minus 20, 60 extra accident are due to drink and drive. So this is incidence exposed minus non-exposed. And this 60 extra accident which occurred, we compare it with total people who were developing disease among exposed, total accident among exposed. So total accident among exposed was 80. This is the incidence in exposed multiplied by 100. So that means attributable risk tell us that how many extra accident occurred in percentage basis, how many extra accident occur among those who were doing drink and drive. So if you do 60 by 80 into 100, it will be 3 by 4 into 100 or 75% extra. So this 75% extra is in which group? Is it in the whole population or is it in the exposed? So this 75% extra is only among exposed. This is not in the whole population. You can see 80 is 75% more than 20. And it is 75% more. You can say it is 4 times more than 20. So that's why how many extra occurred in exposed, that we detect by attributable risk. And the last thing which we have to remember, the formula of PAR, which is incidence in whole population minus incidence in non-exposed by incidence in population multiplied by 100. So whatever PAR will come, we will write PAR in population. PAR is calculated in population, but RR and AR is calculated in exposed group. In those who are doing dangerous work, how many extra case occurred due to that work, that is attributable risk. And how many time extra accident occur in drink and drive, that was relative risk. Okay. So remember, when we talk PAR, only then we talk about whole population. And in this question, we were talking about incidence of asthma in the exposed. So because it was in the exposed, so PAR cannot be the answer. Relative risk talks about time. Whenever they will give question about relative risk, they will use the word time. And whenever they will use attributable risk, they will probably use due to. Like in cigarette packet, it is written, smoking causes lung cancer. Cancer is due to smoking. So they are talking in terms of attributable risk. And whenever they will use PAR, they will use the word decrease by. That if people stop drink and drive, accident will decrease by, let's say, 50%. Okay, so this is the way to identify that. And they have asked it in recent 2 times to identify the correct formula and to do questions based on that. So please do revise these 3 formula again and again before exam. A healthy person get into contact with an infected case and they have to separate him for no more than incubation period. Up to incubation period, we do quarantine. What is quarantine? Quarantine is done on healthy people, like here, healthy people whom we are suspected that they are infected. Healthy people suspected of carrying infection. Okay, let's say your friend Rahul went to New Zealand to meet his girlfriend there. And at New Zealand airport, people think that Rahul might be carrying chickenpox virus in his body. So he will be quarantined till the maximum duration of appearance of symptom will pass away. जब तक दाने निकलने का जो मैक्सिमम टाइम है, जो 14 से 16 दिन है, वो पार नहीं हो जाता है, तब तक उसको अलग रखा जाएगा. Till the appearance of symptom duration is passed away, till then he will be quarantined. So this is incubation period. What is incubation period? This is the gap between entry of pathogen and appearance of first symptom. है ना, आपके अंदर कीड़ा घुसा या मेरे अंदर कीड़ा घुसा और मुझे खांसी आई, पहला सिम्टम आया, उसका जो गैप है, दैट इज इंक्यूबेशन पीरियड. एंट्री ऑफ पैथोजन एंड फर्स्ट सिम्टम, दैट गैप इज इंक्यूबेशन पीरियड. सो वी विल कीप द हेल्दी पर्सन इन क्वारंटीन टिल maximum duration of appearance of symptom pass away or till incubation period pass away. Okay, so suspected of carrying infection, what we do, healthy people suspected of carrying infection, till incubation period we do quarantine. Okay, till incubation period we do quarantine, but isolation is done till they will infect other. Till period of infectivity or communicability we do isolation. For example, let's say Rahul is now in the quarantine for 16 days, which is maximum duration within which rashes of chickenpox occur. And at 15 days, suppose, rashes start appearing in Rahul. So now he will be kept in isolation for 6 more days. That is the isolation period for chickenpox being asked in NEET last time, 6 days. So for 6 days, he will be again kept in that airport, because in that 6 days, he can infect other people with chickenpox. So 6 days is the period of infectivity. Till infectivity period, we do isolation. And isolation, of course, is done on people who have the disease. So on diseased people, we do isolation. On healthy people, we do quarantine. And do remember that quarantine till incubation period, isolation till infectivity period. Now, which of the following statement describe Lakshya under National Quality Assurance Program? So, in Laksh logo, you can find a black color child with a black color mom. And Laksh is only focused on improving facility-based quality care around birth, which normally takes place in labor room and maternity room. So, it's basically improve the facility of labor room maternity ward. This program to promote cleanliness, hygiene and infection prevention, this is known as Kaya Kalp. Kaya Kalp means magical transformation. This program focus on improving hygiene in government hospital. This ICT centers is there, but it is not related with Lakshya. So do remember, if you find black color mother with black color child, this is Lakshya. If you find white color mother with white color child, white means in a way we consider it as foreigner. So this is baby friendly hospital initiative, which is WHO guideline. If you found a blue color mother with blue color child, that is UNICEF. If you found a white, blue, black, we discussed. Now, if you found a yellow color mother with yellow color child, that is Janani Sishu Suraksha Yojana. Sishu, remember, who keep on doing susu? And a Sisu means infant less than 1 year. So because infant is there who keep on urinating, so the logo is yellow color. Yellow color in JSSY. And if you found a logo which the mother and child both incomplete, then that is the logo of PM Matru Vandana Yojana. It has been launched, but actually not implemented in most of the state. So it is still incomplete program. That's why it is PM Matru Vandana Yojana. You will find incomplete mother and child like this incomplete program. Okay, so these are the 5 logo which commonly asked. Do remember them and identify them easily. Now, in the HIV sentinel surveillance, which of the following is not included? So HIV sentinel surveillance is done in 3 group. One is high risk group, other is bridge population, and third is ANC mother. In the high risk group, 4 people come. Do doctor come in high risk group? No, doctor do not come there. You have not performed that well. Huh? Sex worker come in high risk group. Then intravenous drug user come into this group. Male having sex with male come into this group. And all the transgender come into this group. 4 people in high risk group. In bridge population, only 2 people come. One is long distance truck driver. Oh, main nikla, gaddi leke, ting 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 ting. That one. And second is single migratory worker. Okay. So these 2 are in bridge population, and then finally there is ANC mother. So in HIV sentinel surveillance, we try to know trend of HIV in different state. Suppose I want to know in Bihar or in UP, HIV is increasing or decreasing. So what I will do is every year I will test 250 people from high risk, 250 from bridge, 400 from ANC mother. And suppose last year it was 0.3, this year it was 0.26. It means HIV is decreasing in those areas. So sentinel surveillance has 2 components, active and passive. Active means people will go to them and will search for hidden case. So active surveillance will be done in high risk group and bridge population. But ANC mother, they will come by themselves to the hospital. So they are passive. They are coming by themselves. So passive is, do remember, passive is for notified case. Notified case are those cases which come by themselves. Active surveillance is for hidden case. This question has been asked in FMGE exam in a different way, that who make malaria slide? So malaria slide is made by MPW. But second question in the same exam was, does MPW make malaria slide by active surveillance or passive surveillance? So MPW visit every house of the village once in 14 days and search for fever case. If he found any fever case, he will make 2 blood film from their blood. So he is searching by going into their house. So that is active surveillance. So remember that hidden case are detected by active surveillance. Active surveillance is for hidden case. Passive surveillance is for notified case. And if you mix active and passive, that becomes sentinel, and sentinel is for all cases. Okay? So do remember this 2-3 extra point. When we test ANC mother, we test them by opt-out strategy. And when we test bridge population and high-risk group, we test them by opt-in strategy. And you understand now? Like, let's say I am a transgender. You came to me. Why? To take my blood sample. So you will first ask for my permission. You will say ki, kya main le lu? So I will say ki, le lo, take it. I opted in. I gave you my permission. That is opt-in testing. But in ANC mother, we don't take permission because there is too many ANC mother, difficult to explain. But if she does not want to be tested, she can opt out. If she opt out, she will not be tested. So what are the people which we include? Do remember 7 people we include. Sex worker, IDU, MSM, TG, and these 3 people. So that means sex clinic attendant do not come under it. Option D is correct. Injection drug user, female sex worker come, but sex clinic attendants do not come. As Gynae ma'am was also teaching, they will go to Suraksha clinic. Suraksha clinic logo will be confusing with Red Cross, but this is Suraksha clinic, this is Red Cross. Red Cross is completely filled, Suraksha clinic is like this. Suraksha clinic is for STD patient, sexually transmitted disease patient, and sex clinic attendants. Okay, do remember. Now, next question. A 25-year okay, my dear Jack Sparrow has 2 questions from me. First question, what was the answer of previous question? So we have given the answer in this question. If he wishes to express the incidence of asthma in exposed as a percentage. So because it is talking about in the exposed, it cannot be population attributable risk, because population attributable risk is for whole population. And if they are using relative risk, they will be using the word time. How many time more? So it is also not relative risk. This is attributable risk in this question. And in odds ratio also, you will find the same word time. Odds ratio has this formula AD by BC. It also means chance of disease in exposed by chance of disease in non-exposed. Okay. So do remember, relative risk and odds ratio both are represented by time. Like they will say that don't smoke. Smoking increases risk of cancer 20 times more. So time word is used for relative risk odds ratio. Okay, so in this question that was there. Now let's come to the next question. Second trimester is the visit. How much calorie more she should take? Answer is 350 kilocalorie. Actually 342 kilocalorie needed in second trimester. And 460 kilocalorie per day is needed in third trimester. This is being written in guideline of ICMR, but if asked in pregnancy, how much extra? 350 kilocalorie extra. In lactation, how much extra? 600 kilocalorie extra. Second question, if a mother is having vitamin A deficiency, let's say they are not eating carrot and papaya due to abortifacient, and a villager say that papaya can cause abortion, don't eat it. So they are not eating it, causing vitamin A deficiency. Who will screen them and will take them to higher center for treatment of vitamin A deficiency? Answer is ASA. ASA screen mother and children at home and refer the mother or treat the mother for their illness. So screening and reference is not done by Anganwadi worker, it is done by ASA. And this is the calorie extra. Other than the calorie, they can only ask about calcium. Do remember, in pregnancy, the calcium is 1000 milligram. In lactation, the calcium increases to 1200 milligram. And in old age, this remains the same 1200 milligram. So in all these 3 things you have to remember, 1000 in pregnancy, 1200 milligram in old age and lactation. Okay. Now, choose the vacancy which can be used in the next day vaccination. So that means they are asking about open vial policy, because some vaccine can be used up to 4 weeks of opening the vial if they are stored adequately between 2 to 8 degrees Celsius in ice-lined refrigerator, which is shown here. This is the image of Iceland refrigerator. So what are the vaccine which follow open vial policy? Very simple to remember. First remember all vaccine with T. Then remember all polio vaccine. Then remember the pneumococcal conjugate vaccine and fractioned IPV. Only 4 vaccine, they follow open vial policy. Now, what are the tetanus vaccine? You all know DT, TT, DPT, pentavalent. What are polio vaccine? We already know PCV, OPV and FIPV. So OPV, FIPV occurred here. Now along with PCV, the last vaccine which follow it is hepatitis B. So it's so simple to remember. Just remember Hep B, PCV, all tetanus, all polio. And these follow open vial policy. That means when you opened it, still you can use them in the next session. So what can be used in the next session? We cannot use BCG in the next session. We cannot use measles in the next session. So measles question is gone. BCG is also gone. That means only option D, Hep B, DPT, PCV, OPV. This follow open vial policy. So this can be used in next session. Okay. We cannot use MMR in the next session. Next question. The oral glucose tolerance test to diagnose diabetes involve the intake of. For the oral glucose tolerance test, we take 75 gram of glucose in 250 ml of water. Remember, gestational diabetes is best diagnosed in second trimester of pregnancy. But this is OGTT, which we can do some other time also. But best time is second trimester. And how many minimum ANC visit occur? 4 is the minimum ANC visit. If they ask the minimum ANC visit by WHO, then you will answer 8. Otherwise, you will answer 4 only. Now, which type of glucose test we do at subcenter? Random or fasting? We only do random blood sugar because it's difficult to take fasting in villagers. So that is there. 30 cases of influenza-like illness were reported and diagnosed to be COVID in city X, and no case of COVID-19 were ever seen in city X in past. Sunil, a 30-year-old male, was the first case who reported the symptom and was diagnosed to be COVID-19 positive at the city hospital. Who is Sunil? Sunilwa kaun hai? Samjho. What they are trying to say is that Sunil came first to OPD. So Sunil is definitely a primary case because he came first. No. Sunil is a index case. This is the question. They want you to understand index and primary case difference. Index case means first reported case. And primary case means first case. Suppose I went to China and I develop hantavirus infection there. Hantavirus is transmitted by rat. Okay, I should have asked it from you. So hantavirus infection occurred in me and I came to Delhi and I met with my brother Golu. He is also Gol. And I infected Golu with hantavirus and then I went to Kerala to take class. So Golu will be reported to Delhi authority and Golu will be the index case because he is reported. But who is the primary case? I was the primary case. So primary case is not necessarily reported, but index case is first reported. Okay. Now let's question. A 50-year-old sugarcane mill worker will have which thing? Bagasosis. Bicyanosis occur in cotton mill worker. But along with this, please remember that bagasosis also occur in cardboard factory worker. Cardboard factory worker also develop it. And who is the causative organism, they ask. So the causative organism is thermoactinomycetes. Thermoactinomycetes fani is the causative organism of bagasosis. They ask it. Who is the causative organism of farmer lung? Which of course occur in farmer. So farmer lung causative organism is Micropolyspora fani. Do remember this causative organism. Most common respiratory occupational disease is silicosis. And of course, in asbestosis, a special type of cancer occur, which is mesothelioma cancer of lung pleura. This special cancer occur in asbestosis patient. Chalo. Next question is false about panel discussion. So, in panel discussion, 4 to 8 qualified persons sit and discuss topic. This is definitely correct. Panel speaker introduce themselves to the audience and start the discussion. It's not necessarily true. They don't introduce themselves. This is actually wrong. They don't introduce themselves. There is a common person or an introducer who is there. He introduces everyone to the audience. And there is no specific agenda, no order of speaking. This is also wrong for panel discussion. Actually, the topic is predefined, and on predefined topic they talk. There is predefined topic on that. Okay. So their agenda is pre-decided. And on that common topic, 4-6 expert, 4 to 8 expert, they talk about it. After the talking, audience question are taken. So this is panel discussion. And how panel discussion is different from symposium. See, in panel discussion and symposium, main difference is, in symposium, question is taken only at end. Question at end. But in panel discussion, question can be taken after each speaker. After each speaker, if we are taking question, that is a better thing. So that's why panel discussion is better. And in panel discussion, definitely, the order of speaking is not fixed. Anyone can speak based on their interest in the topic. Okay. So, what is the difference between these two? Panel discussion is better one because we can ask question in between, and in panel discussion, as I said, there is no order of speaking. Anyone can speak after one has finished speaking. Anyone can give their idea in between. But in symposium, question at end, and in fixed order, the speaker give their opinion. Of course, this last option, 6 to 12 participant, they are needed for FGD. So this is correct statement about FGD. It has nothing to do with panel discussion. But this question has been came in previous year. So I replaced one option and I put this line because it is being previous year asked question that in FGD how much participant we need? 6 to 12. So in this question, both option B and C will be false. But if I will have to choose one option which is the more wrong option, I will choose B as more wrong option. Panel speaker, they don't introduce themselves. There is a common person who introduced the topic and the speaker. And of course, in panel discussion, there is no order of speaking. So this part is correct. Of course, agenda is usually decided, but they can divulge from the agenda. Agenda is not hard fixed. And they can discuss something, and then let's say they are discussing about in improving health of people, and they can shift to the funding by government, and they can shift to other topic while discussing it. So it's the one option which is definitely wrong is B. D, A is definitely correct. C is partially correct. Next question, what is, if we are using iodized salt in iodine deficiency control, which level of prevention it will be? So primordial is done when there is no risk. That is primordial. And of course, there is a risk of iodine deficiency disorder. That's why we are mixing iodine in the salt. So it cannot be primordial, it is primary prevention. And in place of primary prevention, if they have given the option specific protection, then specific protection would have become the better answer. If both are given an option, you will choose a specific protection. Secondary prevention means early diagnosis and treatment. And tertiary prevention means we are trying to do disability limitation and we are giving the job back to the person. So disability limitation and rehabilitation is tertiary prevention. So let me ask you the question which came from this relevant topic in last 2 years only. One question which was given is that they had a filariasis patient foot as figure, and they ask filariasis patient foot care will be under which example. So this is disability limitation or rehabilitation. Filariasis patient foot care or diabetic patient foot care. Second question they ask is, a son took his hemiparesis father for checkup. So hemiparesis father is taken, but not for physiotherapy, for checkup. And checkup means early diagnosis of second attack, or they want to know whether the antihypertensive medicine which is given is adequate or not. So it is done here for early diagnosis and treatment, so it will be secondary level. But if they ask hemiparesis father for physiotherapy, so physiotherapy is done to make the person self-dependent. That is rehabilitation. Rehabilitation means making the person self-dependent. So it will be tertiary level of prevention. Physiotherapy tertiary level, but checkup will always be secondary level. Okay. If you have any other question regarding this topic, you can ask it in the chat box. Don't hesitate in asking your question. Okay. So that is there. Now, what does this line below represent? That is radiation symbol. Biohazard symbol will be like this. And there will be, I cannot draw it properly, but you can Google it. There will be this type of multiple tooth like thing here. And this is biohazard type sample. This is biohazard symbol. Okay. Cytotoxic waste will have C written over it as cytotoxic waste. What is the first step to be taken after disaster? So after a disaster, first thing which we do is response. We try to rescue the people. We try to rehabilitate the people. After rescue and rehabilitation, we do reconstruction of building. After reconstruction, we do mitigation. Mitigation means decreasing impact of future disaster. Like planting trees and other thing can do the mitigation. It will decrease future disaster. After mitigation, we have preparedness. And after preparedness, of course, whether we are prepared or not, there will be next disaster. So how can you remember it? Very simple. Just remember it. RRR, triple R went to MP. Why they went to MP? To saw some Ajanta, Ellora Gufaye, some idol picture there. They went there. So rescue, rehabilitation, reconstruction, then mitigation, then preparedness, and then there is next disaster. These are the steps. Now one major question is from the vaccination during disaster. So remember that there are 3 vaccines, tetanus, then cholera and typhoid. These 3 vaccines is given to health workforce, like doctor and all who will go to rescue people. Health workforce will get these 3 vaccines, but no vaccine is given during disaster. No extra vaccine to common people during disaster. No vaccine during disaster to common people, to adult, common adult. And it is to adult population affected. These 3 vaccine is only to health workforce. Why? Because most of the vaccine give immunity after 3-4 months. So there is no point of giving vaccination during disaster. But again, from here MCI exam ask one question, that measles vaccine which vaccine induce immunity before appearance of symptom? यानी मीजल्स के सर्दी खांसी बुखार वगैरह आने से पहले, मीजल्स का बुखार वगैरह आता है 10 से 14 दिन पे, और टीका लगता है तो उससे जो सिपाही बनते हैं, एंटीबॉडी बनते हैं, वो 7 से 8 दिन में बन जाते हैं. मीजल्स वैक्सीन गिव इम्यूनिटी in 7 to 8 days. immunity come in 7 to 8 day, and the disease symptom appear at 10 to 14 day. So that means measles is the only vaccine which can induce immunity before appearance of symptom. But still we don't give measles also during disaster. Why? Because during disaster, nurses, doctor are in less number. If we will engage them in vaccination, who will save life? And anyway, measles is not a common disease during disaster. Most common disease during disaster is charchari, gastroenteritis. Okay, the musical sound which comes in gastroenteritis is charchari. Okay, na? So that is most common disease. Do remember all these question which I am writing has been asked in previous year. That's why I am writing it. Very important area. Next question. What is the minimum period of commitment of providing additional support to TB patient? This additional support to TB patient is given by Nikchay Mitra. This is a new thing which has started. So I thought let's give one question which has not been usually taught. Nikchay Mitra. These are the funders. These are the local people, MP, MLAs and other people who funder for some money if TB patient is unable to work and all. They will fund them and they will help them. So they will fund them and help them for 1 year. This is Nikchay Mitra. Then there is one more program, Nikchay Poshan. I hope you all know in Nikchay Poshan, 500 rupees per month is given. Why it is given? For Poshan. Poshan means nutrition. Full form is Prime Minister Overarching Scheme for Holistic Nutrition. So 500 rupees per month given for nutrition to TB patient. Okay, if you divide 500 with 30, it will come 18 rupees. What comes in 18 rupees per day? Small t, small gold fleck. But anyway, at least something is given. So that is there. After Nikchay Poshan, they can also ask about Nikchay and Nischay. So Nischay means to be sure of. And Nischay is a Hindi word which means to be sure of. So in Nischay there is this pregnancy detection kit, urine pregnancy detection test kit for by ASA. ASA distribute this test kit. And Nikchay, Nik means no, Chay means loss of body. Loss of body occur in tuberculosis. So Nikchay means no TB, in which private and government doctor report and follow up TB patient. So if you are a private practitioner and a patient of TB came to you, you can refer that patient by Nikchay app to government hospital and you will get 500 rupees for referral also. So that is Nikchay, Nikchay Poshan, Nikchay Mitra and Nischay. 4 confusing thing which you should clarify. Okay, similarly, sometimes they ask the confusion is between Ujjwala and Ujjavala. Like in recent exam they have asked it also. But it's very simple to remember it. The simple way is, there is a jaw in Ujjavala. Jaw. And what is the function of jaw? Jaw capture food and eat it. So similarly, Ujjavala has a jaw to prevent child trafficking and help in their rehabilitation. So this is for preventing child trafficking and their rehabilitation. But Ujjwala is free LPG cylinder with one-time gas for BPL family people. This is Ujjwala. Ujjwala and Ujjavala is clear. Last confusing question they can ask is, what is Indradhanush scheme? And I think there is a question regarding that. There is no question. There is no question. Yeah, this was the question. This is Mission Indradhanush. Mission Indradhanush was started earlier for 7 disease. Very easy to remember. 3 are DPT. 3 are those which are done at birth. BCG given at birth. BCG, OPV, Hep B. And for these 3 vaccines which are given at birth, ASA don't get paid. Because ASA get paid for motivation. And at birth, mother and mother-in-law are in the hospital. So the ASA is not getting paid. Because whom she will motivate at home? There is no one at home. Whom she will motivate? Sasurji. There's no one. So she do not get paid for these 3 vaccine. But she get paid for all other vaccine. Although vaccination is not theoretically a work of ASA and Anganwadi worker, but ASA are paid as motivator. So DPT and 3 are these, and the last disease is measles. 7 disease they started Indradhanush, but now mission Indradhanush is no more. It is intensified mission Indradhanush which is there. And in intensified mission Indradhanush, we have this 3.0 now, same as 2.0 but just updated version. It is covering all vaccine of national immunization schedule. All the vaccine are covered under it. Third thing is the main thing which I was asking, what is Indradhanush scheme? I am not asking Indradhanush mission. I am asking Indradhanush scheme. Scheme is changing bed sheets. 7 day, 7 different color bed sheets. 7 days, 7 color bed sheet. Where? Not in your bedroom. In government hospital. 7 days, 7 different color bed sheet. That is Indradhanush scheme. Okay. Chalo, do remember it. Now, coming on to the next question. Which of the following is best measure to control housefly or mosquito? If they give best measure, always remember best measure is vector control. Don't let them take birth. Vector control. If they ask best method for rural malaria control, in rural malaria control, best method is intermittent irrigation. What does it mean? Intermittent irrigation means, you must have seen कि in the field of rice, farmer leave this much water together. So government said, don't leave this much water, put a less amount of water for 4-5 days, let it get absorbed, then again 4-5 days small amount of water, then again 4-5 days small amount of water. So this will prevent water wasting, and this will prevent accumulation of mosquito in that accumulated water, and it can decrease malaria cases in rural area. So this is the government guideline, best strategy for rural malaria control. Okay. And breeding place prevention is the best for all kind of malaria and all kind of housefly breeding prevention. Population covered by PSC in plain area is 30,000, not 20,000. 20,000 is for hilly area. Okay, this is for hilly area. Do remember, this 2 point has been already asked in FMGE exam. Sub-center is at 3,000 population and 5,000 population. Hilly area, plain area. And CHC is at 80,000 to 1 lakh population in hilly area, 1 lakh to 1.2 lakh in plain area. Okay, so these are the population norm which you have to remember for sure. Okay, next question is a pregnant woman come to, one more update I want to give. Sub-center can be type A, type B. If it is type A, there is no delivery on it. If it is type B, we can conduct delivery. So type B is better. Similarly, PHC I said can be 20 or 30,000, and PHC can be type A, type B. Type A PHC is when there is less than 20 delivery per month. And type B PHC is when there is more than 20 delivery per month. Okay. CHC they say type A is the one where there is less than 100 delivery per month, and type B is the one where there is more than 100 delivery per month. So always remember, type B is the better version. Okay. A pregnant woman come to PSC for regular follow-up during her second trimester. What is the, which of the following we prescribe? So do remember that prescription is given. She will get a red tablet, red color tablet of this 60 milligram elemental iron, 500 microgram folic acid. This is the same dose which is given for adolescent, which is 10 to 19 year. They get blue tablet once a week. And this is the same dose which they get there in adolescent. Okay. So these are coming from Anemia Mukt Bharat, and a question from Anemia Mukt Bharat in recent MCI exam was, what is the target of Anemia Mukt Bharat? The target of Anemia Mukt Bharat is to reduce anemia each year by 3%. How much? 3% less anemia each year. And this is the dose which we give to adolescent, to pregnant mother, to adult female also same dose is given, and to lactating mother also same dose is given. Only one extra dose you have to remember is 45 milligram iron plus 400 microgram folic acid. This is given for 5 to 10 year children, and they will get red tablet once a week. Just like adolescents are getting blue tablet once a week, they will get red tablet once a week. One thing, in one age group, we give the drug dose twice a week. And in which dose age group we need to give minimum dose? Of course, in infant we need to give minimum dose. So in infant we give 20 milligram iron, 100 microgram, not only in infant, up to 5 years. We give 20 milligram iron, 100 microgram folic acid, twice a week, 1 ml IFA syrup. And up to which age group it is given? It is given from 6 months to 5 years. Very simple to remember. If you multiply 20 with 5, it is 100. So 20 iron, 100 microgram folic acid twice a week in infant. 45 400 in children. 6500 in all other age group. So only 3 doses. 2000, 45 400, 6500. Okay, yes, very good, Praveen Panwar, you are right, 1 to 5 year. Yogi Adityanath was also right, of course. How can he be wrong? You know, he is our chota fenta. Come, what is the minimum recommended amount of free chlorine in water? Free chlorine in water, minimum recommended amount. That is known as minimum recommended amount is the residual chlorine. Do remember in this previous MCI exam, they have asked the concentration of fluorine in water. Fluorine need to be 0.5 to 0.8 and chlorine need to be 0.5 to 0.7 in drinking water. So simple, 0.5, 0.8, 0.5, 0.7. And so it's very easy to remember these normal doses in drinking water. So residual chlorine should be 0.5. And which apparatus detect residual chlorine? It is detected by chloroscope. Under chloroscope, there is 2 tests which we do, orthotoluidine and orthotoluidine arsenite test. And in both of the tests, remember OT and OTA both detect free and combined chlorine, both. In orthotoluidine and orthotoluidine arsenite, both free and combined chlorine are detected. They have asked it in MCI exam 3 years back. That does orthotoluidine detect free chlorine, combined chlorine, or both? Answer is both. Only difference is orthotoluidine detect it together detected, and orthotoluidine arsenite can separately tell how much is free, how much is combined. So they also detect both but separately. And of course, we want separate detection, so orthotoluidine arsenite is better. Okay, so this is a better test, OTA. There is an extra word also, so that is better. Next question. Which of the following will best represent the trend of malaria? Can you answer this question? How do we detect trend? Please answer this question if you can. Pie chart is used to explain this balanced diet to layman. And this pie chart is also used to represent causes of maternal death in India, causes of infant death in India and all. Histogram can represent frequency distribution. Histogram is for quantitative data. Bar chart, of course, you know, but there are 3 types of bar chart. One is this simple. One is this where we have one above another. This is known as component bar chart. This is simple bar chart. But if you have this type of bar chart where the bars are adjacent to each other, This is known as multiple bar chart. So there is 3 type of bar chart. This is component one above another. This is multiple on the side of each other. And this is normal bar chart. But in one of the exam of MCI, they asked this question. They gave this type of image 1, 2, 3, and then there was a gap, then 1, 2. And they asked, what is this? Is it multiple bar chart component or simple bar chart? Answer was, this is definitely histogram. Why it is not multiple bar chart? Because in multiple bar chart, you can see gaps come again and again. But in histogram, gap do not come again and again. Second thing is, in multiple bar chart, the gap will come after fixed number of bars. Like after every 2 bar, there is a gap. But in histogram, there is no fixed pattern. So that is histogram. And very good trend is represented by line diagram. The best example of trend is secular trend. Secular trend means constant increase or decrease in number of cases over a long period of time. And example of secular trend, they ask, this is cardiovascular disease. Cardiovascular disease or cardiovascular death cases, they represent secular trend, because we all know cases of cardiovascular disease are constantly increasing all over the world. So that is secular trend. Secular means constant increase in number of cases. Okay. Chalo. Very good, Yogi Adityanath. You are again right. R is also right. Akash Fuljale, Praveen Panwar, all of you are right. Very good. Very good, Yogi Adityanath. You have really worked hard. Not on your hairs, but on examination question, you have really worked hard. So next question. Which of the following vitamin is given as prophylaxis at the time of birth? We give vitamin K at the time of birth because vitamin K is deficient in mother milk. They ask this question again and again. Vitamin D and C are in less amount, but they are not deficient. Vitamin K is deficient. Vitamin C is deficient in egg. Egg don't have vitamin C. Okay. And regarding vitamin B1, remember, if anyone is alcoholic person, they must have been deficient in vitamin B1 after a long time of alcoholism. So delirium tremens, confabulation, Korsakoff's psychosis, that means, and Wernicke's encephalopathy, all are treated with vitamin B1. Do remember the mnemonic GOA for Wernicke's encephalopathy, because it has been asked in NEET exam recently. Wernicke's encephalopathy will have 3 things in it. G for global aphasia, O for ophthalmoplasia, and A for ataxia. Okay. So this is the 3 things which occur in Wernicke's. Do remember this triad. Next, let's move ahead. And do remember, along with alcoholic, they have asked in NEET exam that a population is eating polished rice. So if anyone eating polished rice, they can develop beriberi, which can be of dry or wet character. Dry beriberi will have neurological symptom, wet beriberi will have dyspnea, congestive heart failure and all. Okay, so these are the things worth knowing here. Which of the following statement is true regarding MTP Act? MTP Act can be performed by a single doctor if the pregnancy is less than 20 weeks. If it is more than 20 weeks, it need permission of 2 doctors. Okay. Next question. This has been asked in recent NEET exam, that people are walking on toes and crossed leg. Which disease they are having? Which poison is responsible for them? The disease is neuroletharism, which you can call as letharism. Poison is BOA, beta oxalyl aminoalanine. And what is the treatment for neuroletharism? That has also been asked in recent NEET. So the treatment is by vitamin C. Vitamin C 500 milligram to 1000 milligram is given for the treatment of this cross-legged walking, neuroletharism. Okay. Now, other than that, of course, they can ask the other food poisoning, which is very easy, important to revise. 2 times they have asked in MCA exam, people eat contaminated groundnut. And after eating contaminated groundnut, there was liver failure or liver cancer, hepatocellular carcinoma. What is the toxin? So here, the toxin is aflatoxin, because the fungus is Aspergillus flavus, which cause liver failure. Groundnut or maize will lead to this thing. If they ask rye or wheat contaminated with black color fungus which cause cyanosis or necrosis of peripheral fingers and toes, and along with that it can also cause hallucination, then what is the poison? The poison is ergotoxin. Because ergotamine group of drug relieve migraine by constricting peripheral capillary. So similar constriction of capillary also occur here, that lead to cyanosis and necrosis. Then they can ask someone is eating junjunia. Junjunia is known as junjunia is the common name which we use for crotolaria. So crotolaria with panicum miliare. Here they will develop endemic ascites, and in endemic ascites the poison they ask is pyrrozolidine. And then the last they can ask is someone is eating contaminated mustard oil with seeds of Argemone mexicana, which is commonly known as Satyanasi, destroyer. So this mustard oil which will lead to epidemic dropsy, eating this type of mustard oil. And epidemic dropsy is due to sanguarine. Poison name is sanguarine. So to remember these two separately, I used to think, and you can use this mnemonic, as for sanguarine, as for sleeping. And it is sung, sleeping together. So imagine you are sleeping with someone of your dream. Go in that imagination. First thing is you will not sleep. You will keep doing something. But if you slept, on sleeping there will be dropping of eyelids. So sleeping lead to dropsy. As sanguarine lead to dropsy. As for sleeping, as for sanguarine lead to dropsy. And the symptom of dropsy, they can give image based question from here, is bilateral pitting edema. So in the symptom also there is pitting, dropping inside. Bilateral pitting edema is the symptom, and it occurred due to mustard oil. And in mustard field, you must have seen in Shahrukh Khan movie, those mustard field. So mustard oil, mustard field have this epidemic dropsy disease, and the poison is sanguarine. Do remember it. Next question, which is not correctly matched by event of family cycle. So do remember this question being asked 3 times. Family cycle, they ask the stages, sometimes confuse you with that. If it is formation, formation means marriage, of course family start with marriage, and then birth of first child. This is formation. Extension means family is expanding. So that means there after the first child birth there will be more child which can be there, and then till birth of last child family is expanding. Like I had one girl child, Prisha, now I am second time father, so now my family is in extension mode. And before Prisha it was formation mode. Before my first child it was formation, now it is extension. Now complete extension means after my next child will be born, it will be the 2 child only, so that will be the last child. And then let's say after 20 years Prisha leave home, first child leave home. That is the time when my family is in the phase of complete extension. So this is a confusing area. They are saying extension, but someone is leaving. That is the end point, not the beginning point. Beginning point is birth of last child, and end point is first child leave. That is complete extension. So extension, complete extension have child going away as the end phase. Contraction means now after the child leave home, my family start contracting. First child leave home and last child leave home. This is the phase of contraction. Complete contraction means first child left home, and then suppose I died before my wife. So that will be the complete contraction of my family, because now there is no more family. Child has left and I have died, so only my wife is remaining. That is complete contraction. And dissolution means After my death, it is start and it ends with death of my wife. So these are the 5 phases. Do remember this confusing area. Complete extension means birth of last child till first child goes away. So that was the question there. Do take picture of this part and revise it frequently. This is easy to understand, but in exam pressure we can get confused. So, which is not correctly paired? Try to answer it now by pausing the video first and then answer. Not correct. Formation is birth of female to birth of first child of the female. Formation means marriage. It is not birth of female. It is start with marriage and it is birth of first child. May or may not be female. That is formation. So of course, which was is not correct? A was not correct. Rest all were correct. Okay. Next question. Which of the following is true about ASA? ASA is selected by A&M. This is wrong. Who select ASA? Gram Panchayat select both ASA and Anganwadi. So that's why this is wrong. Woman in age of 25 to 45, correct. She must be resident of village, correct. At least 1 ASA per 1000, this is also right. Formal education not up to 12th. If they ask this question, minimum education, do remember always this is 8th class. And do remember only 1 ASA is there per 1000. I know some teacher teach some other fact here. But in preventive social medicine, always follow evidence-based medicine. Do not trust on expert or teacher. Trust on data. Trust on evidence. And for evidence, I have recent edition of PARC, which has said it again and again that there is only 1 ASA per 1000 and her minimum education is 8th class pass, up to 8th class pass. Second time also in page number 505 and 923 of the recent edition, they have written it. So again they are saying the same thing. 1 ASA for 1000 and minimum education up to 8th class. Because this 2 question has already been asked in MCI exam. What is the minimum education? The question was like this, that a female is only 8th pass, which are the following positions she can take? So if she is 8th pass, she can become ASA. We want 10th pass, but if minimum is 8th only. Second point, 1 ASA for how much population? For 1000. Okay, do not say 2 ASA 1000, it is only 1 ASA 1000. 2 ASA was a recommendation of one committee in 2011, the high level expert group committee, which is known as Committee on Universal Health Coverage, that gave that recommendation, but it was never accepted. So do remember 1 ASA 1000 and minimum 8th class pass. Okay, very good. Next question. Achha, so what was the answer of this question? The correct answer is woman in 25 to 45, resident of village and 1 ASA per 1000. So correct answer is C. Okay. Next question was that there is 100 case of diabetes divided in 2 group. Investigator gave white pill to one group, yellow to other, and investigator and participator, they don't know which one is the drug, which one is the placebo. So 2 people don't know, that means there is double blinding. Triple blinding is when there is investigator plus participator plus analyzer. The person who analyzed the data, he also don't know. So if all 3 are blind, then it is triple blinding. And triple blinding is the best blinding, but double blinding is commonly done. If there is no blinding, we call it open label trial. Single blinding means participant don't know whether they are getting drug or placebo, but the person who is doing the research, the interviewer, researcher, they know it. So single blinding, only one person, participant are unaware. Double, investigator, participant, both unaware. Triple, investigator, participant, analyzer, all unaware. Okay, this question we have done. Last 2 question. Outbreak of fever with rash occur in remote village during spring season. On investigation, villager reported similar outbreak at interval of every 2 to 3 years. So every fixed time it is repeating, it is cyclic. Cyclic has also one more example, increase accident during weekend. That is also cyclic. Seasonal is like flu, malaria and all. Secular we have all discussed, cardiovascular disease shown by line diagram. What is the area between -2 to +2? In the past they have asked area between -1 to +1. minus 1 plus 1 68%, minus 2 plus 2 95%, minus 3 plus 3 99%. So what is the area between minus 2 plus 2? 95.4. So this is there. But along with that, they ask this question that what are the other two rules of standard normal curve? One rule is standard deviation is equal to variance is equal to area of curve, and all three are equal to 1. Sabka malik ek. Standard deviation, variance, area, all are 1. Second rule is mean, median, mode. In a standard normal curve, all are equal to 0. All are 0. Mean, median, mode 0. Standard deviation, variance, area is 1. And this is the question from area. Now, let me ask you one question. What is the area under mean plus 1 standard deviation? Is it 0.68? Is it 0.47? Is it 0.34? Or is it 0.95? Please answer this question. What is the area under mean plus 1 standard deviation? Plus, if you want to ask any other question from me, you can ask it, because this is my last slide. So we will end this. So if you have any doubt, any question from today's session or from any area, you can ask it. Of course, I will come again to meet you with a rapid revision of the whole course of PSM in simple and interesting way. We will revise all the course of PSM in 3-hour video. I will definitely come with that. So before that, let's just end this with the answer. What is your answer? Praveen is saying 0.47. Dear Praveen, 0.47 is around half of 95. So if I write mean plus 2 standard deviation, that will be 0.47. But I am writing mean plus 1. Acha, you read 1 as 2. Sorry, that is my writing thing. But mean plus 1 if they ask, you will write the answer as 0.34. So Praveen was applying the correct concept. Mean plus 2 is half of 95.47. Mean plus 1 is half of 68.34. Why half of? Because plus 1 only means this blue area. It does not include minus 2 plus. It only includes half of that. And half of 68 is 34. So the correct answer will be 34, which my friend Dr. R has given correctly. It is C. And Dr. R has a question that how many questions we can expect FMGE July exam from today mock test if we study 3 questions with proper explanation. I cannot comment about the whole topics and every subject, but I can comment about my PSM part. We can expect that from the explanation which we have discussed, around 4 to 5 questions will definitely come in PSM FMGE exam from this question which we have discussed here. These are relevant, and these are those questions which are repeated in last 2 years only. So do go through this PSM part at least, and of course the other part is also useful, so go through it. So keep enjoying your life and do give importance to previous year question and revise it again and again. Hasta la vista, das vidania, bye bye. We will meet again in next session.
Hello students. So I think you had a good grand test. So there were a few questions from anesthesia which I would like to discuss. The first question which was asked from anesthesia was this question: a patient was presented to the emergency in unconscious state. So whenever a patient presents to emergency, we have to see the response, responsive or unresponsive. So this patient was unconscious, so patient was not responsive. Then what we do? We see the pulse and breathing of the patient. So there was no pulse in that case, in this question. Cardiopulmonary resuscitation was started. So this is a question of an unresponsive patient, and we are doing a BLS approach. So CPR was started. When ECG was attached, it depicted ventricular fibrillation. So immediate defibrillation with 200 joules of biphasic energy was given. What would be the next step? So this question is a question on ACLS, in which the algorithm, we have to remember to solve this question, the algorithm which manages the shockable rhythm of the cardiac arrest. So what is the two shockable rhythm of the cardiac arrest? Ventricular fibrillation and pulseless ventricular tachycardia. So in this case, our patient had ventricular fibrillation. So this is shockable rhythm of cardiac arrest. So what is the definitive management of shockable rhythm of cardiac arrest? Shock. So definitive management was given, 200 joules of biphasic shock was given. Now immediately after giving the shock, what do? Immediately after giving the shock, what we do is we continue with resuscitation. We continue with chest compression and ventilation. We don't try to see the pulse or anything of that sort. We go for CPR. So what are the options here? Epinephrine 1 milligram IV was given. Resume chest compression, check for pulse, amiodarone 300 milligram IV given. All the 4 options are the interventions which we do in a shockable rhythm of cardiac arrest. But after giving the shock, what is the immediate thing which we continue? We go for chest compression. We resume the chest compression. We had stopped the chest compression and we had given the shock. So after shock, what do? We resume the chest compression. This is very important. We don't check pulse, we don't do anything. We resume the chest compression. So let us talk about ventricular fibrillation, which is asked in this question. Ventricular fibrillation, that is the shockable rhythm of the cardiac arrest. So what kind of ECG tracing which we could have got in this patient? This is the ECG tracing of ventricular fibrillation. So what is it? This waveform does not have any morphology, nothing. These are just irregular lines on the ECG strip. So irregular lines up and down, no morphology, is something called ventricular fibrillation. So there are some electrical activity, but it has no morphology. It is ventricular fibrillation. So how do we manage ventricular fibrillation? So this is the algorithm which we have to remember like anything. This is the algorithm for managing cardiac arrest patient. This is ACLS algorithm. So first thing, we have a cardiac arrest patient, we attach in ACLS, we attach the ECG and we see whether the rhythm is shockable or non-shockable. So if the rhythm is shockable, the 2 rhythm is possible. One is this ventricular fibrillation and another is pulseless ventricular tachycardia. What is the immediate management? If question is asked, what is the immediate management of shockable rhythm? Answer is shock. We give shock immediately. So for shockable rhythm, we have to shock immediately. And then we have to resume the compression ventilation for next 2 minutes. And meanwhile, we take the IVIO axis. After 2 minutes, again give the second shock. Rhythm still shockable, give the second shock, because shock is priority. Shock can change the cardiac arrest rhythm into a sinus rhythm. So we give shock. After the second shock, we resume compression. After every shock, we have to resume compression ventilation. And now we start giving the emergency drug. What are the emergency drug in shockable rhythm? Epinephrine, the first drug. And we give epinephrine 1 milligram, 1 in 10,000. Okay. And after 2 minutes, again we see the rhythm. Every 2 minutes we have to see the rhythm. So we stop the CPR, we see the rhythm. Rhythm is still shockable, again we'll give the shock. And we'll resume compression ventilation after the shock. We give epinephrine, the second dose, or we can give another drug, amiodarone, the second drug which we can give in shockable rhythm. So for shockable rhythm, we have to do CPR, we have to do immediate defibrillation, and after, let's say, second shock, we start giving the emergency drugs. When we are doing the compression ventilation, along with compression ventilation, we give the emergency drugs. Adrenaline is the first drug, 1 milligram, 1 in 10,000. We repeat every 3 to 5 minutes. There is no upper limit. Amiodarone is the second drug, 300 milligram IV bolus is the first dose, 150 milligram IV bolus is the second dose. We don't give beyond second dose. Okay? Shock in shockable rhythm doesn't have any upper limit. We can go on giving shock every 2 minutes till the rhythm is shockable. And adrenaline has no upper limit, and we continue doing CPR. If it is non-shockable rhythm, that is asystole or pulseless electrical activity. In asystole and pulseless electrical activity, we don't have to give shock. So what do? We resume compression, we do compression ventilation, we take an immediate IV access. Here we have to take immediate IV access as soon as possible and start giving adrenaline. Adrenaline, the same dose, 1 milligram, 1 in 10,000. Repeat every 3 to 5 minutes. We cannot give amiodarone in non-shockable rhythm. And we, let's say, continue doing CPR. Okay, so rhythm is not shockable. We continue doing CPR. We try to treat the reversible causes, the 5H and 5Ts of cardiac arrest. So this is the management of, this is the flow chart which we have to remember in case of ACLS, advanced cardiac life support. So always remember. So if we have given the shock, immediately after shock, we have to resume the compression ventilation. So this was the first question. Now coming on the second question. The second question which was asked was this one. A 6-year-old boy is scheduled for tonsillectomy and adenoectomy under general anesthesia on daycare basis. So first thing which we got in this question, this is a daycare surgery. So daycare basis, daycare surgery. Okay. He has a history of recurrent tonsillitis, obstructive sleep apnea. The radio anesthesiologist decide to use IV and intravenous induction agent for anesthesia, and the most commonly used intravenous anesthetic induction agent in this patient would be. So they are asking in a simple way in this long question that for daycare surgery, which is the IV anesthetic agent of choice. This is a child. If it was inhalational asked in the question, if inhalational was asked in the question, okay, then we would have answered sevoflurane. If inhalational would have been asked, we would have answered sevoflurane. So inhalational induction agent of choice is sevoflurane. But the question was IV induction agent of choice and the surgery is daycare surgery. The answer has to be blind in this case, and that is propofol. So propofol is IV anesthetic agent of choice for daycare surgery, adult or pediatric, and we can use it in every patient. There is no age limit, nothing of that sort. So for daycare surgery, propofol is agent of choice. So answer is propofol. So just very quickly, what are the indication of these 4 important IV anesthetic agents? Thiopentone, propofol, etomidate, ketamine. Thiopentone, nowhere IV anesthetic agent of choice. 2 indication, narcoanalysis and for neuroprotection, it is drug of choice. So non-anesthetic use, narcoanalysis as a tooth serum, and for neuroprotection we use. Propofol, it is anesthetic agent of choice. Propofol is anesthetic agent of choice. At most of the places, propofol has replaced thiopentone. Anesthetic agent of choice for daycare surgery, right? For daycare surgery. It is anesthetic agent of choice for neurosurgery. It is for neurosurgery. It is anesthetic agent of choice for thoracic surgery. It is anesthetic agent of choice for malignant hypothermia, patient with malignant hypothermia. It is anesthetic agent of choice in porphyria, right? It is agent of choice in pre-existing liver and kidney dysfunction, pre-existing liver and kidney dysfunction. Got my point? It is anesthetic agent of choice in all these conditions. Okay. Etomidate, it is anesthetic agent of choice in patient with cardiopulmonary dysfunction. Cardiopulmonary dysfunction. So any patient with cardiopulmonary dysfunction, etomidate is agent of choice. Why? It is cardio stable. And ketamine is anesthetic agent of choice for, very important, it is anesthetic agent of choice for shock patient, patient in shock, bronchial asthma because it is the best bronchodilator, and in cyanotic heart disease. Cyanotic heart disease. Okay. So these are the 3 conditions where ketamine is anesthetic agent of choice. So for ketamine, shock, bronchial asthma and cyanotic heart disease. For etomidate, it is cardiopulmonary dysfunction, and for rest everything else, anesthetic agent of choice is propofol. So for everything apart from this. So this question was on daycare surgery, right? In pediatric, IV agent to be used. Answer has to be propofol. Okay. Now very quickly, what are the contraindication of these drugs? Thiopentone has 3 important contraindications. Shock, we cannot use it in shock patient. Bronchial asthma, we cannot use it in bronchial asthmatic patient because it is bronchospastic, and porphyria because it will precipitate porphyria. These 3 contraindication. Propofol has only 1 contraindication, it's cardio unstable, so contraindicated in shock. Etomidate is not much used, only not much used. Why? Because it causes adrenal suppression. Adrenal suppression, right? The only thing good about it is cardio stable. So a good star point of etomidate is cardio stable. Since it is cardio stable, so it is kind of good agent for cardiopulmonary dysfunction. Okay, otherwise we are not using it. Ketamine is contraindicated in many conditions because it is a sympathomimetic agent. Sympathomimetic, ketamine is sympathomimetic. Since it is sympathomimetic, what can it do? It can increase the blood pressure and heart rate. So it is contraindicated in coronary artery disease, coronary artery disease. It is contraindicated in hypertension. It is contraindicated in neurosurgery because it will increase the intracranial pressure. It is sympathomimetic agent. It is contraindicated in epilepsy. So these are contraindication of ketamine. So we discussed very important point, indications and contraindications of these 4 important IV anesthetic agent. Okay, this was our second question. Coming on the third question. Again, a very popular question which can be a very much expected question in exam. During Viva, a medical student was asked about the mechanism of action by which local anesthetic act. So, mechanism of action of local anesthetic. The professor was satisfied with the answer. What could have been the answer? So, they are asking what is the mechanism of action of local anesthetic. Options: closure of activated voltage gated sodium channel, closure of resting ligand gated sodium channel, closure of sodium channel in inactivated state, inhibition of inactivated ligand gated sodium channel. So, first one thing very clear, that definitely local anesthetic acts on sodium channel. Okay. So, now you see this image, this is a nerve fiber. So, this is a nerve fiber. Okay. And on the membrane of the nerve fiber, we have the sodium channel. We have the sodium channel. Okay. Now, this sodium channel, through this passes the sodium ion, passes, and what happens? The resting membrane potential changes into the action potential, and the propagation of the nerve impulse takes place. So, if this sodium channel is closed, if this is closed, the movement of sodium ions will not take place across this sodium channel, and resting membrane potential would not get achieved into action potential, and the propagation of the impulse will stop. So, we have to close the sodium channel. But how does local anesthetic closes the sodium channel? The receptor where local anesthetic attached to the sodium channel is on the inner part of the membrane. So, intracellular area. This is the where the local anesthetic attaches. Right, everyone? Okay. Now, sodium channel in a nerve fiber is in 3 states. So, if this is a nerve fiber, this is the sodium channel on the nerve fiber. This can be present in 3 states. It can be present in resting state. Resting state, the sodium channel is closed, already closed. Okay. It can be present in active state. In active state, it is open, and in this state only the movement of the ions take place. Or it can be in inactivated state, right? So, what happens in an active nerve fiber? They go from one state to another very quickly, and the propagation of the nerve impulse happens. What local anesthetic does? It binds to the sodium channel on its cytoplasmic site during inactivated state, okay, and keep it in this inactivated state for a long period of time, and prevents the movement of the ion across it. So, propagation of the nerve impulses stop because action potential is not achieved. So, local anesthetic can only bind to the sodium channel in inactivated state, not in active, not in resting. So, question here that local anesthetic closes the sodium channel, right? What is the answer? It closure of sodium channel in inactivated state. So, this you have to remember. Closure of sodium channel in inactivated state would be the answer. Definitely it acts on sodium channel, but in what state? Inactivated state, not in active, not in resting. Okay. So, this was our third question. Now, coming on the fourth question. Again, a very probable question in FMG exam. Endotracheal intubation was done for a patient. Which of the following would be the confirmatory for the placement of the right placement of the ET tube? So, ET tube has been placed. Which would be the confirmatory, right? Now, there are a number of ways by which we can confirm the ET tube. Now, this is, let's say, a respiratory tract. This is the glottic opening. And when I put the tube, endotracheal tube, this tube has been put, we inflate the cuff. It creates a seal in the trachea, and we ventilate the patient through this. Now, when I do a laryngoscopy and put this tube, there is a possibility that tube can go into esophagus. So, we have to confirm whether the tube has gone into trachea or in esophagus. What are the ways? So, when we ventilate, we will give air to both the lung, and we will see the chest chest wall movement of both sides of the thorax. So bilateral chest wall movement can be one thing. We can confirm by auscultation. We can put a stethoscope and hear for the breath sound when we ventilate through tube. Or we can see the bilateral chest expansion, or we can see the vapor in the tube, because expiratory gas, when it will go out, it will leave the vapor. So vapor on the tube, on ET tube, okay, right? And very important, when we put the tube, after putting the tube, we attach a device on the tube, right? This device is called capnograph. This is called capnograph. Now this capnograph has ability to recognize carbon dioxide, ability to detect carbon dioxide. So when the gas passes through this capno, the graphical representation of this can come like this. This is capnograph. Okay, this is the capnograph. Okay. Okay. So when I attach the capno, if I get this kind of graph, this is expired CO2 against time. This is confirmatory. Confirmatory, 100%, I am sure the tube has gone at right place, right? If this is not coming, if I have put the tube and I am getting a flat line, the tube has gone into esophagus. So this capnography is confirmatory. So in this, what would be the answer? Option is EtCO2, that is expired carbon dioxide, or we call it capnograph. Chest X-ray, which is not immediate confirmation, it is a late confirmation, so it cannot be the answer. Immediately after putting the tube, how would be confirmed? Chest radiograph cannot be the answer. Oxygen saturation, well, this is a late sign. Okay, so answer would be capnograph. Okay, saturation will fall, but it will take time. What is confirmatory? This graph not coming is confirmatory. The tube has gone into esophagus. Got it? So answer always has to be capnography. Okay, this was our fourth question. Now coming on the last question. The last question which was asked in the exam on pre-anesthetic evaluation, a 49-year-old female comes for elective minor surgery. In pre-anesthetic evaluation, the patient gave history of comorbidity type 2, diabetes and COPD. Investigation shows that glycosylated HB is 5%, which is well controlled, right? If it is above 7%, then only we say it is not controlled, right? It is well controlled, and she rarely requires salbutamol inhaler. So COPD is also well controlled. So she belongs to ASA grade. So which ASA grade? ASA grade. The question was on ASA grade. So which ASA grade she belongs to? Okay. So ASA grade we have discussed. What does ASA grading tell us? What does ASA grading tell us? So ASA grading, first thing which we need to know, tell us about risk associated with surgery. Risk associated with surgery, right? From we have ASA grade 1 to 6, and from 1 to 6 the risk is gradually increasing. From 1 to 6 the risk is increasing. So this ASA grading was established in elective surgery. Later on it was adapted for emergency surgery, then it became 1E to 6E, but 1 to 6 is for elective surgery. So what is 1 to 6? ASA grade 1, healthy patient, that is no comorbidity, okay. ASA grade 2, patient has a systemic disease. So our patient also has a systemic disease, that is type 2 diabetes and COPD. So patient has a systemic disease, okay. ASA grade 1 was no comorbidity, right. ASA grade 2, patient has some systemic disease, but it is medically well controlled, right. It is well controlled. So controlled comorbidity. So I think our patient falls into this group. Why? Because patient has diabetes, patient has COPD, but both are well controlled. So controlled comorbidity, not causing any limitation in the patient, no functional limitation. ASA grade 3, patient has a comorbidity which to some extent limits his activity. Patient is not symptomatic on normal activity but becomes symptomatic on strenuous activity. So comorbidity with moderate limitation, okay, moderate limitation. So patient would have become symptomatic on some activity, clinical symptoms would have come on some activity, then patient is ASA grade 3, okay, right. ASA grade 4, severe, the comorbidity is very much deteriorated and it is causing severe limitation. So comorbidity with severe limitation, okay, severe limitation. ASA grade 5, moribund patient. 1 to 4 is something else, now 5 and 6 are different. ASA grade 5, moribund patient, not expected to live if surgery is not done. Surgery is the only option for survival. So surgery is the only option for survival is ASA grade 5, okay. And what is ASA grade 6? It is brain dead patient only for organ transplantation. So brain dead patient posted for organ transplantation is ASA grade 6. So these are our ASA grading. So our patient definitely has a comorbidity. So ASA grade cannot be cannot be the answer, but has a comorbidity, but it is thoroughly controlled with the medicines. So belongs to ASA grade 2. So this is the answer, ASA grade 2. These were the 5 questions which was asked from anesthesia. So let me very quickly revise all the 5 questions. First, this question, the answer was on pre-anesthetic evaluation, this question was on ASA grading, the answer was ASA grade 2. The second question was, what is the confirmatory for ET tube, confirmation of ET tube placement in the trachea? So confirm placement of endotracheal tube, answer would always be ETCO2 or capnography, right? Next question, mechanism of action of local anesthetic, answer would be closure of sodium channel in inactivated state, okay? Then question on that for daycare surgery, IV anesthetic agent of choice, answer is propofol. And the first question was the question on CPR, patient with ventricular fibrillation, shock was given, what is the next thing immediately we do? We go for we resume the chest compression. So these were the 5 questions. I hope you have done all the 5 questions correct, and best wishes for your exam. Perform well. Thank you.
Okay, so let's start the session on anatomy. I'm Dr. Ankit Khandelwal, your faculty of anatomy. So here's the question number 1 over here. The question says that which of the following are the derivatives of the dorsal mesentery? Options over here are, first option is greater omentum, second is gastrosplenic ligament, third is the linorenal ligament, and the fourth is coronary ligaments of liver. But the options here are these multiple A, B, C and D. We have to choose out of these. So it's a conceptual question. We should know what are the various derivatives of the dorsal as well as the ventral mesentery or mesogastrium, if we can say. Remember over here that this question is about the embryology. So regarding development, if we look at development of a gut, particularly the foregut, what actually happens is that this foregut over here, it rotates 90 degrees to the right side, right? Posteriorly it will rotate like this and anteriorly it will rotate in this way. So it goes to the right side, meaning by that the initially whichever was the ventral attachment, ventral mesentery goes to the right side, and initially which was the dorsal mesentery will go to the left side. We can remember it by ventral going to the right side, the dorsal going to the left side. If you combine, you can have the mnemonic of VDRL. VDRL, as we all know, the VDRL test for syphilis. So ventral is to the right and dorsal is to the left side. So we have to look at the dorsal mesentery. So they are to the left side, so we have to search for options which are going to the left side of the gut. Now what are the various attachments or mesenteries or the mesogastrium, to be more perfect, which are going to the left side of the foregut? Let us see that. Here's the image over here. Here we can see that there is a gastro, that is a stomach region, right? Here is the esophagus over here. There is a stomach and continuing into the duodenum. This is to the right side of the stomach, that is to the left side of the stomach. So all these attachments that are to the left side are derivatives of the dorsal. So what are the various derivatives of the dorsal mesentery or dorsal mesogastrium? Let us see. So the biggest attachment over here is coming from the greater curvature of the stomach, that is a greater omentum. So first of all will be the greater omentum. Second will be going from the stomach to the spleen and stomach to the diaphragm. They are known as gastrosplenic and gastrophrenic ligament. As we can particularly see over here, greater omentum, gastrosplenic, gastrophrenic ligament. But continuing also posteriorly from spleen to the kidney, left kidney, we have the lino or the splenorenal ligament. So we call it as a linorenal, or we also call it as splenorenal ligament, right? So these are all derivatives of the dorsal mesogastrium, right? But if you talk of the derivatives of the ventral mesogastrium, then here in the derivatives of the ventral mesogastrium, all the structures which are to the right side. So what will be those derivatives? Those derivatives over here will be, first of all, going from the lesser curvature of stomach to the liver, that is the lesser omentum. So here we will have the lesser omentum. Second derivative of the ventral mesogastrium will be the peritoneal coverings of the liver, which are basically those coronary ligaments, those triangular ligaments. So all those liver peritoneal coverings. And third one will be going from the liver to the anti-abdominal wall, that is known as falciform ligament, right? So that will be our falciform ligament. So these structures will be actually our derivatives of what? Derivatives of the ventral mesogastrium. But here they ask the question of derivatives of the dorsal mesogastrium or dorsal mesentery. So we come back to the options. Here we can now quickly look at it. Greater omentum, yes, it is derivative from the dorsal mesogastrium. Gastrosplenic, yes, dorsal. Linorenal, yes, dorsal. Coronary ligament, liver, ventral. So 1, 2 and 3 will be the correct answer over here. And if you look at the options, option number A, 1, 2 and 3 is our best bet, is our best answer over here. Hence answer is option number A. Okay, I hope the point is clear. Remember the rotation, embryology, everything going to the right is coming from the ventral, everything going to the left of the stomach is coming from the dorsal mesogastrium. That's it. Let's come to the next question over here. And this question over here asks that which nerve is damaged if a fracture happens at the site of the marked arrow. So here's a bone, here's an arrow. Bone over here, we can very well understand the bone over here is the humerus, right? If you look at the bone, is it the anterior or the posterior view? Look at the olecranon fossa over here. This is the olecranon fossa, right? Here is this greater tubercle. Are we seeing any lesser tubercle? Answer is no. Lesser tubercle is on the anterior side. So this is the posterior aspect of the humerus. This arrow over here is to the mid shaft, and there is a groove which passes from here. There is a groove which passes from here, which is that groove. That groove is known as the radial or the spiral groove. It is known as the radial or the spiral groove. So arrow is pointing at that location. So what is the content of this radial or the spiral groove? The content of this radial or the spiral groove is obviously the radial nerve. Then there is also a vessel which runs along with the radial nerve. Which vessel is that? It's a branch of the brachial artery. The vessel is profunda brachii vessel. Vessel is profunda brachii vessels. So therefore these are the contents, and therefore the nerve over here which is related to the mid shaft of the humerus is the radial nerve. Hence the answer over here will be definitely be our radial nerve. But this was a question now. Questions can come in a different way. They can even put an arrow tomorrow at this site. This is the medial epicondyle, and the nerve which is traveling over here, the nerve is traveling on behind the medial epicondyle. Here the answer will be the ulnar nerve. Ulnar nerve. There can be another question where the arrow is towards the surgical neck of humerus. The nerve which is revolving around over here is known as the axillary nerve. So therefore questions might change, arrows might change, the location, the answer you should know. The axillary nerve is also known as circumflex nerve. Here's an image to show you the same thing over here. This is the image over here. Have a look at this particular image. You can see the axillary nerve is towards the surgical neck of humerus. This was the question they asked about the radial nerve. Then the ulnar nerve going behind the medial epicondyle. This, mind you, is the anterior view of the humerus. You can still look at the lesser tubercle over here. And you can also miss out the olecranon fossa over here, which was present posteriorly, right? So therefore, the answer is radial nerve. And also do remember, the axillary nerve, as it is located at the surgical neck, it can be injured if there is a fracture of the surgical neck, if there is a shoulder joint dislocation, or there is improper placement of the intramuscular injections. Ulnar nerve can be damaged if there is a fracture medial epicondyle. Right? So therefore, the arrow, mid-shaft humerus, answer radial nerve, and we have looked at all the other options. Let's see the next one over here. The next question asks us that all of the following are included in the contents of the occipital triangle except, don't forget the except, people normally forget this word except over here. So, which of the following is not a content of the occipital triangle? So here we should know some basics. That occipital triangle is a part of the posterior triangle. Posterior triangle is actually bounded by sternocleidomastoid trapezius and the middle part of the clavicle. So below we have the clavicle, behind we have the trapezius, and anteriorly we have the sternocleidomastoid. This particular triangle is present on the side of the neck, side and posteriorly, is known as a posterior triangle. And here the majority part of the posterior triangle is the occipital triangle, So what is the smaller lower part? Smaller lower part of the triangle will be known as supraclavicular triangle, also known as subclavian triangle. Supraclavicular or subclavian. Why we call it as supraclavicular? Because it is above the clavicle. Why we call it as subclavian triangle? Because it is having a contents as subclavian vessels. Now coming to the question. So what is not lying in the occipital triangle, or what is the main structures which are in the occipital triangle? The spinal externum is a major content, clinical applied. It is the most important clinical content of the occipital triangle, and the spinal externum goes from sternocleidomastoid to trapezius, because it is supplying both of these muscles. Which nerve? The spinal external nerve. What is the content? Carotid sheath. Now carotid sheath will be having the carotid vessels, carotid artery. Where do we palpate the carotid artery? In front or behind the sternocleidomastoid? Remember, feel it over here in the carotid triangle. Therefore, this sheath is present in the carotid triangle. Is that a part of the occipital or the posterior triangle? The answer is no. So this probably looks as the answer till now. Let us see more options. Brachial plexus trunk. Now do remember that in the subclavian triangle we have the subclavian vessels, and here also lies close to this area we have the trunks of the brachial plexus. So brachial plexus trunks also lie in the posterior triangle. So this will be a content. Subclavian artery. The name of the triangle is subclavian triangle. So subclavian artery basically in the lower part of the posterior triangle might also be somewhat in the occipital triangle. So therefore it is also content. So here the answer is option number B, the carotid sheath. Let us see all the triangles over here in this image. What we are discussing till now was our occipital triangle. So here is the occipital triangle over here, right? This is the occipital triangle, and here is the carotid triangle, right? So these triangles over here, the carotids, the muscular, the digastric, and the submental, they are a part of anterior triangle. And the carotid sheath will be located over here, where we palpate the carotid artery. The occipital triangle and supraclavicular or subclavian, they are a part of posterior triangle. And this is where the nerve will be lying, which is the spinal accessory nerve, spine root of accessory nerve, right? So therefore, if you look at the question again, answer is option number B. So remember, all these triangles, we should know basically what are the contents, where are they located. Now it's very easy. Why? Because these are structures, the gross structure which we can feel in our own body. So look at the mirror, look at your own neck, feel out the triangles which triangle is present, and you will never forget it, right? So in this particular question, the answer was carotid sheath. Let's see the next one. Now this question asks us that which of the following structure is derived from ectoderm. It is a pure embryology question and very important topic, derivatives of germ layers, frequently asked. Now ectoderm, they have given a bigger name as, or a larger name as ectoderm. We all know that ectoderm divides into two ectoderms, which are the surface ectoderm, from where the skin, basically the epidermis, hairs, nails, all that are derived. And one is the neuroectoderm, where the CNS, the brain and the spinal cord are derived. Now do remember that in case of neuroectoderm, associated with the neuroectoderm is also another specialized group of cells which are known as the neural crest cells. Neural crest cells. So on the edges of the neural tube, neural fold, some cells are derived from the epiblast, which are known as neural crest cells. They are very much part of the ectoderm. Right. These are the basically you can say the subdivisions of the bigger term ectoderm. Other germ layers we already know. We have the mesoderm and we have the endoderm So basically there are three germ layers, ecto, meso, and endo, and here's the neural crest cell also, which is somehow regarded as the fourth germinal layer, but actually it is coming from the epiblast, a part of ectoderm. Now let us see the options now. Adrenal medulla. It's a part of the adrenal gland. It's basically a ganglion, sympathetic ganglion, and it is coming from the neural crest cells. Thymus. Thymus, you all should know, it's part of the endodermal pouch, the pharyngeal arches, endodermal pouch. The third pouch over here, the third endodermal pouch, gives rise to thymus and the inferior parathyroid gland. So therefore, it is part of endoderm. Lining of the body cavities. Body cavities which are lying inside, lining all of them are coming from endoderm only. Same is the respiratory system. Again, its lining will be coming from the endoderm. Why? Because the respiratory system, it is derived from as a diverticulum from the foregut, and gut we all know is lined by endoderm. So therefore, B, C, and D are basically endoderms, and the A is neural crest cell, which is supposedly a part of the neuroectoderm. Therefore, this will be our answer over here. Now let us see a couple of tables over here showing you all the various derivatives. This is the derivative of the ectoderm over here, basically the surface ectoderm. You see, it's the epidermis, not the whole dermis. So epidermis, hairs, nails, inner ear, external ear, and other derivatives over here. Mesoderm, basically the muscles, the connective tissue, all those parts will come from mesoderm. Here is the endoderm over here, epithelial lining of the foregut, and here is the respiratory system, which they asked. body cavities are all these body cavities, right? Next also let's have a look at the neural crest cells over here. Neural crest cells, here is the answer, adrenal medulla, which they asked, a part of the ectoderm, neuroectoderm, and the other various derivatives over here. Notochord, they frequently ask the question, derivative is nucleus pulposus. Neuroectoderm over here, which gives rise to the CNS, basically the brain and spinal cord, and this again is endoderm, which was lining the other organs over here. We come back to the question, the B, C and D are coming from the endoderm. The answer over here is option number A, adrenal medulla. Now, mind you, if tomorrow they give you adrenal cortex, then what will be the origin of it? Remember, adrenal cortex is coming from mesoderm. It's coming from mesoderm. It is not endo, it is not ecto, it is mesoderm, right? Intermediate mesoderm. Right, so this was the question. Let us see more questions over here. And here's the next one. What are they trying to ask us? Which of the following is or are incorrectly matched? Underline that in your mind, incorrectly matched. Which is wrong over here? Let's see. It's a question from the general anatomy. The topic is joints. Very, very important topic in the subtopic of general anatomy is joints. Let us see. Sternoclavicular joint plane sign over there. It's right or wrong? It's a false statement. Then what is the correct statement over here? Sternoclavicular joint. If you feel this joint over here, it is multi-axial joint. Wherever you move your upper limb, this joint, you will feel some movement over here. It is a variety of saddle, variety of synovial joint. So first is false. Wrist and knuckle joint. Wrist and knuckle. Knuckle is this metacarpophalangeal and this wrist joint over here. They are sort of ellipsoid and condyloid variety. What they're saying, hinge is wrong over here. Hinge is always a uniaxial joint, and the ankle, elbow, knees, they are a variety of hinge joints. Here it will be somewhat close to the ellipsoid variety. So second statement also is false. Third statement, middle tibiofibular joint syndesmosis. Yes, middle tibiofibular or middle radioulnar joint, they are a part of, you can say, as the fibrous joint. They have interosseous membrane, and that comes under syndesmosis. Perfectly correct. That is a true statement over here. Calcaneocuboid in the tarsals. Remember, calcaneocuboid is a saddle variety. Yes, they are true over here. It's a saddle variety of joint. Other joint they can ask in the tarsals is about the talonavicular. The talonavicular joint over here is a variety of ball and socket, is a ball and socket variety. Do remember this too. So fourth option also true. Elbow and ankle, we just said they are hinge joints. Here they are saying ellipsoid, so it is also false over here. So which is incorrectly matched? 1, 2 and 5. Now we know the basics. We will look for 1, 2 and 5, and here is the answer. Simple, straightforward. Topic simple is types of joints, fibrous, cartilaginous and synovial, and there are various different varieties. This is a must-know topic, and all the different varieties of synovial joint, we should know there are at least a couple of examples. That is what is needed from us, right? So this goes with option. This question answer is option number D. That is a wrong statement over here. Let us see more questions over here. Okay, here's the question. The question says the 40-year-old male presented to the emergency after trauma. Patient is conscious. After stabilizing the vitals, you perform a complete examination and observe that is unable to localize pain, temperature, sensation on the left lower limb. That we need to underline in our heads. Unable to localize pain, temperature in the left lower limb. And there is no pressure proprioception on the right lower limb. So on the right lower limb, there is no pressure proprioception. Now this basic thing should run in your mind. If there is a pain, temperature loss, which tract of the spinal cord, we are dealing with the spinothalamic tract. Right? And if there is loss of pressure proprioception, which tract are we dealing with? We are dealing with the dorsal column tract. Right? So there is a problem in the dorsal column tract on which limb? On the right lower limb. Problem with the spinothalamic tract on the left lower limb. Right. Image given below shows a cut section of the spinal cord representing the various sensory tracts. Which of the following marked areas is responsible for his symptoms on the left side of the body? So left side of the body they are asking. So they're basically asking, do you know how to localize the spinothalamic tract? That is what they're asking. Simple. Can we localize the spinothalamic tract over here? Let's try to do it. So if you look at the section over here, you should clearly understand there's an anterior part, there is a posterior part, looking at the fissures and the grey horn. Next, you see that A and B over here, if you slightly zoom it a bit over here, A and B over here, they are present posteriorly, they are a part of dorsal column. These are part of dorsal column. They are asking about the left limb, what happened, they are asking the spinothalamic. This option number C over here, that is about the corticospinal tract. The corticospinal tract, that is the motor tract which is going down. The D over here, this one over, this is the spinothalamic. This is spinothalamic. And I guess as they are asking about the left limb, we have to deal with the spinothalamic. And therefore, our answer over here would be option number D. But look at the options now. A is C, B is D, C is A, D is B. Right, so don't jump to option number D, you have to go with option number B, whose answer is option number D, right? So keep that also in mind. There are ways to confuse, but if you are practicing, you are running all these tests, you practice what makes human perfect. Okay, let me show you an image over here regarding the same thing. And here also you can see, here's a beautiful image, the same thing. Look over here about the posteriorly, what we can see over here is about the fasciculus gracilis, fasciculus cuneatus, the dorsal column. This is the corticospinal tract over here. This was option number D, spinothalamic tract. What else is shown in this particular image is all the sensations which these carry. That's a beautiful thing to see in this image. Here you can see pressure, vibration, movement, position, touch, dorsal column. Pain, temperature, that is by the spinothalamic. And that is why option number D was our best answer over here, right? Okay, let's move now forward. A fairly easier question, if I may say so. Dermatome supplying the marked area. Marked area over here, they are also showing the umbilicus. We know from our earlier times that if I take example of appendicitis, the referred pain goes around the umbilicus. If there is a gastroenteritis in the small intestine, the referred pain goes to the around the umbilical region. That is what we call as periumbilical. Why? Because the sympathetics from the midgut, they are around the T10, they go around the umbilicus. And what is the dermatome of umbilicus? Dermatome of umbilicus was T10. Dermatome of the groin region is around L1. So dermatome topic is very important. Here the answer is straightforward, T10 over here. And if you just correct this, this was T over here. Option number C would be the correct over here. Option number C is T10. Let me show you an image over here. Have a look at this. Have a look at the around the umbilicus region. It is T10 over here. And the groin, it is L1. Around the epigastric, you have T6 and T7. And so on and so forth. Now, what is missing over here? If you just follow it for a second, you'll realize that we have C3, we have C4, then we have T2. What happened to C5 to T1? They formed brachial plexus and they went where? They went to upper limb. So remember that part also. So in the trunk region, we have a C4 T2 junction. What we have? We have a C4 T2 junction over here. This is C4 T2 junction. So from C4, we directly go to T2 around the sternal angle. Around the sternal angle, right? But here they also have the umbilicus and answer was T10. Right? Okay, let's move to the next one. Select the correct order. Correct order over here, they're asking about the layers of the abdominal wall. Now, this is a very important topic of anatomy. Why? Because during surgery, during laparotomy, whenever you are putting an incision on the abdominal wall, you should know that which layers you are cutting. So, obviously, there are various options over here, 1 to 7, and there's sequence as A, B, C, and D written over here to choose one over here. So, obviously, the skin fascia, which are lying most superficially, so 1 and 2 are given in all the options. Then the trick starts. So we should know what are the various layers, right? So skin fascia, then we have muscles, and peritoneum will be or should be at the last one. Okay, so if you apply common sense, suppose you have missed this topic and it comes in the exam. So skin must be on the out, most superficial, right? And peritoneum must be most deep, right? So 1 and 6, if you look at 1 and 6, they are even given 2 options. So you can rule out actually with your smart work, you can rule out option C and D. Now you have to rule out between A or B. So you have 50% probability chance, right? It's double the chance which you had a few seconds before. But if you have knowledge, then you have 100% chance of marking it correct. So let us see the layers over here. Let's show you this image in a while. So we have the skin, then we have fascia. This fascia is always superficial fascia, which has 2 layers, an outer campus layer and an inner scarpas layer. Remember, the deep fascia is missing. Then we have the muscles like external oblique. Deep to it, we have an internal oblique. Deep to it, we have a transverse abdominis. 3 muscle layers aligned like this. Then we have deep to transverse abdominis, we have a fascia known as fascia transversalis. Then we have a small fatty layer known as extraperitoneal fatty layer. Extraperitoneal fatty layer. And deepest layer of the abdominal wall will be the parietal peritoneum. So in the deepest layer, we have the parietal peritoneum. Parietal peritoneum. So this is if we go from superficial to deep. This is if we go from superficial to deep, right? This is a sequence. Now, if we look at the options over here, 1, 2, then options should come as 5 option over here. So 1 to 5, then 3. So therefore, correct answer is option number A over here. 1, 2, 5, 3, 4, 7, 6. 5, 3, 4 is this, 7 is yes. Answer is option number A over here. That is the correct answer. Answer is option number A. That is the correct answer. This figure over here, we're trying to show the inguinal canal, but not just particularly the inguinal canal, showing you different layers. Some layers which you can see over here. Focus on the various layers over here. So what you see over here is the different muscle layers. We have outside external oblique, deep to it with the internal oblique, then your transverse abdominis, then your fascia transversalis, then the peritoneum. This was a sequence. If you go from superficial to deep, the skin fascia lies outside. The skin fascia lies outside. Okay. I hope the question is clear. The answer is clear. Why? Answer is option number A. Therefore, now let's move to the next one. A young female patient presented with complaints of numbness, tingling, and burning pain. These are sensory or motor? These are sensory findings. in the outer aspect of the thigh, in the lateral part of the thigh. Some of you, most of you must have now reached the diagnosis by now. After examining, you observe tone, power and the movement of the thigh muscles are within normal. So motor sensation is fine. There's sensory paresthesia in the lateral part of the, or the outer part of the thigh. The lateral part of the thigh, there is some problem in the sensation, right? So he explained to her that her symptoms are due to entrapment of a nerve in her thigh. Which of the following options correctly matched with the nerve and its root value? So, it is lateral part of the thigh. So, looking at the options A, B, C and D, okay, we can go with the lateral cutaneous nerve of thigh, but wait a second, there are two options B and D, both saying lateral cutaneous nerve of thigh. So, they also asked over here the root value, right? So, remember the lateral cutaneous nerve of thigh, it is coming from the lumbar plexus. It is coming from the lumbar plexus that we discussed in our videos. Lumbar plexus, but the root value over here is L2, L3, not L1, L2. L1 and L2 will be the root values of a different nerve, that is genitofemoral nerve. This is the answer over here. So this root value over here fits into genitofemoral nerve. Genitofemoral nerve, right? Remember the cremasteric reflex. And this disease over here is known as meralgia paresthetica. I am sure that most of you may have recalled its name by now. Meralgia paresthetica. Entrapment of the lateral cutaneous nerve of thigh, because this nerve runs very close, around a centimeter or two, close to the iliac crest, ASIS. Therefore, if there is a hypertrophy of the muscles of the thigh, this muscle can get entrapped. Or if there's any cannulation, there's any instrumentation, there's a laparoscope surgery being done in the abdomen, this nerve might come into the procedure and it might get damaged over there, leading to meralgia paresthetica. Here's the lumbar plexus. This was the nerve that they were asking, lateral cutaneous nerve of thigh. There is root value L2, L3. All the branches of lumbar plexus are important over here. Let us briefly go through it. Subcostal nerve is always T12. Iliohypogastric, ilioinguinal, they are L1. They are L1 over here. Genitofemoral, as told to you, is L1, L2. The femoral and obturator, they are always L2, 3, 4. There was L2, 3, 4. Right? I guess there was an option about this also. So this option, see, option number B and C are, as an option, they are wrong. Femoral nerve L2, 3, it is right as an option, but not as an answer. Right? So femoral nerve is L2, 3, 4. The difference between femoral and obturator nerve is it is from the dorsal division of ventral rami, and obturator nerve is from the ventral division of ventral rami. That is the main difference. This is the lumbar plexus L1 to L4. Right? Fine. Let's move to the next one. Okay, here we go. Identify the type of epithelium in the following slide. What is epithelium in this slide over here? So look at this slide carefully. What you're seeing that there are cilia at the top, right? There are cilia at the top. Okay. Then you're seeing that the multiple cells, and cells are quite there's considerable amount of height, so they are columnar cells. But if you trace each cell over here, their basement membrane is matching to all of them. So this looks like a stratified, having a nuclei at different heights, but it is pseudo stratified. It is pseudo stratified. So it is pseudo-stratified, ciliated columnar epithelium, and you should know that this type of epithelium is found in which part of the body? So this type of epithelium is found in respiratory epithelium. It is respiratory epithelium found in the upper or the proximal part of the respiratory tree, respiratory epithelium. Like we have the urothelium, this is the transitional epithelium in the urinary tract. We have the respiratory epithelium in the respiratory tract. So here, therefore, the answer will be our respiratory epithelium, pseudostratified, option number A. Other options: transitional, urinary tract, simple squamous found in the alveoli and in other areas like the endothelial cells. Keratinizing stratified squamous, that is part of the skin. So here, therefore, answer is option number A over here, the respiratory epithelium. Right? Fine. Let's move to the next one. Which of the following are the unpaired cartilages? Unpaired meaning by they are single. So they are single, they are not paired, so they are close to midline. They are at the midline. They are at the midline, therefore they are unpaired. Like for the example, they can ask you which is the unpaired venous sinus in the brain. So those venous sinuses which are exactly at the midline, those are unpaired, like supraoccipital and all that. So here they are asking about the cartilages. Right, unpaired. So that's a basic question. We should know that which cartilages are paired and which cartilages are unpaired. Simple as that. The paired cartilages, some very basic examples, we have the arytenoid cartilage, that is paired cartilage. We have the corniculate cartilage, that is paired cartilage. We have the cuneiform cartilage, that is paired cartilage. These are all paired cartilages. Remember, hyoid bone is not a part of larynx. Hyoid bone, I repeat again, is not a part of larynx. They recently asked us. Now, with unpaired, if you start from the top, we have the epiglottis over here. That is unpaired. We have the thyroid cartilage, single thyroid cartilage. That is unpaired. We have single cricoid cartilage. That is unpaired. Total there are 9 cartilages, 3 paired, 6 and 3 unpaired, 3. 6 plus 3, basic maths, we should know this much at least. Being a medical is 9. So there are 9 cartilages at least. Now, if we look at the options over here, cricoid, is it unpaired? Yes, it is unpaired. Epiglottis unpaired. Yes, unpaired. And what else? Cricoid, epiglottis. Yes. So 1 and 3. So 1 and 3 is the answer over here. We have to identify the unpaired ones. Here is 1 and 3, option number C. Right? Therefore, answer is option number C over here. Should be very clear. Let's see an image over here showing the anterior view of the larynx. What is shown over here is the anterior view of the larynx. Sir, why it is the anterior view? Are you looking at epiglottis coming from front? No. We are looking at the Adam's apple over here, laryngeal cartilage. Yes. Here's the site of the Adam's apple. So in the front view, you can see thyroid, cricoid and epiglottis. They are unpaired. And behind you can see 2 arytenoid over here. One is this, one is this one. And the other corniculate cuneiform, they will be in the lying in the aryepiglottic folds. So those are also paired. But this 3 over here, they are U, that is unpaired. And this was the answer. Epiglottis, remember, is elastic cartilage. Let's see the next one. Okay, and they're very important. Image given below shows dorsum of the hand. Okay, dorsum means this part of the hand which has the nails over here. Here you can see also shown as a nail, so it is a dorsum part. Now they're asking that which nerve gives sensory supply to the marked area. So looking over here, this is the lateral part, the thumb side, that is the medial part. This area they're asking. They already colored, all are color coded. So remember over here, always do remember that this medial aspect, this is the ulnar nerve over here, innervation. This is the superficial branch of the radial nerve. This is a superficial branch of the radial nerve. And this at the fingertips and also on the palmar aspect, on the lateral 3.5 digits, we have the median nerve. So it's a simple question over here, straightforward. You should know the dermatomes, right? The supply or the cutaneous innervation of the limbs at least. Here the answer is radial nerve, but there are 2 options over here to confuse you. But answer is option number B. Let me tell you what is the confusion part over here. The option number A, PIN, it's also a branch of radial nerve. It's also a branch of radial nerve. This might give a confusion. Now do remember over here that when the radial nerve is coming down through the lateral part of the cubital fossa, it divides into a very thin, what is known as a superficial branch of radial nerve. Very thin superficial branch of radial nerve and a normal size going behind posterior interosseous nerve. So if this is the main trunk of the radial nerve in front of the cubital fossa, literally it's coming from behind, this very thin will be the superficial branch, and that is only sensory. It is pure sensory. It is not supplying any muscle. And this bigger one, which is going to the posterior part of the forearm, the extensor part of the forearm, that is a posterior interosseous nerve, and this is pure motor. This is pure motor. It is not supplying any skin. Therefore, option A is not the answer over here. Option number B, radial nerve. You can go with the answer because they are not giving an option as a superficial branch. So if there is no superficial branch as an option, go with the radial nerve. Medial nerve already discussed. Right? Do also remember that radial nerve does not supply the palmar aspect, the sensory over here. It is simply medial and the ulnar nerve over here in the palmar aspect. Right? Okay, let's see the next one. Here's a question of the neuroanatomy. The superior temporal gyrus lesion leads to. So with gyrus, in the temporal lobe, the superior temporal gyrus lesion leads to anomic aphasia. We are not able to remember any names over there. Wernicke's, that is a sensory aphasia, also known as a fluent aphasia. Broca's, that is a motor aphasia, non-fluent aphasia, right? And same, see, option number D is also non-fluent, so it is same as Broca, so they both are similar. So therefore, apply your common sense. C, we have to choose any one answer. C and D cannot be the answer because both are same. So rule out C and D. What we are left with A and B over here. Now they are saying superior temporal gyrus. That's a location of the Wernicke's area. It's a location of the Wernicke's area. And therefore, our answer becomes very straightforward and simple that we have to go with the Wernicke's aphasia. But this question, if they are, they should have given over here, and they have not given, so we assume it that they are asking about the left lobe or the left hemisphere, because these speech areas are basically present in the dominant or the left side of hemisphere. Do remember that too. In the exam, if they give you the right hemisphere, the answers might change over there. So left hemisphere or the dominant hemisphere is where these speech areas, the Broca's and the Wernicke's, they are basically lying in the left or the dominant hemisphere. Okay. Let's see an image over here also. This is an image which is showing us the lateral part of the hemisphere and the middle part of the hemisphere with their Brodmann's area number, right? So here with this 22 number, if you can see over this 22 which is stretched around over here, that is the area, Wernicke's area in the superior temporal gyrus, right? Remember that this over here is the lateral sulcus, this is the lateral sulcus over here, and below it we have this as the superior temporal gyrus, Wernicke's area. Now where is Broca's area? Broca's is 44-45 over here, that is the Broca's area. Brodmann number 44-45, that is the Broca's area. Let's see quickly at other areas as well. 17 over here, that is the visual area, primary, 18-19 are secondary. 4 is the motor area, primary motor. 312 is the sensory area. 6 is the premotor. 8 is for the frontal eye field, for the horizontal conjugate eye reflex, frontal eye fields, right? And 14-42 over here, that is for the acoustic. That's also located in the superior temporal gyrus, but that is more on the inside, and you can call it as a transverse Heschel's gyrus. And the second thing is that if there is damage to the any one side of this 14-42, that is the acoustic area, there is very less problem in hearing because that is bilaterally innervated. Right. So coming back to the question, the answer over here was Wernicke's aphasia. Let's move on to the next one. Muscle derived from the first pharyngeal arch. And this again a topic from the, you can say, embryology of the head and neck. That's very, very important. So there are various pharyngeal arches. There are around 5 pharyngeal arches which we should know. The first, second, third, fourth and sixth one, and the respective cranial nerves. First pharyngeal arch is mandibular nerve. Second is facial nerve. Third is glossopharyngeal nerve. Fourth is superior laryngeal. Sixth is recurrent laryngeal. Both are branches of the vagus nerve. So here they are asking us about what? They are asking us about the first pharyngeal arch, that is the mandibular nerve. So do we know that what muscles are derived or what muscles are supplied by the mandibular nerve? That will be the answer. So for that, let me first show you an image of this. Again, the same pharyngeal arch, but these are the skeletal derivatives. Here color coding, this orange is for the first arch, blue is for the second, yellow is for the third, the red and green are for the fourth and sixth as written over here. These are skeletal derivatives, but here they ask about us the muscle derived. So let us see what is the muscle which is supplied by the mandibular division of the trigeminal. Do first of all understand that mandibular division is a mixed nerve, right? And the muscle supplied by it, we will be very specific, are first of all the masticatory, the 4 masticatory muscles. So all the masticatory muscles are supplied by the mandibular nerve, which are our masseter. Then we have the temporalis, then we have the 2 pterygoids, the medial pterygoid and the lateral pterygoid. These are the 4 masticatory muscles supplied exclusively by the mandibular nerve. Apart from this, do remember there are 4 other muscles supplied by mandibular nerve. Mnemonic you can remember is MAT, M-A-T-T. What does M-A-T-T mean? M is for the mylohyoid muscle. A is the anterior belly of digastric. A is the anterior belly of digastric. T is the tensor tympani muscle in the middle ear. This T is the tensor palatini muscle in the soft palate. These are the 8 muscles supplied by the mandibular nerve. 8 muscles supplied by the mandibular nerve, 4 masticatory and 4 mat muscles. Now we know everything. Let us just now choose the answer. Mylohyoid, yes, that was the M of mat. That is the answer. Let us see other options. Posterior digastric, facial nerve. Levator palatini, pharyngeal plexus, basically the vagus nerve. Buccinator, part of the facial muscle, so again facial nerve. Answer is option number A. If you know the concepts, we know the answer, then you have to literally search for the answer. Because once you have the knowledge, then this exam is the easiest exam in the whole world. Why? Because answer is in front of us, you have to click on the correct answer. That's it. Let's see another one over here. 36-year-old man got a brain injury. After crashing his motorcycle. A series of the skull revealed the sella turcica on which the pituitary gland sits. It was fractured. Sella turcica is a bone that was actually fractured. Which bone is most likely to have been injured? That's fairly straightforward question, if I may say so. Well, we should know that sella turcica is a part of which bone, and that is answer way. That is definitely the sphenoid. And which part of sphenoid? That is from the body of sphenoid bone. Sphenoid bone as a topic has been asked quite frequently in our previous few years, a couple of years. So sphenoid bone is remember, it's an unpaired bone, single bone, it's an unpaired bone, and there's a big body in the center which has a sella turcica and has 2 pair of wings. They are known as the lesser wings, and bigger wings over here, they are known as the greater wings. Which will actually going on the lateral side, and they form a part of the pterion. Pterion is that H-shaped suture over here, greater wing. That is part of the greater wing. Therefore, it's a sphenoid bone over here is the answer over here about this sella turcica. And here is a cranial fossa with all the different foramens shown to you, but here we are looking mainly on the sella turcica part. And remember over here, this area is the sella turcica over here, right? This will be the part of the lesser wing and that will be part of the greater wing, and these foramens, all the foramens are labeled. So it's basically right half of the cranial fossa is the image, but here what we are basically looking at is the sella turcica. Do remember the pituitary gland sits over it, and over it we have the optic chiasma that is also going, because this is the optic canal. The optic nerve goes like this on both the sides. Remember that NOPAs which happen after the pituitary adenomas, that is also a famous question, right? So sella turcica is sphenoid bone, that should be clear. Let's see the next one over here. A question of the thorax. During anesthesia, 53-year-old patient vomited and subsequently breathed in a part of vomit, so it's somehow aspirated. On bronchoscopy, it was discovered that partially digested food was blocking the right upper lobe bronchus. Right upper lobe. In the right lung, we have 3 lobes, upper, middle and lower. But right upper lobe was being somewhat blocked. That is most commonly right, because when we aspirate anything from the trachea, it normally goes to the right bronchus. Which of the listed bronchopulmonary segments will be impacted? So basically they are asking you that do we know the names of the bronchopulmonary segments in the right upper lobe? That is the question. Let us see how many bronchopulmonary segments are there. There are 10 on the right side, there are 10 on the left side. Here the different color coding. These 3 are from the right upper lobe, apical, anterior and posterior. These 3 over here, right? Then these 2 lateral meter are from the right middle lobe. I am writing RML, right middle lobe. And rest all of these blue colors over here, they are from the right lower lobe. They are all basal, anterior, posterior, medial, lateral and apical part, or a superior part of the basal. The question which they asked was about the right upper lobe bronchus, and for apical, anterior, posterior, this will be our answer. We will see the answer. Let's complete this topic. On the left lung, we have 2 lobes of upper and lower. This whole apical, posterior, anterior and superior inferior lingual lobes or lingular bronchopulmonary segments, these are part of the left upper lobe. And these again 5 similar on the right side, these from the left lower lobe. Answer will be our apical, anterior, posterior. Now let us see the answer. Apical, anterior, posterior, if you start searching it, you reach at option number C, and which will be our best possible answer. Right, so just at least know the names of the segments, that is important in this particular question. Coming from the thorax, lungs. Okay, let's see next one. 45-year-old diabetic and hypertensive male patient presented with severe pain in his right eye. So you can see the beginning, diabetic and hypertensive, 45-year-old, pain in the right eye and forehead. So this pain, some sensory involvement. He also has fever for the last 2 weeks. A day prior to the onset of symptoms, he had attempted to burst a furuncle in the outer margin of the left nostril. In the outer margin of the left nostril, tried to burst a furuncle. Not a very good thing to do. Cranial MRI and non-contrast CT scans were done. On examination, the treating physician could not test the extraocular muscles of the affected eye, as movement of the eye were extremely painful. So can't test the movement of the eye. There was a lot of pain, and there was this furuncle that was being busted. There was fever, there was diabetes, hypertension, everything. On observation, there was edema also with exophthalmos. So we know that we are dealing with what? This is the dangerous area of the face. He bursted a furuncle, the thrombus went behind. It went to a sinus, that is what we have to look for, and blocked that sinus. Due to blocking of that sinus, the sensory supply to the orbit and the eye, as well as the motor supply to the orbit and mainly the extraocular muscles, they were actually being compressed. That lead to our thrombosis of that particular sinus. That is the answer. That is the cavernous sinus thrombosis. So it's a typical case of cavernous sinus thrombosis. And mind you, it starts from one eye, go to the other eye, because both the cavernous sinus, they are interconnected by the intercavernous sinuses. Right. So here let us see a area that is, this is a dangerous area of face. So what this in this question what the patient did, there was a furuncle over here and tried to burst a furuncle. So bad luck, and the thrombus of the infection went behind and blocked the vein. Which veins? That could be the next question. Now here is the next image over here showing us the various communications between the veins which are present on the face. So this is the face anteriorly over here and the cavernous sinus over here and the cavernous sinus. So what are the various veins which are connecting it? Let us understand it. What are the various veins which are connecting it? This is the superior ophthalmic vein and inferior ophthalmic vein. These two, they directly communicate with the cavernous sinus. So these are from the face, they directly go behind into the cavernous sinus. And then apart from this, there is also indirect route, which is involved the deep facial vein and the pterygoid venous plexus. So these two are indirectly associated, or they are indirectly communicating. So from here we have a deep facial vein that will go inside, and from here they go to pterygoid venous plexus, finally they reach the cavernous sinus. So therefore this is the point why we said this part of the face is the dangerous area of the face, basically the center part of the face, and that may lead to cavernous sinus thrombosis, which was actually being shown in this particular question over here, right? So answer is cavernous sinus thrombosis will be our best possible answer over here. And this is the coronal section. Finally, what we are looking at, a coronal section of the cavernous sinus. So what actually happens when this part of the sinus gets blocked? Look over here, this is one cavernous sinus, this is one cavernous sinus. In the lateral wall we have the third nerve, the fourth nerve, right? The V1, ophthalmic sensory supply, this V2, which might also be present somewhat outside as well. This is the sixth nerve over here, abducens. So you can see over here that due to involvement of the third, fourth and sixth nerve, the extraocular muscles, or there is a ophthalmoplegia for the patient. Due to involvement of V1, there is a lot of pain. And as the veins over here, as the veins are blocked, as the veins start to block, obviously there is going to be congestion in this particular area, as was given the question. This is our cavernous sinus thrombosis. It's one of the emergencies of the ophthalmology, right? So these are all the questions, guys. I hope you enjoyed it, and all the best. And that's all. Thank you.
Hello everyone. So let's discuss the biochemistry section of your paper. So question number 1. Gluconeogenesis occurs in which of the following compartments of the cell? So guys, this is the question which is based on the site or the location of a particular pathway that we should always remember. So to remember the pathway, we can remember this mnemonic that there are few pathways which occurs in both mitochondria plus cytoplasm. Okay, so both the areas of the cell are used, and for this we can remember a mnemonic that is PUBG. Okay, so where the P stands for the pyrimidine synthesis. Okay, U stands for urea cycle, right? And B for blood synthesis. So guys, blood means heme synthesis, like the pathway which makes the heme. And G for the question, gluconeogenesis, right? Now guys, when we talk about the gluconeogenesis, right, so the answer for this question is C. Okay, so for gluconeogenesis, there was an old question which was asked like this, that the sequence will be cytoplasm, mitochondria and endoplasmic reticulum. Okay, cytoplasm, mitochondria and endoplasmic reticulum is also involved, right? Now guys, there is a pathway that is called as glycogenolysis that also uses cytoplasm plus endoplasmic reticulum. So endoplasmic reticulum, the last enzyme glucose 6-phosphatase that is also deficient in von Gurkis is also part of endoplasmic reticulum. So glycogenolysis. Then guys, there are a lot of pathways which occurs only in mitochondria, like we can say beta oxidation of fatty acids, for example, and electron transport chain, right? Then there are pathways which occurs in certain other parts of the cell, like peroxisomes, right? So peroxisomes, guys, they have certain pathways which are happening there. For example, the very long chain fatty acid oxidation. So in the PX for peroxisomes, very long chain fatty acid beta oxidation, right? So fatty acid and the defects in peroxisomes are associated with Zellweger syndrome, right? Zellweger syndrome also. So remember some of the pathways like this. Also the alpha oxidation also occurs in alpha oxidation of branch chain fatty acids, that also occurs in peroxisomes. So that is again deficiency causes the Refsum's disease, which is again an important question, right? Okay, fine. So remember the mnemonic PUBG, fine, for the common questions which have been asked in exams. Okay, next question. So there are total 17 questions here, and so we are on question number 2. Okay, which enzyme is deficient in von Gurkis disease, right? So guys, in the von Gurkis disease, the type 1 glycogen storage disorder, fine. So first of all the names that we should know, that is type 1, type 2, 3, 4, 5 and 6. Okay, so we have to remember the name of all the disorders. Okay, so we can remember a mnemonic, that is like, let's make it V for V, von Gerke's disease. So you can remember a mnemonic, that is Viagra pills can augment the male happiness, right? Okay, so that will be more convenient to remember. Viagra pills can augment the male happiness. Okay, so that you can remember. So V for the von Gerke's disease, right? What's the name of enzyme deficient in the von Gerke's disease? There is a deficiency of an enzyme that is called as glucose 6-phosphatase. See, von is 1 and G for Gerke's and G for glucose 6-phosphatase. So that is ending with the G. Von Gerke's, G for glucose 6-phosphatase. Now P for Pompe's disease, right? We all know Pompe's disease. Now guys, in the Pompe's disease, this is the only disease which is also a lysosomal storage disease. That means the glycogen accumulates in lysosomes. Okay, so here the heart is commonly affected. So Pompe's affect pump. Find one thing. Now guys, Pompe's affect pump. If I write like this, Pompe's affects the pump. Pump means heart. And guys, heart has 4 chambers. Right, so heart has 4 chambers, and these 4 chambers represent here that the name of the enzyme that we can remember here, that is called as alpha 1,4 glucosidase, right? Alpha 1,4 glucosidase. Okay, or we can also call this acid maltase, right? Acid maltase. Clear? Then we have C for the Cory's disease. Now guys, in the Cory's disease, the name of the enzyme deficient, okay, A for Anderson's disease. Okay, so ABCD, remember like this, A branching enzyme, Anderson branching, Cory's debranching, right? So Anderson has the branching enzyme deficiency and Cory's has the debranching enzyme deficiency, right? Debranching enzyme deficiency. Now guys, debranching is also called as alpha 1,6 glucosidase, right? So guys, also remember like this way, that Cory's means core means our abdomen means like 6 packs, though we don't have, probably you might be having, right? So debranching enzyme, that is alpha 1,6 glucosidase. So remember like this, core has 6 packs, heart has 4 chambers, right? Okay, otherwise ABCD, very simple. But sometimes the examiner will mention alpha 1,6 glucosidase like that. M for McArdle's disease. So we all know McArdle's disease. And guys, in the McArdle's disease, there is a deficiency of the enzyme that is called as muscle phosphorylase. Okay, muscle phosphorylase. So M for muscle phosphorylase, M for McArdle's. H for Hirsch's disease and hepatic phosphorylase. Right, then guys, there is type 7 disorder also, that is called as Taruy's disease. Okay, Taruy's disease. Okay, so guys, Taruy's disease, remember like Turai, remember that you wanted to do a party and your mom make Turai ki sabji, right? So in the Taruy's disease, what is deficient? PFK1, right? That means you wanted to do party, but your mom made what? Turai ki sabji. So party fir kabhi, right? Today you have to consume turai, right? So that is just the way to remember, else you can make your own. So party fir kabhi karenge. Clear? Abhi bas padhenge. So that is all the disorders. But guys, I also want you to remember the GSD type 0. That has been recently asked in some other exam. GSD 0. In the GSD 0, there is a deficient enzyme that's called as the glycogen synthase. Okay, glycogen synthase. Clear guys? So that's all to remember, all the glycogen storage. Very important MCQ. Always there in the exams, most common, one of the common MCQs, right? Okay, 4-week-old female was brought to the hospital by her parents. The infant appeared lethargic, complaining of persistent jaundice, failure to thrive, and has a distinct rotten cabbage. Guys, actually, instead of rotten, the word should be boiled cabbage, This can be just to make you distract from the what you know already. Okay, so boiled cabbage odor from her urine. Biochemical examination shows amino acid urea and the phosphate urea. Which of the following is the most likely to be the clinical diagnosis? So guys, just mentioning the order. If you remember the order, we can easily remember. So like in the maple syrup urine disease, this is not the answer. The order is called as burnt sugar order. Isovaleric. Okay, it is isovaleric. No, this is misprinted here. So isovaleric acid urea, that is a order that's called as the sweaty feet order, right? Phenylketonuria has mousy or the musty order. And guys, tyrosinemia is our answer. That has a order that is called as a boiled cabbage, or we can also call this as a rancid butter, right? Rancid butter or the boiled cabbage. Any other order that we need to remember? Guys, we can remember one more order here, that is called as a tomcat urine order, right? What is tomcat urine order? That is found in biotin deficiency. That is a case of multiple carboxylase deficiency, right? So multiple carboxylase, right? Biotin deficient enzyme, dependent enzymes are known as carboxylases, like pyruvate carboxylase and gluconeogenesis. Okay, so multiple carboxylase deficiency or the biotin vitamin deficiency. Any other order? Right? So guys, you should know all the orders. Whatever the orders that you have, you must know them. These are the most common one in the exams, right? Okay, so that is our case of tyrosinemia, right guys? Guys, just for your mnemonic purpose, tyrosinemia. How to remember the tyrosinemia? Okay, everything about tyrosinemia or tyrosin. So guys, tyrosin, right? That means TYR. Let's say the tire. Okay, tire. So where is the tire present? So tire is found in the car or the cab, right? So that's way you can remember cabbage like order. And guys, car, C for catecholamine is one of the product of, like dopamine for example, is the catecholamine, right? So catecholamines are the product of tyrosin. Then we have, apart from this, so tire is in the on the car, right? In the car, tires are what color? Black color, right? So this is a tire which is black in color. So what is black that makes us black? Melanin, right? Melanin is one of the product, okay, which is deficient in albinism, right? So this black color tire, so it was running on the road, so tire on the road, okay? So tire on road, right? So just remember thyroid, okay? So just similar to that, tire on road, thyroid, 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 clear? Then guys, we have the next one, that when, what is the name of the enzyme deficient in tyrosinemia? Again, a common question. So guys, when the tire was running on the road, there appears a fire because it was running at a fast speed. So guys, tire, there is a fire, catches the fire. Because it catches the fire, the fumes appear, right? Fumes appear, and the fire or the fumes are doused by, adding the water, right? So we will just add the water to it. So water means hydro. So guys, just to remember the name of the enzyme, fumaryle, okay, fumes, fumaryle acetoacetate hydrolase. What's the name of the deficient enzyme? This is the name of the enzyme, simple. Fumaryle, fumes, acetoacetate means appears, A for appear, fumes appear. So acetoacetate hydrolase means we added the water to it. So imagine a tire and like this. There guys, that's it. That's all about tyrosinemia. Which of the following is true related to the energetics of glycolysis? So guys, glycolysis, in the anaerobic we get 2 ATPs. So that's our answer. In the aerobic glycolysis we get 7 actually, so not 6. right? So this is my answer, option number A, right? Guys, some of the points that you should know apart from glycolysis is that on the complete oxidation of glucose, you will be getting 32 ATPs, right? 1 acetyl CoA in the Krebs cycle makes the 10 ATPs, right? 10 ATPs. And lactate to glucose conversion, right? When you do the gluconeogenesis, lactate to glucose conversion, 6 ATPs are used. How much? 6 ATPs are used. And guys, 4 ATPs are used in the peptide bond formation, right? Peptide bond formation during the protein synthesis. So that's it. This much you should know about the number of ATPs. Clear? Moving to our next question. Which of the given are formed in the HMP shunt pathway? HMP shunt pathway, see guys, also called as pentose phosphate pathway, right? So you should always remember the other name, pentose phosphate pathway. So obviously it is making a pentose phosphate. So option 3 is correct. It is also making NADPH. So 2 and 3 are correct, right? So that is our option number B, right? So remember, hexose monophosphate shunt produces NADPH, and NADPH is very, very important for maintenance of reduced glutathione, right? And that's why the deficiency of G6PD, kya hoga? What happens? The NADPH levels will be low, and because of that, glutathione levels will be low in RBC, and that's why it will be easily damaged by the oxidative stress. Clear? So that's the point. So that is an answer. Simple one, right? Okay. Then comes the next question. A 40-year-old male chronic alcoholic, right, present with the complaints of forgetfulness and unintentionally making his own stories to fill the gaps, right? So you already made the diagnosis. Okay, difficulty in walking, that is ataxia. After examination and laboratory test, diagnosis was established, and the patient was explained that, because of alcohol abuse, there is vitamin deficiency. So guys, which vitamin deficiency? So this is a case of, as we can see, this is a case of because of excess alcohol consumption. This is the patient presenting with Wernicke's, okay, Wernicke-Korsakoff, okay, psychosis, Wernicke-Korsakoff syndrome. Okay, in the Wernicke-Korsakoff syndrome, this is vitamin B1 deficiency. Okay, B1 deficiency is there. Fine. So the Wernicke's syndrome without Korsakoff present with GOA. That is G for the generalized confusion, O for ophthalmoplegia, that present with the nystagmus, horizontal nystagmus, and A for ataxia, like not able to walk straight, as in the MCQ also, right? So global confusion G, O for ophthalmoplegia, A for ataxia. Now apart from this, in the Korsakoff, what happens? There is memory loss and confabulation, right? So first there will be definitely the memory loss, and confabulation means making own stories, right, to fill the gaps that like yesterday I went to a party, but then I don't remember what happened. Then this is unintentional making of the new stories, and I met someone special, right, like that. You got my point? So that is memory loss and confabulation. Clear, guys? Okay. And which part of the brain is most commonly affected in this case? That is also a question. To thalamus and mammillary bodies, right, are most commonly affected in this case, right, guys? So that is vitamin B1 deficiency. Okay, guys, vitamin B1, one thing that I want to just tell you here, that to remember vitamin B1 or thiamine, so to be number 1 in life, okay, that is B1. Okay, so what mnemonic that you can remember? So to be number 1 in your life, what you can do is, first is you avoid alcohol, right? Avoid the alcohol. Then, okay, then we will do the studies. So पढ़ ले, right? So lactic acidosis. देखो, just to remember, I'll tell you again. See, पढ़ ले, lactic acidosis. right? Then vernix, varna. Okay, avoid alcohol, perle varna. क्या होगा? Like if you don't study, what will happen? So perle varna. Then bura for berry, right? So varna and bura. क्या होगा? Bura, thak jayega, right? Okay, or you can remember something else like bura thakega, right? So I'm writing TK. So TK for, guys, very important question. That is the name of the enzyme that's called as transketolase is the name of the test. Bura means, I mean to say berry, right? Vernix encephalopathy, lactic acidosis due to the PDH deficiency. Lactic acidosis is very important. PDH is very important for carbohydrate metabolism and avoid the alcohol, right? So that's all about thiamine that you should remember. Okay, so see again there is a question on vitamins. So which of the following vitamin deficiencies are incorrectly matched with their syndromes? Okay, so what is the answer? Which of the following vitamin deficiencies are incorrectly matched with their syndromes? Okay, so guys, B3 deficiency causes niacin deficiency causes pellagra, correct. So this is correct. B5 deficiency megaloblastic anemia, no. This caused by the B12 and folate, as we all know. So that is not correct. Okay, vitamin E, hemolytic anemia, correct. And guys, also you can remember the cerebellar ataxia, right? Cerebellar ataxia. Okay, though it is rare. I mean, like vitamin E deficiency is rare. B7 or biotin. Guys, biotin deficiency doesn't causes the burning feet. So my answer is 2 and 4. So this is the answer, 2 and 4. Burning feet syndrome is caused by B5 deficiency, right? And B7 deficiency causes multiple carboxylase deficiency, I told you, which presents with the tom-cat urine order, right? And that can be caused by consumption of avidin, that is raw egg white. Am I clear? Okay. So guys, these are the points that you should know. Okay, let me just revise very quickly. Thiamine deficiency, most importantly, we have discussed already. Riboflavin deficiency presents with the angular stomatitis, right? And new blood vessels around cornea, so circumcorneal neovascularization. Pellagra, you all know, and pellagra is caused by consumption of corn, right? And presents with the Castle's necklace. Then B5, burning feet syndrome, and active form is coenzyme A for B5. Then B6, pyridoxine. Pyridoxine deficiency present with a lot of features, and number one that you have to remember is the neonatal convergence, right? Second you have to remember is the homocystinuria, right? Third you have to remember is microcytic anemia, just like iron, microcytic anemia or X-linked sideroblastic anemia. Okay, please note down. Okay, X-linked sideroblastic anemia. So that is all about B6. Biotin is biotin deficiency causes multiple carboxylase deficiency. Then also it causes a disease that's called as Lener's disease. That's a type of dermatitis plus diarrhea. L-E-I-N-E-R. Fine. Then after biotin, we have the next one that is folate and B12. So guys, folate and B12 deficiency causes megaloblastic anemia, and B12 deficiency, always remember your last year question, causes methylmalonic aciduria. B12 deficiency also causes methylmalonic, but not folate deficiency. So a patient with megaloblastic anemia but high methylmalonic acid, its B12 is the best answer. Patient with megaloblastic anemia but methylmalonic acid is normal, okay, can be folic acid deficiency, right? If I have to choose between the two answers, clear? That's it. Okay, vitamin C deficiency is called as scurvy, that you all know. Vitamin D deficiency is rickets and osteomalacia. Vitamin E deficiency, I told you, and vitamin A deficiency is night blindness, right? That is number one. And phynoderma, don't forget phynoderma, that is number 2. Okay, that's all. Deficiency of which of the following minerals? So guys, remember my suggestion, vitamins and minerals you should revise on the last day before your exams. 100% you will be having at least 1 or 2 MCQs, and that is not 1 or 2. That doesn't mean just they are having few marks or something like that, but you have very high chances to get multiple questions on vitamins. Minimum one, I assure you, right? Okay. So deficiency of which of the following minerals leads to Keshan's disease? So the answer is clear. We all know answer is selenium. So guys, zinc deficiency causes what? Zinc deficiency causes acrodermatitis enteropathica, and it also causes hypogonadism or infertility. Okay, hypogonadism, very important question also. Fine. And guys, it also causes already MCQ hypojuicia, that means low taste sensation. Okay. Then guys, copper deficiency causes Menkes disease. Okay, Menkes disease. Selenium, I told you. Chromium is a part of glucose tolerance factor. Already MCQ, GTF, glucose tolerance factor. That is something which increases the insulin sensitivity. Chromium has been tried in the treatment of diabetics also, right? But not a only solution, right? But yes, you should remember GTF, glucose tolerance factor, which also has niacin. Okay, guys, so these are the important minerals and their disorder. Moving to our next question, xeroderma pigmentosum is a disorder which occurs due to defective DNA repair mechanism. And the patient presents with a dry skin, photosensitivity, and the skin cancer. So UV induced disorders, like, these are generally UV damage. Ultraviolet rays, when we are exposed to them, they produces something that's called as, very important, pyrimidine, or one of the pyrimidine is T. So thymidine dimers. Don't forget this. Very, very, very important. Okay. And guys, this is repaired by nucleotide excision repair. That is our answer. And if it is defective, the disease is called as xeroderma pigmentosum. Okay. Fine. So, if there is a defective mismatch repair, the disorder is hereditary non-polyposis colon cancer. If there is a deficient nucleotide excision repair, the disorder is called as xeroderma pigmentosum. There is one more disorder that is called as, it presents with the 100% risk of cancer. Yeah, I can write skin cancer risk. Okay. So risk of skin cancer, that is also present here. Then deficiency of base excision repair. Okay, base excision, like, it removes the uracil, base, the wrong base. Guys, this is not causing, till now, not much disorders are known, but there is a gene that is called as MUTYH, right? Okay, so that is the name of the disease, and gene MUTYH associated polyposis means increased colon cancer risk. So guys, that's a type of actually a colon cancer, right? That's the name of a gene which codes for the enzyme which helps in removal of unwanted bases, like, this is adenine, this is uracil. So uracil should be removed from DNA. That is base excision repair. And what does nucleotide excision do? Repairs the UV damage. And what does the mismatch repair do? Mismatches, like A bind with the G. That is mismatch. This is not mismatch, right? This is wrong base. A bind with the G, A bind with the C, like that. Or the T bind with the C, T bind with the G. Okay guys, also remember one thing, every day we are also exposed to a lot of chemicals which produces the reactive oxygen species in our body, which damages our DNA. So ROS repaired by, answer is base excision repair. So whenever there is a reactive oxygen species like superoxide, it damages the DNA and it is repaired by base excision repair. That can be important. So please remember it. And also I just want to tell you that the damage which is caused by, let's say, the X-rays, ionizing radiation, okay, that can also be repaired by base excision repair. Okay, single strand damage basically. Okay, so guys, these are the three names I told you. Homologous recombination needs BRCA1. So what is the name of disease? You can remember the name of disease is familial or hereditary cases of breast cancers and ovarian cancers. Okay, so in the homologous recombination disorders, there is ovarian and breast cancers. Fine. Okay, so you can remember that. Then guys, I just want to add one more line: non-homologous and joining. Non-homo, one is homologous, right? Homologous means, you know, taking the information from the other chromosome. We have the 2 copies of each chromosome, that is homologous. But if the DNA is lost and it is still repaired, that is called as non-homologous and joining. Just join the ends. So guys, the disease deficiency of this can lead to SCID, MCQ, severe combined immunodeficiency, SCID, right? Already being part of MCQs. MCQs, except the C, disease of C, all are MCQs. So my answer right now is B. Clear guys? That's all about the. So don't forget, that can be a new question, that is damage caused by reactive oxygen species in X-ray can be repaired by base excision repairs. Okay, which of the given are comparative inhibitors? See guys, actually when you have seen this question, I would go for all the options are correct, right? Okay, but sulfonamides do not inhibit directly, they indirectly inhibits the, because the PAB analog, it doesn't inhibit the folic acid synthesis directly. So just in that case, I will go with the answer D. Otherwise, I would go for all of the above, right? Like disulfiram inhibits aldehyde dehydrogenase, correct. Ethanol inhibits the methanol poisoning basically. So ethanol binds with alcohol dehydrogenase and displace or, you know, make it unavailable for methanol binding in the cases of poisoning. Allopurinol inhibits, you know, xanthine oxidase, hyperuricemia. Statins inhibits HMG reductase, hypercholesterolemia, right? So nothing much here, you all know already, right? Complex 3 of electron transport chain. So guys, this is again one of the question apart from vitamins, which is very commonly asked, that is inhibitors. Okay, so you should remember all the inhibitors of ETC, like for example, cyanide. Rotenone is for complex 1, malonate is for complex 2, dimer-caprol is for complex 3 and cyanide is for complex 4. Now if I want to add for complex number 4, it's cyanide, H2S, azide, that everybody forgets, azide, don't forget this name, azide, okay, and carbon monoxide. So these all are complex 4, which is most common question in the exams. Right now our answer is B, okay. Then dimer-caprol is also called as British anti-leucite. So that name you should know, right guys? Complex 2 is also inhibited by carboxin apart from malonate. And complex 3 is also inhibited by antimycin apart from BAL, antimycin, okay? So I told you complex 4, 3, 1 and 2, all of them, right guys? Inhibitors are very, very important. Also remember one more inhibitor, and that is called as atractyloside. Okay, that is inhibitor of ATP ADP translocase. Okay, translocase, right? That is called as translocase. So ATP ADP translocase. Clear? So that is you should know that also. And guys, don't forget dinitrophenol, very, very, very important. That is a case of uncoupler, okay, of oxidative phosphorylation. Uncoupler of oxidative phosphorylation. So guys, don't leave any inhibitor, especially in biochem, because there are very few. In forensic, you may have a lot of other names, but in biochemistry, the list is very small. Hardly 14 or 15 names are there that you can easily gulp down, right? And questions are, there are high chances that you will get one question, right? 40-year-old male present with a joint pain and long standing black urine. So as soon as you see the black urine and joint pain, it's a arthropathy caused by deposition of homogentisic acid, right? So on examination, right, black pigmentation on the sclera and pinna, right? So ferric chloride test is non-specific and Benedict is also non-specific. So you're going to ignore that. What is your probable diagnosis? So guys, it's a case of L-captonuria or it's a case of ochronosis, right? We can also say this is a case of ochronosis. Fine. Okay. So see, it is a 40-year-old. So it's not an inborn error of metabolism as such, like the babies are not affected. The PKU patient, you will definitely get the baby present with, hyperpigmentation or the light skin color and some other features like mental retardation. Homocystinuria, the baby presents with, or the child just 2 to 3 years old, when going to the school was unable to focus on the blackboard. So lens dislocation in homocystinuria. Though joints are also affected, but not the black urine. Na? Then MSUD, the term that is most important is the burnt sugar order in the urine, and again in newborn child. Never reach age of 40 years, right? So it's only L-captonuria which is possible here, even if I don't know the black urine disease. Got it? Fine, guys. So L-captonuria. Guys, just a mnemonic for that. So when I write L-captonuria, okay. So see, alkaline, the name actually was taken from the word because homogentisic acid has a very high affinity for binding alkalis. That's why the name was given L-capton, alkalosis, alkaline, I mean to say. Okay, just to remember, see, what's the name of deficient enzyme? Homogentisic acid oxidase. Okay. So how we can remember it? That, imagine a girl, her name is Alka, right? And she was going to the gym, right? To tone her body up, right? Okay. So L-capton. Yeah, she was also wearing the cap in the gym. So Alka went to the gym to tone her body, right? And in the gym, she met a boy, right? Or a gents, right? Like I'm meant to say the male or the boy. So who was homo, right? Okay. Tendency to be homo, right? So no need to elaborate that. You got my point. So homo gents, right? Just to remember, like homo gents. Fine. So Alka, and she was in the gym, imagine like this, to tone up her body, L-captonuria and homogents. Simple, you can remember it now, okay? Because this is again a very, very common question in the exams. See, in this question, they have asked diagnosis, but this is a less common question. The question will be name of enzyme, clear? So guys, don't forget, in biochemistry, the most important is to remember the name of enzyme first, then anything else second, okay? Fine. Insulin stimulates the fatty acid synthesis by all of the following mechanisms except. See guys, insulin is an anabolic hormone, so it helps in making cholesterol, fat and everything like, glycogen, protein, okay. Increase activity of acetyl-CoA carboxylase. This is a rate limiting enzyme, so yes, it do this. Inhibits pyruvate dehydrogenase, no. First, let me take this option C. Decrease concentration of cyclic AMP. Yes, guys, cyclic AMP is a secondary messenger of glucagon. So obviously, insulin, activates some enzymes like phosphodiesterase and decrease the activity of cyclic AMP or the glucagon. I meant to say both. They both act opposite, na? So cyclic AMP is glucagon messenger. Insulin should decrease it. Yes, correct. Increase the transport of glucose into the cells. Yes, by increasing the GLUT4. So GLUT4 is which is only found in the muscles, heart and adipose tissue. Guys, heart again has 4 chambers and 4 means GLUT4. Because, examiners sometimes ask GLUT4 is present in and they give the option heart and we forget easily. Because we don't remember heart. Heart is a small organ which normally use fatty acids but also can use glucose, and it has GLUT4s, though it is using very less glucose. So remember, like 4 chambers of the heart, GLUT4. And I told you also in the Pompey's pump heart, alpha 1-4. Heart has 4 chambers. Clear, guys? Okay, so all of them are correct except the option B. So guys, even you are unable to answer it, you can check the other three options. So this is a rate limiting step of fatty acid synthesis. This is antagonizing in glucagon action, and transport of glucose is correct. Why it is not inhibiting PDH? Obviously guys, PDH is an enzyme which converts pyruvate to acetyl coenzyme A. So that is done by PDH complex. And this acetyl CoA is acted upon by acetyl CoA carboxylase to make the fatty acid. So obviously we should not inhibit PDH, right? It should be active. Clear? Fine. Which of the following is not true about restriction endonuclease? Okay, let's see options. Option A, correct. So, okay, what was the answer for the last question, guys? Option number B. Which of the following is not true about restriction endonuclease enzyme? Right? So, it cuts the palindromic site, correct. Breaks the DNA and creates sticky ends, yes. Palindromic sites like GAATTC. Okay, that is on the one end, GAATTC. So it reads same 3 to 5 up and 3 to 5 down. Reading same na? In one direction, 3 to 5. So that is palindrome. So it cuts here and creates the sticky ends which will have the free bases. Breaks the sugar phosphate bond, yes, but not the hydrogen bond. So this is my answer. Right? That's your answer. Guys, which enzyme breaks the hydrogen bonds? Helicase. Okay? Helicase. So helicase breaks the hydrogen bond, not the restriction endonuclease. Okay guys, helicase deficiency present with Bloom syndrome. Okay, one of the question. And also present with Werner syndrome, which is also called as adult progeria syndrome. You have seen the movie Pa. In the Pa, it was Hutchinson-Gilford progeria. But, this is Werner syndrome. So, where the faster aging starts after a certain age, not in the childhood, but after crossing certain age. Let's say after crossing certain age of 20 years, 25 years, like that. Okay. So, that is called as a Werner syndrome. And the Bloom syndrome. So, both the disorders are linked with cancer. Right? Like high incidence of cancers. Okay, 7-month baby present, 7-month-old baby present with the complaints of vomiting and irritability. On examination, found to have hepatomegaly with jaundice. Okay, and it started after weaning. So 6 months is given the breast milk, right? Exclusive breast milk. But this is a weaning phase, that is the baby is consuming top feed. So present with these features after consuming fruits and vegetables. Urine has Benedict test positive, right? So this, don't think about diabetes here because it's hepatomegaly and jaundice is also present and vomiting, and this is 7-month-old baby. So Benedict test may be positive by fructose also. So guys, what is our important point here? Age and fruits ka history. 7-month baby which is not given breastfeeding now, to say not exclusive breastfed baby now, and fruits, fruit history of fruits. Fruits means fructose. Okay, so guys, just to remember, this is a case of hereditary fructose intolerance, not the essential fructosuria, because that doesn't present with any symptom. This is hereditary fructose intolerance. Just to remember the mnemonic, that all bees, imagine the honeybee, all the bees, okay, love high fructose items. Correct? So what I mean to say is, all bees means the name of enzyme is aldolase B. Okay, and it is deficiency causes the disease that's called as hereditary fructose intolerance. Okay, remember this much. So what is important? History of no clinical features still given exclusive milk-based diets. I mean to say breastfeeding, because milk has no fructose. But symptom starts only after given juices, honey or something like that. Okay, so guys, my answer here is the only option says aldolase. okay, or fructose 1,6 bisphosphate aldolase. Remember, aldolase is also found in the glycolysis, right? Okay, it is also found in glycolysis. So guys, this is actually, I want to say something here. This is the answer which is given not correctly. Please, let's change it. The answer should be fructose 1-phosphate aldolase, not 1,6. Okay, 1,6 bisphosphate aldolase is found in glycolysis. So don't worry, in the exam most commonly you will see aldolase B as the option, or fructose 1-phosphate aldolase is the option, not this one. Okay, fine guys. Okay, so not the A. A is the case of essential fructosuria with no symptoms. There's transparency of cornea. Remember, cornea needs keratin sulfate. Okay, so this is my answer, B. Right? Heparin sulfate is found in the renal or the glomerular basement membrane. So important for filtration. You know, it provides the negative charges basically. That is also the question. Heparin sulfate. Okay, fine. Moving to the last question of our discussion. So a patient with an intellectual disability was found to have hyperuricemia, self-mutilation. So see, intellectual disability is also there, that is mental retardation, right? Self-mutilation. Which of the following enzyme is deficient? So guys, this is the line here. Unique point, self-mutilation. No other disease you will find the self-mutilation, right? This is the only case you will find it. So the answer is Lesch-Nyhan syndrome, and answer is C. Okay, C is the correct answer. See, the finger is shown, that means mutilation. Okay, just to remember, L-E-S-C-H. So guys, L for, you know, the lips bite. Okay, E, just to remember, excess uric acid or urate. S is for self mutilation. C for chorioathetosis, and H for the name of enzyme, that's called as HGPRT. Okay, HGPRT. Fine. I can also remember H for hyperuricemia. But again, the uric acid you have to remember. What hyperuricemia. Fine. And guys, I can also remember that Lesch-Nyhan syndrome is a case of, you know, defect, very important, defect in purine salvage pathway, right? Purine salvage pathway, salvage, don't forget this. You know, sometimes they can ask you to just directly the name of this pathway, not the name of enzyme. Fine. So purine salvage pathway, that is also the correct point, right? Okay, right guys. And L, I can also remember L for low IQ, that is mental retardation, right? Low IQ. And guys, Lesch-Nyhan syndrome is a X-linked recessive disease, and so boys are affected most commonly, right? Okay, so the patient who is affected is, you know, him, not her. But just to remember, like, you know, remember it like this way: X-linked recessive Lesch-Nyhan syndrome. That's the case. Enzyme deficiency is almost 100% in Lesch-Nyhan syndrome. Clear, guys? So this is your faculty, Dr. Amit Jain, right? And I wish you all the best for the upcoming exam. Hope you enjoyed the session. Let me know, right, if anything you want to add here. Thank you so much, guys. All the best. Bye-bye.
Hello students, you are with your forensic teacher Dr. Sumit for the discussion of the grand test paper held on 4th of June. The subject is forensic medicine. Let's begin by taking our first question. The first question is, a person sustains multiple injuries. multiple bruises. Actually, it is given as bruises. So, a person sustained multiple bruises due to injury. Which presentation best describes an ectopic bruise? Okay. So, in the question we can understand the question is specifically asking about the concept of ectopic bruise. So, let us first of all see what is this concept of ectopicity in bruising. So, we all know that bruises are what? Bruises are contusions which are extravasation of blood in the subcutaneous tissue when the area receives a blunt force. Okay. So, whenever there is a blunt force which is delivered to an area of a body, the underneath vessels get ruptured and the blood leaks out and it diffuses in the subcutaneous tissue. That is called as an bruise. Now, what is ectopicity in bruise? Ectopic bruise. Ectopic bruise is a bruise which does not develop at the site of impact. What happens is, at the site of impact, the blood which leaks out, it trickles down the tissue planes and it settles in some other area where no body impact was given. That area starts to show the discoloration of bruising which was not even hurt, which was not even impacted, and that is called as an ectopic bruise. Okay. The ectopic bruise is collection of blood in an area which was not even impacted by blunt force. For example, in cases of renal trauma, so if a trauma is delivered to either of the kidney, sometimes the perinephric blood which collects, it trickles down the tissue planes and settles in the iliac fossa region, right, of the abdomen. So, nobody has actually hit the iliac fossa region, but discoloration due to collection of bleed may be seen in the iliac fossa region. That is an example of ectopic bruise. Okay. Now, in the question, if you will see, there are 4 options which are given. One is bruise over forehead. So, there is a collection of bruising on the forehead. Second is bruise around the eye, that is the periorbital area. Third is bruise over the scalp, and then fourth is bruise below the chin, right. So, question is very simple. Which presentation describes an ectopic bruise? Okay. The correct answer here is option number B, bruise around the eye. This bruise is also called as panda sign or spectacle hematoma. What is spectacle? That is your wearing glasses. So, all around the eye, that is periorbital area, spectacle hematoma. If it is bilateral, it may be called as a bispectacle hematoma. And this collection can happen in cases of forehead trauma or also in cases of fracture of anterior cranial fossa, right. So, in those cases where there is a fracture of anterior cranial fossa or maybe a forehead trauma, sometimes the blood which collects in the area of impact, it trickles down and settles around the periorbital area comfortably, called as the panda sign or the bispectacle hematoma. It is one of the best examples of describing ectopic bruising, and that's what was asked in the question. Let's move further. Let's take our second question. Okay. A drug addict is brought to the hospital from a party. So one important thing which is given here is that the person is coming from a party. Okay. He is found to be in euphoria. Euphoria is highly elated. Okay. And is playing an imaginary guitar. Okay. And is simultaneously dancing also. Right. What compound could be responsible for this? And then we have 4 options. The concept is very simple. See, we need to identify the important clinchers which are given in the question. Very important clincher given in the question is party. So, we are expecting some party drug. Okay. So, kind of drugs, which are generally utilized or distributed in parties. So, why would, what kind of drugs would be distributed in parties? Depending upon what is the status of the party. Generally, drugs are distributed in parties for, euphoria of the people. They should feel elated. They should enjoy the party like that. Okay. But simultaneously, further clinchers which are given in the question is that the person is playing an imaginary guitar. So, there is no guitar in his hand. He is just playing an imaginary guitar and is dancing, which means he is exhibiting hallucinations. He is thinking that I have a guitar and I am playing and I am dancing. There is a music which is playing and I am enjoying myself. These powerful hallucinations which are continuing with him, although he has been brought to hospital, are product of a very special compound called as LSD. Which is the correct answer here. LSD is responsible for causing very powerful visual hallucinations. LSD is one compound which is responsible for causing very powerful visual hallucination. The person is elated, he is in euphoria, his heart rate is increased, his pulse is increased, his respiratory rate is increased, because when a person experiences those powerful hallucinations, they are enjoying, they are dancing, they are running, so person will be seen in sweats. Okay. So, our correct choice here is LSD. There are 1 or 2 more important choices which are given in the option, like opioids. Opioids generally are not party drugs. They are generally are not party drugs. Okay. Although there are people who use opioids for their personal recreation, but they are generally not used in parties. Then we have cocaine. Again, yes, cocaine is a choice. Cocaine is also used in party. And consumption of cocaine primarily is responsible for, or presentation of cocaine is increased heart rate, increased pulse, increased respiratory rate, and in cocaine intoxication, generally people present with coronary spasm, that is called as an MI kind of symptomology. So remember this. In intoxication, it produces myocardial infarction like symptoms. Okay. So, if the question would have said that a patient presents with increased heart rate, increased pulse, and when people have pain in chest, MI kind of symptoms, coronary spasms, they don't feel euphoric, they don't play guitar, they don't dance, right? Now this people in this person in intoxication will present with pain. He would rather be dying, and that's not a kind of symptom that is given in question. So cocaine is out of choice, right? Let's move to our third question. The below shown dead body is brought for autopsy. What environmental condition is responsible for its appearance? Now, if you read this question again, the first thing is, the question is asking about appearance of the dead body, and the dead body picture is shown in the photograph. So we need to understand how dead body is looking in the photograph. So if you see the photograph clearly, let me enlarge the photograph for you. Now we can see in this photograph, the dead body is very greasy. If you will see the surface of the dead body, all over in the face, breast, abdomen, there is a greasiness, a shine. In Hindi we call that as a chiknai, that greasy appearance dead body. It's a very greasy kind of a dead body, and this greasy appearance of dead body comes in a post-mortem change called as adipocere formation, also known as saponification, adipocere formation or saponification. Now if we recall our knowledge about decomposition of dead body decomposes in three ways. The normal way of decomposition of dead body, the normal way of decomposition is putrefaction. What do we see in putrefaction? There is destruction of the body, and it tends to have a foul smell. Then another way of decomposition is called as mummification. Mummification happens in hot and dry air. This happens in hot and dry air. So when hot and dry air impacts the dead body, it picks the moisture away from the dead body, and as a result the dead body dehydrates. So in mummification the body has a dehydrated appearance. So dehydrated dead body will rather be looking like a collapsed, shriveled kind of body, which you can see in the photograph. The dead body is not a collapsed or a shriveled kind of, having a collapsed or a shriveled kind of appearance. So it's not a mummified dead body. And the third thing is adipocere formation. Adipocere formation happens in hot and humid air. So whenever the air is humid, lot of moisture in the air, okay, humidity is must. Even if it is not very high temperature, because of excessive humidity, it automatically becomes hot. So whenever the environment is hot and humid, the bacteria, they channelize their efforts towards hydrolysis of body fat, and as the body fat is hydrolyzed, fatty acids are generated. These fatty acids combined with the ions in the body to form soaps, and that's the end product called as saponification or adipocere formation. As a result, the body is greasy, the body is shiny. When you touch the body, you have that greasy appearance. It has a sweet smell. So the features of adipocere are greasy, shiny body, sweet smell, and it is also inflammable. Adipocere has inflammable property, and that is what we see in the appearance of the dead body. So correct answer here is hot and humid hair. Okay, humidity is must for production of adipose. Next question, a doctor who is owner of a nursing home. So a doctor, okay, there is a comma, a doctor owner of a nursing home encourages a quack to practice in a nearby slum. He encourages the quack to practice in a nearby slum area as he gives business to the doctor's nursing home. What act is it? So what are we seeing in the question is that there is a doctor who is owner of a nursing home and he encourages a quack, a non-professional who is practicing in nearby slum area on probably very low practicing fee, because, and he is not reporting him, he is encouraging him to practice because he keeps on giving business to the doctor's nursing home, that whenever any patient is not in the purview of the treatment of that quack, the quack may be sending those patients to the doctor's nursing home only. So what is doctor doing? He is encouraging a non-professional, okay, to practice which is not even his profession. This unethical act is called as covering. Okay, covering is an unethical act and it means a professional covering the mistakes of a non-professional. So whenever a professional covers any non-professional for his mistakes and he encourages them, that is an unethical act, and if it is done by a doctor, it is an unethical covering act by a doctor. Okay. Now there are one or two more important terminologies which are given as choices A and B, which are also very important. The first is dichotomy. Dichotomy is commonly called as fee splitting. When two doctors split their fee over a patient. Now consider a patient comes to you and you treat the patient, you see the patient and you ask certain basic investigations from the patient, and he comes back to you in follow up with all those investigations, and when you see those investigations you think that okay, this is not a patient in my purview and he has to be sent to a nephrologist, let's say that, and you refer him to a nephrologist, right? So you have taken the fee from the patient. Now you have referred the patient to a nephrologist because he has to take a opinion from nephrologist, or he has to be taken by treated by him. When he will go to the nephrologist also will take his treatment money. That is not dichotomy, because two separate doctors are taking money for treating the patient. But if you send the patient to nephrologist and later on you ask the nephrologist to give you a commission for sending the patient to him, that's called as dichotomy. If a doctor is sending patients to another doctor and getting commission for it, that's dichotomy. If a doctor is sending patients to a particular labs for their investigations and then further those labs are paying cuts to the doctor, that's called as dichotomy, which is unethical in medical practice. Then again, vicarious liability, option number B. It's also an important thing to understand. Vicarious liability is responsibility of the employer for the negligence done by his employee. So, if an employee commits a negligence, the employer is also answerable. That's vicarious liability. In vicarious liability, the foundation is a doctrine which is practiced in law called as respondent superior. Okay. So, with vicarious liability, remember a very important doctrine attached, or you can say the foundation of vicarious liability is that doctrine called as respondent superior. Respondent superior means let the superior answer. So, if an employee commits a negligence, the employee can hide behind the shield of respondent superior and his employer will have to answer for the negligence done by the employee. That's vicarious liability. Okay. Let us take up our next question. A blood stain is found at the crime site. On doing Teichmann's test in forensic science lab, it generates crystals on microscopic examination. What are the crystals? So, again, the important things which are to be highlighted in the question is that it is given in the question that it is a blood stain. Okay, so you don't have any problem with it, that it is a blood stain, and the test which is done on this blood stain is a Teichmann's test. Very simple. It is a test which is done for identification of blood stains found at crime site. It is documented. Okay. When Teichmann's tests are done, microscopic crystals are generated, and the question is simply asking what are the crystals. The answer is Teichmann crystals. So, what is Teichmann's test? Teichmann's test is you take the sample and to that sample or smear of the sample on a slide, right? You are going to watch it microscopically, so you need to do the slide preparation. You take a smear of the sample on a slide, to which you add a pinch of sodium chloride, also hydrogen peroxide, and then you see under the slide if it generates any microscopic crystals. So, when we see microscopically, in the microscopic appearance, we will be able to see crystals which are brown in color, rhombic in shape. Okay, crystals are generated which are brown in color, rhombic in shape, which are present singly or in clusters. So, in the photograph also, or the drawing that I have made, you can see that these crystals, they may be present singly, as you can see here, or in clusters, as the cluster of crystals can be seen. Okay. These are called as Teichmann crystals, also called as Teichmann chloride crystals. Okay. Now, there is another test which is done for detection or identification of blood stain, which is called as Takayama test. In Takayama test, there is generation of hemochromogen crystals. So, hemochromogen crystals are generated in Takayama test. Okay. The other two choices, that is option number A and option number D, both are tests done on semen, not on blood. Okay. Choline iodide crystals are generated in Florence test done for semen. Okay. So, the product of identification here is semen, not blood. And spermine picrate crystals are generated in Barberio's test. So, two tests for blood, two tests for semen, all four of them generate crystals. crystals have different name. Okay. Permin chloride generated in Barbario for semen. Choline iodide generated in Florence test for semen. Pigments for blood, the crystals are hemine chloride or hemine crystals. Takayama for blood, the crystals are hemochromogen. Okay. Okay, let's see the next question. A body recovered from water shows cadaveric spasm in hand. The best correct statement is, see, the most important thing which you need to understand in this question is that the examiner wants to know whether you know what is cadaveric spasm. Simple, cadaveric spasm. Cadaveric spasm is the alteration of rigor mortis in one way. Rigor mortis is the stiffening of the muscles that build up gradually after death. Okay. Cadaveric spasm is stiffened muscle seen right at the moment of death. It does not build gradually. Cadaveric spasm is not seen in the entire muscle groups. It is only seen often in a certain or a particular muscle group, most commonly in the upper limbs. Okay. Now, there is a body which is recovered from water here and it shows cadaveric spasm in hands. What does it mean? That the person who has fallen into water, he must have used his hands vigorously, right, to save his life. As a result, during the last few seconds or minutes of his life, all the ATP stores from his upper limb was very quickly getting washed off or very quickly was getting vanished. So, at the moment of death, when ultimately this person would have been, drowning into the depth of the water source, he must have tried to hold something in his hands, and suddenly at that moment death also happens, and whatever he catches in his hand, it remains tightly clinched in his fists. That's called as cadaveric spasm. And when the body is taken out of water, whatever he is catching in his fists, that can be seen firmly held. And what does this suggest? Does this suggest that the person committed suicide, which is given in option number A? Probably yes, because even in suicides it can happen. Can it be homicide? Probably yes, because the same phenomena can happen in homicide also. If you throw somebody into water, he will struggle to survive. So, what is the most important concept that it tells us? The most important concept that cadaveric spasm in hand tells us is struggle to survive. Development of cadaveric spasm in a drowning person is suggestive of struggle to survive, and struggle to survive means antemortem drowning. It means the person was alive when he fell into water, right? It could be suicide, it could be homicide, it could be accident also. The question is asking the best correct statement. The best correct statement is it's a case of ante-mortem drowning, right? Because cadaveric spasm cannot be seen in post-mortem drowning. Post-mortem drowning would be you have already killed a person or there is a dead body, then you throw the dead body into water. There will be no struggle to survive in that case. So, cadaveric spasm would not develop in that dead body. Okay. Right, let's see the next question. A patient dies after an operation because of the negligence of the doctor who disregarded the blood transfusion in the post-operative time period. This is punishable under which section of IPC? It's a very, very clear, clean question. The question is basically asking or it is already telling us that the person has died of negligence, and the negligence is that in the post-operative time period a transfusion had to be given, the doctor disregarded the transfusion and the person died. So, what do we see here? The scenario is death due to negligence of the doctor, and which IPC is responsible for providing punishment if somebody dies due to the negligence of other person. The answer is option number A, IPC 304A. IPC 304A punishes for death due to negligence. The punishment here is two years of imprisonment. The punishment here is 2 years of imprisonment. Okay. Remember another important IPC which is just given beneath IPC 304A, which is IPC 304B. This is punishment for dowry death. It is 7 years. Okay. Because both of them are very close. The difference is A and B. So A is death due to negligence, B is punishment for dowry death. Next question. A fetal dead body is found which measures 16 centimeter in length. What is the gestational age? Again a very straightforward critical question. This gestational age is calculated by rule of Haas, and rule of Haas says that in the first 5 months of gestational time period, the length is square of the month. So, first month, second month, third month, 4, 5. The first 5 months, the length of the fetal body would be square of the time of month. So, the first 5 months, the answer would be 1 centimeter, 4 centimeter, 9 centimeter, 16 centimeter, 25 centimeter. For the next 4 months beyond 5, it is the multiple of 5. So, 6 month, 7 month, 8 month, 9th month will be 5 into 6, 5 into 7, 5 into 8 and 5 into 9. Now your answers would be 30 centimeter, 35 centimeter, 40 centimeter, 45 centimeter. Okay. The answer giving now becomes really easy. In the question, the length is given as 16 centimeter and 16 centimeters mean it is a 4-month-old fetus. Very simple. The correct answer here is option D, which is 4 months. That's rule of Haas. Right. Our next question is, a patient was brought to OPD with greenish color skin and rotten egg smell. The poison could be. The important thing which are given in the question is green color, rotten egg smell, poisoning. And what compound has a rotten egg smell and a green color? Even if you can remember it 2 ways, either by the green color of that compound or the rotten egg smell. Rotten egg smell is produced by gas of organic decomposition. When organ decompose, body organs decompose, the gas which is produced, it is hydrogen sulfide. So correct answer here is option number D, hydrogen sulfide. Right. With that, we come to the discussion or the end of our questions. I would say thank you for being in the discussion, but that's not all. All the very best for your future endeavors of life. And an important thing to remember, which is often said by many of us, which is very, very difficult to do, but it is very simple to hear and understand. And that is, you are awesome. Every one of you is an awesome personality. Just maintain that awesomeness. Keep on working with your awesomeness, your capability. Gradually everything will build up. Right? With that, we come to the end of this discussion. I'll see you sometime in some other capacity of forensic. Bye.
Hello friends, you all must have done your test, and I suppose the micro part is a bit easy only, and I suppose you would have scored up well in that particular portion, and I am here to tell you the right answer and along with that certain points which can come in and around them. Okay. So the first one is a patient who has taken up the clindamycin for a very long time, okay, presented with diarrhea. Which of the following is the causative organism for this? So it's a previous FMG question only. And the answer to this question is obviously what, guys? Clostridium difficile. Okay. First of all, this particular diarrhea is termed as what? It is termed as CDAD. So Clostridium difficile associated diarrhea. That is the full form of it. And if this particular thing is not taken care of in time, it leads to what? Pseudo membranous colitis, that you already know. Okay, and the drug of choice for this is like interestingly what it is due to the antibiotic, and the drug of choice is also another antibiotic. Okay, that is oral vancomycin. And nowadays what is being used, guys? Fidaxomicin. Okay, so if that is there in the option, then you have to mark up that as the answer. Okay, another important question which can come here is that how to demonstrate the toxin of it. So the toxin demonstration, which is actually the combination of A and B, okay, this particular one, which is antero plus cytotoxin, this is being done on the HEP2 cell lines. Okay. Other than this, what needs to be remembered is that there is a antigen which is termed as glutamate dehydrogenase antigen. For this antigen detection, we have the CART test also available. Okay, and this is more feasible and more easy to do. So that's why we go for this, and this will come somewhere. And it is termed as difficile, but you can culture it. Okay, but it is difficult to culture, obviously. That's why the name have come. But you can culture, and culture is always what? The most specific thing. Okay. Now, these all things are there. Rest of all, like if I tell up regarding botulinum and all. So what I should tell about botulinum is botulinum name whenever it comes, you have to associate with this that they are the most potent neurotoxins on earth. Okay, everybody knows it. Besides that, only one of them, the enterotoxin C2, that is there, which associates with this particular food poisoning and all. Can food poisoning associates with this? And the action which was being asked is that it is having a anticholinergic action at various junction. Clostridium tetani, tetanospasmin, pre-synaptic inhibition of glycine and GABA, which are inhibitory neurotransmitters. Okay, that is the inhibition of them happens. So there is a constant stimulation which happens in the tetanus, and you need to know the trismus along with that ophisthodonus posture. Perfringens, whenever you get this name, perfringens, gas gangrene should come in your mind exactly fine. Okay. Other than that, you have those two important things like target hemolysis. which is associated with this, which is also termed as double zone of hemolysis due to the toxin action of it. And it is having the stormy fermentation of litmus milk. And stormy fermentation of litmus milk means what? This particular thing means that the milk, which is colored milk, that is fermented immensely because of Clostridium perfringens. Reverse CAM test is positive here. And you must be remembering that mnemonic seen in NTR, that one Nagler's reaction also associates with the neutralization reaction for this particular one. Okay, so this is regarding the various Clostridium stuff. Now coming to the second question, which virus can cause condyloma acuminata? So you know condyloma acuminata is genital warts, and it was a repeated question of FMG itself. And genital warts, you know, it's being done by what? HPV 6 and 11. And the same thing which is doing up the laryngeal warts. Okay, the same thing which is being doing what? The laryngeal warts. And what I want to add upon here is 5 and 8 leads to epidermodysplasia verruciformis. This question can come. Okay, also termed as Treeman syndrome. And this, everybody knows that HPV 16, 18 or 31, 33, they associates with carcinoma cervix. Now the question in the twisted form comes in which way? The question in the twisted form will come in this particular way, guys, that HPV is a which sort of a virus? It's a double-stranded DNA virus. Okay, it's a double-stranded DNA virus. Important is non-segmented. Obviously, the DNA viruses are not segmented, so it is a non-segmented one. Important is it is non-enveloped, and this is what is being asked. Okay, non-enveloped. This one is non-enveloped, and those two genes which you know, na, E6 and E7, early portion genes of it, E6 and E7. This E6 causes inactivation of which particular gene? Inactivation of P53, which is termed a guardian of genome, and E7 associates with RB gene inactivation. Okay, inactivation of RB gene. So these two important points you need to know regarding this one. And what about the vaccine of it? It is made from Melvin. Now, coming to the third one. The third one is serum concentration of which of the following human IgG subclass is maximum. So this everybody knows IgG itself is maximum, and in that also the number one is which one? IgG1. This is having the maximum concentration. Important regarding IgG is this is the only immunoglobulin which passes through placenta. Okay, only immunoglobulin passes through placenta. This you need to know. Besides that, this particular one, like firstly always IgM is produced, then it changes to what? IgG. So this isotype switching happens here. Another important thing regarding IgG is this is having the max T half. This is having the max T half, and that is around 23 days. This is the T half of IgG, around 23 days. Okay. Now, other than this, what else you can remember regarding IgG? IgG FC portion. FC portion means the down one. The FC portion of IgG, this particular one plays a role in what? Opsonization, guys. And what is opsonization? Opsonization is enhancement of phagocytosis. So that also you need to remember. Another important thing regarding them is like other immunoglobulins, IgA. Whenever this comes, you need to know two things. It is present in secretions. Okay, this particular one is present in secretions. Other one is it is having J chains, joining chains. IgM is the one which is having the max molecular weight. Okay, this is having the max molecular weight. And if it is having maximum molecular weight, it will have max sedimentation coefficient. This particular one always, it is produced up in primary and secondary immune response. The first one, the first immunoglobulin it produced is IgM, does not cross placenta, plays a role of opsonizer. It is a strong opsonizer than even FC of IgG. Besides this, plays a role in classical complement pathway, that also you know. Okay, and the valency is bit tricky here. every particular antibody group is having valency of 2. This is having 5 of them. So 10 is the valency of IgM. So all these important points you need to remember regarding the IgM. Now, which of the following tests is used for the demonstration of diphtheria toxin? Important is ELIC test. You know that ELIC gel precipitation test is being done for the demonstration of diphtheria toxin. And this ELIC gel precipitation test, important extra point is that this is double diffusion in 2 dimension. Okay, what it is double diffusion in 2 dimension. This is the logic of diphtheria toxin test, that is the ELIC gel precipitation test. What is the meaning of it? The meaning of this is that 2 things are diffusing up. That is termed as double diffusion, means the antigen and antibody, they are diffusing up in 2 directions. Okay, so this is what is the logic of this particular ELIC gel precipitation test, that is double diffusion in 2 dimension. Typical example is this one. The Schick test was used to be done before, and it tells about the hypersensitivity status of the patient. Nagless reaction we already have done, that is being done for what? Clostridium perfringens. It is a neutralization reaction. A rapid plasma reagent, you know, RPR test. RPR is being done for those particular troponins and all. Okay, so RPR is a type of a non-troponable test actually, and it is not such sensitive and specific, but still it is being used, and it comes in the form of card test, and that's why it have an importance, because the diagnosis is being fine. Now coming to this one, which of the following is not an enriched media? Enriched media, first of all, you need to know that enriched media is always what, guys? Enriched media is always solid. Okay, so blood agar is solid, chocolate agar is solid, Loeffler's serum slope is solid, even nutrient agar is solid, but this nutrient agar is termed as a basal media. Okay, because it does not have any enriched source. Okay, we don't add anything to it. It is just having what? Peptone and meat extract, which are the basic ones. There is nothing extra factor being added to this. So basically it is a nutrient agar, the answer here, which is not a enriched media. So this you already know. In the blood agar, you know that which blood? 5 to 10% sheep blood is being used. So that is what is the answer of it. And in the chocolate agar, obviously there is no chocolate. It is having X and V, these factors, which are released up when the RBC get lysed off. So these particular ones, they are released when the RBC gets lysed off, and they give the color of this chocolate. Okay. Loeffler's serum slope is used for conjugative, that also you know. Which of the following structures are seen in the cells infected with the yellow fever virus? So answer is Torres body. Okay, and this particular one is intranuclear. This is a intranuclear, fine, this is an intranuclear inclusion body, which is being observed in yellow fever. Okay, which is being observed in yellow fever. And the Coidry type A, that is hay, like that we remember, no? A is seen in hay. H is herpes, Y is yellow fever. So these are there, which are there in the yellow fever. And yellow fever is a disease which is not there in India, obviously. This is a disease which we don't have, and that's why the Indian government is also very sensitive regarding the yellow fever, and they give a vaccine whosoever is going to the Africa, 70D vaccine, which is a live vaccine, but can be given to a pregnant female if she is traveling to endemic zone. And now the certificate which is being issued of that particular one is having a lifetime validity. Before it was 10 years, but now it is lifetime validity. All these are important questions as the arbovirus, so that you know. Henderson-Peterson, you know, guys, it is seen in the molluscum contagiosum, and it is the intracytoplasmic inclusion body. Russell bodies are there in the rhinoscleroma. Okay, they are seen in the rhinoscleroma, that you know, na, rhinoscleroma, that particular one done by Klebsiella rhinoscleromatus, that particular one, woody nose actually. So when you go for the tissue biopsy of it, you could able to observe these particular cells like Miculus cells and Russell bodies. So Russell bodies, basically they are concerned about the immunoglobulin stuff, plasma cells. Negri bodies, everybody knows, and everybody should know in fact this thing. It is a intracytoplasmic inclusion body, and they are found in the hippocampus and cerebellum. And these particular ones, they are the characteristic feature, they are the post-mortem diagnostic features of rabies. If it can demonstrate of the Negri bodies there. Is it fine? So this is important regarding all of them. A 45-year-old male presents to the emergency room with the symptoms of nausea, vomiting and confusion. See this word, confusion. He reports up that he recently returned from a week-long cruise vacation in the Caribbean. During the cruise, he said spent a significant amount of time in the air-conditioned common areas. See, this particular thing is being like talked of, including the dining halls and entertainment venues. Based on the given history, which pathogen is most likely responsible for the patient's symptoms and outbreak on the cruise ship? So guys, I've already told up in the lectures also, whenever they talk about the cruise ship journeys and there is centralized AC plants there in that particular one, you should think for which fellow? Legionella pneumophila. Okay, and obviously they are talking about in this about a disease which is termed as Legionnaires disease, in which basically what happens is there is pneumonia, okay, atypical pneumonia which shows the features of typical. This also is something different here. So this is atypical pneumonia, but it shows the features of being typical. One thing. Another thing is that particular person is having encephalitis, and that particular encephalitis definitely explains of the confusion which that particular patient is having, and having the diarrhea. So these particular diarrheal changes and all, they bring up what? They bring up the hyponatremia. We call it as what? It is due to the SIADH. Okay, this hyponatremia, electrolyte imbalance is there in the Legionnaires disease, and this was asked in AIMS exam, and it can be asked in your FMG exam, that which type of electrolyte imbalances happens in which pneumonia caused by which organism. The answer is Legionella. Okay, another important thing here guys is this particular thing carries mortality, it have a mortality. And if we talk about the culture media for this, the culture media for this is BCYE. What is the culture media? BCYE. And what is BCYE? Buffered charcoal yeast extract. Okay, buffered charcoal yeast extract with iron and cysteine. Okay, this you need to know. And the recent question of your FMG only is that what is the drug of choice for this Legionella? The answer is Ezi. Okay, answer is what guys? Ezi, azithromycin. This is the drug of choice for the Legionella infection. This can come again. Okay. Now coming to the next one. A 50-year-old man with a history of COPD, currently taking up steroids, presents with fever, cough, shortness of breath, decreased breath sounds on the right side of the chest, and a right lower lobe infiltrate is observed on the X-ray. A bronchoalveolar lavage was done, reveals a fungus. We have given directly, reveals a fungus with a septate hyphae, branching at an acute angle. So what hint you want? What is the most likely diagnosis? So answer to this particular question is Aspergillus guys, and you know that it leads to the formation of aspergilloma and all, and this is the typical branching which is being observed, septate at an angle of 45 or 60 degree. Okay, 45 or 60 degree. This particular one is observed in the Aspergillus, and as it is clearly being written in the question itself that they are talking about a septate hyphae branching at acute angle 45 or 60, we are talking about what? Aspergillus. Okay, and the fellow is on steroids, and whenever some sort of immunodeficiency happens, either due to the steroid use or due to some disease, these fungus they ought to come. So this is what is the logic regarding them. Important extra point which I can say is that for this Aspergillus, okay, when it produces invasive type of lesion, invasive aspergillosis means it have gone into the blood. Okay, invasive aspergillosis, for that you do beta D glucan testing. Okay, which particular testing you do? Beta D glucan testing is being done for it. Other than that, you need to know, for this only you go for galactomannan testing. For this only you go for what? Galactomannan testing. So these all are the important points which you need to know regarding this particular question. Histoplasmosis, you already know that done by Histoplasma capsulatum, it's a dimorphic fungus, and chronic histoplasmosis mimics the TB. A tuberculate macroconidia is a feature which is observed in the histoplasmosis, and important here is that in this you take the bone marrow biopsy. And in that, what you observe, that inside the macrophages, you can find the yeast cells. And that is typical of this histoplasmosis. And this question will be coming off. And it is common in HIV positive ones. Cryptococcus neoformans is another opportunistic infection, which is the most common cause of meningitis in the HIV positive, is Cryptococcus neoformans. Okay, important. Most common cause, in fact. And what you go for it, to demonstrate the capsule of it, you go for Indian ink staining, that is the negative staining. And along with that, latex card agglutination test. Rhizopus, that is having a aseptate hyphae, obtuse angle, or this particular one is right angled. Okay, and in this family of Rhizopus only what comes? Muca, which is like famous only, steroid use there also. And it was famous because of the COVID-19 that you already know. And which type of colonies are there? Cotton woolly colonies, and diabetes mellitus, they mostly strongly correlates with these all. Fine. Now, a farmer came with a complaint of ascending lymphangitis. See this word, complaints of ascending lymphangitis. He gave a history of working in his field bare hands, which could be the possible diagnosis. So, possible diagnosis, Candida albicans? No. Answer is Sporothrix kinki. This is what is the answer, and the disease which is being talked about is sporotrichosis. Okay, they are talking about which particular disease? They are talking about the sporotrichosis done by what? Sporothrix shanki or skinky, whatever you call it. Okay, so this is a dimorphic fungus, guys, but mainly it comes in the subcutaneous mycosis. It comes in what? It comes in the subcutaneous mycosis. Okay, but it is a dimorphic one, so it have both the forms. It have the yeast form, which is narrow base budding, and it is having the other one, that is mold form, which looks like a flower-like sporulation. Okay, the drug of choice for sporotrichosis, that is itraconazole, and it is also termed as Rose Gardner's disease. Rose Gardner's disease. And another important thing is what is about this lymphangitis and all. Lymph, lymph vessels inflammation. So there is a typical pattern which is observed in this, which is termed as sporotrichoid pattern. Means the nodules are there which are in a line. Linear fashion nodules are seen up in this particular sporotrichosis, and this is typical of this particular disease, sporo. Now talking about this one, all are true regarding the organism whose eggs is shown below except. Answer is except. You have to answer except. It is a roundworm. So first of all, what is this egg about? This egg is the egg of Ascaris, and the full name is Ascaris lumbricoides. It's a roundworm. Yes, it's a roundworm. It can cause Loeffler syndrome. Yes, it goes to the lungs, and it can cause pneumonia and all, Loeffler's pneumonia. The drug of choice is ivermectin. No, the drug of choice is albendazole. Okay, ivermectin is the drug of choice for strongyloids, stercoralis, and Onchocerca volvulus. These two you need to know. Fine. May cause obstruction at the ileocecal valve. Yes, it can do. Biliary obstruction it can do. Even it can associate with the intestinal perforation. That particular thing, that whenever there is a massive Ascaris load, this leads to this intussusception, and later on this can associate with what? Intestinal obstruction. This particular one associates with what? Intestinal obstruction. So these all you know. Actually, this is a properly made egg. So it's a fertilized egg. Unfertilized is also there, which is elongated one. Okay. So this is regarding the Ascaris, which we are talking about. Okay. Now talking about this one, which of the following is seen in the secondary syphilis? So guys, first of all, syphilis, this time incubation period was asked. And the incubation period for syphilis, it's 9 to 90 days. It's a STD, sexually transmitted disease, done by Treponema pallidum. In the primary syphilis, you have a hard chancre, okay, over the genitals obviously. And along with that, there is painless lymphadenopathy, okay. Now, in the secondary one, these particular things, they heal up and the patient thinks that he or she is okay. But there is the feature which is observed in the secondary one, that is condyloma lata. Along with that, the rashes are observed over the palms and soles. Okay, over the palms and soles, we have the rashes and we have this condylomata lata. And basically, these are wart-like lesions. They can be present over the skin and over the genitals also, condyloma lata. And that is being termed as the most infectious lesion observed. the most infectious lesions which are observed up, these are the condylomata lata. Is it fine? So remember this particular aspect also regarding this, and then you know that it goes in latency after the healing of all this, and finally comes back with the tertiary syphilis in which gummas are present, okay, over the skin, and then we have neurosyphilis and cardiovascular syphilis. Ascending aorta is involved up, and in that Taves dorsalis, and along with that you have GPI, general paralysis of insane. The investigation of choice which I think can come, the investigation of choice for neurosyphilis you should know, guys, and the answer is VDRL. Answer for this is VDRL. Remember this. This might come. Drug of choice, penicillin. Okay. Now coming to this, which of the following is secreted by macrophages? So macrophages secretes up interleukin 1, interleukin 6, TNF alpha also. In fact, the answer is what? D. D is the answer here. And that you already know that the APCs, like antigen presenting cells, they secrete up interleukin 1. Interleukin 1 acts on the T helper cells, okay, T helper cells, and T helper cells secrete up interleukin 2, and interleukin 2 acts upon the natural killer cells and change them into what? LAC cells. And LAC cells is lymphokine activated killer cells. That is what is termed as the sequence which you should know, that antigen presenting cells secrete up interleukin 1, then they activate the T helper cells to secrete what? Interleukin 2, which is having autocrine fashion also. And obviously these all things they observed in the, if you remember of, they are being released where? In the type 4 hypersensitivity. And the natural killer cells, they change into what? Lymphokine activated killer cells. Okay. So this is regarding the macrophages secretion. And obviously they are associated with inflammation and all that you already know. Now talking about this particular image, guys, that if this sort of image comes in your exam, what it is? Is it a macrophage filled with histoplasma, which we were talking in the bone marrow biopsy? Is it Henderson-Peterson bodies of the molluscum contagiosum? Is it Leishman-Donovan bodies of visceral leishmaniasis, which is Kala Azar? Okay, or is it the infection of Ehrlichia, which is having monocytes with morula of the Ehrlichia? And obviously that you know Chaffinensis. Ehrlichia Chaffinensis does human monocytic Ehrlichiosis. So guys, remember this particular point, that these which are observed now, these particular ones, they are termed as LD bodies, Leishman-Donovan bodies, and they are amastigote forms. What forms are they? They are the amastigote forms. Amastigote forms means they are aflagellar forms. They are without the flagella. They are aflagellar forms, LD bodies, amastigote forms. Okay, and they have a particular structure with them that is termed as kinetoplast. And Kala Azar is there in India, in the area of like Bihar and Bengal is having it. Okay, so they might show you this picture again. And they have already asked up. This time they have asked regarding the Leishmania tropica, oriental sore, which is common in Rajasthan and this particular area. Is it fine? So this you already know, guys. Henderson-Peterson, that is the inclusion bodies, intracytoplasmic ones. Macrophage filled with histoplasma, I already told up. On bone marrow biopsy, you observe them. And within them, you can able to see the E cells. Monocytes is morula of Ehrlichia. This is also important. They can ask this particular thing, Ehrlichia, which is previously in the ricket cell family. This is also having this morula-like appearance, and they grow up within the phagocytes. Okay, culture they happens within the phagocytes, and these all are tick-borne diseases. And it was being asked in the exam. Okay. So guys, these are the important questions which you should know. Like these, like along with them, I have told up a lot of important facts also that this should also be remembered of. And I suppose if you like revise this particular one, a major chunk of yours, like from the bacteriology portion, from the like other rest of the others, from the culture media we have discussed of, and we have talked about a number of like this one, immunology portion is also being talked about. So we have touched up, these all are important questions, and you need to know regarding them. Along with them, you should know regarding the topics which are related to them. Okay, then only you will able to answer up most of the questions in your exam. So very best of luck from my side, and I hope you will find this short and crisp discussion helpful. Thank you so much.
Ladies and gentlemen, welcome to ophthalmology discussion of the grand test, and I hope you all done well. These 15 questions, let's discuss them without any further wastage of time. Patient comes to OPD with an intense watering, pain and photophobia. She was a regular contact lens user and forgot to remove contact lenses at night. A very common problem that some of you do. You forget to remove lenses at night. On examination, there was an epithelial defect. What is the first line of treatment that you should have? Discontinue contact lens use immediately. B, start fortified antibiotic steroid treatment. C, normal saline irrigation. Wait and watch. And I think the answer is clear to all of you, gentlemen. Discontinue contact lens use immediately. A is the answer. You do not wait, because contact lens ulcers are very fast moving. You remember Pseudomonas is the number 1 organism attacking contact lens wearer, so you must never wait. Normal saline irrigation incorrect, and fortified antibiotic steroid combination is fatal because the steroid is going to worsen the infection. So you discontinue. First thing that you do, and this applies to many of you who do sleep with your lenses, the young people, they sleep with the lenses, they swim with the lenses, very difficult to persuade them to take them off. Discontinue contact lens immediately is the first and the most important answer. Which of the following tonometers is the gold standard for measuring intraocular pressure? Another one, again, a simple standard one. The gold standard, the most accurate way to measure the intraocular pressure is C, choice C, which is Goldman applanation tonometer. Okay, remember, the Schiot's tonometer, choice D, is for mass screenings. Whenever you have a lot of people, 100, 1,000 people in a camp waiting, we need for screening Schiot's tonometer. Perkins tonometer is the tonometer of choice in children. Remember, in children, would use a Perkins tonometer. A Mackey-Marg is for scarred corneas, corneal scarring. Suppose you have a corneal surface, which is corneal scarring because of injury, because of trachoma, and the surface is not smooth. In this case, you cannot use a Goldman applanation. It will come out incorrect. The best one is a Mackey-Marg, often asked as a question for scarred corneas. Use a Mackey-Marg. Another simple one. So I hope most of you got this correctly. Next one is a 21-year-old male presented with a complaint of diminishing of vision. So that's serious. A young man with loss of vision with excessive glare on driving at night. Now that is the clue. Remember, he has glare. He gave a history of taking corticosteroids for more than a year for his joint pains. Okay, unusual for a young man to have joint pains, but such is the question. Which of the following cataracts are seen in patients with long-term use of corticosteroids? Again, you should all have got this correctly. The answer is A, a posterior subcapsular cataract. Remember, steroids always lead to posterior subcapsular cataracts. And if you remember, posterior subcapsular cataracts, what are your choices when you think of PSC? First, it could be a steroid-induced cataract. You have to remember that. Second, it could be a complicated cataract. That is, cataract caused by disease of the eye. Is it not? Third, it could be a radiation cataract. Radiation cataracts are often, even though rare, are often posterior subcapsular. And fourth, it could be diabetics. Okay, diabetics often have a posterior subcapsular cataract. Choice B, Morganian cataract, incorrect. Oil droplet cataract, as you remember, is seen in galactosemia, and D is sunflower cataract, you might remember, is in Wilson's disease, deposition of copper. Simple ones, not very difficult. Those of you who attended the lectures, seen my app, you should be able to do it very well. A patient present to the OPD with complaints of pain, photophobia, redness, decreased vision and lacrimation. A lot of symptoms. On examination, acute anti-uveitis diagnosed. Which of the following statements is true about anti-uveitis? So you have to see what is correct. KP, sciatic pissars, are pathognomic signs of anti-uveitis, is absolutely correct. Infectious hypopyon is seen in the anterior chamber, incorrect. Remember, hypopyons, please remember, hypopyons are infectious only in fungal keratitis. Remember, I said in fungal keratitis you have non-sterile hypopyon. That is because you see, hypopyons are primarily collections of neutrophils or WBCs in the anterior chamber. Okay, and these are obviously not infectious. So in uveitic hypopyons, bacterial hypopyons are always sterile. But infectious hypopyon is a condition which occurs in fungal keratitis where the fungus can penetrate through the 5 layers of the cornea and penetrate through the Descemet's membrane. Remember fungal ulcer? It penetrates through the epithelium, then goes to the Bowman's membrane, then it goes to the stroma, then it goes to the Duas layer, and then finally it penetrates to the Descemet's membrane, and through the endothelium, and then it comes to the aqueous humor. So, infectious hypotension not in anti-uveitis but in fungal keratitis. Incorrect. Enlarged pupils in anti-uveitis. Incorrect again, because remember in anti-uveitis the pupil is constricted. Why? Because the iris is irritated, it's inflamed, it's irritated, it causes constriction of pupil. And Busaka's nodules are not situated on the pupillary border but on the surface of the iris. Those are the ones that are situated on the pupillary border. Remember, are the Koppe's nodules. These are Busaka's nodules. So, all of them incorrect. The answer is pathognomic signs of anti-uveitis are KPs. Remember, KP is nothing but neutrophils and lymphocytes which are stuck to the endothelium of the cornea. Is it not? And remember the famous triangle area, the Arld's triangle. So, KPs are the answer here. Very well. All good, and I hope you all got it correctly. A 6-month-old child with a white pupillary reflex was present on biopsy and histopath examination. The following features were seen. Which of the following is responsible for the pathology? And you can see this one picture, standard picture. I've always focused on this particular histopath picture. These are the famous Flexner Wintersteiner rosettes, is it not? So, the Flexner Wintersteiner rosettes, these are. And so, the diagnosis is a retinoblastoma. Remember, this is the hallmark of retinoblastoma. Retinoblastoma hallmarks are not clinical, okay? They're always histopath. You cut this open in the lab and you see these rosettes, and they are like they call rosettes because I've mentioned this. They look like the rose windows of a church. So, let's see which of the four responsible. Is RB1 gene is absolutely correct. Again, retinoblastoma 1, remember, pressor gene which is located on 13q14 is the gene which is responsible when this gene gets damaged, is responsible for causing retinoblastoma. HLA-B27 is not responsible. Remember, they cause spondyloarthropathies, which we have studied in anti-uveitis. ATP7B gene causes Wilson's disease, responsible for Wilson's disease. And this is not a ophthalmic gene that we like to ask very commonly. FBN responsible for Marfan syndrome. FBN1 responsible for Marfan syndrome. Again, not a gene which you ask in ophthalmology, but put in there to confuse you. Very well. The next question, ladies and gentlemen, is a very important one, and I hope you've all got this. Identify the investigation given in the picture below. Remember, we have now mostly pictorial questions, which is why we have placed these questions most on pictures. Given in the picture below, and what you can see is a black and white film where you can see some white dye which is filled up the blood vessels of the retina. Is it direct ophthalmoscopy? Incorrect. This is not direct ophthalmoscopy at all, which you do at a distance of around 15 centimeters. B-scan ultrasonography, it is not, because you do not, this is not how a B-scan printout reads. Optical coherence tomography, incorrect, because optical coherence tomography, remember, is a three-dimensional picture of cross-sectional picture of the entire retina, all the 10 layers in different colors, red and green and blues and yellows. However, this is a FA, called FA, or a fundus fluorescent angiography, where we inject the dye called as sodium fluorescein in the, remember, the most common is injected here in the antecubital vein. It takes about 10 to 12 seconds to reach the fundus, and as it fills up the blood vessels, you can see we take a black and white camera, extremely sophisticated and powerful fundus camera, takes photographs of the dye, and as in this picture you can see clearly that the dye is restricted to the vessels here. So this is a normal fundus picture. However, if the dye leaks out in the retina, that means there is some problem here. So in this picture, you can see there is no leakage of dye. So this is a perfectly normal retina, and this is fluorescein angiography of a normal retina. I hope you all got this correct. And then we have the next question. All the following are features of diabetic retinopathy except, let's take a look at that. Microaneurysms, correct. Microaneurysms is, remember, is the earliest ophthalmic ocular feature of diabetes, is the most early. Cotton wool spots is correct. Cotton wool spots you do get in diabetic retinopathy, but you get in other conditions also, like hypertensive retinopathy, you get it in radiation retinopathy and many other conditions. Macular star is not a very common feature of diabetic retinopathy. It is seen in hypertensive retinopathy, okay, where you have over the macula surrounding the fovea, you have these exudates which radiate out like this, looking like a star. This is the macular star, which is more a sign of hypertensive retinopathy, and so this is the answer because it says all of them are except. So macular star is not seen in diabetic retinopathy, but is seen in hypertensive retinopathy. The answer is C. And I'm sure most of you are getting all these correct. A 7-year-old child is diagnosed with amblyopia in one eye. Remember, amblyopia is lazy eye syndrome. What will be the best treatment? Observation. A 7-year-old child, incorrect. There's no, observation is not the treatment of amblyopia at all. Penalization can be used, is as a treatment, is possible, but the best answer is occlusion. Occlusion, where you close one eye. Remember, we close one eye, the good eye, okay? So we close the good eye, usually any time between 6 to 8 hours in a single day. We close the good eye for 6 to 8 hours. It could be occlusion. It's usually mechanical patch. You know, you can put a tape here, you can put a cardboard here, you can put a plastic here. It closes the good eye and forces the bad eye to fixate. And this is how it develops, allows the bad eye to develop fixation. Because if I close the bad eye, or even if I did not close anything, if the child is given liberty to use both the eyes, remember, he will only use the good eye. The bad eye would never be employed because the good eye was fulfilling all the functions. So that is why we close the good eye, we occlude the good eye and force the bad eye to develop fixation. It works very well. This is the first. Penalization is a similar treatment where penalization means to punish. So what we do, these are for children who do not like to wear patches. You know, they would tear off the patch. Okay, it's a mechanical patch, you can easily tear it off. So what you do, often we put atropine with drug of choice in penalization, which means to punish. So we are punishing the good eye. Again, you put a drop of atropine in the good eye. It causes dilatation and ciliary muscle paralysis. So there will be cycloplegia. So you will not be able to see anything and will force the bad eye to see anything. So you penalize the good eye. For what? For being too good. For being too good. And this will also work, but the better treatment is here. C is the correct answer. The next question is a 10-year-old male presented with complaints of foreign body sensation, slight stickiness of the lids, along with scanty mucoid discharge. On clinical examination, the findings shown in the picture are seen and identify the pathology. Now, remember, this is a combination of picture and you have a question of given statements. Remember, sometimes, even though we do focus a lot on the pictures, particularly in my app, if you've seen, and the lectures, we focus a lot on the pictures. But sometimes, because you've seen so many pictures of so many pathologies, so you get confused. So correlate the two. Correlate the picture, tie up the picture with the facts presented. So a young boy presents with complaints of foreign body sensations, stickiness of the lids, and scanty mucoid discharge. Remember, it is telling immediately that we're talking about some kind of conjunctivitis. And how on examination we see that these are the famous sago grain follicles, okay, like sago grain follicles, as we call them, sabudana and sago grain follicles. So sago grain follicles are pathognomic of one particular condition here, which you all know or should know, ladies and gentlemen, is trachoma. The answer is trachoma here. Okay. So these follicles, remember, follicles can be seen in viral conditions, they can be seen in chlamydal conditions, they can be seen in trachoma. Okay. Viral, chlamydal infections of the conjunctiva and trachoma. This is trachoma. So this is the follicle. First, you have to identify the follicle, look at them, and they look like grains of sago grain. So these are trachoma. Okay, remember, but follicles can be seen in other conditions like viral conjunctivitis and trachoma. Also remember the two drugs which can cause follicles, that is pilocarpine and brimonidine, both anti-glaucoma drugs, which also cause follicle formation. Very well. Antihistamine, it is not. STI, definitely not. Gonocole conjunctivitis would be too chemos. There would be too much inflammation. You could hardly see anything. Next question is a 40-year-old female presented with complaints of severe eye pain, vomiting, redness, and sudden loss of vision. Identify the pathology based on symptoms and the clinical image given below. Okay, so the symptoms are quite clear. And a middle-aged lady of severe eye pain and vomiting, redness, and loss of vision. And look at the classic pupil. You see the vertically oval pupil here. If you draw it like this is the vertically oval pupil, mid-dilated, not reacting to light. This is the famous pupil of acute angle closure glaucoma, also called as acute congestive glaucoma. Please remember, acute angle closure glaucoma is also called as acute congestive glaucoma because of the congestion, redness, pain. Similarly, also remember that open angle glaucoma is also called as the older name, and some of the exams, they do use the older name trying to fool you, is called chronic simple glaucoma. So the older name for open angle glaucoma is chronic simple glaucoma. So do not get fooled by these alternative titles. The acute congestive glaucoma. Bacterial keratitis is not, even though bacterial keratitis could have redness and pain, but there is no vomiting and loss of vision like that. Retinal detachment is completely painless and there is no congestion here. Spring cataract is completely, totally different picture. Okay, so this is definitely acute congestive glaucoma, also called as acute angle closure glaucoma. So far so good. I'm sure all of you have got all the answers correctly. Okay, and then we go next question, which is the following statements is a little more difficult, I feel. Which of the following statements is false but the pathology given in the image? And you see here first, look, what is this patient doing? Is being forced to look down. So we often hold the lid like this, ask them to look down like this, and as they look down, look at the indentation of the lower lid. The lower lid, it is caused, this is the famous Munson sign or the Munson sign of keratoconus. You all know that normally when you ask the patient to look down, the lid should be like this. It should be like a crescent, a lunar shape of the lower lid. But in keratoconus, the cone of the cornea would depress or indent the cone or the lower lid into a conical shape called the Munson sign or a Munson sign, seen as a late sign of advanced keratoconus. So, what is it false? They ask what is false here. It causes myopic astigmatism. Very correct. It does cause severe and very large myopic astigmatism. On distant direct ophthalmoscopy, an oil drop reflex is seen. Correct. Oil drop reflex is seen. And peripheral stromal thinning is incorrect. Rigid gas permeable contact lens improve vision. Early case is also correct. Remember, there is no peripheral stromal thinning here. Peripheral stromal thinning you get in peripheral ulcerative keratitis. Here the thinning is often central and inferior stromal. Okay, so thinning of the cornea does occur. Thinning at those ectase of the cornea does occur, but it's not peripheral. It's either inferiorly or central. So central or inferior thinning is keratoconus. The answer is C. This is not correct. This is not correct. The next question, ladies and gentlemen, is identify the disease in the picture, and you can clearly see, if you look at this carefully, the lower lid is turning inwards like that. It's not. There's an inward rolling of the eyelid like this, and you can see the eyelash rubbing against the cornea. This is an entropion, which is described as an inward rolling of the eyelid. It could be upper lid, it could be lower lid. The most common is usually, as you can see here, older people. It's called as senile ectropion, or sometimes called as people with older people. They often have that. Trichiasis, it is not, because trichiasis is just inward rolling of the eyelashes without the rolling of the lid. It is just interning of the eyelashes rubbing against the cornea. Ectropion is outward rolling of the lid margins. Distichiasis means a double row. The word distic, D is 2. It's a double row of eyelashes on the lid margin. Okay, so this is none of them. This entropion indeed is the answer. The next question, ladies and gentlemen, is a patient present to OPD with complaints of a severe headache, which is worse in the mornings, projectile vomiting, diplopia, and transient loss of vision. On fundus examination, the following image is seen. What is the most probable diagnosis? Should not be difficult. It's a no-brainer actually. Look at the questions again. Severe headache, worsening in the mornings. As you get up in the morning from a supine posture to get up with a change of posture headaches. Remember, typical sign of what? Of intracranial or raised agility headaches. Remember, change of posture headaches is a sign often of intracranial of pathology causing a headache. Projectile vomiting without nausea is typically seen again in raised agility headaches. Diplopia, double vision, loss of vision, transient loss of vision. Remember, it's only transient loss of vision. That means you lose vision, which is known as amaurosis fugax. Remember, lose vision for 5 seconds, 5 minutes, maybe 10 minutes, usually not more than 30 minutes, and you get it back again. This is called as amaurosis fugax. And diplopia, double vision, often seen because the sixth nerve is often damaged. As the raised agility pushes the brainstem down, so it pulls on the sixth nerve, which is trapped in the Dorello's canal, and the sixth nerve paralysis occurs. We call this a false localizing sign because it looks like a squint, but it's not. The answer, all of them point to, when you look at the disc picture, there's blurring of disc margins. If you see the blurring of disc margins, you cannot make out where the disc is ending, where the retina is starting. This is papilledema is the correct answer. It is not optic neuritis, where you don't have the symptoms of severe headaches. Primary open-angle glaucoma, you don't get disc margins like this. In primary open-angle, you get cupping. You do not get blurring of disc margins. And none of the above. The answer is A for papilledema. These are all very standard, simple questions. I don't think you can have problems with this. The next question, the lens derived from which embryonic tissue? Again, remember, this is standard questions from where the Lens is derived, remember I told you the TEL structures, okay, the TEL structures often of surface ectoderm, okay, surface or the level structure. If you look at the mnemonic, the level, let's forget the TEL, that is another mnemonic. Level structures, the lens, the epithelium of the vitreous and the lacrimal apparatus are all derived from the surface ectoderm, the level structures. Again, lens, E for epithelium of all the structures except the ciliary and the iris epithelium, V for vitreous and L for lacrimal apparatus. This is surface ectoderm. A simple question based on memory. And the next question is, a 40-year-old farmer got exposed to ammonia accidentally while using fertilizer, and you know that fertilizers are made of ammonia. Which is the treatment of choice in that? Remember, ammonia are very dangerous accidents. These are alkaline injuries, and these are the questions based on chemical injuries. And the choices are anesthetic plus wash with BSS, balanced salt solution. BSS is the correct answer. The most, remember, the immediate treatment of any chemical injury, be it acid or alkali, is to irrigate it thoroughly with 1 to 2 liters of water for 30 to 40 minutes. Water if nothing else available, but the next best option is balanced salt solution, which is really very good. But however, we don't have time to waste. That's even if nothing is available, we just use water. We need to neutralize the acid alkali. Expert ophthalmologist is not the answer. We do not have enough time in chemical injuries to call any expert ophthalmologist or any other doctor for that matter, except the one that is already present. Still time microscope in cleaning is important, but it comes next. Remember, and antibiotic drops comes last. Remember, in chemical injuries, one very simple principle we always follow: first act, ask questions later. Okay, first wash the eye, ask questions later as to what it was, where it was, how it happened, etc. Questions come later, first act. And so that is the answer, choice A. And with that, ladies and gentlemen, I think we have finished our 15 questions of ophthalmology. I think that's about right. And so I hope you've got all of you 15 out of 15. And you have, if you haven't, I would be very surprised indeed. Thank you very much and all the best. May God bless you for your coming exams. All the best.
Hello and welcome to the solutions of this grand test orthopedics for this FMGE examination. You know, the purpose of putting this grand test was give you the questions. For that you would be able to identify it. Actually, you have to identify what is the diagnosis for that long question which is provided to you. All right. So ये सिर्फ एक प्रैक्टिस बेस्ड सेशन है जिसमें कि आपको डायग्नोसिस को अचीव करना है और उसके बाद मेजॉरिटी ऑफ द क्वेश्चंस मींस जस्ट द असेसमेंट ऑफ योर प्रैक्टिस दैट have you read enough that you would be able to decipher any question which is asked in your examination. All right. So let's talk about the first question. And the first question is relatively dicey in order to go for the differential diagnosis of all the options which are provided to you. Like a 30-year-old man, as I told you, for any kind of a question which is pertain to the tumor, the age is exceedingly important because it will exclude at least one of the options which are provided out of the 4. So 30-year-old man presented to OPD with a complaint of progressive pain in the middle 1/3 of the right tibia. Now this is again very important because there are certain tumors which are having a predisposition to involve certain segment of the bone. And some of the tumors are commonly affecting the tibia, some of them are commonly affecting the femur, the proximal end of the humerus, the distal end of the radius. So these are the common sites which are likely to be affected. Now, with an expanding mass which is palpable over the front of the tibia, all right. So majority of the tumor, majority of the benign tumor, because it is a progressive kind of a deformity, a progressive pain. So it is considered to be a benign tumor, which is there in the middle 1/3 of the right tibia. That means it is a diaphyseal kind of the tumor. So basically, just by reading 1 to 2, 3 lines from the top, you have already reached the diagnosis most probably. But you just, in order to rule the other differentials out, you have to read the complete question. Now, the patient further disclosed that he delayed seeking the medical assistance. All right. So there is a story which is provided, but the discomfort has been bothering him for the long time. X-ray of the tibial diaphysis revealed several well-defined radiolucent lesions which were divided by solid sclerotic bone. Now, this is the language of the X-rays which is provided. Well-defined radiolucent lesion which is defined by, means which is surrounded by a sclerotic bone. So this is how it happens. Like if this is the middle 1/3 of the tibia, and here we are having a radiolytic lesion which is surrounded by a well-defined sclerotic bone, and it is a huge kind of a tumor. It is a larger tumor which is palpable, all right. So it is a growing kind of a benign tumor. Now, epithelioid cell island. The epithelioid cell island can be seen in the fibrous background when seen under the microscope. That means a biopsy finding is also provided. And you know, the epithelial lining cell tumor is adamantinoma in the long bone. If the same kind of the tumor is provided in the jaw, then it will be ameloblastoma. If the same epithelioid cell island which is provided or epithelioid cell background which is provided on the biopsy, then these cells are there in case of adamantinoma. Now, if we look at the options which are provided, right? Now, the first option is the osteofibroid dysplasia. This osteofibroid dysplasia. You know, actually osteofibrous dysplasia or the adamantinoma, they cannot be differentiated based on the clinical profile, based on the X-ray findings, based even on the histopathological finding, because they are considered to be the closest differential of each other. The only difference in between the two is that osteofibrous dysplasia is basically affecting the young adults, that means young individuals or the adolescents, while adamantinoma is the tumor which is seen in case of a skeletally mature individual. You see, so all the language which is provided to the question might hold true for osteofibrous dysplasia too. But the only difference is that the age which is provided over here is 30. So it goes more in the favor of adamantinoma instead of osteofibrous dysplasia. So again, we are going to keep the other options again alive. That means we will discuss the other options too. Like the next option is fibrous dysplasia. Now, all of you are aware of the fact that fibrous dysplasia, the most common bone to be affected is the femur in fibrous dysplasia. And the X-ray findings in fibrous dysplasia are that of ground glass appearance. There will be a ground glass appearance, all right. So again, if you try to define this ground glass appearance based on the X-ray findings, so it is almost impossible to delineate with any other lytic lesion, because these are basically the lytic lesions which is having the spiculed kind of a calcification in the form of the irregular boundaries. But what is the specific finding on the X-ray which is there in order to make the diagnosis of fibrous dysplasia? And that is Shepard-Crook deformity. We have discussed this multiple of the times because this is the kind of the question which is in trend today. What is Shepard-Crook deformity? Like if this is the head of the femur, this is neck of the femur, the greater trochanter, it migrates proximally like this, all right. So it gives it an appearance of a Shepard-Crook, all right, the stick of a shepherd. And the reason for this deformity is that the bone, it loses its strength to bear the weight of the individual, and the medial cortex is, because it is compressive kind of the cortex, so it goes on compression under the influence of the weight of the individual, as a result of which the medial cortex compression will result in a progressive Shepard-Crook kind of a deformity. So that progressive Shepard-Crook deformity is a cardinal X-ray finding for fibrous dysplasia. So this option also can be safely ruled out. Now is the Ewing sarcoma. You know, Ewing sarcoma is also a tumor of the diaphysis of the long bone. So it is also likely to be kept in under the options. But you know, what is the difference in between Ewing sarcoma? The Ewing sarcoma is the tumor which is seen in 5 to 20 years of age. That means early year of age, Ewing sarcoma. The most common age for making the diagnosis of Ewing sarcoma is the early second decade of life. You know, but this is the age group for Ewing sarcoma, and 30 years is the greater age which is provided to you in the question. That is point number 1, which goes against Ewing sarcoma. Point number 2 is that Ewing sarcoma is a malignant tumor, so it will be rapidly progressive kind of a tumor, and here we are having a gradual progression. So it is a complaint of progressive pain in the middle 1/3 for a long duration of time. But here in case of Ewing sarcoma, it will be rapidly progressive kind of a tumor because it is a malignant tumor. And finally, X-ray finding. X-ray finding for Ewing sarcoma, there is no lytic lesion which is surrounded by a sclerotic rim. There is a periosteal reaction which is seen in case of Ewing sarcoma in the form of a onion peel appearance. So all of you are aware of this onion peel appearance, that if this is a bone, all right, and these are the periosteal layers which are added to the bone in order to confine the tumor from spreading. So these are the periosteal layers which are added to the frames of the bone and is seen as an onion peel. So onion peel X-ray appearance is the feature for Ewing sarcoma. So this Ewing sarcoma also can be ruled out based on these 3 points. Point number 1, the age. Point number 2, the presentation. Point number 3 is the X-ray findings. So now naturally, obviously, what you are left with is in the form of the answer, it is adamantinoma. So hopefully you have understood how to proceed with these kind of the question. Based on your learnings, you already are aware of that how to proceed with it. You already know what the features of adamantinomas are. It is a lining epithelial cell tumor. It is the tumor which most commonly involves the tibia, as at least 85 to 90% of the cases are affecting the middle 1/3 of the tibia. And one more important feature is that the similar histopathological finding, if it is seen in case of a jaw, in case of a mandible, then the same tumor is going to be called as ameloblastoma. Alright. So that is the difference in between the two. Hopefully you have understood the basic answer for this. Alright. Come to the next question. The next question is that the patient is unable to flex the interphalangeal joints of the 4th and the 5th finger. You know, flexion of interphalangeal joint of 4th and 5th finger. The patient is not able to do so. Actually, it is the distal interphalangeal joint in the 4th and the 5th finger, and you know, this is the feature of flexor digitorum profundus, and flexor digitorum profundus on the medial half is supplied by, means this is the function which is that of a flexor digitorum profundus. All right. So this function is that of a flexor digitorum profundus. You know, flexion of interphalangeal joint of the distal interphalangeal joint of all 4 fingers is the function of flexor digitorum profundus. But the flexor digitorum profundus actually is supplied by 2 nerves. So on the medial half, it is supplied by the ulnar nerve, while on the lateral half, it is supplied by the median nerve. So here we are asking about, or here the question is related to that what is being followed over here is that these 2 fingers, there is a loss of the flexion of the interphalangeal joint of the distal interphalangeal joint of 4th and the 5th finger. So distal interphalangeal joint in the 4th and the 5th finger. That means possibly ulnar nerve is affected. Alright, but because some of the other facts which are provided in the question, so these are also meant to be dealt with. And the patient is not able to hold the paper in between his fingers. Now this is very simple. Inability to hold the paper in between the finger, that means adduction function of the finger is lost. You know, the card test, this is basically nothing but the card test. Inability to hold the paper in between the finger is basically the card test. And card test is for the assessment of the functions of the palmar interossei. And you know, all palmar interossei are supplied by ulnar nerve. So basically what we are talking about is the patient who is or who might be suffering from the ulnar nerve. So what happens in case of ulnar nerve injury? If you are asking a patient to hold the card in between the 2 fingers while asking a patient to apply resistance when the examiner is trying to pull this out, if the patient can hold this, it means the adductor function of the finger is normal. That means palmar interossei are normally functional. But if the patient fails to do so, that means ulnar nerve is injured. So here we are straightforwardly talking about the nerve injury, that is ulnar nerve. So the question is that which nerve is found to be compressed? The answer for that question is ulnar nerve. Alright, you know, if you are sitting in this FMGE examination, these nerve injuries, radial nerve injury, the median nerve injury, the ulnar nerve injury, the features of them, how they are related, what are the bony points where these type of nerve could be injured. 1 to 2 questions are going to be asked in every paper related to these nerve injuries. Alright, so this is something which you should know by heart, which you should have gone through multiple of the times, because gone are those days where they are asking what is the nerve which is injured in pen test, or pen test is positive for, or Killow-Nevin sign is positive for, or pointing index is the feature of. These are not the questions today. They are asking the question like clinically based question, where they are asking these tests. This is what a card test asked in a form of a clinical manner. Alright, the presentation which is kept in the form of a clinical manner. And on to that point, you have to identify that what is the name of the nerve which is likely to get injured. Alright, so ulnar nerve is a straightforward answer for this particular question. Hopefully everything is clear. You know, we have discussed this much in too much detail in peripheral nerve injury about ulnar nerve, median nerve, the radial nerve injury, the musculocutaneous nerve injury. All these things have been done in huge detail. We have discussed it. Alright, hopefully everything is clear related to that question. Next one is, a 21-month-old boy was brought to the physician after his mother noticed deformities in both of his legs since he started walking independently. It's a very common complaint, you know, majority of the times, if the patient is not having any abnormality also, they used to come because they think that there is a deformity. The over-concerned parents, the paranoid parents, they just want to get consulted for the reason that possibly there could be a deformity which might progress with age. All right, so that is one thing. So the first segment of the question has got nothing to do with the answers, obviously. Next is, now his 6-year-old sister was treated for developmental dysplasia of hip. Now this is one family positive history which is provided to you, that why the mother possibly is more concerned because the elder sister of that sibling was suffering from developmental dysplasia of hip. That is point number 1 taken. Next is, the knee do not stay together when the feet and ankles are placed together. That means that when the feet and the ankle, they are placed together, they are bound together, then their knees are not getting sticked. That means possibly the parent or the patient is having a varus deformity of the knee joint, because when both the feet are brought together, the knees are not getting stick together. So possibly there could be a varus deformity happening in this case. All right. So the patient could be having genu varum. Now the gait is unremarkable. That means gait is absolutely normal. Now fontanelles are already closed. You know, the anterior fontanelle is closed by the age of 18 months normally. The posterior fontanelle is closed by 6 to 9 months normally. That means by the age of 21 months, if both of them are found to be closed, then possibly the metabolic disorder can be easily ruled out to some extent. All right. Now the mother is concerned that he has a growth disorder. Now which of the following is the most appropriate next step in the management? Now based on the entire clinical profile, you have to step out, means what should be the next step in management of this kind of a patient. Now point number 1, we'll go option wise obviously. The first option is vitamin D supplementation. You see, vitamin D supplementation has to be given only on the basis of the investigations done. First of all, you have to identify the problem. Before giving the vitamin D supplementation, you rule out rickets. All right. First of all, it has to be rickets. That means, and the rickets is ascertained, it is diagnosed based on the x-rays of both the wrist, AP view, where all those changes of the rickets are present. Then you have to go for the lab investigation of a vitamin D estimation. You have to go for the alkaline phosphatase. You have to go for the serum calcium. Although serum calcium, majority of the time, because of this nutritional deficiency ricket, it seems to be normal. So vitamin D supplementation without prior investigation shouldn't be provided. All right. So you can ask the patient to come in the follow-up. Let's see if this thing is getting reduced. Let's see if there is any problem inside this. Based on the clinical examination, I'm not finding anything which requires any sort of supplementation. If at all it is to be given, then prior investigations are needed. So actually vitamin D supplementation can be provided, but before that the prior investigation is required, and the question is asking about that what is the next step in the management. So possibly we will hold up this option. All right. Next is reassurance and follow-up. Now, why this seems to be the best option out of the options provided? Reassurance, because the patient is having both the fontanelles closed. Now, the patient is having a history of developmental dysplasia of hip, but the gait abnormality is not there. Because in case of DDH, there has to be a Trendelenburg gait positivity. While in this case, there is unremarkable gait. That means absolutely normal. Then he is having some amount of the varus deformity, which could be physiological also. Genu varum could be physiological also. And with time, it heals. Means there, with the growth of the individual, there will be an autocorrection. This thing, it weans off over a period of time. So it is not a feature for which we shouldn't be too much concerned. All right. This is the kind of the feature. Okay. So best options out of the options provided is the reassurance. All right. That you reassure the mother that possibly there is absolutely no problem, because majority of the children are having these kind of the abnormalities, although it is not an abnormality. But yes, we will see the patient in the follow-up. All right. Next is X-ray of the lower extremities. You see, X-ray of the lower extremity is of no use in this particular case. If you have to diagnose the condition with which the patient could be suffering, then X-ray of the wrist is required in order to rule out rickets. All right. The rickets is going to be diagnosed on the X-rays of the wrist. X-rays of the lower extremity is only of help once there is a pathological valgus or varus deformity, which comes on clinical examination only. All right. If the intermalleolar distance in case of a valgus deformity is beyond 8 cm, then scanogram is required. if the intercondylar distance is more than 7 centimeter, 8 centimeters in the pathological genu varum, then the scanogram is required. So here in this case, X-ray of the lower extremity is of no use. All right. And then hip abduction brace. As I told you that the patient is not suffering from developmental dysplasia of hip. The hip abduction brace is required in case of a DDH, established DDH, where you will reduce the hip, you will hold it in abduction, and that too in case of a newborn. All right. There is a management protocol changes once the age is advanced and the patient is having a positive family history of DDH in his elder sister. It does not mean that the patient is having a DDH. All right. There is a possibility of this DDH abnormality because of other reasons also. So the patient is ruled out that there is no DDH abnormality. So this option is also not true. So out of the options which are provided, the best option is reassurance and follow-up. All right. So this is how you have to proceed with these kind of the questions. Hopefully everything is clear related to this particular question also. Next is that which of the following statement about osteomyelitis is not correct or incorrect. So you have to go for the incorrect option. All right. A small bony spicule discharge through the sinus confirms the diagnosis of chronic osteomyelitis. Although we are not going to take too much of the time in the discussion of this question, but pathophysiological feature or pathogenesis of the chronic osteomyelitis is something with which everything is related or every question is relatively asked. Like imagine if this is a bone and here we are having a small segment of the bone, all right, around which the organism is growing, and this because the small segment of the organism is still persistent, so it will always be surrounded by the granulation tissue because it will incite the chronic inflammatory disorder. So the granulation tissue will always be there. And in order to contain this organism, there will be an involucrum. That means a bony cavity, which is likely to reject the progression of this chronic osteomyelitic disease. Now, what is this thing in the center? It is a sequestrum. Now, sequestrum is a necrotic segment of the bone around which the organisms are growing. Why this segment gets necrotic? Because the organism take up the vascularity. The organisms, they interfere with the vascular supply to this small segment of the bone, as a result of which it becomes necrotic. All right. Now, if the organism continues to grow, then it might break this involucral wall, and this break in the involucral wall might result in the formation of a tract which will open all the way up to the level of skin, and this tract is known as sinus. All right. Now, with the increased activity of the infection, there is always a possibility of the abscess formation inside this involucral wall. And if there is too much of the abscess which is getting drained out of the sinus, there is always a possibility of this sequestrum to come out of the sinus. Now, what is the option 1 which is provided to you? It is a small bony spicule discharged through the sinus. Now, when this is small bony spicule which is coming out of the sinus, it means it is the sequestrum which is coming out of the sinus. It confirms the diagnosis of chronic osteomyelitis. Absolutely true. Because this is the clinical feature which is most apt clinical feature on the basis of which the diagnosis of chronic osteomyelitis is already confirmed. So this is the correct option. All right. It is not the incorrect statement. Next is a biopsy with the culture and sensitivity is the gold standard in the diagnosis of osteomyelitis. As I told you that biopsy is the gold standard. All right. Investigation of choice could be different, but the gold standard always is going to be a biopsy because it will identify the organism. It will identify the drugs for which this organism is sensitive. All right. So biopsy with culture and sensitivity is the gold standard for making the diagnosis of chronic osteomyelitis. It is true. And the investigation of choice, remember, these are two different things. The investigation of choice in order to make the diagnosis is the MRI. Why MRI? Because even the smallest amount of the abscess, this bony spicule, could be seen inside the MRI based on the rim sign. All right, the MRI feature of chronic osteomyelitis. Investigation of choice. And you know, the difference in between investigation of choice and gold standard is that investigation of choice is a kind of an investigation which is less painful for the patient, will give you a nearest mode of the nearest method to attain the diagnosis without causing too much of pain. It should be less expensive, it should be less intrinsic, it should be less invasive. All right. So there are multiple criteria which makes the investigation of choice. But another investigation which does not follow any criteria but will give you the exact diagnosis is the gold standard investigation. All right. So it has got nothing to do with the less invasive. It has got nothing to do with the time duration which is required. It has got nothing to do with the pain the patient might suffer from it. All right. Gold standard investigation. So these are the differences in between the two. All right. So this option is also true. Correct. This answer is correct. Yes, Cierney and Mader classification, although no one is going to ask you, but yes, Cierney and Mader classification is the classification system for ascertaining the diagnosis, basically the stages of chronic osteomyelitis. All right, based on the anatomical findings. So this option is also true. So lastly, what we are left with obviously is the fourth option, and that one is that the involucrum is the most common cause of non-healing sinus in the chronic osteomyelitis. Involucrum is just reaction of a normal bone in order to guard this chronic osteomyelitic changes. Basically, the reason for non-healing sinus is always the sequestrum. It is actually the sequestrum which is the reason, not the involucrum. All right. Until and unless there is a sequestrum inside this bony cavity, you cannot get rid of this infection. Means sequestrum is the reason for this non-healing of the chronic osteomyelitis. And you know, this is the reason why the management or the treatment protocol for chronic osteomyelitis is sequesterectomy. You know, until and unless you don't remove this sequestrum by saucerization. All right. Until and unless you don't remove the sequestrum, you cannot get rid of the infection. So how it is being performed? Sequesterectomy. You create a large window and then remove everything out. All right. Sequesterectomy by saucerization. Saucerization means which is having a larger hole, which is not a narrow. It has to be a shallow hole. So that is saucerization, saucer-shaped hole. Why saucerization? Why you are creating a larger window so that in future there is nothing which gets accumulated inside the bone. Everything in the form of the abscess which is getting or bound to get collected inside the bone should be drained out of the bone readily. All right. So that is the management protocol or the principle of the management is sequesterectomy by saucerization. Why is this the management? Because sequestrum, if it is present inside the bone, it will never allow you to get it healed. All right. So it is not the involucrum, it is the sequestrum which is the most common cause of a non-healing sinus in chronic osteomyelitis. Hopefully everything is clear related to this particular question also. All right. Next is again a huge long question, but if you read it carefully, just by knowing the question, you will come to know that what is the diagnosis of the patient who is suffering from it. All right. 48 hours after the accident, 28-year-old male was referred to the clinic due to disorientation and respiratory distress. Now, as I told you, whenever you see these kind of terminologies in any question related to orthopedics, you know, traumatic patient, multiple long bones fractured, disoriented, respiratory distress, answer, do think of fat embolism syndrome. All right. So many times we have discussed this fact. After being hospitalized at an orthopedic service with a right femoral shaft fracture. So everything provided to you this. Now, given that disorientation could be caused by trauma, a brain CT was performed within 12-hour window and no pathology was detected. So no pathology was detected because it is not because of the bleeding spot or intradural or subdural hematoma. So it has got nothing to do with the hematoma. It is because of the fat embolism syndrome. The patient is getting disoriented. Now pulse rate was 106. Now, you know, these are the alarming clinical features where there will be tachypnea, tachycardia. So like tachypnea is already provided respiratory distress. Tachycardia, there will be raised heart rate, and the BP was 100/55. Examination of the respiratory system was absolutely normal. There were no crepitations. There was no abnormal movement of the chest. On the right axillary petechial rash was present. Axillary region petechial rash was present. So what else is required for making the diagnosis? You know, the pathognomonic clinical finding is petechial rash, which could be present on retina, on conjunctiva, on axilla, on abdomen, on trunk. The alarming clinical features are tachypnea, tachycardia and fever. All right, tachypnea, tachycardia and fever. So everything is provided. What are the other clinical features which might help you in making the diagnosis is the confusion, which might result in coma and respiratory distress. So everything is provided in a young patient who is having a femoral shaft fracture. Now they are asking which of the following statement is correct about the given clinical scenario. Now which of the statement is correct? Now if we go with the option 1, usually it is occurring after the fracture of the lower limb. Yes, this is true. Long bone fracture, it might result in the fat embolism syndrome because these fat globules in an age after 20 years of age, these fat globules might reach the circulation and result in this condition. Now CT and the MRI will help to grade the severity of the fat embolism. This is also true. Alright. Now retinal rashes are pathognomonic. So basically all of the above are correct for this particular question. Now, as far as the clinical complications of the fractures are concerned, compartment syndrome and fat embolism syndrome is something that you should be knowing about because every year they are asking a question based on these clinical questions. So hopefully this session was of help in order to make the diagnosis. As I told you, orthopedics being a vast topic or being a vast subject, but you are going to get the questions which are around 9 to 11, and out of these 20 to 25 topics they are asking these questions repeatedly. All you just have to go through it multiple of the times. You have to repeat the questions. You have to go through the previously year asked questions multiple of the time in order to mark the answer very clearly. All right, so that it has to be there on your spine level. You don't need to incorporate your brain in order to mark the answer. Thank you very much. All the best for your examination.
Alright, hi guys. So let's get started with the discussion of grant test that was conducted for our FMGE students. And we have around 14 questions for this discussion. The first question that is going to be about a 34-year-old woman presenting to OPD with a chief complaint of headache and blurring of visions. Okay, so there is a headache, blurring of vision, and the vitals are heart rate 90, respiratory 16, but the blood pressure is extremely high. Her past medical history is unremarkable, but there is a history of pregnancy and examiner is simply asking which drug to be avoided. So in a simple term, if it would be like an exam of 2 to 3 years ago from now, they would ask which of the following antihypertensive drug should be avoided in pregnancy. But here they have given a case-based scenario, and expect this kind of case-based scenario in all of other questions as well in your examination. So which drug should be avoided? Very simple. Is it alpha-methyl dopa, labetalol, amlodipine, or lisinopril? The answer to this question is none other than your lisinopril. Right, remember guys, lisinopril, it's an ACE inhibitor, and I think I have told you previously as well, the be it ACE inhibitor, be it ARB, they are actually associated with teratogenicity. So what kind of teratogenicity are they going to cause? So there are multiple teratogenicity, like they can cause growth abnormality or growth defect, like there will be delay in the growth. Apart from that, there can also be a renal dysgenesis, and they can even lead to lung hypoplasia. That is one more thing. Lung hypoplasia is also something that can be seen here, lung hypoplasia. So these are the important teratogenic effect that can be associated with ACE inhibitor or ARB. Remember that. Now a quick summary of what all drugs that we can give, what all drugs that we cannot give, which I always used to give in almost every classes, right, for the hypertension in pregnancy. So let me make the quick list. Hypertension in pregnancy. And what is the mnemonic that I have given you? Two important things. One is what is safe and what has to be avoided. What is safe? So remember, if there is a pregnant female coming to you, you always send this pregnant female to a medical college known as your Lady Harding Medical College. And this is what I always say, Lady Harding Medical College is her place because this is the safe drug in the pregnancy. This Lady Harding Medical College stands for labetalol. For hypertension in pregnancy, drugs like labetalol, it's a third generation beta blocker with the alpha-1 blocking property. It's a drug of choice. In fact, hypertensive emergency in pregnancy also it's a drug of choice. Then we have a potassium channel opener by the name of hydralazine that can also be utilized, right? Alpha-methyl dopa, drugs like clonidine, both of them are actually alpha-2 agonists. They both are safe. And college stand for your calcium channel blocker. Please remember, in the calcium channel blocker, the one that is ending with dipines, we call it as the DHPs, dihydropyridines, dipines like amlodipine, nifedipine, these are the one that is safe. And C stand for also your cardioselective beta blocker. These are the one that can be used. So Lady Harding Medical College, labetalol, hydralazine, alpha-methyl dopa, clonidine, they both are alpha-2 agonists, calcium channel blocker and cardioselective beta blocker. In calcium channel blocker, remember, not verapamil, diltiazem, they are avoided. So what are the drugs that are avoided? This list you can easily make once again by the mnemonic. You ask this pregnant female to avoid going to DNB colleges. This is just a mnemonic, guys. Avoid DNB colleges. And what are the DNB colleges that we have?
avoid stand for here your ACE inhibitors, as I told you, causing lung hypoplasia, renal degenesis, and growth retardation. ARB, angiotensin receptor blocker, all the ACE inhibitor ending with pril, all the ARB ending with sartan. So I think every student knows, right, how to identify which one is ARB, which one is the ACE inhibitor. Then D stand for all the diuretics are contraindicated in pregnancy. They can also cause renal dysgenesis. Then sodium nitroprusside, it's also avoided. We also avoid sodium nitroprusside as well. And N stand for your non-DHPs, non-dihydropyridine. So what are the non-dihydropyridine, guys? The non-DHPs are drugs like your verapamil, diltiazem. So verapamil is also something that is avoided, and B stand for beta blocker. Please remember which beta blocker should not be used. So non-selective beta blocker should not be selected. Non-selective beta blocker should not be selected. As simple as that. I think it's pretty simple, and this is a quick summary of what all drugs that can be given, what all drugs should be avoided. Lady Harding Medical College में दे दीजिए what is avoided. So always remember that you are going to avoid DNB colleges, right? So that is ACE inhibitor, ARB, diuretics, nitroprusside, beta blocker. So our answer here lies in one of the ACE inhibitor, and this question has been repeated 3-4 times already in the past 5 years. That means out of 8 to 9 examination, 4 times already this question has been asked. So you can easily expect in upcoming days there can be some question from this table, right? Okay, let's take the next one. A patient comes to the casualty with organophosphate poisoning. He was started on atropine. So we all know that organophosphate or carbamate poisoning, the antidote is atropine. Okay. And pralidoxime. Pralidoxime is an oxime that is used also in organophosphate poisoning. They are the acetylcholine esterase reactivators. After 2 hours, the patient has a sudden temperature rise. Okay. So whenever you see rise in temperature after atropine, they are mainly talking about something called your atropine fever. Right, atropine fever, atropine mediated increase in the body temperature is very common, side effect associated with atropine. What is the likely cause of the fever? Is it idiopathic? Is it due to organophosphate poisoning? See, organophosphate poisoning may there is gonna be increase in the level of acetylcholine. Why? Because they are the acetylcholine esterase inhibitor. So level of acetylcholine will increase, and because of that there will be increase in the body secretion. You see, if the body secretion will increase, in actual there will be decrease in the body temperature. Apart from that, there will also be other feature like your pinpoint pupil, pinpoint pupil, and heart rate will also be lesser. There will be bradycardia as well, right? So these are the 3 important feature. I always used to say that eyes never lies, look in the eyes. Heart also you can believe on the heart as well. So eyes may in the organophosphate poisoning there will be pinpoint pupil, heart rate will be lesser, everything will be shortened up. Then what about your body temperature? Body temperature will also be lessen. It's on the lesser side, it's decreased. Okay. Then option C is saying atropine and side effect of pralidoxime. Pralidoxime does not have any such side effect apart from the usual nausea, vomiting, rash, and there is no specific or very severe kind of side effect associated with the oximes. So answer to this question is none other than your atropine toxicity. Atropine toxicity. Now what is atropine? Please do remember atropine, it is one of the muscarinic antagonists. Please remember that atropine as a drug, it's a non-selective muscarinic antagonist, right? What is it? It's a M1 antagonist, it's a M2 antagonist, and it's a M3 antagonist. So it's a non-selective muscarinic antagonist, and maximum action, maximum blocking action, it is seen at the M2. Maximum blocking action it is seen at the M2. Because of M1 blocking activity, what will happen? There will be decrease in the gastric secretion. There can be decrease in the gastric secretion. Apart from that, there can also be some CNS symptom, because I used to tell you that one side that is common for M1, M2, M3, M4 and M5, that is going to be CNS. So atropine poisoning wala patient can present to you with the CNS symptoms as well, right? Psychotic features, CNS, atropine mediated psychosis. M2. Because of M2 blockade, what will be the outcome? See, M2 itself causes bradycardia, and when you block M2, what will happen? The heart rate is going to be lesser. The heart rate is going to be lesser. M3, if you are going to see in the eye, so M3 in the eye, it is present on the circular iridis muscle. When you block, again, there will be mydriasis. There will be mydriasis. Okay. Apart from that, again, if you see 3 important areas, eyes, heart and body temperature. So body temperature will also be high. body temperature is going to be high. Why? Because they are anti-secretory agent. They are going to inhibit the secretion of sweat as well, and therefore body temperature will ultimately increase. There will be many other features, but remember these are the important three areas. So if you want to differentiate between organophosphate poisoning and also your atropine poisoning, please remember three important areas. What I said, eyes never lies. Okay, so with atropine, eyes, how will be the eyes? Atropine, atopine, right? Atropine may everything will be on top. See, atopine, everything will be on top. What is on the top? Pupil size on the top, mydriasis. Okay, heart rate will be on the top, that is on the higher side, heart rate will be high. Okay, what about body temperature? It will also be on the high side. Atopine, everything will be on top. All right, now how are you going to treat atropine poisoning? If there is any treatment of atropine poisoning, the antidote that we have, we call it as the antidote of atropine poisoning, we give a physostigmine. You should never forget, guys, physostigmine is the antidote, and we always used to discuss this one, right? In fact, in our usual classes, I have given you the list of antidotes, right? Like there are 10 to 12 antidote lists that I have given you, the table that I have given you. Very frequently questions are being asked from those areas. Apart from that, if I have to tell you that organophosphate poisoning, OP organophosphate poisoning, or here CB is carbamate poisoning, organophosphate or carbamate poisoning that we have, what will be the symptom here? So again, start from the eyes. So there will be miosis, pinpoint pupil, eyes never lies, heart rate will be lesser, there will be increased secretion. Because of that, body temperature can be low, but this is not one of the specific feature, but body temperature can be low. You can easily understand why body temperature will be low, because secretion is excessively increased in organophosphate and carbamate poisoning. In organophosphate and carbamate poisoning, how will you manage this case? How are you going to manage organophosphate or carbamate poisoning wala cases? You will be managing this using atropine. So antidote for this one is going to be none other than your atropine. So these two poisoning are very, very frequently asked. These two poisonings are commonly asked, right? So right now I have summarized both of them. Expect one question definitely from this area. All right. So atropine toxicity was the cause of rise in the body temperature. Simple. Next question. What should be recommended as a prophylaxis in a pregnant lady who are on anti-epileptic drug having enzyme inducing property? See, anti-epileptic, all the anti-epileptic drug, not all, but most of the anti-epileptic drug have enzyme inducing property. We have an exception by the name of valproate. Valproate is the one that is having enzyme inhibiting property. So what are the example of these enzyme inducing property? We have many drugs, like your phenytoin, okay, they are enzyme inducer, potent enzyme inducer. Drugs like your carbamazepine, they are also a very potent enzyme inducer, right? Your barbiturate, they are also very potent enzyme inducer. See, all these drugs are enzyme inducer. And any enzyme inducer, what are they going to do? Any enzyme inducer, what will they do? They are going to increase the metabolism. They are going to increase the metabolism of associated drug. Not only that, they can also increase the metabolism of something in body, something like vitamin K. And if they increase the metabolism of vitamin K in the body, what will happen? There will be apparent deficiency of vitamin K, and there can be, hemorrhagic disease of the newborn, and also there can be risk of hemorrhage in the pregnant female as well. Okay, so in a pregnant lady, always remember what will be recommended always and always to write prophylaxis as a vitamin K, because again bleeding risk will be very, very high. So again, these enzyme inducer, they always and always are having enzyme inducing property even for the vitamin K as well. And when they increase the metabolism, there will be increase in the bleeding risk in a pregnant female. Therefore, vitamin K dose ko you will be always and always, even if the person is not on this one, we just as a prophylactic in the last trimester, we always and always recommend vitamin K injection to the pregnant female. Here, all other option like anti-D immunoglobulin, steroid, indomethacin, they are not something that will be given because of the enzyme inducing property. See, steroids are something if you want to do the maturation of the lung, or indomethacin especially in pregnant female, if you are going to give indomethacin, it can it's a COX inhibitor, indomethacin, it can cause premature closure of ductus arteriosus. Premature closure of ductus arteriosus. So COX inhibitor anyway should be avoided in pregnant female, especially in the last trimester. Last trimester means it should be avoided. So vitamin K is the correct answer for a question like this. Moving forward, a 51-year-old man was presented to emergency with history of fever and night sweat. Okay, so whenever you see fever and night sweat, you always think about something called tuberculosis. He also report 10 kg. Okay, so weight loss again is a very specific feature of tuberculosis. Weight loss is also there. All right, next what we have, unintentional weight loss of around 10 kg. He has a history of diabetes mellitus. Okay, so in diabetic patient, the risk of TB is always high. Sputum examination shows acid fast bacilli, raising the suspicion of pulmonary TB. Okay, so there is already a suspicion of TB. Whatever I was telling you, they are already talking the next line here. While prescribing isoniazid, so what are the first line antitubercular drug? Isoniazid, rifampicin, pyrazinamide, HRZE, isoniazid, rifampicin, pyrazinamide and ethambutol. Okay, the physician adds which vitamin to prevent the common side effect of isoniazid? I think all of you guys are already aware, guys, that isoniazid as a drug, I'll just write it here. Isoniazid as a drug, remember, it is going to inhibit the pyridoxine conversion to the active form of the pyridoxine, that is known as your pyridoxal phosphate. So it is inhibiting the activation of the pyridoxine. And what is the active form of pyridoxine? That is pyridoxal phosphate. Not only that, isoniazid, it also increases the vitamin B6 ka excretion. It promotes the vitamin B6 ka excretion. Because of this reason, what is pyridoxine? It's also vitamin B6. So one way it is inhibiting the activation. Second way, it is also promoting the excretion. Therefore, apparently, what will happen? There will be increase in the vitamin B6 deficiency, or I would say there will be deficiency of vitamin B6. Deficiency of vitamin B6, and this will present to you with the peripheral neuropathy. Peripheral neuropathy. So sometimes they don't use the term peripheral neuropathy, they use the term that the patient after being started on antitubercular drug presenting with a tingling sensation. Tingling sensation is the word they use. So a specific question has been included, and I think I have included in the textbook as well, FMG solution, you can check it out. Exact line has been given, tingling sensation, which drug is responsible. So tingling sensation is the term that they use sometime. Okay, so if vitamin B6 is already lesser, what would you like to supplement to this patient? What would you like to supplement? So as a treatment or as a therapeutic modality, you will be adding pyridoxine. What is pyridoxine? That is none other than your vitamin B6. Pyridoxine is none other than your vitamin B6. I hope it is making sense to all of you guys. And how much vitamin B6 will you be supplementing here? So you can supplement, let's say if you want to give as a prophylactic, you can use somewhere between 10 to 40 milligram on the daily basis, or if you want to give for the therapeutic purpose, this is for the prophylaxis, you can give 100 milligram on the daily basis, 100 milligram per day for the treatment of this peripheral neuropathy. So always and always remember, along with isoniazid, what is important? That is pyridoxine, not folic acid, biodine or thiamine, right? So do remember, isoniazid ka simple question is asking isoniazid ka side effect. So you already know. There can be other side effect as well. So if the examiner is going to ask you, what are the other side effect of isoniazid? Other side effect. Now isoniazid is a drug that is usually metabolized by acetylation. Okay, and any drug that is metabolized by acetylation, they can lead to what? A drug-induced lupus, SLE, drug-induced lupus. It can also lead to peripheral neuropathy, hepatotoxicity, that is something also there, and it can also cause psychosis. Psychosis is something that has also been reported with the isoniazid. Alright, so peripheral neuropathy is one. Apart from that, the usual nausea, vomiting, that is never going anywhere, drug-induced lupus and hepatotoxicity, and they can even lead to psychosis as well. Alright. Moving to the next question. Which of the following is a long-acting bronchodilator? Salbutamol is a bronchodilator, terbutaline is a bronchodilator, formoterol is a bronchodilator, and ipratropium bromide is a bronchodilator. All of them are bronchodilator, but examiner is asking which is the long-acting bronchodilator. Always remember, boys and girls, whenever they talk about bronchodilator, you can do this, or the active form of bronchodilator. I'll just classify this very easily for all of you guys. Whenever you talk about bronchodilator, there will be two types of bronchodilator, active bronchodilator and passive. So expect this exact line, which of the following is the active bronchodilator, which is a passive bronchodilator. Active bronchodilator will be any drug that is going to directly cause the bronchodilation by increasing the activity of any receptor that is causing bronchodilation. So see, what receptor causes bronchodilation? Beta 2 receptor causes bronchodilation, right? So if you increase the beta 2 activity, they will be causing active bronchodilation. Okay. In the lungs and from the parasympathetic nervous system, we are having M3 receptor. If you give M3 agonist, there will be bronchoconstriction because parasympathetic causes bronchoconstriction. M3 agonist will be causing bronchoconstriction. And if you give M3 antagonist, it will be causing bronchodilation. But you are directly not causing dilatation. What you are going to do, you are blocking the parasympathetic so that sympathetic outcome will be high, sympathetic tone will be high. So we have sympathetic, we have parasympathetic. If you remove parasympathetic, sympathetic tone will automatically be high. I hope it is making sense to all of you guys. Active and passive bronchodilator, please remember. And likewise, I want you to remember active and passive miosis and mydriasis as well. Same concept. Repeating again, active bronchodilator, any drug that is directly going to increase the activity of any receptor that is causing dilatation. Which receptor causes dilatation? Only one receptor, beta 2. Right? Passive bronchodilator, you are trying to inhibit the bronchoconstriction. So what causes bronchoconstriction? M3 receptor on the bronchial smooth muscle. So when you block it, there will be apparent bronchodilation. Okay. Now let us quickly summarize this active and passive wala area. Okay. The beta 2 agonist that we have, it is further subdivided into two important areas. One is short acting beta 2 agonist and other one is a long acting beta 2 agonist. So under short acting beta 2 agonist, we are having many drugs. For example, we have drugs like your salbutamol. This is SABA. SABA is short acting beta 2 agonist. Salbutamol, terbutaline, perbuterol. There are so many drugs actually. Perbuterol. LABA may we have drugs like your salmeterol. We have formoterol, carmoterol, indacaterol. Indacaterol is the longest acting among all. Indacaterol. So we call indacaterol also as a ULABA. ULABA is ultra long acting beta 2 agonist. So this is salmeterol, formoterol, carmoterol, indacaterol, and all of them are mainly LABA. So you can remember very easily, country like India is very large, no? It's a very large country. In a country like India, if you travel by car और मेट्रो यू कैन ट्रेवल फॉर लॉन्गर डिस्टेंस. इंडिया में कार और मेट्रो से आप लंबे दूरी के लिए जा सकते हैं. यू कैन ट्रेवल फॉर लार्जर एरिया, यू कैन कवर लार्जर एरिया, राइट. सो इंडाकेट्रॉल लार्जेस्ट है ना, कार्मेट्रॉल, फॉर्मेट्रॉल, साल्मेट्रॉल, राइट. दे आर ऑल लॉन्ग LABA, long acting beta 2 agonist. Any long acting beta 2 agonist can be utilized for the prophylaxis. Right now, formoterol is one such drug that can be used for the prophylaxis, and it can also be used for the acute because formoterol has a fast onset of action. So F has a fast onset of action. So this is one that can also be used in acute scenario. In fact, according to GINA guideline, that is Global Initiative of Bronchial Asthma or Global Initiative of Asthma, they are telling as a step 1 modality for the control of bronchial asthma, you give formoterol along with the inhaled corticosteroid. Formoterol with the inhaled corticosteroid. So any person that is coming, patient more than age 12 year, as a step 1 modality in bronchial asthma treatment. I am just telling you this. You can expect the direct question as well, direct line by line. Step 1 modality, you give formoterol with inhaled corticosteroid, ICS with the inhaled corticosteroid, right. Now let's talk about passive bronchodilator. Very easy. Passive bronchodilator, you can simply say that M3 antagonist that we have. Let me just zoom it in a bit. M3 antagonist that we have, it is further divided into two. One is known as SAMA. What is SAMA? Short acting muscarinic antagonist. Another one is the LAMA. LAMA is a long acting muscarinic antagonist. So under SAMA, we are having a drug by the name of ipratropium. So they are also short acting. No, ipratropium, it's also a short acting, ipratropium. And LAMA, what is LAMA? That is going to be tiotropium. Tiotropium. We are having other drugs as well, right? Tiotropium, glycopyrronium, and there is a new drug as well, revifenacin. They are also M3 antagonists, no? M3 antagonists. But ipratropium, what I am trying to explain here, is a shorter acting muscarinic antagonist. They are bronchodilator, they are not direct bronchodilator, not active bronchodilator, they are passive bronchodilator. In other term, we can also call it as the indirect bronchodilator. Passive bronchodilator also we can also call indirect bronchodilator. So if you look at the options, salbutamol, it's a short acting beta 2 agonist. Terbutaline also short acting. Formoterol is the only one in the option that is long acting bronchodilator. Very, very simple question, but what is expected that they can ask you which of the following is the active bronchodilator. So don't think this question is going to be repeated, but no, from the discussion part, from this area, the topic can be repeated in a different form. Okay, a patient given a drug X, all right, there is a X drug given. What is the name? They are not mentioning, and having a side effect called nausea and vomiting. All right, the serum concentration of the drug X is okay. So right now At present, the serum concentration, they have measured it 8 milligram per deciliter. The therapeutic plasma concentration, okay, so therapeutic range is only 1. What is the therapeutic range? Only 1. But how much is it now? That is 8, that is already on the higher side. Let's read the question again. If the half-life of the drug X is 40 hours, okay, how long one should wait before resuming the treatment? Alright, so it should be 1. But at present, when you are measuring, it is around 8, right? And half-life is around 40. That means 40 hours the plasma concentration will become half. That is half-life, right? That is the definition of half-life. So let's start with the current plasma concentration. The current plasma concentration, it is 8 milligram. 8 milligram per deciliter. And it is telling in the 40 hour it will become half, right? So it will become 4 milligram per deciliter in around, the half-life is 40 hours, no? So in around 40 hours. I hope it is pretty simple. Now in the next 40 hour, it will become 2 milligram. In the next 40 hour, if you see, it will become 1 milligram. Now it will be taking another 40 hour. Now if you see 40 hour here, first half-life, 40 hour here, second half-life, 40 hour here, third half-life. After third half-life, after 3 half-life, this is becoming 1 milligram per deciliter. That was the therapeutic. This is the excess plasma concentration, but the therapeutic range is around 1 milligram. So how many hour it is taking? 40 hour, 40 hour, 40 hour. So total it is taking around 120 hours to bring it to the therapeutic plasma range. And what is the therapeutic plasma concentration that we want actually? The therapeutic plasma concentration that we want is around 1, right? So you have to wait for how many hours? 120 hours to bring the plasma concentration to 1, right? So therapeutic plasma concentration is 1. So you have to wait 120 hours to bring it to the therapeutic plasma concentration, that is 1 milligram. I hope it is pretty simple. But if the examiner is going to ask you that how many T half-life it is required to bring the plasma concentration to close to 0. See, close to 0 will never happen. It will be, most of the drug are following zero order kinetic. Close to 0 is not going to happen. But what you need to understand, that if the plasma concentration become around 5% of the initial, we say, okay, this is not going to be effective anymore. So usually if you are going to start from 100, it will become in one half-life, it will become 50. In next half-life, it will become 25. Next half-life, it will become 12.5. Another next half-life, it will become 6.25, 3.12. This will keep on happening. Now there is no end to this. Always remember 3.12 again it will become 1.5, right, 1.6, something like that. It will keep on happening. It will keep on, right, going below and below. But when the plasma concentration goes around 5% of the initial, 5% or below 5%, we say okay, now the effect is negligible. So close to 0 or close to negligible effect, right, this will be taking around 5 T half-life, around 5 T half-life, right? Because see, 1 half-life it will half, 2 half-life, 3 half-life, 4 half-life and around 5. So it is taking around 5 half-life to bring it to less than 5. Are you guys following me here? So they can also use the term that for the complete excretion of the drug, see, close to 0 or for the complete excretion of the drug, that will be taking around 5 T half-life. So any drug, the overall duration of action of a drug, it is around 5 times of the T half-life. I repeat again. What is T half-life? The time which is required to bring the plasma concentration to half. Duration of action मतलब कब तक वो काम करेगा body में, until when it will be working in the body. So that will be somewhere around 5 half-life, right? So it will be for the next 5 half-life, it will be there in the body and it will be working either at the lesser efficacy or higher efficacy, that we're not talking, but it will be working in the body for the next 5 half-life. So there are 2 questions here that I have summarized here. Alright, next, a patient developed neutropenia while on anti-cancer therapy. Which drug can be given to stimulate the growth of neutrophils? Very simple question. In fact, in 2023 examination, one of the examination, they asked directly which drug is given to increase the level of platelet. But this time here in the GT, they are asking which drug is given to increase the neutrophils. So I think it's pretty simple. If you want to increase, it will be filgrastim. So look at the name filgrastim. It is the granulocyte stimulant. Filgrastim is what? It's a granulocyte stimulant. Always remember filgrastim, or we have one more that you know sure, pegfilgrastim. Filgrastim or pegfilgrastim. These are the agent that will be, they are the granulocyte colony stimulating factor. granulocyte colony stimulating factor, and they are utilized for any case of neutropenia like congenital neutropenia or neutropenia in chemotherapy patient, neutropenia in chemotherapy patient, or neutropenia in any advanced systemic diseases. In any advanced systemic diseases also, if there is neutropenia, we can use filgrastim, right? What is amifostine? Amifostine is not a drug to form any cell. It is actually a nephroprotective drug. It's a nephroprotective drug. Which one? Amifostine is a nephroprotective drug. So, as a prophylaxis of cisplatin-induced nephrotoxicity, cisplatin-induced nephrotoxicity, we will be using amifostine. What is oprelivecin? Look at the name, oprelivecin. These are the 11 interleukin. Oprelivecin is what? 11 interleukin. So, this is interleukin 11 agonist, and it is mainly used for chemo-induced thrombocytopenia. If there is chemo-induced or any other cause of thrombocytopenia like idiopathic thrombocytopenia purpura also we can use, है ना? Chemotherapy-induced thrombocytopenia. Alright. Darbepoetin, again, they are the erythropoietin agonist, EPO, erythropoietin agonist. They can be used in chemo-induced anemia or end-stage renal disease induced anemia. Chemo-induced anemia or end-stage renal disease induced anemia. In any of the scenario, you can use epoetin, darbepoetin, all of them you can utilize. Alright. So, answer to this question is none other than C. Filgrastim, they are the granulocyte stimulant, right? The name itself is having everything. See, granulocyte stimulant. Then we have granulocyte monocyte stimulant, melgramostim, regramostim, sergramostim. They have the name granulocyte monocyte stimulant. Next question. 45-year-old female who has been taking medication chronically for several years, for present to you with the feature depicted, right? Look at the image. I think you have easily seen this image in your GT as well. Consistent with the endocrine disorder. So, she is taking some drug, and this is leading to the problem as shown in the image. What is the probable drug? So, very simple. Look at the image. Let me zoom it in a bit. Now, you can easily see that there are multiple features here. What are them? Weight gain. So, you can easily see here, right? Apart from that, there will be muscle wasting, peripheral muscle wasting. Look at the buffalo hump, extra fat around the neck, right? Moon facies, right? Increased facial hair. So, where is it indicating mainly? They are mainly indicating towards a drug that is going to cause Cushingoid appearance. It is going to produce what? Cushingoid appearance. And which drug will be producing Cushingoid appearance, guys? Systemic use of drug like steroids. Steroids systemically can cause Cushingoid appearance, है ना? तो उसको बोलते हैं lemon on stick appearance. You must have heard about this lemon on stick appearance, right? Where there is a weight gain. Apart from that, if you see in the later on scenario, it can even cause other problem like a cataract, systemic, है ना? Systemic steroid. Ocular side effect means systemic steroid. It can be associated with the cataract. Okay, it can be associated with cataract. Not any other drug. I mean, metformin is a drug for diabetes. It will not be causing all this, side effect that has been mentioned. Tamoxifen, it is one of the selective estrogen receptor modulator. They are used for the breast cancer. Again, they can be associated with increased risk of endometrial carcinoma and other side effect, but not Cushingoid appearance. Phenytoin is an anti-epileptic drug. This is not a drug for any endocrine disorder, and phenytoin can cause side effect. What are the side effects caused by phenytoin? Gum hypertrophy. Phenytoin can cause skin abnormalities, nausea, vomiting, rash. All this problem can be there. It can cause peripheral neuropathy as well. It can even cause megaloblastic anemia as well. And all this problem can be caused by phenytoin. All right. So, correct answer for this question is steroid. Steroid can cause Cushingoid appearance. This was an easy peasy question. Okay, 55-year-old male with a history of Hodgkin lymphoma, okay, is being treated with a combination of chemotherapy drug. During a follow-up visit, the patient complained of noticing hyperpigmented patches on the trunk. On further inquiry, he mentions receiving a drug known to cause the side effect. Okay, which of the following drug is most likely responsible for hyperpigmentation of the patient's trunk? All right. So, first thing first, they are giving a history of patient presenting with the Hodgkin's lymphoma. So, what is the preferred regimen for Hodgkin lymphoma? For Hodgkin lymphoma, we use ABVT regimen, that is adriamycin, bleomycin, vinblastine, and dacarbazine. All right. This is ABVD regimen. Now, out of them, they are mentioning which drug could have caused this one, right? So, the shown side effect that is mentioned here, we call this one as a flagellate dermatitis. This is known as what? Flagellate dermatitis. Flagellate dermatitis, right? I'll just write this again on the next slide as well. I hope you are able to see this one. Flagellate dermatitis is what we are going to call this one, right? And the drug that is associated usually is known as your bleomycin. Why not others like let's say doxorubicin? Doxorubicin, remember, it's a drug that is causing cardiotoxicity mainly, apart from the bone marrow suppression, nausea, vomiting, alopecia. They are mainly cardiotoxic drug. And again, doxorubicin is not a part of Hodgkin lymphoma regimen, okay? Then we are having vincristine, mainly associated with peripheral neuropathy. They are associated with SIADS, syndrome of inappropriate ADS secretion, nausea, vomiting, and all those other side effects. Cyclophosphamide again is a drug that is not a part of ABVD regimen, and they will be associated with side effects like bone marrow suppression, alopecia, and the cyclophosphamide. They can have other side effects like hemorrhagic cystitis. Always remember, hemorrhagic cystitis is very important side effect. But here, flagellate dermatitis is caused by bleomycin. Please remember, bleomycin is a drug. Bleomycin is a drug that is one of the G2 phase specific anti-cancer drug. G2 phase specific anti-cancer drug. Bleomycin is a drug that is getting metabolized by, it gets metabolized by an enzyme known as hydrolase. It gets metabolized by an enzyme known as your hydrolase. Please do remember a very important point, that the site of hydrolase that we have, it is mainly present. Hydrolase as a enzyme that we have, it is mainly present in certain areas. Like for example, they are present mainly in the liver and spleen. So they will be rapidly metabolized there, right? Wherever they go, they cause fibroblastic proliferation. So this hydrolase as an enzyme that we have, they are present mainly in the liver and spleen, and they are less present in the lungs. And these are absent in the skin. Absent in the skin. If they are less present in the lung, what will happen? There will be excessive fibroblastic proliferation. Please remember, they are lesser in the lungs. They are mainly inhibiting the fibroblastic proliferation actually. And when they are absent, there will be more fibroblastic proliferation, and that can lead to type 1 pneumocyte damage. Because of the type 1 pneumocyte damage, remember, they can lead to a side effect known as your pulmonary fibrosis. Okay, pulmonary fibrosis. Again, more fibroblastic proliferation, they will involve more and more inflammatory cytokine, and when they will come, there will be more and more damage of type 1 pneumocyte, type 1 pneumocyte damage, and that type 1 pneumocyte damage can be leading to pulmonary fibrosis. If they are absent in the skin, they get deposited. The drug will get deposited in the skin, and they can cause bluish skin, that will be thickened out. Bluish thickened out skin, and we use the term as a flagellate dermatitis. We use the term as a flagellate dermatitis. So this side effect that is mentioned, it's actually a typical question that was asked in 2020 AIMS examination. In 2020 AIMS, there was a similar kind of image that was asked, and they simply asked which drug could have caused this one. So bleomycin is a drug. But in upcoming examination, they can ask that which enzyme is possibly deficient in the skin that is causing the problem. So option can be enolase, hydrolase, elastase, caspase. This type of option can be there. So remember, it is the hydrolase deficiency in the skin. It is causing flagellate dermatitis, and because this enzyme is lesser in the lung, there will be more proliferation of fibroblast. There will be more, they will be inviting more inflammatory cells, different interleukins, that will be causing more and more type 1 pneumocyte damage that can cause pulmonary fibrosis. Okay, so the answer to this question is none other than your bleomycin. So now I have told you what is this and the underlying reason, because upcoming examination mein you will be getting question like this: concept based question, case based question. Next question: which of the following medication used in the treatment of the inflammatory bowel disease is associated with increased risk of hepatotoxicity? Mesalamine, azathioprine, infliximab, prednisolone. Right? So can we use prednisolone? Steroids, very common drug, and it's a drug that is preferred in the inflammatory bowel disease. The most preferred drug. Most preferred, steroids are always preferred in autoimmune condition like inflammatory bowel disease. But the problem with steroids, systemic steroid, they will be causing again the same side effect as I mentioned earlier: Cushingoid appearance, weight gain, dyslipidemia, increase risk of diabetes, diabetes mellitus. They can also lead to side effect like cataract if you're going to give them systemically, right? These are the side effects that will be associated with them. Increasing the risk of fracture, increasing the fracture risk. Infliximab can cause renal toxicity. They will have other side effect. Unlike increasing the risk of hepatotoxicity, they are not hepatotoxic. They are mainly nephrotoxic. This one, it is one of the purine analog. It is one of the purine analog, right? And this purine analog, it is known as your hypoxanthine, and this hypoxanthine mainly it is getting metabolized with the help of enzyme xanthine oxidase. And this purine analog, which is one of the hypoxanthine analog, we also call it as a hypoxanthine analog. We can call it as a hypoxanthine analog as well. This purine analog, they are highly toxic to the liver. They are toxic to liver. Drugs like your 6-mercaptopurine, drugs like azathioprine, right? They are mainly toxic to the liver, right? So remember, the correct answer for this question is azathioprine. Mesalamine again is not a drug that is going to produce mainly hepatotoxicity. There are many other side effects. Unlike azathioprine, mesalamine will have other side effects like skin related abnormalities. They can also lead to nausea, vomiting, rashes like feature. They can also produce a nephrotoxic effect. They can cause proteinuria, nephrotoxic effect, but not hepatotoxic. Hepatotoxicity mainly, I mean, if you have to choose, azathioprine is more hepatotoxic as compared to any of them. Okay, so we'll take the next question here. And azathioprine again is a second line drug also that can be used in autoimmune condition like rheumatoid arthritis. That was also one of the question in 2021, which is second line drug for rheumatoid arthritis, azathioprine. Okay, a 45-year-old woman with hypertension is taking diuretic for fluid management. She complains of muscle cramp, and muscle cramp could be a feature of electrolyte imbalance, and numbness in her extremities. Okay, on examination her serum calcium levels are low. As I said, that electrolyte imbalance, so calcium levels are low. I think this is a very important indicator of what the examiner is asking. Which of the diuretics is most likely responsible for hypocalcemia? So I think you all know, guys, that I used to say that loop diuretics that we have, loop diuretics, it usually causes loss of calcium. It causes loss of calcium, and because of this there can be hypocalcemia. They will be promoting calcium excretion, and because of this hypocalcemia as a side effect, please remember, they are usually contraindicated in already existing hypocalcemia patient. They are also contraindicated in renal stone patient, in patient with the pre-existing renal stone. In those patients also these are going to be contraindicated. Contraindicated hypocalcemia, also contraindicated in patient with the renal stone. So which is the only loop diuretic in the option that we know is furosemide is the only one. What is the site of action of loop diuretic? That is another question that they can ask. It is mainly acting at the thick ascending limb of loop of Henle. Thick ascending limb of loop of Henle by mainly inhibiting sodium NaK2Cl, sodium potassium 2 chloride co-transporter, NaK2Cl co-transporter को inhibit करके they will be working. Other option like hydrochlorothiazide, they are thiazide diuretics. Spironolactone, they are potassium sparing diuretic. Triamterene is also one of the potassium sparing diuretic, है ना. So spironolactone, if you see, they are the aldosterone receptor antagonists. They are also acting at the collecting duct. They can cause hyperkalemia. Triamterene, it is one of the epithelial sodium channel blocker. They are also potassium sparing diuretic. They can also cause hyperkalemia. But if you are going to see which can decrease the calcium level, that will be only loop diuretic. And thiazide diuretics, please remember, thiazide diuretics that we know, thiazides always and always increase the calcium level. They inhibit the loss of calcium. They inhibit the loss of calcium. The site of action of thiazide, it's the early part of DCT. This is another question. So all these are important question. By inhibiting NaCl co-transporter, NaCl co-transporter at the early part of DCT. Okay, and because they are increasing the calcium level, remember, they can be used in hypocalcemia patient. I mean, if there is a hypocalcemia, there is no such contraindication, Remember, I am not telling that you solely get dependent on this. No, these are very slow acting diuretic. You cannot get dependent for the treatment of hypocalcemia just because they are slowly increasing the calcium level. They are used. They are safer in hypocalcemia. There is no such contraindication. And apart from that, they can also be considered as a preferred diuretic in a renal stone patient, in patient with the renal stone. So in upcoming examination, you can expect this question: which diuretic will be preferred in already known patient of renal stone? Alright. So thiazide diuretic is the one. What is the site of action? In fact, the site of action has also been asked in the 2023 FMGE examination, early part of DCT. They have given an image of the nephron and they put the arrow at the DCT and they ask which diuretic will be working here. So again, this question is done here. Next one, a new drug is being developed to treat rare disease. What are the drugs that are used to treat rare disease? The drugs that are treating rare disease are known as orphan drugs. Okay, now read the question further. The drug has been shown to be safe in animals. Alright, so that means preclinical trial has been done. Preclinical trial has been done and is now being tested on humans. So if they are going to do the human trial, we will be now doing clinical trial. Right, preclinical trial pass ho gaya, so now we will be doing clinical trial. Which phase of clinical trial will be done? Very simple. Clinical trial you will be always starting from phase 1, then you will be going to phase 2, then you will be going to phase 3. Once the phase 3 is done, then you will be writing the next application and we call this one as a NDA, new drug application. And once it is passed, then you will be getting the permission to launch the drug and you will be getting the permission to market. Getting the permission to market and launch the drug. And in this one, after this one only, you can do the phase 4 of the clinical trial, that is post-marketing surveillance. Alright. So very simple, we will be starting from phase 1 only. Clinical trial always is started from phase 1. So phase 1 is the correct answer. Right. Always remember what is the aim of the phase 1? To determine the safety, or to also assess the maximum tolerable dose of agent, maximum tolerable dose. You are going to do this one in normal healthy volunteers. Normal healthy volunteers. How many healthy volunteers will be required? Somewhere around 25 to 100. So you can remember like this, in phase 1 we will be needing around 100, around 100. So phase 1 100. Phase 2 may patients will be enrolled for the very first time. In phase 2 you are going to enroll the patients. So for the very first time, when are you going to enroll the patient? The answer to this question is going to be phase 2. Phase 3 is very much similar to phase 2 with the more number of patients. So again, phase 3 mein number of patient will increase. So that will be somewhere around 1000 to 5000. Here it will be around 200 to 400. Here it will be around 1000 to 5000. So average number you can take out in between that. Around in phase 3 you will be taking around 3000 people. So let me just repeat again. 1 may around 100, 2 may 200 to 400, 3 may 3000 and 4 may there is no limit on the sample size. 4 is also known as your post-marketing surveillance. Which phase is post-marketing surveillance? Phase 4 is also known as your PMS. What is PMS? Post-marketing surveillance. Okay. So NEET PG has already asked this question. NDA. When will you apply for NDA? New drug application, or when will you write the application of new drug? So after phase 3. But here it is asking what will you do after PCT, that is preclinical trial. So after preclinical trial, remember one more application that we write, and this time the application is known as your IND. What is IND? IND stand for your investigational new drug application. Investigational new drug application. So this time they can even ask in your examination, because they have already asked NDA, that IND will be written when? After preclinical trial, right? So a preclinical trial is usually done in animals, no? It is usually done in the animals. And clinical trial, it is all done on the human. Initial, that is phase 1 clinical trial, we are going to do in the normal healthy volunteers. 2 and 3 will be doing in the patients, alright? So quick summary of the most of the questions of the clinical trial we have covered here. Terbinafine is an antifungal medication commonly used for the treatment of dermatophytic infection. In fact, terbinafine is the drug of choice for dermatophytosis. Drug of choice for dermatophytosis, including onychomycosis. Because onychomycosis is a type of dermatophytosis only. Including onychomycosis, the drug of choice it is going to be terbinafine. Right, it's an antifungal drug, fungicidal drug that is acting by squalene epoxidase. It is one of the squalene epoxidase inhibitor. right? So saying what is the correct mechanism of action, the answer it is going to be squalene epoxidase inhibitor. Now always remember guys, few important thing, that if you see option C, that inhibition of ergosterol synthesis, this could also be one of the correct answer. But if it is asked that terbinafine is what, or what is the mechanism of terbinafine? Antifungal drug, antibacterial drug, antiviral drug, and antiretroviral drug. Then your answer in that case scenario will be antifungal. How terbinafine is working, or what is terbinafine? It's an antifungal drug. But specifically if it is asked that how is it going to work, what is the correct mechanism of action of terbinafine? So correct mechanism of action of terbinafine will be squalene epoxidase. Now what will happen if you inhibit squalene epoxidase? Ultimately the fungal cell membrane that is made of ergosterol synthesis will be compromised, right? So saying ergosterol synthesis inhibitor, that can be correct, but that is a very broad term, because there are many other drugs that can target ergosterol, right? Azoles, ketoconazole, itraconazole, and luliconazole, all the azoles, they are inhibiting ergosterol synthesis. But a specific mechanism of action of terbinafine, if you see, it will be squalene epoxidase, right? So if you see, we are having the substrate, like they will be taking substrate like squalene, this squalene with the help of enzyme squalene epoxidase, right? Squalene epoxidase. They will be utilizing a couple of more enzyme actually, and that is C14 alpha demethylase. I am just skipping a couple of steps here. C14 alpha demethylase, and ultimately they will be leading to formation of ergosterol. Okay, this ergosterol that is formed, this is the main constituent of the fungal cell membrane, and ergosterol, it is forming the fungal cell membrane. Now there are different drugs that are going to work. One is squalene epoxidase inhibitor. This is going to be drugs like your terbinafine. One of the conjugate of the terbinafine is known as your naphthefene. C14 alpha demethylase inhibitor. This will be by all the azoles, and all the azoles like ketoconazole, itraconazole, right? All the azoles, jitne bhi jiske naam mein azole aaye, like fluconazole. This is itraconazole actually. Itraconazole, fluconazole, voriconazole, all of them. Then if there is already a mature ergosterol formation, you can also have some drug that is targeting here. This drug will be binding again, and after binding here, they will be creating a pore in the ergosterol membrane, and that will be causing leakage of this intracellular content of the fungus, and that will be causing side effect. And the drug that can directly target this area, right, this is going to be none other than your amphotericin B. So see, three different drugs are involved at the level of ergosterol, and out of them squalene epoxidase inhibitor specifically, it is going to be a terbinafine. So I hope that saying ergosterol inhibitor is a very broad term, but a specific mechanism of action, if you have to choose between B and C, I would go ahead with the B. C is a very broad term. Inhibition of beta-1,3 glucose synthesis, this is the beta-1,3 glucan, they are involved mainly in the fungal cell wall synthesis, fungal cell wall synthesis, and we call this drug as a fungal cell wall inhibitor, So what are the drugs that we have under the fungal cell wall inhibitor? We have many drugs that are coming under the fungal cell wall inhibitor, like caspofungin, micafungin, anidulafungin. These are the fungal cell wall inhibitor. They are acting by inhibiting beta-1,3 glucan synthase, right? Inhibition of DNA topoisomerase, no, right? They are not in, the terbinafine is not inhibiting DNA topoisomerase. So correct answer for this question, it is going to be squalene epoxidase. However, DNA and RNA inhibitor in the antifungal drug, it is going to be 5-flucytosine. So you can even see, examiner can ask you which of the following is a simple DNA and RNA inhibitor in antifungal drug, that is 5-flucytosine. That's one of the pyrimidine analog. Okay, right. So this will be the last question that we have for pharmacology. So we have around 14 questions quickly if you want. In 1 minute, in the last 1 minute, I can quickly take you through all these questions. So question number 1, what is the mechanism of action of terbinafine if you see? I mean, this is the last question. This is going to be squalene epoxidase inhibitor. It's a fungicidal drug of choice for dermatophytosis, including onychomycosis as well. Then examiner is asking after preclinical trial, which phase? So phase 1 will be done, followed by phase 2, phase 3. Whole summary of these phases I have already given to all of you guys. Then examiner asks which drug among diuretics is causing hypocalcemia. So loop diuretics always and always causes loss of calcium. So loop diuretic, the only loop diuretics in the option, it is your furosemide. There are other like torsemide and all, they are also loop diuretics, right? Site of action of both these diuretics I have summarized, and here about thiazide also I have given you few important pointers, right? Then remember among drugs that are used in the inflammatory bowel disease, which one is more hepatotoxic? The answer to this question is azathioprine, that is one of the purine analog. Right. Then next that we are having is drugs causing flagellated dermatitis, bleomycin, because of the enzyme hydrolase which is absent in the skin. We are having Cushingoid appearance caused by steroid. Then we have one drug that is used to increase the neutrophil, so filgrastim, granulocyte stimulant. We also have the simple concept of half-life. So if a drug is in 8 milligram, for you to bring in 1 milligram range, how many half-life will be required? So 8 will become 4, 4 will become 2, 2 will become 1. So 8 say 4, 4 say 2, 2 7. So we are needing 3 half-life, and in 3 half-life we will be needing around 40, 40, 40, 120. So the simple calculation was there. Long-acting bronchodilator, formoterol is the only one. It's the only agent that can be utilized in acute attack and also in the prophylactic condition as well. Then isoniazid usage leading to what kind of side effects? So peripheral neuropathy, pyridoxine will always be added. Next is enzyme-inducing drug. They will always be causing treatment failure. They can increase the risk of bleeding as well. So vitamin K is always and always advised here, not other drugs in the given option. Then atropine usage can also lead to atropine toxicity, atropine fever, and I have also taught you here how to differentiate between atropine and organophosphate. What is the different antidote for both of them? Both of them I have given you already. Safer drug in hypertension, I have told you already. Lady Harding Medical College, always safe. Labetalol, hydrolazine, alpha methyl dopa, calcium channel blocker like dipines, and cardioselective beta blocker, they are safe. Drug of choice for hypertension, pregnancy, it is none other than labetalol. Is a third generation beta blocker, beta plus alpha 1 blocking property. Then what is avoided? Avoid DNB colleges. So ACE inhibitor, ARB, diuretics, nitroprusside, non-DHP sign, beta blocker, non-selective beta blocker are always contraindicated, right? So this was the first question, and this will be everything about our Pharma GT in the FMGE examination. Thank you very much for all of you guys for your presence and attendance. I'll see you guys in the upcoming class.
So hi, I hope you enjoyed this session of FMGE mock exam. So I'm Dr. Saurabh Dikshit, and I'm going to discuss the solutions in a brief way. Already you will get the detailed description with every question and the solution, everything. But I'll just have a quick overview of the today's paper. So let us see these options and let us read the questions. So when we talk about the first question, we can see a nipple and erythematous lesion around that nipple. Without reading the question, I know that this is something to do with mastitis. On ultrasound, you can see there is a purulent collection also. So there is a purulent collection. So this is a question related to breast abscess. Students, this is how you actually use your knowledge, use your, you can say, improvisation of the question, and this helps you to save some time. So now when you read the question, you know the answer also. A 25-year-old lactating patient presents to you with breast abscess. On ultrasound, there is a collection also. What is the next line? So the treatment of choice for them, answer is not incision and drainage. Remember, incision and drainage is not the first line option for any breast abscess. Breast is organ of cosmesis. You are not allowed to destroy the cosmesis. So the first line is, it's USG guided aspiration. Remember, once it fails, you do re-aspiration. When it fails again, multiple failed aspirations, or if the overlying skin would have blackened, then I would have gone for incision and drainage. Why? Because if there is overlying blackening of the skin, this initiates the necrosis, and necrosis means that the skin will heal with fibrosis only. So here you cannot avoid scar. That is why in that case also you will go for incision and drainage. So what is the answer here? Incision and drainage, suction revised drainage. So students, it's that USG guided drainages, they have just changed the variant of the option. So it's B, which is the answer. So B is the correct answer here. Let us go to the next question. If you see this patient, let us see there are there is an image given where you have nodules over the lip, nodules over the tongue, and let us see the other information that can be grasped. So from the image only these things can be grasped. Patient walks into the OPD with enlarged lips and nodules over the lip, tongue and eyes. Let us see more. He had a swelling in front of the neck, moving with deglutition with the lymph nodes. So this could be a thyroid swelling. So nodules, thyroid swelling, and this thyroid swelling is present with something like lymph nodes. Yeah, and this is moving with deglutition. That is why I am saying. So his mother also had the same, you can say, condition. So this is something which is showing you a familial angle. So familial thyroid related swelling with nodules. So where are you thinking? You are thinking on pretext of a MEN syndrome, maybe a MEN 2. Let us see more important things. Now she also had palpitations which were resolved by bilateral adrenalectomy. So what is the classical triad of a pheochromocytoma? Palpitations, diaphoresis, and headache. This is what is a classical triad that raises the suspicion of pheochromocytoma. And the boy underwent total thyroidectomy. So why was total thyroidectomy done? This was done because there was MTC diagnosed. So which of the following tests should be done for the following patients? So in that cases you need to rule out the pheo. So yes, plasma metanephrine. Since this is a case of MTC, so you should also go for calcitonin, and CEA is a marker for prognosis. So CEA level more than 1000 international units per liter, that is actually a poor prognostic indicator in MTC. So option C is the right thing. So if you see option B and C, they are too close, but here again you need to rule out the pheo also. That is what is making it very important. If you see the option A, there is no utility of plasma aldosterone because this is not aldosteronoma. And when you talk about option D, it's only evaluating the plasma metanephrines. So when you talk about plasma metanephrines versus urine metanephrines, many of you must be thinking, why not urine? Students, if you are evaluating something in urine, you need to maintain, you can say there's a checklist that you don't have to take these drugs for next, you can say 1 week, and then you have to collect all the urine in the jar and then you have to send it. So when you are expecting something to be present in the plasma, it has to be there first in the plasma. So plasma is not having a very high positive predictive value, but it is having a high negative predictive value. So in a patient of pheo, if plasma metanephrine is positive, then we go for confirmation with urine. If plasma is negative, then pheo is ruled out at very first step, and that is why C is actually the best option amongst the other provided here. Next is a patient with dysphagia and anorexia. For 6 weeks underwent an endoscopy. A tumor was found at the level of GE junction. So this is a tumor in relation with the GE junction. So we are talking about nothing but the Sievert's classification. Now when we talk about Sievert's, now it's very simple. Taking the GE junction as the midline, 5 centimeter above it, 5 centimeter below it, this is the zone that we include. So plus 1 centimeter to 5 centimeter, this is zone 1. Then we have zone 2 and then we have zone 3. Zone 3 is cardia. Zone 2 is actually the G junction and zone 1 is the lower esophagus. So here the tumor is asked. So what is the class of the tumor where we are actually talking about? So it's Sievert's 1 because they are asking X. So the tumor in the X is the lower esophagus, and that is what is Sievert's 1. It's very important. It's a very simple, straightforward question. Also discussing how we manage these patients. So Sievert's 1. They are treated with esophagectomy. Sievert's 3, they are treated with gastrectomy. When you talk about Sievert's 2, now here the query is what to do, because Sievert's 2 is this zone. Yeah. So here you will see the pattern. If the growth is towards the esophagus, then you do esophagectomy. If the growth is towards the stomach, then you do gastrectomy. So this is what is very important. Next is, let us see a very simple question. This is a very day-to-day scenario that we get in hospitals. So a patient with coin ingestion or a foreign body ingestion. So this is a foreign body ingestion, and this foreign body is located at the level of what, students? Esophagus. Now whenever the patient is having a foreign body, then the next thing is you need to see whether the patient is having any symptoms or no. So the patient is having no symptoms, no respiratory distress. So if the symptoms are not there, then you need to go for observation, and this is for 24 hours. After 24 hours, repeat the X-ray. If the body passes down, then you will have to wait and watch. If it doesn't, then you will have to go for endoscopy. So if the obstruction or if the, you can say, location is not relieved, so it's not changed, then you will go for endoscopic removal. So upper GI endoscopy plus removal. Now if it is cleared, so if it is cleared, then again observation. If the symptoms are there, again you will go for upper GI endoscopy. This is what is the classical rule that we follow. Students, if anything manages to cause the upper esophageal, you can say cricoesophageal sphincter or upper esophageal sphincter, that will cause majority of the sphincters, because upper esophageal sphincter is the narrowest part of your body. So when we see the options, how will you manage this? So right now we will be going for wait and watch for 24 hours. If this doesn't help, then we will go for endoscopic removal. The next question we have is, a patient presents to you with dysphagia, cough and foul breath. And if you see this, can you see something like an outpouching? So 65-year-old age with a classical presentation of intermittent dysphagia, halitosis. This is what is a Zenker's diverticulum. So what is a Zenker's diverticulum? Between the oblique muscles of thyropharyngeus and horizontal muscles of cricopharyngeus, you only have one thing. What is that? There is mucosa and submucosa here. So when there is mucosa and submucosa, this is going to pouch out or bulge out, and that is where we actually get to see a diverticulum. So is this a true diverticulum? No, this is a pseudo diverticulum. It develops with increasing pressure, and that is why it is known as pulsion. So the first option, that it's a pulsion type of diverticulum, yes, it's true. Do you know the mid-bronchial or mid-esophageal or parabronchial diverticula? That's a true or a traction type. Traction, that is, it is pulling, something is pulling it out. And what is that? It may be a lymph node, it may be a Gons focus, it may be an inflammatory site, so anything. So that's a traction type. Traction is true, pulsion is pseudo. Occurs between the oblique fibers of thyro and horizontal fibers of cricopharyngeus, I have already told you. It's the most common esophageal diverticula. Yes, it's a very common esophageal diverticula. Dolman's procedure is an open repair. No, it's an endoscopic. It's an endoscopic diverticuloplasty. Basically, we say endoscopic diverticulectomy. So here what you are doing, you are just fusing the diverticula with the esophagus, with the esophageal wall, by passing a specially designed mountable endo-GI stapler. So what we do, the stapler goes like this and then it will fuse this wall. So it's just like the diverticuloesophago anastomosis or stomy. This is what is. That is why we say actually it's not a endoscopic diverticulectomy, it's a endoscopic diverticulostomy with the esophageal wall. Anyways, but it is done for the patients who are having 3 to 5 centimeter defect, and it's an endoscopic procedure. So option D is wrong. It's not an open procedure. Next is, a patient visited the OPD department with the following symptoms. Now what are they? Increased fatigue over a 6 months phase, recent development of itching or pruritus. Okay, so you are talking about now fatigue with pruritus. So we can say that pruritus might be a symptom associated with obstructive jaundice. Let us see more thing. And this is not instantaneous, it's over the time of 6-8 months. So we are dealing with something inflammatory in this case. The patient also had a medical history of ulcerative colitis. So now it is clear, obstructive jaundice, then fatigue with a history of you can say ulcerative colitis. So you are actually inclined towards primary sclerosing cholangitis. This is what is very important. Middle-aged males are involved in this, and there will be focal dilatation of biliary tree. ERCP is the tool that we use. Why? Because not only is diagnostic, it is also therapeutic. Rather than MRCP, ERCP is preferred. So the first option, MRCP, is the gold standard. No, it's ERCP better. MRCP shows multiple segmental structures. Since for obstructive jaundice, the first line investigation is, you can say, MRCP. That is why if you do go for MRCP, you will say strictures with focal dilatation. Now, why in this case I would not say MRCP? Because here you have an inclination towards primary sclerosing cholangitis. Had it been only an obstructive jaundice with the similar profile of things detected on ultrasound like biliary trees dilated, I would have gone for MRCP first, because the most probable cause may be a stricture or maybe a stone. So there MRCP would have been the choice. But when you know that it's a primary sclerosing cholangitis, I would favor more towards ERCP. More common in middle-aged males, true. Antimicrobial antibodies may be positive, may not be positive. So majority of them are ANCA negative also. Some of them are ANCA positive also. So yes, option A is the best answer to be ruled out here. Let us see the next question. This is a very simple question, that is on SEEP. So when you talk about in C stands for the clinical, C1 stands for reticular veins or telangiectasias, C2 stands for varicose veins, and C3 stands for edema. C4 stands for the skin changes, that includes, you can say, pigmentation, yeah. Then you can have lipodermatosclerosis. C5 is a healed ulcer, and C6 is a non-healing ulcer. So if you see in this case, it's obviously C6. Now you have two options, B and D. So it could be A if it is asymptomatic, it could be S if it is symptomatic, and if it is recurrent, then we add R also. So let us read it. So he also gave a history of untreated varicose vein with pigmentation involving the lower limb. The patient was previously diagnosed with a similar ulcer which healed actually. So now this is the recurrent ulcer, so it is C6R. This is a very simple question to be understood. Let us go to the next question and understand it. A 56-year-old male presented to OPD with swelling of the left lower limb for the past 2 years. So it's a unilateral swelling. Let us take out all the information. Swelling reduces significantly when he wakes up in the morning. Why? Because the blood flow when you are sleeping to the limb is reduced, and then the dependency, or you can say in the dependent portion there is more pooling of the blood. So obviously it's good. Now we can understand that it's probably a vascular, you can say, inclination now that is being, you can say, taken out from this. So it may be a venous defect. Let us see as the question progresses. Now this worsens progressively throughout the day as the patient is standing. Now there will be more pooling. So now it is more going in favor of venous insufficiencies. He has no significant medical problems except hypertension, for which he is taking atenolol. Right now BP is also controlled, pulse is also in control, respiration and JVP, CVP is normal. So cardiac causes might come into play, but actually if you see everything is normal, CVP is also normal. The lungs are clear on auscultation, no murmurs, there is no hepatosplenomegaly. If we talk about the cardiac causes, there will be some cardiac symptoms, and along with that bilateral limb edema is very common. Doppler examination of leg shows no evidence of thrombosis. So now what are you thinking that it could be? It's a chronic venous insufficiency, which is actually the valvular or venous valve incompetency, which is the most frequently seen cause. Now lymphatic obstruction, there is no you can say precedent or antecedent history describing the typical presentation of a tree trunk limb, the skin changes, the, you can say, stemmer sign. There is nothing like squaring of toes, everything is fine. And in lymphatic obstruction, the swelling will not decrease on sleeping and will increase progressively as the day passes. So there is no such changes. Decreased liver protein synthesis, liver hepatosplenomegaly is not there, point number 1. Second is there is no generalized anasarco or edema also in this patient. So option C is not only the best, it's actually the answer. Now 35-year-old male presents with a history of severe pain and ulcer in the lower extremity. Pain and ulcer in the lower extremities, especially in the toes and the foot. Now we are now again inclined towards a peripheral arterial disease like profile. Pain worsens on exposure to cold temperatures. He has a long history of heavy smoking. Now we understand that it is atherosclerosis. Now diminished distal pulses in the affected limb. So this is a case of peripheral arterial disease. Now you must be thinking it could be Berger's disease. Yeah, it may be. Let us see. Because the age profile. Which of the following is the diagnostic test most appropriate to confirm? Try to understand now here. It is angiography versus Doppler. A versus C. Now try to understand angiography is an invasive procedure. Doppler is a readily available, fairly good sensitivity, specificity, and that is why C is better answer than A here. If you get anything suspicious and you are now planning for an intervention, so for just confirmation, C is more than enough. For intervention, you need to study the status of the skip lesions, and there you need to go for the angiography. So if skip lesions are there, you will not be able to do the bypass, and that is why the angiography is reserved for a later, you can say, stage evaluation. C is the most or the best appropriate investigation that we can do for Berger's. Of course, you will have an angiographic evaluation also. So there we go for CT angiography, not a traditional angiography. Let us see the suture, a grey colored suture. My favorite, it's a PDS and it's a synthetic suture. Yes, it's a synthetic polydiaxon suture. 180 days, it gets absorbed. It's a monofilament suture. It's a suture of choice for the abdominal closure and also for gut anastomosis for surgeons like me. So it's a synthetic absorbable suture. Yes, it's a polyfilament suture. No, it's a monofilament. this is what is very important, dissolves in 180 days and they are inert, and that is why they don't cause any suture site granuloma, because they get absorbed also over the time. So option B is incorrect in this case. The next question, 65-year-old male with hypertension and coronary artery disease presents to ER department with chest pain, shortness of breath and altered mental status. Let us see, the patient might be in some shock. Assessment shows hypotension. Now this time the patient is having decreased cardiac output, tachycardia, obviously the reflex, elevated CVP. So elevated CVP and decreased cardiogenic, you can say decreased cardiac output. This means that the heart is not pumping the blood properly. The question finishes here. It's a case of cardiogenic shock. Let us read the last line. Which of the following is the most likely responsible? And there are now ECG changes because the heart is not pumping the blood properly. So hypovolemic shock, you will have hypotension but not elevated CVP. This is what very important. Same way, septic shock, no, you can say no question of elevated CVP. Same way, neurogenic shock. So these are very important ways to diagnose and clinically rule out the different types of differential diagnosis that can be generated. 43-year-old electrician has an electrocution, shows this image. Now what are the things? High voltage more than 1000 volts are high voltage, less than 1000 volts are low voltage. Low voltage alternating current causes the spasm or the tetany, and that is why many a times you might not be able to, you can say, because of that tetany, you people think that okay, if there is current you should remove the hand, but many a times that gets tetanic and it gets locked, spasm is there, and that is why the people are not able to leave the, you can say, the structure from where they are getting the current. So this is also very important. Flash burn is a burn with combustible fluids, and flash burn is also one burn which is considered with electrocution. It's always the flash, that's a high voltage, you can say thunder strike type. So that's always a high voltage injury, not a low voltage injury. So this is false. And compartment syndrome can develop in the foot or hand because of any inflammatory exudate in a compartment where the expansion is not possible. Thus, there will be increase in or rise in pressure, and gangrene or necrosis will supervene. So option C is not correct in this case. Which of the following is not true about Fisher Nano? You know, in Fisher Nano, what is done? Sitz bath. Sitz bath is, you can say, the heat mediated relief of the pain is there. Second is calcium channel blocker. They are chemical, this is chemical sphincterotomy. So they reduce the tone. So this is what is referred as chemical sphincterotomy. High fiber diet, and this is to avoid constipation. This is what is very important. Along with that, laxative. But remember, examination is not done. The moment you do, you actually tear off the already increased toned anal orifice, and it might generate excruciating pain to an extent that patient might have a syncopal attack also. So proctoscopic or any form of anal examination is not done in case of digital manipulation is not done, or mechanical manipulation is not done in case of Fisher Nano. You do only do an inspection, and then based on that you just see and make the diagnosis. Next is a 20-year-old male patient presents to ER with sudden onset dyspnea, chest pain, decreased breath sounds on right side. Dyspnea, chest pain, decreased breath sounds. So let us see. He appears visibly distressed and tachypneic on physical examination, decreased chest wall movements also, and hyperresonance. So there is more accumulation of air in between the pleura and the chest wall and whatever is it. So this is profile favoring what students? A pneumothorax. Let us see, a diagnosis of pneumothorax has already been suspected. Which of the following is not correct? So needle decompression is needed. Why decompression is needed? Because the air is getting entrapped in this cavity, that is pleural cavity. So when you put a needle, this is just like a busting a balloon. So when you put a needle, the extra air comes out, the inner pleura actually relaxes, and the lung which was collapsed now again gets some volume. So this is again a time buying procedure. So this is absolutely right. The tension pneumothorax, what is the tension generated? So the expanding lung will always compress the heart, and this is going to generate the hypotension. So what is the tension pneumothorax? Tension pneumothorax is any pneumothorax where the simple pneumothorax is compounded along with cardiogenic shock. So this compression on the heart which impedes the cardiac functioning, and this is what is very important. So if compressive cardiogenic shock is not seen, it is not a tension pneumothorax. In the later stages, you might get obstructive cardiogenic shock also. You can go to my lectures, I have discussed this a lot of times and see there. Now, tension pneumothorax doesn't require any radiological confirmation to intervene. This is what is very important, because this might be a life-saving maneuver. And many a times wasting your time in radiological assessment, you might lose the patient. So this is also right, this is also right. The diagnosis is not confirmed with FAST. It is, if it would have been E-FAST, I would have said, okay, bedside evaluation of the thorax is also done for pneumo and hemothorax in E-FAST, but not the FAST. Definite management is connection of the tube with a water seal. Underwater seal, this is what is the definite. So via triangle of safety at the 5th intercostal space, you do this. So C is not right in this case. Now 35-year-old male presents with ER department after head injury. He lost the consciousness, then he regained it, and then developed progressive decline. So I have already told you that this is a stage of concussion, and then you have recovery from this concussion, and now the hematoma is expanding, so you have complications. So what are you dealing with? You are dealing with EDH, which has 3 stages, and this is what is known as lucid interval, the stage of normal neurological behavior or no neurological deficiency or defects in between the 2 stages of loss of consciousness. So which of the following shows this? So if you see, this is EDH, the classical idli or a biconvex. This is SDH. Yeah, this is SDH. Then this is intraparenchymal hemorrhages that you are seeing in this. So it is A which is reflecting the scenario which has been described here. Let us talk about the next question. 52-year-old female undergoes MRM. Now this is what is very important. What is MRM? Removal of breast, and along with that axillary lymph nodal dissection. 1 week later, she presents with a bulging fluctuant mass at the surgical site. What is that? When you do the plucking of the axillary lymph nodes, so when you do this plucking, you actually damage the lymphatics. So when you damage the lymphatics, there will be oozing of the serous fluid, and you like it or you don't like it, there will be a seroma. This is what is very important. Now if you see the ultrasound, this is a clear fluid, and this is indicative of a seroma. It's not an abscess. So I will not even read the question further. So on ultrasound, the following image is given. What is the most likely diagnosis? It's a seroma. Are you getting? This is what is very important. SSI with an abscess will have the clinical presentation of the features of SIRS also, along with that, with red inflamed tender skin, but this is not. Mass is non-tender. This is one very important thing. So this is seroma. Now in later stages, this will be followed with, in later stages, maybe after months, so there will be lymphedema because of the lymphatic obstruction. So it's a very simple question. Students, if you have the concepts, it hardly takes 10 seconds to solve a question. Now this question seems to be very big. Let us see. A 45-year-old patient presents with a painless palpable nodule in the neck. FNAC was done. The histopath shows samoma body. So you are dealing with papillary. So now you are dealing with papillary C, and let me read the last line. Which of the following is not correct with respect to this? Patient has undergone total thyroidectomy with central leg dissection, and post-operative patient develops recurrent laryngeal nerve injury, which is a very frequent complication. So let us see. Radioactive ablation is not indicated in the management of cancer. None of the cancers are managed with this radioactive ablation. Remember, post-total thyroidectomy, we do a scan to rule out any residual, or you can say recurrent mass. In that case, you might go for radioactive ablation, but it's not a primary therapy. Post-operative recurrent laryngeal injury is a common complication. This is true. The most common site for distant metastasis is bone. No, students, it's lung in case of papillary. Next is total thyroidectomy with central compartment dissection is always done. Now this is absolutely wrong, because neck dissection is not done routinely. Let me tell you, point number 1. If Delphian lymph nodes are present, yes, it is done. The second is, there are certain cases where you can also do a partial thyroidectomy. Partial thyroidectomy, that is a case of micro or occult. Students, if you see, the option A is also correct. Option C is also correct in this case. Now here you have to understand that when you're talking about the nerve injuries, it is recurrent laryngeal nerve also which is often injured, or it is external branch of superior laryngeal nerve also, which is very commonly injured. So seeing the options, now these kinds of questions are always creating some controversy. So total thyroidectomy with central compartment dissection is not always the management. It is either total plus minus central compartment plus minus MRND, or it may be total thyroidectomy only. It may be partial in case of micro or occult, or some cases, some literature says less than 2 centimeter no risk of history, no history of radiation or no risk of radiation exposure with low family profile, yes, you can go for hemi also. So here I would say A and C both are correct. If I would have to choose one in this case, I would have chosen C is better. So students, you don't have to argue that okay sir, A is wrong or no, both are right. But C is relatively better option in this case. This is again, this was a PYQ which was asked in exam. A 55-year-old male presents with bothersome lower urinary tract infection symptoms. So this is LUTS. Now, these are the symptoms of LUTS: increased frequency, urgency and weak stream. On distal examination, a smooth, symmetrical and large prostate. So you are talking now in context with BPH. So LUTS with these features is BPH. Which of the following, his uroflowmetry has already suggested, which of the following is to be considered transurethral dissection of the prostate, or maybe you can talk about the lasers. But the prostatectomy is not the option for this. So you need to just create the space, you need to ablate the adenoma which has been created in the gland. So that is done, not prostatectomy. So TURP is the best answer here. Now, which of the following is not true about the most common congenital anomaly of the urethra? So when we are talking about the congenital normal anomaly of the urethra, it is hypospadiasis. What is hypospadiasis? Yesterday only I saw this patient in OPD and luckily their question is there. So you can talk about the meatus not present at the tip, rather it is opening on the ventral surface. So opening of the meatus on the ventral surface, there will be fibrosis of this and thus it results in a chordae or a ventral curvature. So this is a dorsal penile curvature. This is not true. It's a ventral curvature. Simple clinical examination with a chordae with a hooded skin, because the profuse is not complete. So hooded profuse, the snake like. Now, disorders of sexual development should be ruled out because many a times it is because of androgen receptor blocker or deficiency of androgens, which might result in incomplete tubularization of the urethral plate, and that is why this might cause a premature fusion and underlying, or you can say an opening of the urethral meatus on the under surface of the ventral part of the penis. This is what is important. Surgery should be done by 18 months. This is not always mandatory, but yes, chordae correction is important. Chordae correction. So first we do orthoplasty and then granuloplasty. Next is, what is the sequence in which we do the Whipple's anastomosis? So this is the pancreas that we have. Now this is the liver with the common hepatic duct, and now this is the stomach that you have done a distal gastrectomy, or maybe you have done a pylorus preserving Whipple's. Now this is the jejunum that we have. So you bring the jejunum and you bring it like this. So this is how you bring the loop of jejunum. The first anastomosis that you do is PJ, then you do is HJ, and then you do a GJ. So PJ, you may be doing a Duncan anastomosis or duct to mucosa, whatever you type, like, then HJ and then GJ. So let us see PJ, HJ and GJ. So D is the right option in this case. Next is, let us see this image, and it's a barium showing you a typical bird beak appearance. So bird beak appearance with no filling defect, smooth things, it's a diagnosis of achalasia. I will not read even the question. No filling defects. 35-year-old male presents with dysphagia more to liquids than solid, more in favor. Regurgitation of undigested food and occasional chest pain. A barium was done, which is not a true. So due to loss of inhibitory ganglions, yes, in both Meissner's and Meintrick plexus. So Meissner's also and Meintrick plexus, where Meintrick plexus are more important, and along with that you need to have dysfunctional nitric oxide synthetase, and that is why nitric oxide synthetase will not cause relaxation of LES. Dolman's procedure is for Zenker's diverticulum. LES fails to relax. This is what is actually the true thing that happens. So aperistalsis plus failure of LES to relax. This is how the diagnosis is made, and along with that, low amplitude waveforms. Indication, infection with Trypanosoma cruzi is associated, not the Trypanosoma brucei. So here the option C is one of the best options. It's far better than option A. Which of the following statement is false? Herniotomy is the treatment for congenital hydrocele. Yes, congenital hydrocele, the herniotomy, and along with that, if you are doing a laparoscopic repair, you can go for repair of the deep ring. Most common cause of failure of herniorrhaphy is the increased tension repair. That is why we say tension free repairs. The repairs are never done in tension. Surgery of choice for inguinal hernia is Lichtenstein tension-free mesh repair. Yes, you can say this, or you can also go for TAPP or TEP now. Laparoscopy is also. So nowadays only open is not advocated. Most common nerve injury in open hernia. So when you talk about the nerve, so it is ilioinguinal. It is ilioinguinal nerve which is lying on the posterior wall. And when you are placing the mesh, this is the nerve which can be damaged or impinged here. So it is the ilioinguinal which is often injured, not the iliohypogastric. So D is incorrect here. Next is when we talk about a patient. Now if you see, I could see one word, that is it's a congenital diaphragmatic hernia, and when you see the X-ray on this side, the eventration of the bowel is on the left side. So this is left sided congenital diaphragmatic hernia. I will leave all the things, I will not even read the question. Placement of orogastric tube for decompression, yes, this is true. Endotracheal intubation and mechanical ventilation, true, and this is the best step initially to have a respiratory stabilization. Immediate repair of the surgical defect, immediate is not required. You stabilize the patient and then you plan for. Bag and mask, this is absolutely contraindicated. So what is the most appropriate? B is the most appropriate option of management right now. Let us go to the next question. A patient underwent splenectomy. Let us see which of the following is incorrect with respect to complication associated with post-splenectomy. So post-splenectomy, you have opportunistic post-splenectomy infection where you have pneumococcal, meningococcal, Haemophilus influenzae infections. And yes, let us try to understand which is incorrect. So let us start from option D. Post-splenectomy, there is a transient increase. Yes, you know, if you talk about kids, erythropoiesis is there in spleen. But when you talk about the sieving action of the spleen, that is lost. So yes, there may be a transient increase in RBC, WBC and platelets. So they are not broken down for a long time. Most common complication post-splenectomy is upper lobe atelectasis. Now if you see the location of the spleen, this is how the spleen is located. So if there is splenectomy and if there is a problem, so there is lower lobe atelectasis, not the upper lobe, because many a times during splenectomy inferior phrenic nerve might also be damaged. So it's a lower lobe, left lower lobe in this case, it is not. So C is incorrect. Injury to the tail of the pancreas can lead to pancreatic fistula. Of course, this is very common because it's a duct and duct is constantly producing pancreatic fluid. So this is common. OPSI may be associated with streptococcus. So we know that pneumococcal infections are very common. Any encapsulated bacteria can increase the risk of OPSI. So option C in this case is incorrect. Let us see the another question. 31-year-old with minor pelvic fracture with RTA presented to ER with hematuria. So hematuria with pelvic fracture, there is either problem with bladder or the problem with the urethra. Now the patient was stabilized and following investigation was done. So a delayed image was shared. So when we talk about the pelvic fracture and when we put a contrast, so this is the pelvis and the contrast is confined to pelvis. So confined to pelvis. If you see paracolic gutters, so paracolic gutters, they are absolutely free. So if it is confined to pelvis, contrast is confined to pelvis on voiding cystogram, you can see something which is very important, that it is extraperitoneal injury. So you know that bladder is having two surfaces, extraperitoneal, intraperitoneal. This is an extraperitoneal surface injury and you need only urinary Foley's catheterization. So Foley's catheterization for 10 you can say 10 to 12 days is more than enough. So non-obstructive, non-operative management. If it would have been intraperitoneal injury, this urine would cause extravasation into the peritoneal cavity. So the bowel would, you can say the paracolic gutters are all failed. It's not only confined to the pelvis, it may be going up. The next is it will risk the formation of chemical peritonitis and superimposed bacterial peritonitis. Their surgical importance is there, surgical repair is there. So intraperitoneal injury is surgical repair. Extraperitoneal injury is just collapse the bladder, put a Foley's, it will shrink and there will be granulation over the defect and this is what is done. Next is in a patient undergoing coronary artery bypass graft, what is the classical type? So we use Lima, we use BIMA, left internal memory, or BIMA bilateral, so internal right and left, or you can use the GSV. So it's the autograft, not the allograft. So it's the autograft. One's own veins are harvested and used. In this case, they are preferred more over the, you can say, the synthetic stents. Now again a very simple question. Identify the surgical blade used for incision and drainage, and this is what is a classical stab. So it's a blade number 11. So this is a straightforward gift for you, a bonus question for you. Now next is, what are the sites for gastric ulcers? So you know that type 1 is along the incisura angularis, type 2 is around the duodenum, or it may be into the body. Then type 3 is pre-pyloric. Then type 4 is higher up along the, you can say, lesser curvature, and type 5 can be anywhere since it's acid induced. Amongst them, it's a Daintree-Johnson classification which says that it's the type 1, that is along the incisura angularis, which is the most common. So lesser curvature near the incisura is the right answer for the chronic gastric ulcer. This is important. Now patient underwent surgery for inguinal hernia. Patient comes to your hospital with fever. What is the most important thing? Post surgery, it's a surgical site infection. So it's a surgical site infection which is the most common cause. It's a mesh which is having a foreign body, and it's going to show you a reaction, and that is why the meshes are prone to get infected. So most common cause after infection, after 3 days. Pulmonary embolism or thromboembolism, chest infection, they are more frequent in less than 3 days. Post 3 days, it is the surgical infections which are actually presentable. Now a patient presented with bluish swelling over the floor of the mouth. Now what are you thinking of? You are thinking of either a dermoid cyst, sequestration dermoid cyst, or a ranula. Now what is this? Transillumination. So any floor of the mouth swelling which is transilluminantly illuminated, and along with that it's a bluish cystic swelling. Answer is, it's a ranula. Ranula is the answer. Now then you have a patient with cleft lip, and this is a cleft palate. So it's a cleft lip versus cleft palate. Let us read the last question. At what age it should be constructed? I will not read anything else. Cleft lip should started at 3 to 6 months, and soft palate between 6 to 12 months, and hard palate later. So students, the answer is 3 to 6 and 6 to 12. Why 3 to 6? Because if you don't develop, repair the cleft lip, there will be problem in the phonation, and vocal development will be drastically impaired. So there are a lot of things which will supervene after non-repair. So soft palate 6 months to 12 months, hard palate 12 to 18 months, or 6 months later to the traditional first repair that is done for the soft palate. And cleft lip, it is 3 to 6 months. If you are doing cleft lip and cleft palate together, 3 to 6 months or maybe 4 to 5 months is the mean that we prefer. So best answer here is C in this case. Next is a gentleman presented with recurrent UTI, and this is in his IVU. So can you see a horseshoe kidney? It is a very common renal fusion anomaly. Yes, this is true. Ureter insertion is lower. This is wrong. This is not true. Ureters are anteriorly, pelvis is anterior. So ureter insertion is absolutely normal in this case. These individuals have higher risk of Wilms tumor. Yeah, most of them are asymptomatic. So option B in this case is actually wrong. So students, I hope you enjoyed this session of FMGE mock. I hope you learned something. Do revise these questions or these topics, and we tried to create a very same you can say looking like environment for your exams. And do share the links of the solutions also with your near and dear friends who actually missed it. We are having more, you can say, revision programs running. So we have a recent program which will be conducted in the month of June and July. So do join Alan next, and we will ensure that your journey to this, you can say, crossing this hurdle and becoming a specialist course, you can say, smooth. So I hope you enjoyed this session. Thank you for watching me.
So now we'll be starting with the radiology part of today's grand test. So the first question was a 3-week-old infant underwent sonography. So the keywords I'll highlight, it is an infant. Okay, so we are talking about a very young onset kidney disease. 3-year-old infant underwent ultrasound of the abdomen which revealed a small sized right kidney with the presence of multiple enlarged cysts, and the left kidney was normal. So it is a unilateral disease. Subsequently, he went renal DMSA scan. Now, renal DMSA scan is done for looking at the scars, okay, for looking at renal scars. And what did it show? It showed increased tracer uptake on the left side and minimal uptake on the right side. So it means that the right kidney is non-functional, right? The right kidney is non-functional. So we have a unilateral non-functioning right kidney with multiple cysts within it in a 3-week-old neonate, right? So what will be the answer to this question? So answer here would be a multicystic dysplastic kidney, because it is favoring the age. MCDK is seen in prenatal period as well and in neonates, right? Now autosomal dominant polycystic kidney disease, ARPKD. Now these are usually not non-functional. Usually the kidney has some preserved function, and the difference between these two is the age of onset. So ADPKD is seen in adults and ARPKD is seen in children, right? Now pelviureteric junction obstruction in children is a congenital variety. It is a congenital problem in children, and it has a hydronephrosis. It does not have cysts within it. It has hydronephrosis. So let's look at the various images of these. So the first image here is that of ARPKD. And what do we see here? We see that there are these multiple small cysts scattered throughout the kidney, and the kidney is enlarged. And you see that there is no corticomedullary junction. So what have I said? There is no corticomedullary differentiation. The kidneys are enlarged, and there are multiple tiny cysts. Multiple tiny cysts are there. Okay, and the renal echogenicity is also raised. Renal echogenicity is also raised. It is appearing more bright. So these are features of an ARPKD patient, and these are typically seen in children. Whereas an ADPKD, the second image here is that of an ADPKD, and what do we see here? We see that the bilateral kidneys are enlarged. So the first criteria is bilateral enlarged kidneys. Okay. Now, what else do we see here? We see multiple large cysts, okay, multiple large cysts as compared to tiny cysts in ARPKD. And also we see that there are associated liver cysts, okay. So liver cyst along with bilateral kidney cysts are seen in ADPKD, whereas in ARPKD, usually congenital hepatic fibrosis, berry aneurysms, these are the things that are seen in ARPKD. Now, both ARPKD and ADPKD are bilateral diseases, whereas multicystic dysplastic kidney and PUJ obstruction are usually unilateral disease. Whereas in PUJ obstruction, what will you see? You will see hydronephrosis. So this image is that of a PUJ obstruction, in which you see that there is hydronephrosis within the kidney, but the ureter is not dilated. So there is hydronephrosis, but ureter is not dilated. Okay, so how do you differentiate between hydronephrosis and cysts? So hydronephrosis has intercommunicating cysts. So you will see that these areas are communicating with each other. So that means they are not cysts, but that they are part of the pelvic-calyceal system. So that is how you differentiate between a cystic disease and a PUJ obstruction. Now this typical third image here is that of a MDCKD, MCDK, multicystic dysplastic kidney, and you see that the right kidney is small and there are multiple these cysts and large cysts replacing the entire renal parenchyma, and such kidneys are usually non-functional. So the answer here is a multicystic dysplastic kidney. Now we move on to the next question. A 51-year-old male underwent contrast-enhanced CT of the chest and abdomen for generalized weakness and vague abdominal pain. Now the reporting senior resident asked the junior resident about the attenuation values of different materials on CT. So we want to look at the HU values. How do we look at the attenuation values of materials on CT? By Hounsfield unit, or we call it HU value. HU value, right? And the question is asking us to arrange them in decreasing order. So whichever has the large maximum HU value, we'll put it first. Now, what are the various HU values of different materials on a CT? So if we draw a line, if we plot every attenuation values of the common materials on CT in a line, we take the reference value of 0 HU as water. Okay, and in this side and in this side, we'll keep objects which are bright or have high attenuation values, and on this side, we'll keep objects which have low attenuation values, or they'll appear black. Okay, so the highest attenuation values are that of metals. So for example, if iron metal is there, it show very streak artifacts. So they have very high attenuation values. So around 400 to 800 HU, we have cortical bone. Okay, very high attenuation value, appear bright. Then around 200 to 400, we have calcifications. Now the more common soft tissues, that is liver, spleen, pancreas, they have an attenuation value of 30 to 50 HU. So these includes liver, spleen, muscles. Okay, these are, we'll commonly club them under soft tissues. Okay, and remember, we are talking about attenuation values on a non-contrast CT. These are HU values on an NC-CT, right? Remember this point. Now, the darker objects, darker than water, are fat and air. These two things you have to remember, which appear black on CT. So what is the typical attenuation value of fat? Usually minus 40 to minus 100 HU. And air has an attenuation value of minus 1000 HU. Okay, so given the question, if you want to arrange them in decreasing order, what will be the answer? So the maximum attenuation value will be that of bones, followed by liver, followed by water, followed by fat, and then followed by air. So the answer here is option number B. Okay. Now let's move on to the next question. A 75-year-old male, so it is an elderly male, fell down the stairs. So it is a trivial trauma. Okay, and sustained a head injury. Now in a head injury, in an elderly more than 75, yes, we'll go ahead and do a NCCT head. And what does the NCCT head shows? So look at this image right here. So this is a non-contrast CT of the brain. We see this hyperdensity along the right frontoparietal convexity. And what type of hyperdensity is it? It is showing this convexo-concave shape. It is like a convexo-concave shape, and it is crossing this frontoparietal suture. So what have we learned here? So it is an acute bleed, yes, because it is appearing hyperdense. So it is an acute bleed. Its shape is concavo-convex. It is crossing the sutures. Okay, and it is occurring in an elderly male with a trivial trauma. So yes, you guessed it right. The answer here is a subdural hematoma. Anything else that you want to comment on this CT clinically? Suppose you are sitting as a radiologist in trauma center and you're given with this CT. So I think almost everybody would recognize that it is an FTH, but the thing that you have to mention in the report is the midline shift. Very important clinically, midline shift. Okay, so you draw a line from the center and then measure the deviation of the septum pellucidum from the midline, and if it is more than 5 mm, it is an indication for emergency decompression. So the answer here is a subdural hematoma. Now how does an EDH and an SAH looks like? So an EDH typically will have a biconvex margins, but not necessarily true. And its usual location is that in the temporal lobe. Temporal lobe has a biconvex margins, right? And it does not cross the sutures. It does not cross the sutures. Okay, and if you're given in the history a lucid interval, okay, or a high velocity trauma, or there is an associated fracture of the skull, so the chances of it being a EDH is much more common than it being an FTH. Okay, remember, for brain hemorrhages, the shape of the bleed is not so important, but the crossing of the suture, crossing of midline, associated skull fracture, trivial trauma, high velocity trauma, these are much more important things differentiating between an FTH and an EDH. Now SAH has a sulcal, it has